In everyday life, we rely on our hands for a variety of reasons, from vigorously typing out notes while watching an osmosis video to playing musical instruments or participating in sports. Unfortunately, since we use them so much, the hands are quite prone to injury. Alright, let's start by looking at distal forearm fractures. There are two kinds: Colles fracture, which are a direct result of falling on an extended wrist, and Smith fracture, which results from falling on a flexed wrist or a direct blow to the posterior forearm. With Colles fractures, the displaced radial fragment moves posteriorly or dorsally, and the ulnar styloid process can also become fractured. Clinically, when the distal radial segment moves dorsally, this is called a dinner fork deformity because when viewed laterally, the hand and wrist are slightly curved anteriorly, making it look like a fork. With Smith fractures, on the other hand, the displaced distal radial fragment moves anteriorly or ventrally, which clinically translates as a garden spade deformity. Next, let's look at carpal bone fractures, of which the most common are scaphoid fractures. Scaphoid fractures occur as a result of falling on the lateral side of an outstretched hand in abduction. Clinically, this results in pain and tenderness on the lateral side of the wrist and hand, in a location called the anatomical snuff box, which is where you can palpate the scaphoid bone between the tendons of extensor pollicis longus on the medial side and extensor pollicis brevis and abductor pollicis longus on the lateral side. The big problem with these fractures is that because the blood vessels supply the distal part of the scaphoid first, then come back and supply the proximal part, a fracture in the middle of this bone disrupts the blood supply. This can cause avascular necrosis and non-union of the proximal fragment of the scaphoid, which is basically when the bone dies off because of lack of blood and degenerative wrist joint disease. Initial X-rays often miss scaphoid fractures at first, so when there is tenderness on palpation of the anatomical snuff box in a patient who fell on an outstretched hand, it's important to still treat it as a fracture to avoid this complication. When still suspecting a scaphoid fracture after an initial negative X-ray, a CT or MRI scan can be done, or a follow-up X-ray can be done in 7 to 14 days. Management for a non-displaced scaphoid fracture is immobilization with a cast or thumb spica splint, where displaced fractures may need to be treated surgically. Furthermore, serial X-rays should be done during recovery to monitor for osteonecrosis of the proximal segment. Another carpal bone, called the lunate, can also be subject to injury. The lunate is found in the proximal row of carpal bones medial to the scaphoid and is susceptible to volar or anterior dislocation into the carpal tunnel during a fall on an outstretched hand, though less likely to be injured than the scaphoid bone. Lunate bone dislocation can result in compression of the median nerve within the carpal tunnel, resulting in median nerve compression signs and symptoms. This includes pain and paresthesia in the radial 3½ digits, weakness of the first and second lumbrical, thenar atrophy, and weakness of thumb abduction and opposition of the affected hand. On a lateral X-ray of the hand, volar lunate dislocation can be recognized by the spilled teacup sign. Another common pathology of the hand that you probably have heard of is carpal tunnel syndrome. Carpal tunnel syndrome occurs when the median nerve is compressed within the carpal tunnel, which is a space created by the transverse carpal ligament forming the roof of the carpal tunnel and the carpal bones forming the floor. The median nerve, along with 9 flexor tendons, enter the hand through the carpal tunnel, and increased pressure in this space can compress the median nerve, resulting in median nerve compression signs and symptoms. Risk factors for carpal tunnel are pregnancy, edema, obesity, rheumatoid arthritis, hypothyroidism, diabetes, acromegaly, and may be associated with repetitive use of the hands and wrist. There are 2 popular clinical tests used to test for carpal tunnel syndrome. The first is Phelan maneuver, when both wrists are flexed to 90 degrees and the dorsal surfaces of the hands are pressed together. A positive test is when the symptoms of carpal tunnel are reproduced in prolonged position of up to 60 seconds. The second is the Tinel sign, which is performed by repeatedly percussing firmly over the carpal tunnel, and if carpal tunnel symptoms appear, that's a positive test. To confirm the diagnosis of carpal tunnel syndrome, a nerve conduction study frequently combined with electromyography is used to assess the degree of nerve damage and muscle denervation. The management of carpal tunnel syndrome is typically non-surgical. Initially, a wrist splint can be used to immobilize the wrist in a neutral position to prevent excess flexion or extension that can worsen symptoms. If this does not work, steroid injections can be used to reduce inflammation. Significant impairment may require surgical decompression of the median nerve with a longitudinal incision through the transverse carpal ligament to decrease pressure. However, it is important to avoid the recurrent branch of the median nerve, which is susceptible to injury during this operation, or any superficial laceration of the palm in general. Injury to the recurrent branch of the median nerve would lead to dysfunction of the 3 thenar muscles which it supplies, but no sensory deficits, resulting in thumb movement dysfunction and loss of the thumb's overall usefulness. Another nerve, called the ulnar nerve, is also susceptible to compression within the ulnar canal, or Guillain canal, which is the space where the ulnar nerve enters the wrist. The ulnar canal has a roof, made up by the thickened superficial palmar fascia, a floor made up by the transverse carpal ligament, a medial wall consisting of the pisiform and pisohamate ligament, and a lateral wall made up by the hook of the hamate. Fracture of the hook of the hamate can cause compression to the ulnar nerve at the wrist, resulting in sensory loss to the medial 1.5 digits, weakness in abduction and adduction in digits 2 to 5, weakness in adduction of the thumb, weakness in flexion of the 4th and 5th digits, as well as weakness in opposition of the 5th digit. Atrophy of the hypothenar muscles will eventually occur, and injury to the distal ulnar nerve can result in an ulnar claw deformity when the hand is at rest. Now, let's switch gears and look at the bones of the hand. Some of the most common injuries at this site include fractures of the 5th metacarpal, also called boxer's fractures, and injuries of the fingertip, called mallet finger and also called baseball finger. Let's look at them one by one. 5th metacarpal fractures occur when throwing a punch with a closed and abducted fist. Fingertip injuries are caused by damage to the extensor tendon at the distal interphalangeal joint, and it's called a baseball finger because it's often the result of a forceful impact of an object, like a baseball, with the fingertips. Clinically, mallet finger results in drooping and inability to extend the fingertip. Alright, now we're still in the hand region, so let's talk about Dupuytren contracture, which is when the palmar fascia and aponeurosis gradually thickens, shortens, and becomes fibrotic until the 4th and 5th fingers are pulled into permanent partial flexion. Some risk factors for developing Dupuytren contracture include family history, alcohol dependence, smoking, liver or thyroid disease, and diabetes. Up next, there's tenosynovitis, which is the inflammation of the sheath surrounding a tendon. One form is de Quervain tenosynovitis, which affects the tendons of the abductor pollicis longus and extensor pollicis brevis, which have the same common tendon sheath, because of repetitive forceful movements of the hands during gripping and wringing, like when squeezing water out of clothes. Clinically, this causes sharp pain on the lateral side of the wrist, which can be elicited using Finkelstein test, where the examiner grasps and ulnar deviates the hand when the person has their thumb held within their fist. It most commonly occurs in women between the age of 30 and 50, and it also has a higher frequency 4 to 6 weeks postpartum. Golf and racket sports players are also at risk. These injuries can be managed conservatively with analgesics such as non-steroidal anti-inflammatories and thumb spica splinting. Another form of tenosynovitis is known as trigger finger or stenosing tenosynovitis, which can affect one or multiple fingers, causing them to snap or lock into place during flexion, making it hard to extend these fingers and leaving them in the classic trigger position. Finally, one last condition that can affect the wrist is a ganglion cyst, which is a small mass typically filled with mucinous fluid, which can overlie the joints or tendon sheaths in the upper and lower limbs, but most commonly they affect the wrist. These are generally harmless lesions which communicate with the underlying joint, and those with underlying joint disorders or previous injury are more at risk. They are typically diagnosed clinically and are confirmed using transillumination of the mass with a light pressed up against it. Rarely, an ultrasound or MRI is needed to confirm diagnosis. They are often asymptomatic but can produce some pain and tenderness, and if they get large enough can cause local compression on nerves such as the median nerve. Typically they resolve on their own, but aspiration or surgical removal are sometimes necessary. Alright, as a quick recap, distal forearm fractures include Colles and Smith fractures. Colles fractures result from falling on an extended wrist, and this may result in a dinner fork deformity, whereas Smith fractures usually result from falling on a flexed wrist, causing a garden spade deformity. In the hand region, the most common carpal fracture is a scaphoid fracture, which often results from a fall on an outstretched hand. This mechanism of injury can also result in lunate bone volar dislocation, which may also compress the median nerve. Nerve compression can also affect the median nerve as it travels through the carpal tunnel, or the ulnar nerve as it passes through the ulnar canal. Superficial laceration of the palm can cause damage to the recurrent branch of the median nerve, which innervates the thenar muscles controlling movement of the thumb. Ganglion cysts are mucinous-filled lesions mostly overlying the wrist. Fractures of the fifth metacarpal is called boxer's fractures, and injury to the fingertips is called mallet finger and also called baseball finger. Dupuytren contracture is when the palmar fascia and aponeurosis gradually thickens, shortens, and becomes fibrotic until the fourth and fifth fingers are pulled into permanent partial flexion. Sharp pain on the lateral side of the wrist during ulnar deviation is called de Quervain tenosynovitis, and trigger finger is when one or more fingers can catch or lock into flexion and have difficulty extending.
Our upper limbs are complex structures. They've got bones, muscles, fascia, nerves, and blood vessels, and everything in between. Our upper limbs are prone to injury, however, and oftentimes even a small injury can have a huge functional deficit, as we are so reliant on our upper limbs in everyday life. One of these commonly injured areas is the shoulder region. Okay, so let's start by taking a look at the injuries of the clavicle. Because of its subcutaneous position, the clavicle is prone to fractures, which are usually the result of direct or indirect trauma. An example of direct trauma is falling directly on the shoulder. Indirect trauma, however, may occur when falling on an outstretched hand, and the force of impact is transmitted through the bones of the forearm and the arm to the shoulder, which can result in a clavicle fracture. Most of these fractures occur in the middle third of the clavicle, particularly where the middle third meets the lateral third, which is the weakest point of the clavicle. So with clavicular fractures, the medial fragment is usually pulled up by the sternocleidomastoid muscles, which can be apparent to the naked eye and palpable. At the same time, the trapezius muscle is having trouble holding the lateral fragment up because of the weight of the limb, so the shoulder drops. And since the two fragments may glide under each other, the clavicle is also shortened. Additional features may signal complications of a clavicle fracture. For example, if the skin above the fracture seems to be tenting, meaning it looks like a tent, that suggests the fracture may become an open fracture in the future and warrants surgical stabilization. Alright, now another thing that can happen in this region is an acromioclavicular dislocation, also called a shoulder separation. Just like the name says, the clavicle and acromion process separate, usually because of a direct blow to the shoulder or a fall landing directly on the shoulder joint. And this may be seen in contact sports like football, soccer, or hockey. In most cases, the dislocation is mild if the acromioclavicular ligament is just stretched or partially torn. In severe cases, both the acromioclavicular ligament and the coracoclavicular ligaments are torn. If the coracoclavicular ligament tears, the shoulder can completely separate and drop due to the weight of the upper limb. If the joint capsule also tears, the acromion process may slip under the clavicle. Clinically, there is swelling of the acromioclavicular joint and pain that worsens with overhead arm movement and lying on the affected side. You can also get osteoarthritis of the acromioclavicular joint, often the result of a previous injury. To test pathology of the AC joint, the scarf test may be used, where the arm of the affected joint is flexed and adducted across the chest and neck, similar to a scarf, producing pain over the AC joint. Now, right below the acromioclavicular joint, there's the glenohumeral or shoulder joint, which is a ball and socket joint, where the ball is the humeral head and the glenoid cavity of the scapula is the socket. The joint is supported by ligaments and surrounded by the rotator cuff muscles, commonly remembered with the sits mnemonic: supraspinatus, infraspinatus, teres minor, and subscapularis. The glenohumeral joint is freely movable, which lets us make complex movements like throwing a baseball. But this also means that this joint is highly unstable. So one thing that can happen is a glenohumeral joint dislocation, which can be anterior, meaning the humeral head is dislocated toward the front, or posterior, when the humeral head is dislocated toward the back. Anterior dislocations are more common in young people, and they occur because of a direct blow or a fall on an outstretched arm. Think of a soccer goalkeeper jumping to catch the ball, arms outstretched, and landing right on his side. This usually happens when the arm is externally rotated and abducted, and when there is a hard blow to the humerus, the humeral head gets pushed down toward the weaker inferior part of the joint capsule. If it tears or weakens, the humeral head goes inferiorly, and the strong flexors and adductors pull it forward. Clinically, the shoulder is visibly displaced and may appear squared off, since the curvature of the deltoid muscle is lost. One possible complication to be aware of is damage to the axillary nerve, which is located inferior to the glenohumeral joint. Axillary nerve damage causes a loss of sensation over the lateral part of the proximal arm, and atrophy of the deltoid muscle, resulting in weakness of abduction of the shoulder. Posterior dislocations, on the other hand, are rare, and they usually happen because of forceful muscle contraction during an electric shock or seizure. One issue that's commonly associated with a shoulder dislocation is a rotator cuff injury. But rotator cuff injuries may also occur on their own. Degenerative injuries of the rotator cuff occur in the context of repetitive stress, such as in sports like baseball or tennis, or occupations that require repetitive overhead movements. This causes a lot of inflammation and an accumulation of small tears in the tendons over time. The most commonly injured tendon is the supraspinatus tendon, which can become impinged as it passes between the acromion process and the humeral head during abduction. This space is already very small, so anything that makes this space smaller, like inflammation, bone spurs of the inferior part of the acromion, or subacromial bursa inflammation, can cause the tendon to become repetitively impinged and irritated. In rotator cuff impingement, also called tendinopathy, these damaged tendons result in constant pain with movements such as abduction, external rotation, and internal rotation. However, typically the individual has normal range of motion. The empty can or full can tests can help assess for supraspinatus tendinopathy, where the patient has their arm raised parallel to the ground in the scapular plane, either in internal rotation for the empty can or in external rotation for the full can test. The examiner then pushes down at the elbow or wrist while the patient resists. The test is positive if there is weakness and/or pain. Other tests of subacromial impingement are the Neer's test, where the individual's arm is internally rotated and passively flexed forward above their head to elicit pain, and the Hawkins-Kennedy test, where the individual bends their elbow to 90 degrees, flexes their arm to 90 degrees, and is put into internal rotation to elicit pain. On the other hand, acute injuries that occur when falling on an outstretched arm or when lifting something heavy with a jerking motion can result in a rotator cuff tear. Instead of pain on movement, individuals with rotator cuff tears may have pain and weakness during abduction, external rotation, or internal rotation. If it's severe enough, they may have significant movement deficits. The most common rotator cuff tear is to the supraspinatus and can be tested with the drop arm test. With the patient holding their arm abducted above the head, when they're asked to lower it slowly, they will be unable to do it smoothly and will have a rapid drop around mid-descent. In addition to tendinopathy and rotator cuff tears, the glenohumeral joint is also prone to osteoarthritis. This results in the gradual onset of anterior and deep shoulder pain, and also causes a decrease in active and passive range of motion of the shoulder. Risk factors for glenohumeral osteoarthritis are age, trauma, and previous shoulder injuries. Next, there's adhesive capsulitis, or frozen shoulder, which is when connective tissue around the glenohumeral joint, mainly the joint capsule, gradually becomes inflamed and stiff, usually in people between the ages of 40 and 60. This process may be initiated by injuries like glenohumeral dislocations or rotator cuff injuries, as well as many others. Clinically, there are usually 3 stages. In the first stage, there is disabling pain and increasing stiffness for up to 9 months. The second phase is characterized by progressive range of motion limitation to the point where both passive and active movement is nearly impossible, but the pain is less pronounced. This phase can last up to 12 months. And lastly, the third phase is the recovery phase, where patients regain their mobility, which can take up to 2 years. Finally, let's look at one of the more famous structures crossing the shoulder joint, which is the biceps tendon. Most often, prolonged tendinitis of the biceps tendon weakens it over time, where it can rupture, resulting in a biceps tendon rupture. It can also be damaged during forceful flexion of the arm against resistance, such as weightlifting. The rupture typically occurs at or near the proximal supraglenoid attachment and is associated with a loud pop. The detached muscle belly then forms a ball distally near the lower anterior aspect of the arm, commonly referred to as a Popeye deformity. So take it easy when you're at the gym. All right, as a quick recap, clavicular fractures may result from direct or indirect trauma. They often occur in the middle third of the clavicle and result in shoulder drooping and a shortened clavicle. Another injury of the shoulder girdle is a acromioclavicular dislocation, which is usually the consequence of a direct blow to the shoulder, and this may be seen in contact sports like football, soccer, or hockey. Then there's glenohumeral dislocation. Anterior glenohumeral dislocations occur because of a direct blow to the shoulder or falling on an outstretched arm. Clinically, the shoulder is visibly displaced and may appear squared off since the curvature from the deltoid muscle is lost. Posterior dislocations are rare, and they usually happen because of forceful muscle contraction during an electric shock or seizure. Repetitive activity above the head can lead to impingement and tendinopathy of the rotator cuff muscles, most frequently affecting the supraspinatus muscle, resulting in pain on movements. Rotator cuff tears are similar to tendinopathies, but result in pain and weakness of movements, again with the supraspinatus being the most commonly injured. The glenohumeral joint is also susceptible to osteoarthritis, resulting in gradual onset of pain and decreased range of motion. Adhesive capsulitis, also known as frozen shoulder, occurs due to inflammation and resulting stiffness of the connective tissue, like the joint capsule around the glenohumeral joint. The biceps tendon can also rupture, most often at or near its proximal attachment, often due to long-standing tendinitis or forced flexion against resistance, resulting in the characteristic Popeye deformity. The median, ulnar, and radial nerves course through the forearm and wrist, and they help coordinate the movement of our forearms and hands. These nerves, however, are prone to injury because of various causes, and depending on which one of them is injured, that will result in characteristic symptoms that can help us recognize and identify it. For the median nerve, the clinical manifestations depend on whether the lesion has occurred distally, as in carpal tunnel syndrome, or proximally, as in an anterior displaced portion of a medial supracondylar humerus fracture. The most common cause of median nerve injury is carpal tunnel syndrome, which is when the tunnel in the wrist through which the median nerve passes becomes narrower and compresses the median nerve. This can happen due to repetitive use, like typing on a keyboard, injuries like an anterior lunate dislocation, or it can be associated with conditions such as hypothyroidism, diabetes, or in pregnancy. Symptoms of median nerve injury would be pain and paresthesia in the radial 3.5 digits, weakness of the first and second lumbrical, thenar atrophy, and weakness of thumb abduction and opposition of the affected hand. Specifically, the recurrent branch of the median nerve is what provides motor innervation to the thenar muscles of the hand, which are responsible for abduction, flexion, and opposition. So with injuries, people may have issues opposing the thumb, and it may be difficult to perform actions like buttoning up a shirt. Damage to the recurrent branch of the median nerve alone causes what is known as apehand, which refers to atrophy of the thenar eminence and inability to oppose the thumb. Damage to the entire median nerve at the level of the wrist presents clinically as a median claw. Let's break this down quickly. So the first and second lumbricals are innervated by the median nerve, and the lumbricals normally flex the metacarpophalangeal joints and extend the distal and proximal interphalangeal joints. If the median nerve is injured, the opposite occurs. So at rest, or when the patient tries to extend all the fingers, the index and middle fingers stay extended at the MCP, and the DIP and PIP stay flexed, especially since the finger flexors are unopposed, resulting in the median claw. Now, in a proximal lesion to the median nerve, as in a supracondylar fracture, we have all of the same deficits as in a distal lesion. But now, all of the finger flexors of the second and third digit are also affected, such as the flexor digitorum superficialis and the lateral half of flexor digitorum profundus. So when an individual is asked to make a fist, they can only flex the fourth and fifth digit, and this presentation, or claw, is referred to as Pope's blessing, or hand of benediction, and it is indicative of a proximal median nerve injury. Okay, next, there's ulnar nerve injuries, which can occur anywhere between its origin from the brachial plexus to the ulnar canal or Guillain canal in the wrist. Most commonly, it's associated with elbow injuries, such as fracture of the medial epicondyle of the humerus. In a distal ulnar nerve injury, like a fracture to the hook of the hamate bone, or when cyclists compress the hook of the hamate bone when holding onto handlebars, there's numbness and sensory loss to the medial 1.5 digits, weakness in abduction and adduction in digits 2 to 5, weakness in the adduction of the thumb, weakness in flexion of the fourth and fifth digits and opposition of the fifth digit, as well as hypothenar eminence atrophy. It also manifests clinically as an ulnar claw. This is the exact opposite of the median claw, where this time we have paralysis of the medial 2 lumbricals. So at rest, or when the patient tries to extend their hand, the ring and pinky fingers stay extended at the MCP, and the DIP and PIP stay flexed, and the finger flexors are once again unopposed. Okay, so in a proximal lesion to the ulnar nerve, as in a medial epicondyle fracture, trauma, or prolonged leaning or sleeping on your elbow, we have all of the same deficits as in a distal lesion. But now there is the additional problem that we have lost function of the flexor digitorum profundus on the medial side. So when a patient is asked to make a fist, they can only close their second and third digits or fingers, and this is called an OK gesture. Additionally, there is a loss of flexor carpi ulnaris resulting in wrist adduction deficits. So, when they try to flex their wrist, it deviates radially. Finally, radial nerve injury can happen a few different ways. First off, it can occur by repetitive pronation and supination of the forearm, for example, when using a screwdriver. In this case, it manifests clinically as finger drop. This occurs because the deep branch of the radial nerve pierces the supinator muscle as it travels distally, and overuse of supination can cause impingement here. After the supinator muscle, this branch goes on to innervate the extensor indices, so reduced function of this muscle can result in a finger drop due to weakness of the finger extensors and unopposed action of the finger flexors. Radial nerve injury can also occur because of a midshaft fracture of the humerus, or because of a lateral deviation of a displaced supracondylar fracture of the humerus. This manifests clinically as weakness of the supinator and extensor muscles of the wrist and fingers, as well as sensory loss to the posterior forearm, dorsolateral hand, and dorsal thumb. The classic clinical finding is wrist drop, which is when the wrist hangs in a partly flexed position on account of unopposed wrist and finger flexors. Finally, it can occur due to compression of the brachial plexus. For example, when using crutches or sleeping with your arm hanging over a chair, hence the term Saturday night palsy. Since this injury occurs superior to the branches of the triceps brachii, this also causes paralysis of the triceps, leading to loss of elbow extension in addition to loss of wrist and finger extension. There will also be loss of sensation over the dorsal hand and thumb, as well as the posterior forearm or arm, depending on how high up the nerve damage is. Alright, as a quick recap. The median nerve, specifically its recurrent branch, can be injured at the level of the wrist, resulting in atrophy of the thumb and an inability to oppose the thumb, called an ape hand. Injury to the entire nerve at the wrist results in a median claw, which is when the index and middle fingers stay extended at the metacarpophalangeal joints, while the distal and proximal interphalangeal joints stay flexed when trying to open the hand from rest due to weakness of the lateral two lumbricals. Proximal median nerve injuries have the same deficits as distal injuries, plus additional weakness of the forearm muscles innervated by the median nerve. This results in a clinical finding called Pope's blessing, or the hand of benediction, when an individual is asked to make a fist, and they can only close their medial two fingers. Ulnar nerve injuries distally at the wrist result in numbness and sensory loss to the medial 1.5 digits, weakness in abduction and adduction in digits 2 to 5, weakness in adduction of the thumb, weakness in flexion of the 4th and 5th digits and opposition of the 5th digit, as well as hypothenar eminence atrophy, plus the characteristic ulnar claw, which is the exact opposite of a median claw. A proximal ulnar injury has the same deficits as the distal injury, as well as weakness of wrist adduction and flexion of the medial 2 digits, and also results in the OK gesture. Finally, radial nerve injury may result in either finger drop, wrist drop, or Saturday night palsy, as well as sensory deficits to the dorsal hand and thumb, forearm, and arm, depending on the mechanism and location of the injury.
The majority of things we do every day require the use of our arms and forearms. Sometimes we forget how heavily we rely on our arms and are quickly reminded how important they are when injury occurs. So let's take a look at common injuries occurring to the arm and forearm. Alright, let's begin by looking at fractures of the humerus, the main bone of the arm. The most common kind are fractures of the surgical neck of the humerus, which occur more frequently in elderly people with osteoporosis who have structurally weaker bones. The cause is usually indirect trauma, like falling on the hand with an extended arm. Surgical neck fractures can result in damage to nearby structures, such as the axillary nerve causing cutaneous deficits in the proximal lateral arm, as well as damage to the anterior and posterior circumflex humeral arteries. Next, there are humeral shaft fractures, which are usually caused by direct trauma. Now, remember that the radial nerve passes through the radial or spiral groove on the back of the humerus, so a common complication of midshaft humeral fractures is radial nerve injury. Radial nerve injury results in damage to the extensors of the wrist and potential wrist drop, as well as cutaneous sensation dysfunction of the dorsal hand, forearm, and upper arm. Additionally, the deep brachial artery travels with the radial nerve in the spiral groove and can also be damaged. Finally, distal humeral fractures are a result of trauma to the elbow region, or hyperextension injuries. In a supracondylar fracture, which is a fracture above the epicondyles, an anteriorly displaced portion of the fractured humerus on the medial supracondylar region could injure the median nerve, resulting in wrist flexion weakness and cutaneous deficits of the anterior 3.5 digits, as well as the brachial vessels. An anterior displaced fracture of the lateral supracondylar region could cause damage to the radial nerve, again causing weakness of wrist and hand extensors and posterior forearm and hand sensory loss. Distal to the supracondylar region, a fracture of the medial epicondyle of the humerus can result in damage to the proximal ulnar nerve. This can occur due to hyperflexion injuries, falling, or direct trauma to the medial elbow, or laceration injuries. As a result, there's sensory loss over the fifth digit and half of the fourth digit, as well as weakness in flexion of the wrist and fourth and fifth digits, making it difficult to make a fist. This is sometimes called a claw deformity and creates an OK gesture when trying to make a fist. Okay, now let's have a look at the elbow region and discuss another kind of wear and tear injury called epicondylitis. Epicondylitis is when there is inflammation and small tears of the tendons that attach to the epicondyle. Lateral epicondylitis usually results from repetitive use of forearm extensor muscles, which is commonly seen in tennis players, and results in pain around their muscle origin on the lateral epicondyle that radiates down the posterior forearm. The same thing can happen with the medial epicondyle, which results in medial epicondylitis, or, and here's another sports injury, golfer's elbow. Medial epicondylitis occurs from repetitive use of forearm flexor muscles, which is commonly seen in golfers, hence golfer's elbow. This results in pain on the medial epicondyle that radiates down the anterior forearm, which worsens when trying to make a fist, like when squeezing a stress ball. Initial management for medial and lateral epicondylitis is activity modification and compression bracing, as well as icing, anti-inflammatory use, stretching, and physiotherapy. The elbow also has a bursa on its posterior aspect, called the subcutaneous olecranon bursa. Falling on the elbow, abrasions, constant pressure, or infections of the overlying skin can cause injury to this bursa, leading to an olecranon bursitis. This is also known as student's elbow because students often study a lot, so their elbows are constantly on the table. Olecranon bursitis leads to pain and discomfort of the posterior elbow and can also lead to infection. Another clinical correlate in the elbow region is radial head subluxation and dislocation. These injuries are common in children, especially when they're suddenly lifted by the upper limb while their forearm is pronated. Subluxation, also called a partial dislocation or a pulled elbow, occurs when the radial head pops out of the annular ligament. This happens more in children because the radial head has not completely formed, so it's small enough to slip out of the annular ligament. Clinically, the child may cry and refuse to use their arm, holding it close to their body with the elbow flexed and forearm pronated, and there can be significant pain in the elbow region. Another important area in the elbow is the cubital fossa, which is a common site for withdrawing blood and venipuncture. Typically, blood is drawn from the median cubital vein, which runs diagonally from the cephalic vein of the forearm to the basilic vein of the arm, crossing the bicipital aponeurosis, separating and protecting it from the deeper brachial artery and median nerve. With this in mind, laceration to the cubital fossa can damage these structures, with brachial artery laceration resulting in bleeding, and the median nerve resulting in pronation impairment, wrist and hand flexion dysfunction, and sensory deficits to the areas of the median nerve distal to the elbow. Structures less likely to be damaged by a laceration are the radial nerve and biceps brachii tendon, as they are found deeper in the cubital fossa. Alright, as a quick recap, humeral fractures can be caused by direct or indirect trauma. Surgical neck fractures can damage the axillary nerve as well as the anterior and posterior humeral circumflex arteries. Humeral shaft fractures can result in radial nerve and deep brachial artery injury, whereas anterior displacement of medial supracondylar fractures can damage the median nerve and brachial artery, where anterior displacement of lateral supracondylar fractures can damage the radial nerve. In the elbow region, medial epicondyle fractures can damage the ulnar nerve. Repetitive injury to the lateral epicondyle and medial epicondyle is called lateral and medial epicondylitis, respectively, or tennis and golfer's elbow, respectively. Posterior inflammation of the elbow can result in an olecranon bursitis, resulting in pain and potential infection. You can also have radial head dislocations or subluxations, which are especially common in children who are suddenly lifted by the upper limb when the forearm is pronated. The medial cubital vein in the cubital fossa is a common site of venipuncture, where laceration to the cubital fossa is most likely to damage the median nerve and brachial artery.
The axilla, also known as the armpit, is first and foremost incredibly ticklish. But from an anatomical standpoint, it's a key location that contains many important structures that may be damaged, causing significant functional deficits. The axilla is like a train station, where a number of vascular, nervous, and lymphatic structures pass between the trunk and the upper limb. One very important structure is the brachial plexus, which can be divided into 5 roots, 3 trunks, 6 divisions, 3 anterior and 3 posterior cords, and 5 terminal branches. The order can be remembered using the mnemonic, "Remember to drink cold beer." But you may want to wait until at least the end of the video before you act on that. Now, an upper brachial plexus injury affects the superior root, namely spinal nerves C5 and C6. And a classic example of an upper brachial plexus injury is Erb palsy, which can happen in adults as a shoulder trauma that results in an increase in the angle between the neck and the shoulder, or in newborns, when excessive stretching of the neck occurs during childbirth. The clinical consequences reflect the affected nerves, which are the ones that are derived solely from C5 and C6 roots, namely the musculocutaneous, axillary, and suprascapular nerves. This causes paralysis of muscles like the biceps brachii, which normally allows forearm flexion and supination, and the infraspinatus and teres minor, so lateral rotation of the arm is affected, as well as the deltoid and supraspinatus muscles, which would usually cause arm abduction but would also be affected. So, with superior brachial plexus injuries, the classic finding is a waiter's tip position, which reflects arm adduction and medial rotation, and forearm extension and pronation. Lower brachial plexus injuries are much more uncommon, and they affect the interior roots of the brachial plexus, namely C8 and T1. This can happen because of excessive abduction of the arm, aka an increased angle between the trunk and the upper limb. This could happen to a person falling from a tree and grabbing onto a branch, or during delivery if the newborn is pulled out by the arm. The result is what's clinically known as Klumpke palsy, which has serious effects on nerves derived from the C8 and T1 roots, like the median and ulnar nerves, and causes loss of sensation along the medial side of the arm, and paralysis of the intrinsic hand muscles. The classic finding is a claw hand, which is due to flexion of the interphalangeal joints and extension of the metacarpophalangeal or MCP joints. This is mainly due to paralysis of the lumbricals, which normally act to flex the MCP joints and extend the interphalangeal joints as if you were to be waving bye-bye, resulting in unopposed flexion of the interphalangeal joints and unopposed extension of the MCP joints. Lower brachial plexus injuries can also occur due to compression of the lower trunk, for example, by an extra or cervical rib, or by an apical lung tumor called a Pancoast tumor. This is an example of thoracic outlet syndrome and results in the same deficits as seen in Klumpke palsy. However, thoracic outlet syndrome can also result from damage to any structures that enter and exit the lower neck and upper limbs via the superior thoracic aperture, which is the region above the first rib between the clavicle, sternum, and cervical vertebrae. These structures include the subclavian vessels, which are usually compressed in the scalene triangle, formed by the anterior and middle scalene muscles. The brachial plexus trunks, along with the subclavian artery, pass through this scalene triangle, where the subclavian vein travels anterior to it. Compression of the subclavian vessels results in upper extremity swelling and exertional arm pain. And speaking of compression, the radial nerve can also be affected by compression injuries. This happens when the radial nerve is compressed against the hard surface of the humerus, often occurring when we are sitting down and have our arms spread out over a chair next to us. This is commonly referred to as Saturday night palsy because it might happen on a Saturday night if you fall asleep with your arm hanging over the chair. But it can also happen from any direct pressure on the radial nerve, for example, when using crutches. Spending an extensive amount of time in that position can cause weakness in elbow extension and wrist extension, classically known as wrist drop, in addition to loss of sensation over the dorsal hand and thumb, as well as the posterior forearm or arm, depending on how high up the nerve damage is. Finally, the axilla is also home to the axillary lymph nodes, which are often dissected and sent for pathologic analysis in the evaluation of breast cancer. Axillary nerve dissection, however, comes with a risk of long thoracic nerve injury, which clinically translates as a winged scapula. A winged scapula is more apparent when a person tries to push against a wall. The medial border and inferior angle of the scapula pull away from the posterior thoracic wall, making the scapula look like a wing. Besides protracting the scapula against the posterior thoracic wall, the serratus anterior also helps abduct the arm above the horizontal plane, so patients may have trouble doing overhead movements, like, for example, brushing their hair. Alright, as a quick recap. Superior brachial plexus injuries cause Erb palsy, and the classic finding is a waiter's tip position, which reflects arm adduction and medial rotation, as well as forearm extension and pronation. Inferior brachial plexus injuries cause Klumpke palsy, and the classic finding is a claw hand due to flexion of the interphalangeal joints and extension of the metacarpophalangeal joints. Compression of structures at the superior thoracic aperture can result in superior thoracic outlet syndrome, which often affects the lower trunks of the brachial plexus or subclavian vessels. Compression of the axilla can result in radial nerve palsy, resulting in wrist drop. Finally, the axilla is also home to the axillary lymph nodes, and during axillary lymph node dissection, damage to the long thoracic nerve may result in a winged scapula.
If it wasn't for our thoracic wall, many of the important organs in our thoracic cavity would be unprotected and vulnerable to injury. But sometimes the thoracic wall itself can be injured, which has a wide range of clinical consequences depending on the affected structures. Let's start by talking about the ribs. First, like any other bone in our body, ribs can break, causing rib fractures. These usually result from direct trauma or crushing injuries. The middle ribs are the ones most commonly fractured. The weakest part of a rib is the posterolateral bend, anterior to its angle. However, direct trauma can cause a rib to fracture anywhere. The broken part of the rib can harm internal organs, such as the liver, kidney, or the spleen. Rib fractures higher up can cause mediastinal injuries, and if the fracture is lower, then it can tear into the diaphragm. Furthermore, rib fractures at any level have the risk of causing an intrathoracic injury such as a pneumothorax, which is when there's air in the pleural cavity, and that doesn't allow the lung on that side to expand properly. Since ribs move during respiration, coughing, laughing, and sneezing are very painful after a rib fracture. A related injury is a flail chest, which is when 3 or more ribs fracture in 2 or more places, which can allow a big segment of the thoracic wall to move freely. During a normal inspiration, the thoracic wall expands outwards and increases its diameter, whereas during expiration, it decreases its diameter to expel air. However, when there's a flail chest, the movement is paradoxical, meaning that during inspiration, the free segment actually moves inward, and during expiration, it moves outward. This is an extremely painful injury that impairs ventilation, and as a consequence, blood isn't properly oxygenated. Management-wise, for a flail chest, you want to ensure adequate pain control and supplemental oxygen if needed. If respiratory failure occurs as a result of the flail chest, then positive pressure ventilation can be used to force the flail chest segment out during inspiration. Sometimes a chest tube may also be required. Now, between the ribs, in the anterior part of the chest, there's the sternum, which is the protector of the mediastinal viscera. In some situations, however, we may need access to those viscera, like during open heart surgery or to remove a tumor in the lungs. And that's when a median sternotomy can be performed, which is when the sternum is split in the median plane and retracted. Retraction is possible because the ribs and costal cartilages are very flexible and allow spreading. And following surgery, the two halves are joined together and typically joined using wires or sutures. Another clinical situation involving the sternum is when it doesn't develop normally. One of them is pectus excavatum, or funnel chest, which is when the sternal cartilages grow abnormally, leading to a caved-in or sunken appearance of the anterior thoracic wall due to chest wall depression. This can sometimes be associated with conditions such as Marfan syndrome, osteogenesis imperfecta, mitral valve prolapse, and Ehlers-Danlos syndrome. If the condition is severe, then it can lead to shortness of breath, fatigue, and even compression of the heart. Another sternum abnormality is pectus carinatum, or pigeon chest, and in contrast to pectus excavatum, this is typically characterized by the sternum protruding outward. This condition is typically asymptomatic. However, at the protrusion site, there can be tenderness on palpation, and individuals can experience tachypnea during intense exercise. This condition is sometimes associated with scoliosis, Marfan syndrome, Noonan syndrome, or osteogenesis imperfecta. Quiz time! Which image shows pectus excavatum and which one shows pectus carinatum? Alright, as a quick recap, the middle ribs are the ones most commonly fractured, and the weakest part of the rib is just anterior to its angle. A flail chest is when multiple ribs are fractured, allowing a big segment of the thoracic wall to move freely in a paradoxical way. It is initially managed with analgesia and oxygen, but may require positive pressure ventilation and a chest tube. A median sternotomy is useful during heart surgery or to remove a tumor in the lungs. Pectus excavatum is when the chest has a caved-in appearance, while pectus carinatum is when the chest is protruding outward.
Before you start watching this video, relax and take a deep breath. Think about the air filling up your lungs, which are located on either side of your thoracic cavity. Now, we often take breathing for granted because it's under autonomic control, and it's not until we have trouble breathing when we realize just how important our lungs are. There are many conditions that can affect the lungs, which can have a huge impact on our day-to-day lives. Let's look at some causes for lung ailments, starting with injuries of the cervical pleura and the lung apex. Both of these structures project through the superior thoracic aperture into the neck. So when there's an injury involving the base of the neck, the lungs and pleural sacs can be injured as well, which can cause a pneumothorax. The pleura is also exposed to potential injury in its inferior portion because it descends below the costal margin in 3 regions, where penetrating injury may enter into the pleural sac. The first is the right part of the infrasternal angle. The other 2 parts are the right and left posterior costovertebral angles, which are inferomedial to the 12th ribs and posterior to the superior poles of the kidneys. So kidney surgery can pose a risk for pleural injury. When discussing injuries to the pleura and lungs, it's important to understand what pleuritic chest pain means. Pleuritic chest pain is caused by irritation to the pleura, which results in the classical sharp stabbing pain that gets worse when you breathe in and is exacerbated even further by deep inhalation and exhalation. Pleuritic chest pain can have multiple causes, including a pneumothorax, which is when there's air trapped within the pleural cavity, or a pleural effusion, when fluid builds up in the pleural cavity. Inflammation of the pleura can result in pleuritic chest pain, which is often the result of infection or inflammatory diseases such as rheumatoid arthritis, and may even result in an empyema where infected fluid builds up in the pleural cavity. Pulmonary emboli can also result in irritation of the pleura, resulting in pleuritic chest pain. pleuritic chest pain is mostly experienced at the site of pleural irritation. However, we can also have a phenomenon we call referred pain. Portions of the parietal lung pleura are innervated by branches of the intercostal nerves peripherally and the phrenic nerves centrally, where the parietal pleura covers the diaphragm. So, for example, if there's irritation of the parietal pleura caused by something like an infection or effusion overlying the mediastinal and central areas of the diaphragm, then we get referred pain to the dermatomal areas supplied by the same spinal levels. So in this case, the central diaphragm is innervated by the phrenic nerve, which is supplied by spinal levels C3, C4, and C5. So the dermatomes of the same spinal levels C3, C4, and C5, which innervate the root of the neck and shoulder, could result in referred pain to the neck or shoulder. Now let's look at a procedure called a thoracentesis, also known as a thoracocentesis, which is when a hypodermic needle is inserted through an intercostal space and into the pleural cavity to remove pleural fluid, blood, or pus from the pleural space. With a thoracentesis, the needle can be inserted between the 6th and 8th rib on the mid-clavicular line, between the 8th and 10th rib along the mid-axillary line, or between the 10th and 12th rib along the paravertebral line. Always remember to insert the needle above the superior border of the rib in order to avoid damage to the intercostal nerves and vessels, which run along the inferior portion of each rib. For example, if doing a thoracentesis at the mid-axillary line between rib 8 and 9, you would insert the needle along the superior border of the 9th rib as your guide. To enter the pleural cavity, the needle passes through skin, then the intercostal muscles, and finally the costal parietal pleura. If the individual sits in an upright position, the intrapleural fluid accumulates in the costodiaphragmatic recess due to gravity. In this case, the needle should be inserted into the 8th or 9th intercostal space in the mid-axillary line during expiration, which will help avoid injuring the inferior border of the lung. Additionally, the needle should be oriented upward in order to avoid penetrating the deep side of the recess, which is a thin layer of diaphragmatic parietal pleura and diaphragm overlying the liver. Of note, caution should be taken as any thoracentesis done below the 9th rib has a risk of injury to abdominal structures, like the liver, if doing a thoracentesis on the right lung. Okay, now just a few words on pneumothorax. Air can accumulate in the pleural cavity because of a penetrating wound in the parietal pleura, such as a bullet or knife wound. The lungs are particularly vulnerable at the apices as the cervical pleura extends above the first rib and clavicle. However, a pneumothorax can also occur spontaneously, in which case it's termed a spontaneous pneumothorax. No matter the cause, when there's air in the pleural cavity, this can present with varying degrees of severity, depending on the extent of the pneumothorax. Symptoms of a pneumothorax include shortness of breath and sudden unilateral pleuritic chest pain. On clinical examination, the chest wall on the affected side might appear bigger than the normal side. On palpation, chest expansion is uneven due to decreased chest wall movement of the affected side, and tactile fremitus is decreased on the affected side. On percussion, the extra air in the pleural space causes hyperresonance on the affected side, and breath sounds are diminished on the affected side. On a chest X-ray, there's a retracted visceral pleural edge, which is seen as a thin, sharp white line, alongside a decreased lung volume due to the lung collapsing. The space beyond the visceral line is mostly black because the space where the lung should be is filled with air. When there's only a small amount of air in the pleural space, the individual is usually hemodynamically stable and can be treated conservatively. However, a larger pneumothorax can result in significant collapse of the corresponding lung and requires advanced treatment. A pneumothorax can also escalate into what is known as a tension pneumothorax, where air continues to enter the pleural space and is unable to leave. This is because with a tension pneumothorax, there's a flap of tissue close to the area of air entry that creates a one-way valve for air to flow in the pleural space, but does not allow air out. A tension pneumothorax typically has a more severe clinical presentation. See, that's because air can't get out, so it rapidly accumulates in the pleural cavity, compressing the other organs in the mediastinum, including the heart, leading to increased thoracic pressure, which causes lower systemic venous return to the heart and a decreased cardiac output. Other clinical signs include increased heart rate and breathing rate, distended neck veins, and distant muffled heart sounds. With a tension pneumothorax, there may also be a mediastinal shift on a chest X-ray, which is seen as a tracheal deviation and displacement of chest structures away from the affected side. However, a tension pneumothorax should be recognized clinically and treated immediately to achieve decompression, since it can cause rapid deterioration of vital signs. So typically, the quickest way to allow for air evacuation is needle thoracostomy, which is often done in the second intercostal space on the affected side, at the mid-clavicular line, which decompresses the chest and provides an escape route for the trapped air. Since anatomy always comes in handy, you can identify the second costal cartilage by using the sternal angle. Once you locate the sternal angle, the intercostal space below it is the second intercostal space, which you can follow by palpation to the midclavicular line for needle insertion. Alternatively, you can also use the fourth or fifth intercostal space at the mid-axillary line for decompression. Following needle decompression, a thoracostomy tube is typically placed. Speaking of which, chest tubes can be used for a variety of other reasons as well. Right off the bat, a chest tube is a good idea when air, blood, fluid, pus, or a combination of these accumulates in the pleural cavity. In this case, the chest tube is inserted in either the fourth or fifth intercostal space at the anterior axillary or mid-axillary line, and then guided through the skin, subcutaneous tissue, serratus anterior, intercostal muscles, and parietal pleura. In order to safely do this and prevent injury to surrounding structures, we use the triangle of safety, which is formed anteriorly by the lateral border of the pectoralis major muscle, posteriorly by the lateral border of the latissimus dorsi muscle, and inferiorly by a horizontal line from the nipple or fifth intercostal space. So the preferred area for chest tube placement is at the mid-axillary line in the triangle of safety, and this is done in either the fourth or fifth intercostal space, depending on situational and patient factors. Additionally, the tube should also be placed in the inferior portion of the intercostal space to avoid injury to the intercostal neurovascular structures coursing along the inferior ribs. The tube can be directed superiorly toward the cervical pleura for air removal, for example when there's a pneumothorax, or directed inferiorly toward the costodiaphragmatic recess when fluid needs to be removed. The end of the tube that's outside the body is then connected to an underwater drainage system to prevent air from being sucked back into the pleural cavity. Now, let's take a breather and focus on where we can best hear the lungs. Let's remember some anatomy facts on the lungs. To locate the different lobes of the lungs, we can trace out the lung fissures using anatomical landmarks. In both lungs, the oblique fissure runs posteriorly at the level of T3 to the sixth rib anteriorly at the mid-clavicular line. The horizontal fissure, which separates the superior and middle lobes of the right lung, connects to the right oblique fissure at the mid-axillary line near the fifth rib, and runs anteriorly to the area of the fourth costal cartilage. This shows us that when auscultating, most of the posterior auscultation will be examining the inferior lobes, where the anterior auscultation is mostly examining the superior and middle lobes. Auscultation of the lungs is very important for clinical examinations, as it allows assessment of airflow through the tracheobronchial tree. Auscultation should be done sequentially from the apices of the lungs to the base of the lungs, comparing the left and right lung as you move distally, and listening to multiple places on both the anterior and posterior chest. The lung apices can be auscultated in the root of the neck above the inner third of the clavicle. The superior lobes of the lungs are best heard when the stethoscope is placed anteriorly in the second intercostal space on the midclavicular line. Moving inferiorly, the middle lobe of the right lung can be heard around the fourth intercostal space along the midclavicular line, while auscultation of the fourth intercostal space over the left lung would still be examining the left upper lobe. The inferior lobes can be heard anteriorly in the sixth intercostal space on the mid-axillary line and posteriorly between T3 and T10. Finally, the base of the lung is best heard over the posterior thoracic wall at the level of the 10th thoracic vertebra. Okay, now let's switch gears and look at clinical correlates regarding the tracheobronchial tree. Remember that the trachea bifurcates into two main bronchi at the level of the sternal angle. The right main bronchus is wider, shorter, and has a more vertical trajectory than the left one. Because of this, aspirated foreign bodies or food are more likely to enter and lodge in the right bronchus or one of its branches. Now, when an individual aspirates, they are at risk of developing aspiration pneumonia. Because of gravity, aspiration pneumonia is most likely to occur in the dependent lung segments. Which segment is the dependent segment depends on the individual's position. In the supine position, the dependent lung segments are the posterior segments of the upper lobes and superior segments of the lower lobes. Individuals in an upright position will most likely develop aspiration pneumonia in the basilar segments of the lower lobes. Finally, when lying on the right side, aspirate usually enters the right upper lobe. And finally, sometimes lung resections may be needed in clinical practice, which is when parts of the lungs need to be surgically removed. Now remember that there are about 10 bronchopulmonary segments for the right lung and 8 to 10 for the left lung, as some of the segments may be combined. So if tumors or abscesses are located in a single bronchopulmonary segment, they can be surgically removed through a segmentectomy. If an entire lobe needs to be removed, it's called a lobectomy. And if the entire lung needs to be removed due to a disease process, this is called a pneumonectomy. A particular type of tumor is the apical lung tumor, also known as a Pancoast tumor, which is typically a non-small cell lung cancer. This cancer develops in the apex of the lung near the superior sulcus, which can go on to infiltrate or compress nearby structures. One such structure is the stellate ganglion, a sympathetic cervical ganglion, which is a collection of sympathetic nerves that supply the face or the arm. Compression or infiltration leads to Horner syndrome, which has 3 distinct features: a constricted pupil, called miosis, due to interruption of the sympathetic fibers innervating the dilator pupillae muscle, leading to unopposed parasympathetic innervation; partial ptosis, or drooping of the eyelid, due to loss of sympathetic control of the superior tarsal smooth muscle of the upper eyelid; and anhidrosis, or impaired sweating, due to dysfunction of the sweat glands of the face. If the tumor compresses the brachial plexus and subclavian vessels, also known as thoracic outlet syndrome, it can cause symptoms which include arm muscle weakness and paresthesia, similar to Klumpke palsy, as well as ischemia and pain due to vascular compression. Sometimes this tumor can compress the phrenic nerve, in which case it can lead to hemodiaphragm paralysis. It can also compress other structures, such as the recurrent laryngeal nerve, causing hoarseness of the voice. It can compress the superior vena cava, leading to superior vena cava syndrome, which impairs blood drainage from the upper limbs and the head and neck, leading to venous congestion of these areas, resulting in venous engorgement, redness, and edema, as well as headaches and dizziness. Compression can also occur at the brachiocephalic veins draining into the superior vena cava, causing similar symptoms as superior vena cava syndrome, but only on the side of the body which they drain. Also, due to the size of these tumors, dysphagia might be present due to local invasion. Oh, look at the time! It's quiz o'clock. Can you remember what a thoracentesis is and where it's performed? Also, does this chest X-ray show a regular or a tension pneumothorax? All right, as a quick recap, a thoracentesis can be done to remove blood, pus, or to obtain a pleural fluid sample from the pleural cavity. It requires that a needle be inserted between the 6th and 8th rib in the midclavicular line, the 8th and 10th rib along the mid-axillary line, or between the 10th and 12th rib along the paravertebral line, and the needle is always inserted superior to the rib to avoid injury to the intercostal neurovascular structures. With the pneumothorax, there are varying amounts of air in the pleural cavity, leading to a range of symptom severity, while with a tension pneumothorax, the air is trapped in the pleural cavity, so presentation is usually more severe. On a chest X-ray with a tension pneumothorax, the trachea is deviated towards the unaffected side. Air evacuation is done by inserting a needle or chest tube in the space between the second and third rib of the affected side at the midclavicular line, or in the fourth or fifth intercostal space at the mid-axillary line, or placing a chest tube. A chest tube is also used to drain fluid, blood, pus, air, or a combination of all of these from the pleural cavity. It's inserted in the fourth or fifth intercostal space in the mid-axillary line. Foreign bodies are usually aspirated into the right main bronchus and lodge into one of its branches. Tumors and abscesses of the lung can be partly or entirely surgically removed, depending on their location. Finally, an apical lung tumor, known as a Pancoast tumor, can cause a variety of clinical conditions, as it can compress on nearby structures, such as the subclavian vessels and brachial plexus, phrenic nerve, recurrent laryngeal nerve, superior vena cava, the brachiocephalic veins, and stellate ganglion.
Now, we all know how important the heart is, but everyone forgets about the mediastinum, which is the area between the two lungs where the heart actually sits. The mediastinum doesn't just house the heart, but many important structures in the thoracic cavity, from the superior thoracic aperture down to the diaphragm. So let's take a closer look at the clinical conditions that can affect the mediastinum and the structures within it. First up, there's widening of the mediastinum, which can be seen on a chest X-ray. Since the mediastinum contains so many structures, each of them can contribute to pathological widening. It can be observed after a trauma that causes laceration or dissection of the great vessels, typically the aorta, which can cause hemorrhaging into the mediastinum. Other times, malignant tumors such as lymphomas can produce massive enlargement of mediastinal lymph nodes and widening of the mediastinum. Another cause of mediastinal widening is heart hypertrophy due to congestive heart failure. Next up, there's the esophagus. The esophagus may have up to 4 normal anatomic constrictions as it descends. However, there are 3 sites of constriction that can occur specifically in the posterior mediastinum caused by 3 structures it meets on its way down. 2 thoracic constrictions, with the first being where the esophagus is crossed by the arch of the aorta, and second where it is crossed by the left main bronchus, and 1 diaphragmatic constriction where it passes through the esophageal hiatus of the diaphragm. The 4th site of constriction occurs in the cervical region before the esophagus enters the mediastinum, where constriction may be caused by the cricopharyngeus muscle. At these locations, there's a slower passage of substances, and this is where foreign objects that are swallowed are most likely to lodge. These narrowings can be seen in chest radiographs of a person who underwent a barium swallow study. These areas are also at risk of stricture after ingesting caustic liquids such as cleaning products, so seriously don't try that at home. Now, even though we try to prevent foreign objects going into our esophagus, one thing we are okay with is the use of transesophageal echocardiography, or TEE for short. TEE is a device which uses ultrasound within the esophagus to show images of the cardiac structures, particularly the left atrium, which makes up the majority of the posterior heart and is directly anterior to the esophagus. In addition to the left atrium, TEE can visualize the atrial septum and mitral valve. TEE allows for assessment of conditions such as atrial enlargement due to mitral stenosis or regurgitation, which is important as severe enough left atrial enlargement can cause external compression on the esophagus leading to dysphagia. Furthermore, the descending aorta lies posterior to the esophagus, so TEE can visualize aortic abnormalities such as dissection or aneurysm. Okay, now a little bit higher up, there are the recurrent laryngeal nerves, which supply all intrinsic muscles of the larynx, except the cricothyroid, which is supplied by the external laryngeal nerve, a branch of the superior laryngeal nerve. Now you might be thinking, what does this have to do with the thorax? Well, procedures in certain thoracic regions, like a mediastinotomy, or a disease in the superior mediastinum, such as esophageal cancers and mediastinal lymph node enlargement, can injure these nerves and affect the voice, leading to hoarseness or even a loss of voice called aphonia. Furthermore, as the left recurrent laryngeal nerve wraps around the arch of the aorta, any dilation of the arch of the aorta can stretch and damage this nerve. Damage to both recurrent laryngeal nerves at the same time would lead to bilateral paralysis of the vocal cords and would require intubation. Now, speaking of the aorta, let's have a look at some variations of the aortic arch. Sometimes there may be a right arch of the aorta, which courses to the right of the trachea instead of its usual course to the left of the trachea. In rare cases, a double arch of the aorta can occur, which forms a ring around the esophagus and trachea, which can compress these structures and potentially result in difficulty with breathing and swallowing. The aorta can also be subject to something called coarctation of the aorta, which is when the aortic arch or thoracic aorta has an abnormal narrowing or stenosis of the aortic lumen. This causes an obstruction of blood flow distal to the stenosis and to the inferior part of the body. The most common site for a coarctation is near the ligamentum arteriosum. If the stenosis is proximal to the ductus arteriosus, also called preductal coarctation, this can cause the ductus arteriosus to remain patent at birth, instead of closing off to become the ligamentum arteriosum, ultimately allowing blood from the pulmonary trunk to bypass the stenosis. When the coarctation is inferior to the ligamentum arteriosum, called postductal coarctation, good collateral circulation develops between the proximal and distal parts of the aorta, through the intercostal and internal thoracic arteries. As the subclavian arteries are proximal to this stenosis, they are not affected, so their internal thoracic artery branch can provide blood to the intercostal arteries, which in turn provide blood to the descending aorta distal to the stenosis. The collateral vessels may become so large that they cause a notable pulsation in the intercostal spaces and erode the adjacent surfaces of the ribs called rib notching, which is visible on a chest X-ray. Other clinical signs may include hypertension in the upper extremities and a weak and delayed pulse in the lower extremities. The aorta is also susceptible to dissection. Aortic dissection happens when there's a tear in the layer of the aorta called the tunica intima, and this results in a false lumen within the aorta. Aortic dissection is associated with things such as hypertension, bicuspid aortic valve, and connective tissue disorders, where individuals may present with sudden onset chest pain radiating to the back and unequal blood pressures between the arms. There are two types of dissection, Stanford type A and Stanford type B. Type A is a dissection that involves any part of the ascending aorta, so think of A for ascending aorta. These typically start at the sinotubular junction and extend to the aortic arch, but can also encompass the descending aorta. Type B refers to all other dissections involving only the descending aorta and originate close to the left subclavian, so think below the subclavians. The aorta can also suffer traumatic lesions, which lead to aortic ruptures. These are most often a result of the rapid deceleration that is frequently associated with car crashes, but can also happen because of a fall from height. The most common site of injury is the aortic isthmus, just distal to the left subclavian artery origin, as this is tethered by the ligamentum arteriosum and is thought to be the transition zone between the mobile ascending aorta and the fixed descending aorta. Unfortunately, over 80% of people die from this before reaching the hospital. And just before we wrap up, let's quickly look at something called subclavian steal phenomenon. With subclavian steal phenomenon, the vertebral artery on the same side as an occluded or blocked subclavian artery steals blood from the contralateral subclavian artery circulation. This happens when the occlusion is proximal to the vertebral artery, so blood from the contralateral vertebral artery flows to the basilar artery and then continues as retrograde flow through the ipsilateral vertebral artery. This allows blood flow to the area supplied by the occluded subclavian vessel, and is often asymptomatic. When subclavian steal becomes symptomatic, however, it is considered subclavian steal syndrome. Symptoms include upper extremity ischemia and neurological symptoms such as dizziness or vertigo. Alright, as a quick recap. A wide mediastinum can be caused by trauma, various malignant tumors or mediastinal enlargements, aortic dissection or rupture, and heart hypertrophy. Foreign bodies or strictures in the esophagus usually occur at the site of the esophagus's impressions, such as where the cricopharyngeus muscle, the aorta and left main bronchus, and the diaphragm leave a mark. Injuries to the recurrent laryngeal nerve lead to hoarseness and aphonia. A transesophageal echocardiography is an ultrasound technique that allows visualization of cardiac structures and the aorta from inside the esophagus. Coarctation of the aorta happens when the aortic arch or thoracic aorta has an abnormal narrowing that diminishes the caliber of the aortic lumen. Aortic dissection occurs when the aortic intimal lining tears, creating a false lumen within the aorta, and it is either type A, mainly involving the ascending aorta, or type B, only involving the descending aorta.
Have you ever wondered what the secret to someone's heart is? That's right, a chest x-ray. Alright, so here at Osmosis, we don't actually have the secret to one's heart, but we do know how to identify the different medical conditions that can affect the heart. Let's start off by identifying the heart borders on a chest x-ray. The heart silhouette is between the lungs, and the right border, made up by the right atrium, as well as the left border, made up by the left ventricle and part of the left auricle, can be clearly seen. Above the left auricle, we can identify the pulmonary artery and the aortic arch. And in some clinical circumstances, the silhouette sign can be present, which is when the normal silhouette of the heart compared to the lungs is lost. More appropriately, you might want to think about it as a loss of the heart silhouette. The loss of the heart silhouette only occurs when the pathological process is in direct anatomical contact with the heart. Usually, the middle lobe is seen close to the right border of the heart, so consolidation in the right middle lobe can also obscure the X-ray silhouette of the right heart border. Alright, now even though the heart is protected by the sternum and the thoracic cage, it's still susceptible to injury. During penetrating trauma, like for example a stab wound, the right ventricle is the most commonly injured structure because of its anterior position in the chest and the fact that it forms the majority of the anterior surface of the heart, followed by the left ventricle, which forms the apex of the heart and may be injured as far laterally as the left midclavicular line at the fifth intercostal space. The atria are less commonly injured than the ventricles. It's also worth noting that the lungs overlap most of the anterior surface of the heart, so many penetrating injuries to the heart will also result in concurrent lung injury, particularly to the parietal pleura. Are you ready to listen to your heart? Because we're now going to talk about heart auscultation. The gist of it is to listen to the areas that best project the sound coming from each heart valve. Blood tends to carry the sounds in the direction of its flow, so each area is situated superficial to the chamber or vessel into which the blood has passed and in a direct line with the valve orifice. Let's start with the aortic valve, which is located posterior to the left of the sternum at the level of the third intercostal space. To auscultate the aortic valve, you need to move your stethoscope to the second intercostal space, right of the sternal angle. Moving on to the pulmonary valve, it's located at the level of the left third costal cartilage and is auscultated at the second intercostal space left to the sternal angle. The tricuspid valve is posterior to the body of the sternum to the right side at the level of the fourth and fifth intercostal space and is auscultated at the fourth or fifth intercostal area left to the sternal edge. The mitral valve is located posterior to the sternum at the level of the fourth costal cartilage to the left and is auscultated at the left fifth intercostal space on the midclavicular line. And now let's talk about conditions that may affect the heart. First, there's dextrocardia, which is a rare embryological folding defect where the heart is reversed, so the apex is misplaced to the right instead of the left. Dextrocardia is associated with mirror image positioning of the great vessels and arch of the aorta. Basically, everything that normally is on the left is on the right and vice versa. This condition might be part of something called situs inversus, which is a general transposition of the thoracic and abdominal viscera, or it occurs as isolated dextrocardia, where the transposition only affects the heart. When dextrocardia is associated with situs inversus, the incidence of other cardiac defects is low, and the heart usually performs normally. However, in isolated dextrocardia, the congenital anomaly is complicated by severe cardiac anomalies, such as transposition of the great arteries. Clinically, dextrocardia can be determined by palpating the apex beat over the right chest. Typically, the apex beat, which is the most lateral inferior palpable portion of the heart on the chest wall, typically found in the 4th or 5th intercostal space at the midclavicular line, is on the right side. An X-ray can then be done to confirm dextrocardia. And while dextrocardia is rare, a myocardial infarction, unfortunately, is not uncommon. That's when an artery of the heart is blocked by an embolus and the myocardium supplied by the occluded vessel no longer receives blood. That area can undergo necrosis, resulting in a myocardial infarction. Symptoms of a myocardial infarction include severe crushing chest pain that can often radiate to the back, jaw, left arm, right arm, shoulder, or atypical chest pain that's felt in the abdomen. Associated symptoms include dyspnea, diaphoresis, which means profuse sweating, as well as nausea and vomiting. The 3 most common sites of coronary artery occlusion are the anterior interventricular branch of the left coronary artery, approximately 40 to 50% of the time, the right coronary artery, approximately 30 to 40% of the time, and the circumflex branch of the left coronary artery, approximately 15 to 20% of the time. Now, dominance of the coronary arterial system also affects what areas of the heart are affected during a myocardial infarction, as dominance determines whether the right or left coronary artery gives off the posterior interventricular branch. Therefore, during an occlusion to the right or left coronary artery, dominance will determine if the area supplied by the posterior interventricular branch will be affected. In 67 to 85% of people, the right coronary artery gives rise to the posterior interventricular branch. In about 8 to 15% of cases, the left coronary artery is dominant, and the posterior interventricular branch comes from the circumflex artery. In 7 to 18% of people, there's codominance, and both right and left coronary arteries give rise to branches that run in or near the posterior interventricular groove. So, if the right coronary artery is occluded, then the right atrium, parts of both ventricles, and the sinoatrial and atrioventricular nodes are affected, along with the area supplied by the posterior interventricular branch, which is the inferior adjacent area of ventricles, and the posterior third of the interventricular septum. If the left coronary artery is occluded, then the left atrium is affected, along with parts of both ventricles, the AV bundle, the anterior 2/3 of the interventricular septum, along with the area supplied by the posterior interventricular artery if it's dominant. Also remember, the right coronary artery supplies the SA node via the SA nodal branch 60% of the time, and the AV node via the AV nodal branch when it has dominance, so the loss of blood supply to these 2 nodes also varies during a myocardial infarction. Following a myocardial infarction, the conducting system of the heart might be damaged. The left coronary artery gives off the anterior interventricular branch, which gives rise to the septal branches that supply the AV bundle in most people. Additionally, the branches of the right coronary artery mainly supply both the sinoatrial and atrioventricular nodes, as we have said before. The occlusion of one of these arteries can lead to a heart block. In this case, the ventricles will begin to contract independently at their own rate, which is approximately 25 to 30 per minute, as they do not receive a signal from the SA or AV nodes, which is slower than their slowest normal rate of 40 to 45 per minute. If the sinoatrial node has been spared, the atria continue to contract at the normal rate, but the impulse generated by the sinoatrial node doesn't reach the ventricles. Damage to either the left or right AV bundle branches leads to a bundle branch block, where excitation passes along the unaffected branch and causes a normal systole of that ventricle only, and the affected ventricle receives conduction via muscle propagation to produce a late asynchronous contraction. Now, individuals with obstruction of their coronary circulation and severe angina might undergo a coronary bypass graft operation. This is when a segment of an artery or vein is connected to the ascending aorta or to the proximal part of a coronary artery, and then to the coronary artery distal to the stenosis. This procedure provides a detour or bypass around the stenotic area or blockage and reestablishes blood flow to the obstructed cardiac muscle. It's preferred to use arterial grafts compared to venous grafts, as patency is higher in arterial grafts, meaning they're more likely to stay open and allow blood flow than venous grafts. Preferred graft choices are the internal thoracic artery, followed by the radial artery. However, in multiple coronary artery disease, the great saphenous vein may need to be harvested as it offers lengthy portions. In some individuals with a myocardial infarction, a percutaneous coronary intervention can be done. This is when a catheter with a small inflatable balloon attached to its tip is placed through the obstructed coronary artery. When the catheter reaches the obstruction, the balloon is inflated and the vessel is stretched to increase the size of the lumen and to improve blood flow. After dilation of the vessel, an intravascular stent can then be introduced to maintain the vessel open. The catheter can be introduced through the femoral or radial artery to reach the heart and the affected vessel. However, there's always the risk of arterial hemorrhage when undergoing these procedures. Now, before we move on, can you recall what are the 3 most common sites of coronary artery occlusion? Another type of heart catheterization is venous catheterization, where a venous catheter enters the heart to measure intracardiac pressures and study circulation of the functioning heart for things such as congenital heart defects or arrhythmogenic foci. The cardiac venous catheter is inserted in the femoral vein and travels into the right atrium through the IVC. In order to access the left side of the heart, the catheter must transverse the interatrial septum at the site of the foramen ovale, which is covered in adults by a thin membrane and can be easily punctured to enter the left atrium. In addition to cardiac venous catheters, there are also cardiac ablation catheters, which we'll talk about shortly. These deliver radiofrequency ablation to parts of the heart to help correct electrical abnormalities such as supraventricular tachycardias. Supraventricular tachycardias often arise from abnormal electrical activity in the AV node, an accessory electrical pathway, or the atria, such as an atrial fibrillation. Generally, these lead to a ventricular heart rate of over 100 beats per minute and can lead to things such as shortness of breath, chest pain, and hemodynamic instability. To fix these electrical abnormalities, we can use cardiac ablation catheterization like we mentioned previously. The cardiac catheter can then be directed to specific structures of the heart such as the right atrium, right ventricle, and pulmonary veins where radiofrequency ablation is done to eliminate these accessory electrical pathways to try and restore normal heart function. One area in the heart where supraventricular tachycardias can occur is the crista terminalis in the right atrium. However, the right phrenic nerve courses along the pericardium over the right atrium and is at risk of injury during right atrial ablation. Damage to the right phrenic nerve would cause paresis on the right side of the diaphragm and can be recognized by elevation of the right hemidiaphragm on X-ray. Now, a subtype of supraventricular tachycardias is atrial fibrillation, which is actually the most common cardiac arrhythmia. Atrial fibrillation is when the normal atrial heart contractions are replaced by rapid, irregular, and uncoordinated contractions in different parts of the atrial wall. These irregular contractions are associated with a major risk of thrombus formation and subsequent systemic thromboembolism, such as a stroke. This occurs because ineffective atrial contraction leads to blood stasis and arterial inflammation. The most common site of thrombus formation is the left atrial appendage, a small sac-like structure of the left atrium. Speaking of the atria, let's see what happens when the left atrium of the heart becomes enlarged, which is often the result of pressure or volume overload. This can result from mitral valve stenosis or regurgitation, as well as left ventricular dysfunction. Now, as the most posterior chamber of the heart, the increasing size of the atrium can compress nearby structures such as the esophagus, leading to difficulty swallowing or dysphagia, or it can compress the left recurrent laryngeal nerve, leading to hoarseness of the voice. Okay, now remember that the heart is contained in a sac called the pericardium? Well, you guessed it, this also has clinical implications. First, the pericardium has a sweet spot called the transverse pericardial sinus, and that's very important for cardiac surgeons. After the pericardial sac is opened anteriorly, a finger can be passed through the transverse pericardial sinus just posterior to the ascending aorta and pulmonary trunk. By passing a surgical clamp or a ligature around these large vessels, inserting the tubes of a coronary bypass machine, and then tightening the ligature, the surgeon can stop or divert the circulation of blood in these arteries during cardiac surgery. Alternatively, the pericardium can be affected when fluid accumulates in the pericardial cavity. When there's too much fluid in the pericardial cavity, it can compress the heart, causing cardiac tamponade. This excess fluid can be removed during a procedure called pericardiocentesis, which is when a wide-bore needle is inserted through the left fifth or sixth intercostal space near the sternum. This approach is possible because the cardiac notch in the left lung and the shallower notch in the left pleural sac leaves part of the pericardial sac exposed. The pericardial sac can also be reached through the infrasternal angle, also called the subcostal angle, formed by the right and left costal margins by passing the needle supero-posteriorly. At this site, the needle avoids the lung and pleura and enters the pericardial cavity. However, there's a risk of puncturing the internal thoracic artery or its terminal branches. Alright, as a quick recap. On a chest x-ray, the heart silhouette is between the lungs and the right border, made up by the right atrium, as well as the left border, made up by the left ventricle and part of the left auricle, can be clearly seen. Dextrocardia is when the heart is positioned on the right side of the body. It can be isolated or it can be associated with situs inversus, where the organs that are supposed to be on the left are on the right, and vice versa. The three most common sites of coronary artery occlusion are the anterior interventricular branch of the left coronary artery, the right coronary artery, and the circumflex of the left coronary artery. A myocardial infarction is when an artery of the heart is blocked by an embolus and the myocardium supplied by the occluded vessel no longer receives blood. A coronary bypass graft operation is when, preferably, a segment of artery is connected to the ascending aorta or to the proximal part of a coronary artery and then to the coronary artery distal to the stenosis. A percutaneous transluminal coronary angioplasty is when a catheter with a small inflatable balloon at its tip is placed through the obstructed coronary artery to reinstall flow in the respective artery. Other types of cardiac catheterization include venous catheterization, which measures pressures in the heart and arrhythmia foci, and ablation catheterization to correct abnormal cardiac pathways. Atrial fibrillation is a common cardiac arrhythmia which may lead to left atrial appendage thrombus formation. Pericardiocentesis can be done by inserting a needle through the left fifth or sixth intercostal space near the sternum, or by inserting the needle through the infrasternal angle.
The breasts, formerly known as the mammary glands, are situated in the subcutaneous tissue overlying our pectoralis muscles. There are many conditions that can affect the breast, the most well-known being breast cancer. Breast cancer, as well as other conditions that can affect the breast, can often go unnoticed, which has serious clinical consequences, so it is important to understand and recognize these conditions as early as possible. So let's start with breast cancer, which causes changes to the structure and appearance of the breasts. One of the classic changes is the presentation of a palpable breast mass, which is typically a hard, immobile lesion with irregular borders, most commonly found in the upper outer quadrants. Another indication of more advanced disease are skin changes, specifically the orange peel appearance, also called the peau d'orange sign, which happens when there's prominent edema and dimpling of the overlying skin. Larger dimpling of the skin can result from cancerous invasion of the glandular tissue and fibrosis, which may also pull on the suspensory ligaments of the breast and can cause retraction of the nipple. If the cancer interferes with the lymphatic drainage, this can lead to lymphedema, which is when there's excess fluid in the subcutaneous tissue. This, in turn, results in deviation of the nipple and the skin appears thickened and leather-like. Cancer cells can spread through contiguity, which is when the adjacent tissue is invaded. When breast cancer cells invade the retromammary space or the pectoral fascia, or when they metastasize to the interpectoral nodes, the breast elevates when the muscle contracts, and this usually signals advanced cancer. Furthermore, the local cancerous invasion to the pectoral fascia and pectoralis major muscle below may result in deep fixation of the breast tissue. Breast cancer usually spreads through lymphatic vessels, which basically carry cancer cells from the breast to the lymph nodes, especially those in the axilla. Communications among lymphatic pathways and among axillary, cervical, and peristernal nodes can cause metastases from the breast to develop in the supraclavicular lymph nodes, in the opposite breast, or in the abdomen, but the most common site of metastasis of breast cancer remains the axillary lymph nodes. Cancer cells can also spread from the breast through venous routes. For example, the posterior intercostal veins drain into the azygous system of veins alongside the bodies of the vertebrae. As a consequence, cancer cells can spread to the vertebrae and from there to the cranium and brain. Breast cancer mainly affects biological females, and it is the most commonly diagnosed malignancy in women in the United States. However, up to 1.5% of cases occur in biological males. In males, the cancer also usually metastasizes to the axillary lymph nodes in addition to bone, pleura, lung, liver, and skin. In male individuals, a visible or palpable subareolar mass or secretion from a nipple can suggest breast cancer. In males, breast cancer tends to infiltrate the pectoral fascia, pectoralis major muscle, and apical lymph nodes in the axilla. Unfortunately, it frequently goes undetected until there are already metastases. A less worrisome breast clinical condition is polymastia or supernumerary breasts. They are smaller than the usual breasts and consist of only a rudimentary nipple and areola, which can be mistaken for a mole until they change their color during pregnancy. They might even have glandular tissue that can develop during lactation. Supernumerary breasts can appear anywhere along a line that extends from the axilla to the groin. That's because this is the location of the embryonic mammary crest from which the breasts develop and along which breasts develop in animals with multiple breasts, such as female dogs. Now, amastia is when there's no breast development or when nipples and areolas are present but there's no glandular tissue. And finally, polythelia is when accessory nipples are present, just like Chandler Bing's third nipple. Last subject on the breast is gynecomastia, which is a benign proliferation of the breast tissue in biological males, and it is typically caused by an imbalance between estrogenic and androgenic hormones. It is age-dependent, and it most frequently affects males going through puberty, in which case it resolves spontaneously. Less frequently, it affects older males, and it can be caused by liver cirrhosis or testicular cancer, medications like spironolactone, cimetidine, and ketoconazole, among others, and other conditions such as Klinefelter syndrome. Okay, as a quick recap, breast cancer can change the appearance of the breast. Signs include a palpable irregular mass, peau d'orange, retraction of the nipple, lymphedema, and a leather-like appearance. It mainly affects females, though up to 1.5% of cases occur in males. Polymastia is a condition where an individual has an additional, smaller than usual breast consisting of only a rudimentary nipple and areola. Amastia is when there is no breast development, and polythelia is an accessory nipple. Finally, gynecomastia is when breast tissue becomes visibly enlarged in males, and it can happen because of drugs like spironolactone or conditions such as liver cirrhosis or testicular cancer.
The pelvis lies between the abdomen and the lower limbs, forming the lower part of the trunk. It supports and contains organs of the gastrointestinal system, the urinary system, and the reproductive system. Furthermore, the structure and contents of the pelvis differs between biological male and biological female individuals. For biological males, there are many clinical conditions that can affect the pelvis and the perineum, and we mean more than just the ones that will make you famous on YouTube or get you on America's Funniest Home Videos. The pelvis is formed by the ilium, ischium, pubis, and sacrum, forming a ring of bones called the pelvic ring. Pelvic bones, like any other bone in the body, are susceptible to injury and subsequent fracture. Fractures of the pelvis usually occur following severe trauma, and this can happen through a variety of mechanisms. Fractures can occur in isolation, but since the pelvis is shaped like a bony ring, they tend to occur in 2 or more areas simultaneously, which means they're unstable fractures. Think of trying to break a pretzel at only one point. Direct trauma, for example a car crash, may fracture susceptible areas such as the pubic rami, the acetabulum, the sacroiliac joints, and the ala of the ilium. Other mechanisms of injury include falling directly on one of the lower limbs, which can force the head of the femur into the pelvic cavity through the acetabulum. These different injuries can damage pelvic structures such as vessels, nerves, and viscera, resulting in a variety of clinical manifestations. One classic example is called an open book fracture, where there is pelvic ring disruption due to anterior widening, typically at the pubic symphysis. Fracture of the medial portion of the pubic rami can lead to injury of the urinary bladder and urethra, as well as sensory damage to the anterior and medial thigh, and motor weakness to the muscles supplied by the femoral nerve. Generally, pelvic fractures cause pain that increases with movement and mobility, as well as swelling and bruising at the area of impact. In more severe cases, pelvic fractures can cause damage to vascular structures and organs of the pelvis, which can lead to life-threatening hemorrhage that fills the expanded pelvis and extends into the retroperitoneum. In patients with life-threatening hemorrhage and hemodynamic instability, quick stabilization with a pelvic binder is done. This is a device that compresses the pelvis along with the hemorrhaging vessels, therefore controlling the bleeding. Surgery may be done, which aims to stabilize and reduce the fracture. Alright, now let's switch gears and talk about the prostate gland, which is a small gland about the size of a walnut, which is positioned inferior to the bladder and anterior to the rectum. One of the most common conditions affecting the prostate is benign prostatic hyperplasia, or BPH for short. This condition occurs due to the hyperplasia or proliferation of the prostatic tissue within the prostatic transitional zone. This condition can begin to affect males as early as age 40 and can affect up to 60% of males at age 60 and over 80% of males at age 80. BPH can be asymptomatic. However, it can also compress the prostatic urethra, causing symptoms such as nocturia, which is the need to void throughout the night, frequency, which is peeing more often, typically in smaller volumes, incontinence, which is the inability to voluntarily urinate, dysuria, which is difficulty or pain during urination, and urgency, which is the sudden need to void. Patients typically report that they have a slow urinary stream, they strain when trying to void, or they have dribbling of urine. This can all lead to an increased risk of urinary tract infections, bladder distension, and renal injuries. BPH is often diagnosed clinically with a digital rectal examination, or DRE. Here, a finger is inserted into the rectal orifice where it is directed anteriorly to feel the prostate through the anterior wall of the rectum, which is in contact with the posterior surface of the prostate. In benign prostatic hyperplasia, the DRE findings may be normal. However, the prostate can be enlarged, where it will have a homogeneously smooth and soft consistency. This is in contrast to adenocarcinoma of the prostate, where a DRE would reveal a hard, irregular consistency of the prostate. However, it's worth noting that a definitive diagnosis of either BPH or prostate adenocarcinoma requires a prostatic biopsy, and only histological and pathological examination can distinguish benign disease from malignant disease. Now, there are also some clinical differences between the two. BPH typically affects the transitional zone and compresses the prostatic urethra, so it causes symptoms earlier than adenocarcinoma. Prostatic adenocarcinoma, on the other hand, typically affects the posterior lobe or peripheral zone of the prostate, So patients experience urinary symptoms much later, and they'll often present with more advanced disease progression and metastases, most often to lymph nodes, liver, lungs, brain, and bone. Metastases mainly occur in the internal iliac and sacral lymph nodes, which drain the prostate. Metastasis to the skeletal system occurs because the prostatic venous plexus directly communicates with the vertebral venous plexus, which also has valveless communication with the cerebral circulation, allowing metastasis to the vertebrae and brain. Treatment of BPH aims at relieving the obstruction and allowing the urine to flow normally. This can be done by using 5-alpha reductase inhibitor medications such as finasteride, which inhibits the action of androgens on the prostate by preventing conversion of testosterone to dihydrotestosterone, trying to limit prostate enlargement. Alpha-adrenergic blockers such as tamsulosin can also be used, which relax the smooth muscle in the prostate and bladder neck to alleviate the symptoms. Additionally, a transurethral resection of the prostate, or TURP, may be done, where transurethral means, well, through the urethra. During a TURP, an instrument called a cystoscope is inserted through the tip of the penis and into the urethra to access the prostate gland. Then, the enlarged part or even the entire prostate can be removed. Following TURP, or instead of it, a prostatectomy can also be performed, which is the surgical removal of the prostate or part of it. There are two types of prostatectomy. A simple prostatectomy refers to the removal of prostate tissue within its capsule through methods such as open surgery, laparoscopic surgery, or even robotic surgery, where a transurethral approach is difficult and is often reserved for BPH. On the other hand, a radical prostatectomy is the removal of the entire prostate gland, seminal vesicles, ejaculatory ducts, terminal ductus deferens, and potentially the surrounding lymph nodes. This is typically done to treat more invasive disease like prostate adenocarcinoma. In a prostatectomy, potential injury to the internal urethral sphincter can occur, and this results in urinary incontinence. Additionally, within the prostatic fascia, there's the prostatic nerve plexus, which originates from the inferior hypogastric plexus, which receives parasympathetic innervation from the S2 through S4 nerve roots. This prostatic plexus may become damaged during surgery, and this is important as it gives rise to the cavernous nerves, which carry postsynaptic parasympathetic nerve fibers innervating the corpora cavernosa, which are responsible for maintaining an erection. To remember this, think of the phrase S2-3-4 keeps the penis off the floor. So, damage to the prostatic nerve plexus can result in erectile dysfunction, which is the inability to get or maintain an erection. Remember that an erection happens when the parasympathetic nerve fibers are stimulated, which causes the cavernosal spaces to expand and fill with blood. Then, the corpora cavernosa grow in size, and the penis maintains an erection. Ejaculation, on the other hand, and prevention of retrograde ejaculation is governed by sympathetic innervation, which comes from the T11 through L2 nerve roots and travels with the abdominopelvic splanchnic and hypogastric nerves. Finally, the expulsion of sperm is assisted by somatic nerves, specifically the pudendal nerve. A good memory trick is the phrase point and shoot, where the P in point stands for parasympathetic and is responsible for erection, and the S in shoot stands for sympathetic and somatic, which is responsible for ejaculation. Besides injury to the cavernous nerves, other causes for erectile dysfunction include psychological and pathological causes. Psychological causes include stress, performance anxiety, and depression. Cardiovascular diseases such as atherosclerosis may decrease the blood supply to the penis, resulting in erectile dysfunction. Finally, endocrine disorders such as hypogonadism, which causes low testosterone levels, can also cause erectile dysfunction. Okay, now let's take a deep breath and have a quick quiz. Can you name this condition in the prostate? Okay, now this condition may be diagnosed with this clinical exam. Can you recall its name? Okay, now let's switch gears and look at how the anatomy of the male reproductive organs can impact reproduction. Remember that the testes produce sperm cells, technically called spermatozoa, which are stored for maturation in the epididymis. Then, the sperm cells are transported through a series of ducts which eventually continue as the ductus deferens before traveling through the urethra during ejaculation. In males who no longer want to reproduce, a procedure called a deferentectomy can be done, most commonly known as a vasectomy. Here, part of the ductus deferens is manually felt in the superior part of the scrotum, where local anesthetic is placed and a small incision is put into the superior part of the scrotum. The ductus deferens is then located, and it is either ligated or excised. Following a vasectomy, the male can still ejaculate, but the semen contains no sperm. But where does the sperm go? The sperm eventually degenerates in the epididymis and the proximal part of the ductus deferens. And of note, vasectomy does allow for second chances, as the procedure can be reversed and the section ductus deferens can potentially be reattached. Alright, now let's switch gears and talk about the urethra, which is anatomically different between biological males and females. In females, the urethra is only about 4 centimeters long, and it's also straighter and more elastic. In males, the urethra is longer, measuring roughly between 18 and 22 centimeters, curved and less elastic. Due to the urethral length, along with a drier periurethral environment in males, they are less prone than females to microbial contamination and subsequent urinary tract infection. Understanding the anatomy of the male urethra can also come in handy when it comes to transurethral catheterization. This is when a soft, hollow tube is passed through the urethra and into the bladder to drain urine in an individual who can't urinate. When using a catheter, the curves of the male urethra need to be considered. The male urethra has 4 parts. Starting proximally from the bladder, there is an intramural or preprostatic part, a prostatic part, and an intermediate or membranous part, and lastly, the spongy part. Okay, now incorrect placement of the catheter during a urethral catheterization can damage and potentially rupture any part of the urethra, usually the membranous part, which is not as well protected. The membranous part of the urethra travels anterior-inferiorly as it passes the external urethral sphincter. So, increased force may be needed to account for this curvature when inserting the catheter in order to get into the bladder. Increased force may also be needed during male catheterization when there is an enlargement of the prostate or potential urethral strictures. But care should be taken not to apply too much force, as it can result in urethral injury. So you see, the shorter female urethra, along with the lack of prostate, makes urethral catheterization often easier in these individuals. Now, in males, there are 2 other types of urethral injuries which are a result of pelvic trauma. Posterior urethral injuries can be the result of pelvic fracture and occur proximal to the bulb of the penis at the membranous urethra, as we said before, or the prostatic urethra. This results in urine or blood passing into the deep perineal pouch, and the fluid may pass superiorly through the urogenital hiatus to surround the prostate and the urinary bladder. Anterior urethral injuries typically occur with straddle injuries, such as trauma from a bike seat, and are located within the spongy urethra. Here, blood or urine instead escapes into the superficial perineal pouch. Fluid then may pass inferiorly into the scrotum or the penis, or superiorly into the inferior part of the anterior abdominal wall, deep to the membranous layer of the subcutaneous connective tissue. Typically, urethral injuries cause inability to void or painful voiding. Additionally, there may be bleeding at the external urethral meatus, as well as a high-riding boggy prostate during digital rectal examination when a hematoma develops below it. Now, if an urethral injury is suspected, urethral catheterization is contraindicated because the catheter may pass through the ruptured part of the urethra, worsening the injury. Other contraindications for transurethral catheterization include urethral obstruction, bladder neck masses, severe benign prostatic hyperplasia, and prostate cancer. In these cases, suprapubic cystostomy may be done, in which a catheter is introduced through the anterior abdominal wall and into the bladder. Just a quick note here. The superior border of an empty bladder is at the same level as the superior border of the symphysis pubis. So when trying to place a suprapubic cystostomy with an empty bladder, there is a very high risk of puncturing the peritoneal cavity. But as the bladder fills with urine, it pushes the parietal peritoneum out of the way and puts the filled bladder directly against the anterior abdominal wall, which makes it easy to puncture without going into the peritoneal cavity. Okay, now let's take a deep breath and have a quick quiz. Can you name this procedure? How about this other procedure? Alright, now let's take a closer look at the penis, which is made of 3 long cylindrical bodies: the corpus spongiosum, surrounding the penile urethra, and the 2 corpora cavernosa, made of erectile tissue. The corpora cavernosa are wrapped in a fibrous coat called the tunica albuginea, and each corpus cavernosum is made up of blood-filled spaces called the cavernosal spaces. The penis receives both somatic and autonomic innervation through the cavernous nerves, which innervate both the corpus spongiosum and the corpora cavernosa. Now, males have a bit of skin covering the head of the penis, and this is called the foreskin or prepuce. This prepuce protects the head of the penis and acts as a natural lubricant. Typically, the prepuce is elastic and can be easily retracted over the head of the penis. Some males are born with a prepuce that fits tightly over the glands of the penis, making it difficult to retract, and that's called phimosis. This causes the oily secretions from the sebaceous gland of the prepuce to accumulate in the preputial sac, which is a space between the head of the penis and the prepuce. These oily secretions have a cheesy consistency, and they're referred to as smegma. When these secretions build up, they can irritate the skin covering the penis. Now, in some males, retracting the prepuce over the head of the penis constricts the neck of the glans penis, which causes blood and fluid to accumulate in the glans penis. This decreases the blood supply to the tip of the penis and causes it to swell up. This swelling prevents the prepuce to be drawn over the head of the penis, forming a condition called paraphimosis. Treatment of phimosis and paraphimosis can be done by circumcision, a surgical procedure that removes the prepuce and exposes the head of the penis. Circumcision is also done as a religious practice in Islam and Judaism, but some individuals also choose to do it for non-religious reasons. Now let's look at penile fractures, which are urological emergencies that result from blunt trauma to an erect penis. Onset of this injury usually starts with individuals hearing a snapping sound, followed by significant pain, swelling, immediate loss of erection, and penile shaft hematoma. Surgery is the mainstay of treatment in penile fractures, in which stitches are used to close the tear in the tunica albuginea and corpus cavernosum. A retrograde urethroplasty can also be performed to assess for concomitant urethral injury. And finally, just a few words on malignant tumors of the scrotum and testes. These tumors usually spread through the lymphatic system. Remember that the testes start developing in the abdomen and descend in the scrotum during the last months of intrauterine life. So metastatic disease from the testes usually spreads to the para-aortic or retroperitoneal lymph nodes, and from here can spread and metastasize through the blood to the lungs, liver, brain, and bone. Next is the scrotum, which is an extension of the anterolateral abdominal wall. In scrotal cancer, tumor cells usually pass to the superficial inguinal lymph nodes, which lie just inferior to the inguinal ligament, and from here, they drain into the deep inguinal lymph nodes. Pelvic lymph nodes form a very complex network whose interconnections allow cancerous cells to spread in any direction, which makes it difficult to guess the specific route of cancer metastasis. Alright, as a quick recap, pelvic fractures usually happen during high-energy traumas such as car crashes or falling from height, and this can injure pelvic neurovascular structures and organs. Benign prostatic hyperplasia typically affects the transitional zone, and this growth may obstruct the prostatic urethra, causing nocturia, dysuria, and urgency. Treatment is usually done with TURP. Prostatic adenocarcinoma typically affects the posterior lobe or peripheral zone, and usually metastasizes to lymph nodes, liver, lungs, brain, and bone. On DRE examination, BPH can cause the prostate to have a smooth, homogeneous, soft consistency, while adenocarcinoma may have a hard, irregular consistency. Sometimes a prostatectomy can be performed, which is when parts of the prostate, all of the prostate, or the prostate and surrounding structures may be removed to treat prostatic disease, such as benign prostatic hyperplasia and adenocarcinoma. Now, male sterilization is done in a procedure called deferentectomy, famously known as vasectomy, where the ductus deferens is ligated or excised, preventing sperm cells from being expelled. Urethral catheterization describes sliding a soft, hollow tube through the urethra and into the bladder to drain urine in individuals who have difficulty voiding. Urethral catheterization and pelvic fractures can cause anterior or posterior urethral injury, making urine and blood pass into the surrounding tissues. If urethral injury is suspected, urethral catheterization is contraindicated to prevent further complications. A good alternative to urethral catheterization is suprapubic cystostomy, which is the insertion of a catheter through the anterior abdominal wall and into the bladder. Now, some males are born with a prepuce that is firmly attached to the head of the penis, making it difficult to retract, and that's called phimosis. Paraphimosis, on the other hand, describes the swelling of the glans penis that prevents withdrawing the prepuce over the head of the penis. Treating phimosis and paraphimosis is done by circumcision, which is a surgical procedure that removes the prepuce and exposes the head of the penis. Blunt trauma to an erect penis can result in penile fracture. Erectile dysfunction is the inability to get or maintain an erection. Causes can be psychological, but also include cardiovascular or endocrine disease. Erection is controlled by parasympathetic innervation, where ejaculation is controlled by sympathetic and somatic innervation. Testicular cancer cells usually metastasize to para-aortic lymph nodes and can further metastasize to lung, liver, brain, and bone. Scrotal cancer usually metastasizes to the superficial inguinal lymph nodes. The pelvis lies between the abdomen and the lower limbs, forming the lower part of the trunk. It supports and contains organs of the gastrointestinal system, the urinary system, and the reproductive system. Furthermore, the structure and contents of the pelvis differs between biological male and biological female individuals. These anatomic differences are important to understand as they have large clinical implications in biological females for things such as fertility and childbirth. So, why don't we make like a baby and dive into the clinical correlates of the female pelvis and perineum head first? Speaking of babies, as cute and adorable as they are, pregnancy and childbirth can lead to a number of complications, such as the risk of perineal or pelvic floor injury. The pelvic floor holds the pelvic organs in a stable position, and during childbirth, the pelvic floor makes every effort to support the fetal head. During delivery, the fetal head stretches the pelvic floor, frequently resulting in injury to the perineum, levator ani, and ligaments of the pelvic viscera. Specifically, injury to the pubococcygeus and puborectalis muscles of the levator ani often occur. These muscles surround and support the urethra, vagina, and anal canal. So injury to these muscles can lead to decreased support for the vagina, bladder, uterus, or rectum. Another important structure that can be damaged is the perineal body, which is the fibromuscular center point of the perineum that serves as an attachment point for structures such as the muscles of the levator ani, fibers from the external urethral sphincter and urethrovaginal sphincter, and the external anal sphincter. Damage to the pelvic floor or perineal body can lead to urethral hypermobility and stress urinary incontinence, which is when drops of urine come out when intra-abdominal pressure increases. Unfortunately, this can occur with coughing, lifting, laughing, and constipation. Also, if the injury to the pelvic floor is severe enough, a pelvic organ may lose its support and herniate into the vagina, called pelvic organ prolapse. Examples of this would be prolapse of the bladder into the anterior vaginal wall, the rectum into the posterior vaginal wall, or the uterus through the vaginal orifice. Childbirth can also cause damage to the pudendal nerve, which can be stretched and damaged along its course near the ischial spine, especially during prolonged labor when there's pressure on the pelvic floor for a longer period of time. The pudendal nerve provides motor and sensory innervation to the perineal region. so damage to it can cause weakness in the perineal muscles. This can lead to inability to control bowel movements, leading to fecal incontinence. Individuals may also experience urinary incontinence, as well as perineal pain and sexual dysfunction. Now, trying to prevent injury to the pelvic floor or management of stress urinary incontinence can be done through Kegel exercises, which aim to strengthen the pelvic floor muscles by contracting and relaxing the levator ani muscles a few times each day, which is similar to the contraction when trying to stop peeing midstream. Regularly performing these exercises lowers the risk of them getting injured during childbirth, which lowers the risk of having a stress incontinence. On the other hand, sometimes an episiotomy can be performed during childbirth. This is an intentional incision of the female perineum and the posterior vaginal wall. This incision enlarges the opening for the baby to pass through, so it reduces the risk of severe perineal lacerations and helps accelerate delivery during the second stage of labor. Episiotomy is done in cases of fetal distress and a large baby that is stuck and can't get out. There are two main ways to perform an episiotomy. First is median episiotomy, which runs from the posterior vaginal wall to the perineal body and tries to spare the external anal sphincter and rectal muscles. This type of episiotomy is done because it's thought that the fibrous tissue that develops during healing is similar to that of the already tendinous perineal body. However, even though care should be taken not to injure the perineal body, median episiotomy can cause damage to the perineal body. Next is mediolateral episiotomy, which runs at 45 degrees from the middle of the vaginal opening to the buttocks. This type has much lower risk of injuring the anal muscles, but it can potentially cause more pain, more bleeding, and a more difficult repair. Now, childbirth can be painful, but for those soon-to-be mothers, don't worry, because there are different anesthetic techniques which can be used for pain control. These techniques include general and regional anesthesia. General anesthesia makes the mother become unconscious and is often used during emergency procedures, as it completely eliminates the pain and discomfort of delivery. Here, both the mother and the baby are continuously monitored, and childbirth happens passively. Next is regional anesthesia, which is used for mothers who wish to participate in the delivery but don't want to experience the pain. There are three types of regional anesthesia: spinal anesthesia, epidural block, and pudendal nerve block. With spinal anesthesia, the anesthetic agent is introduced with a needle into the subarachnoid space at the L3 to L4 vertebral level, and anesthesia usually occurs within 1 minute. The spinal anesthesia produces a temporary anesthesia below the waist, so individuals can't feel pain in the perineum, pelvic floor and birth canal, or the sensation of uterine contractions and the motor and sensory functions of the entire lower limbs. This means that the mother is conscious, but they depend on electronic monitoring of uterine contractions to coordinate pushing. However, bear in mind that with extended labor or inadequate anesthesia, it's almost impossible to re-administer the spinal anesthesia. Furthermore, the anesthetic agent ascends proximally and circulates into the cerebral subarachnoid space in the cranial cavity when the individual lies flat. So the most common side effect of this type of anesthesia is a severe headache. Patients may also experience a decrease in blood pressure during administration of the anesthesia, as well as pain around the injection site. Next is the epidural block, which uses a catheter to inject an anesthetic agent into the epidural space within the vertebral canal, and does not pierce the dura or subarachnoid mater to enter the subarachnoid space like the spinal anesthetic. Similar to the spinal anesthetic, this method affects all the nerves below the level of administration, especially trying to target the S2 through S4 nerve roots. This causes anesthesia of the superior vagina and the uterine cervix, as well as the structure supplied by the pudendal nerve, which include the entire birth canal, the pelvic floor, and the majority of the perineum. Epidural anesthesia can be titrated based on delivery, but is typically not as potent as spinal anesthesia, so the individual can often still feel and move their legs. Now, the body of the uterus lies above the pelvic pain line, so visceral pain from the uterine body will travel with sympathetic fibers to the spinal cord at the level of T10 to L1, where epidural anesthesia is usually given at the L2 to L4 level. But since the epidural space is a continuous space along the length of the vertebral canal, the anesthetic agent can travel superiorly and often blocks those sympathetic pathways at the T10 to L1 level, which is great for blocking all of the relevant pain pathways in labor. Furthermore, an epidural block when done correctly doesn't cause a headache as the spinal and epidural spaces are not continuous. However, headache may be a potential side effect if the needle is inserted too far and penetrates the dura. Epidural anesthetic must be administered in advance of delivery as it takes time to become effective. Finally, we have the pudendal nerve block, which is used when a woman has progressed too far into labor and is unable to receive an epidural. Here, a needle is used to inject the anesthetic agent into the tissues that surround the pudendal nerve. This is done by palpating the ischial spines intravaginally and injecting the anesthetic intravaginally through the sacrospinous ligament medial to the ischial spine. This anesthetizes the area supplied by the pudendal nerve, which includes some of the areas supplied by dermatomes S2 through S4 and the lower quarter of the vagina. This helps in the second stage of labor or when the baby is descending through the birth canal. Now, the upper part of the vagina, the uterine cervix, and the uterine body are not anesthetized, so the mother still feels uterine contractions during delivery. Complications include incidental injection or injury to the pudendal artery and vein, which run in close proximity to the nerve, causing a hematoma. Okay, now let's take a deep breath and have a quick quiz. Can you name each of these types of regional anesthesia? That's right. The first area is where spinal anesthesia and epidural blocks can be administered. Both spinal and epidural anesthesia will block everything inferiorly, where spinal anesthesia works quicker and is typically more potent. Yep, next is the pudendal nerve block. Note how the anesthetic agent is pushed into the tissues surrounding the pudendal nerve. Alright, now some bleeding is normal after delivery. However, when there's more bleeding than expected, this is called postpartum hemorrhage, or PPH for short. Postpartum hemorrhage is defined as losing more than 500 milliliters of blood in a vaginal delivery, or more than 1,000 milliliters in a cesarean section. There are two types of postpartum hemorrhage: primary PPH, which happens in the first 24 hours of delivery, and secondary PPH, which happens after the first day up to 6 weeks after delivery. The main causes of postpartum hemorrhage can be remembered using the 4 T's: lack of uterine tone, trauma such as lacerations or uterine damage, thrombin, which refers to issues with coagulation, and tissue, which refers to retained products of conception. Okay, postpartum hemorrhage is mainly caused by uterine atony, which is loss of uterine tone, one of our 4 T's, and happens when the muscles of the uterus fail to contract after delivery. This contraction is necessary to clamp the blood vessels shut where the placenta was attached, preventing bleeding. Other causes of postpartum hemorrhage include trauma to the birth canal, retention of the placenta, and bleeding disorders. Treatment of postpartum hemorrhage involves giving fluids, stopping the bleeding, as well as identifying and stopping the cause of the bleeding. Treatment starts with giving fluids, which replaces lost blood, while properly examining and repairing any visible lacerations to the birth canal. If bleeding persists, manual massage of the uterus is tried, which stimulates muscles of the uterus to contract. If this does not control the bleeding, medications that stimulate muscles of the uterus to contract, such as oxytocin, may be used. Other medications, such as ergot alkaloids and tranexamic acid, may also be used. Then, if these options fail to stop the bleeding, surgery is indicated. The uterus is supplied by branches of the internal iliac arteries, namely the uterine arteries, so bilateral ligation of the uterine arteries or the internal iliac arteries is done to stop hemorrhaging. If the internal iliacs are ligated, the uterus still has a blood supply due to collateral blood flow from the ovarian arteries. Finally, if bleeding cannot be controlled, a hysterectomy may be done. Simply put, a hysterectomy describes the removal of the uterus vaginally, laparoscopically, or abdominally. Conditions that may require hysterectomy, in addition to postpartum hemorrhage, include uterine fibroids, endometriosis, adenomyosis, prolapse, and cancers of the reproductive organs. There are different types of hysterectomy which can be used, depending on the type of disease and patient factors. First is a radical hysterectomy, which is the removal of the uterus with the surrounding perimetrium, including the round, broad, cardinal, and uterosacral ligaments, the cervix, and the upper 1/3 to 1/2 of the vagina. Next is a total hysterectomy, which is the removal of the entire uterus and the cervix. Finally is a partial or supracervical hysterectomy, which is the removal of the uterus sparing the cervix. Alright, now surgical intervention of the uterus and its surrounding structures, such as a hysterectomy, carries a risk of injuring the ureters. This is due to the course of the ureters as they enter the pelvis towards the bladder. Once past the pelvic brim, they cross anterior to the bifurcation of the common iliac arteries, and descend posterior to the ovarian arteries, then traveling posterior to the uterine vessels near the anterolateral surface of the internal cervical os. This puts the ureters at risk of getting ligated, clamped, or transected during a hysterectomy when the uterine vessels are ligated. A good way to remember this relationship is the phrase, bridge over troubled water, where the troubled water is the filtered urine we think about going through our ureters, and the bridge is the uterine vessels. Furthermore, the ureters can also be damaged during an oophorectomy from ligation of the ovarian arteries during removal of the ovaries. Alright, let's talk about the obturator nerve, which arises from the L2 through L4 lumbar spinal nerves. It travels posteromedial to the iliopsoas muscle and passes through a small opening in the obturator membrane called the obturator canal. These branches enter the thigh and branch into an anterior and posterior division to supply the adductor muscles and overlying skin of the medial thigh. Injury to the obturator nerve can occur during trauma, childbirth, and pelvic surgery, such as bladder cancer removal. This can lead to weakness of thigh adduction and loss of sensation on the medial thigh. Okay, now let's take a deep breath and see if you can label these important structures. Now let's look at a condition called ectopic pregnancy, which has the potential to cause a medical emergency. An ectopic pregnancy is when the fertilized ovum implants in a place other than the uterus. The most common place an ectopic pregnancy can occur is the ampulla of the fallopian tubes. However, implantation can also occur in the fimbria, infundibulum, fallopian tube isthmus, or abdomen. This can result in rupture of the fallopian tube and severe hemorrhage into the peritoneal cavity, causing peritonitis. Clinical features of an ectopic pregnancy include severe abdominal pain, amenorrhea, and vaginal bleeding, and diagnosis is confirmed with ultrasound. It is important to note that the appendix lies close to the right ovary and fallopian tube, which explains why right-sided ruptured ectopic pregnancies can be misdiagnosed as acute appendicitis. Alright, now let's move on to fistulas, which are defined as an abnormal connection between two body parts, and can often occur between the different organs of the pelvis. Fistulas can occur between the vagina and the surrounding organs such as the bladder, urethra, and rectum. They are typically caused by an injury or prolonged inflammatory process, weakening the walls of these organs, causing fistulas to form. Now, fistula formation between the bladder and the vagina is called a vesicovaginal fistula, and between the urethra and the vagina, it's called a urethrovaginal fistula. These can occur during labor, where weakness or tears in the vaginal wall may occur along the bladder and urethra. These two fistulas can result in urine entering the vagina, potentially leading to pain or infection in the genital area, as well as abdominal pain and pain during intercourse. Another type of fistula is between the rectum and the vagina, called a rectovaginal fistula. Rectovaginal fistulas can also result from childbirth and pelvic surgery, as well as inflammatory bowel diseases such as Crohn's disease. This can lead to patients presenting with gas and fecal matter passing through the vagina, and may also result in pain and infection. Alright, now let's talk about ovarian or adnexal torsion. The ovaries are held in place by the suspensory ligament of the ovary, also called the infundibulopelvic ligament. Traveling through this ligament is the ovarian artery, vein, and nerve plexus, which go on to innervate the ovary. Ovarian torsion occurs when the ovaries twist around the suspensory ligament of the ovary, which holds it in place, in addition to twisting around the ovarian ligament as well. When the blood supply to the ovary is completely occluded, the ovary becomes edematous and ischemic, leading to necrosis and bleeding, which can cause sudden severe unilateral pelvic pain and nausea, and may also induce vomiting and fever. Typically, ovarian torsions happen when the ovaries are larger than normal, which may be caused by an ovarian mass, such as a cyst or a tumor, or by fertility treatments, which aim to induce ovulation. Also, being pregnant increases the risk of ovarian torsion. Complications of ovarian torsion include infection, bleeding, and infertility. Now let's wrap up these correlations by discussing the greater vestibular or Bartholin's glands, which are two P-shaped glands that lie on each side of the vaginal vestibule, posterolateral to the vaginal orifice. These glands secrete mucus to lubricate the vagina during sexual arousal through ducts that open into each vestibule of the vaginal orifice. Now, the ducts of these glands may become blocked, which causes mucus to build up inside the gland, forming a Bartholin gland cyst. This cyst causes the gland to swell up, which makes it visible and palpable near the vaginal opening. The accumulated mucus may cause infection of the Bartholin's glands, resulting in an abscess, which can lead to pain around the vaginal opening, pain during intercourse, discomfort while walking, as well as fever. Okay, now let's take one last quiz before doing a recap. Here are the two common fistulas that may happen in the female pelvis. Can you name each of these types? Alright, as a quick recap, injuries to the structures of the pelvic floor, such as the levator ani and perineal body during delivery, may cause stress urinary incontinence and pelvic organ prolapse. Childbirth can also cause pudendal nerve injury, leading to loss of motor and sensory function of the perineal region. An episiotomy can be done to help prevent severe perineal lacerations and assist delivery during fetal distress. The pain and discomfort of delivery may be reduced using anesthetic techniques. These include general anesthesia, spinal anesthesia, epidural block, and pudendal nerve block. A common complication of childbirth is postpartum hemorrhage, which is an abnormal increased bleeding after delivery and is typically caused by uterine atony. A hysterectomy is a surgical removal of the uterus and can be done vaginally, laparoscopically, or abdominally, and can be either radical, complete, or partial. In some surgeries of the pelvis, such as a hysterectomy or oophorectomy, the ureters are at high risk of getting ligated, clamped, or transected. Injuries to the obturator nerve causes weakness of thigh adduction and loss of sensation of the medial thigh. An ectopic pregnancy is when the fertilized ovum implants in a place other than the uterus, most commonly the ampulla of the fallopian tubes. The most common fistulas in females are vesicovaginal, urethrovaginal, and rectovaginal fistulas. Ovarian or adnexal torsion is where the ovaries twist around the suspensory ligament of the ovary and the ovarian ligament, causing severe pelvic pain, nausea, and vomiting. Finally, when the Bartholin gland ducts become obstructed, that causes mucus to build up, forming a Bartholin cyst.
The neck houses a number of important anatomical structures and serves as the gateway between our head and body. These structures include major blood vessels and nerves, parts of the respiratory and digestive tract, as well as important endocrine glands, such as the thyroid and parathyroid glands. However, the neck is very exposed and vulnerable to injury, and all of these important structures in the neck are susceptible to a variety of clinical conditions. So take a quick moment, stretch out your neck, and let's get started. Let's begin with the thyroid gland. When there is abnormal growth of the thyroid gland, it is called a goiter. When the gland gets big enough, it can be seen as a bulge in the lower part of the neck, and may even extend deep to the sternum. Causes of a goiter include iodine deficiency, autoimmune disorders such as Hashimoto's thyroiditis, and Graves' disease, thyroid cancer, or a thyroid cyst. The thyroid gland can enlarge anteriorly, posteriorly, inferiorly, laterally, or even substernally, but it won't enlarge superiorly. because of the superior attachments of the overlying sternothyroid and sternohyoid muscles. If it enlarges, it has the potential to compress nearby structures such as the trachea, causing difficulty breathing, the esophagus, leading to difficulty swallowing, the recurrent laryngeal nerves, leading to hoarseness, as well as the jugular veins, leading to thrombosis and superior vena cava syndrome in rare cases. Another condition that causes swelling of the neck is a thyroglossal duct cyst, which is the most common congenital cyst in the neck. This condition occurs because during development, the thyroid gland actually develops in the floor of the embryonic pharynx, in a small area identified as the foramen cecum, which is found on the dorsum of the tongue. During development, the thyroid gland migrates from the tongue into the neck, passing anterior to the hyoid bone, through the thyroglossal duct. This duct attaches the developing thyroid gland to the foramen cecum, and normally disappears after birth. However, sometimes parts of this duct remain, and a thyroglossal duct cyst can form along any part of it. The cyst is usually located along the midline of the anterior neck, close or just inferior to the hyoid bone, and can form a visual and palpable mass. Most cysts are asymptomatic, but sometimes they can cause neck pain and dysphagia. Other complications include infections or rupture, where rupture can lead to a thyroglossal fistula. In rare cases, a thyroglossal duct cyst carcinoma can develop from the ectopic thyroid tissue within the cyst. Clinically, the neck mass will move with swallowing or tongue protrusion, as the duct is tethered to the tongue, which is the way to distinguish it from other neck swellings. Now, when a tumor of the thyroid is diagnosed, partial surgical removal of the gland, called a partial thyroidectomy, or complete removal called a thyroidectomy, is required. However, during a thyroidectomy, caution is needed in order to prevent damage to other important surrounding structures. For example, sometimes the parathyroid glands can also be removed during a thyroidectomy due to their small size and variable location within the thyroid gland, particularly the inferior parathyroid glands. Removal of the parathyroid glands will lead to hypoparathyroidism and can result in tetany, which is a severe neurologic syndrome caused by low calcium levels in the blood due to the decrease in parathyroid hormone. This manifests as muscle twitches, cramps, and contractions, and sometimes can even progress to death if the laryngeal and respiratory muscles are involved. To prevent removal of the parathyroid glands during a thyroidectomy, surgeons usually preserve the posterior part of the lobes of the thyroid gland. If that's not possible, the parathyroid glands are carefully isolated with their blood vessels intact and can be transplanted back into the body, for example, into the arm, so they won't be damaged by subsequent thyroid surgery or radiation therapy. Also, remember, during a thyroidectomy, a few other structures can be damaged as well. The recurrent laryngeal nerves run near the inferior pole of the thyroid gland and pass near the inferior thyroid artery, which needs to be ligated and cut, as well as the external branch of the superior laryngeal nerve, which may be damaged during the removal of the superior portions of the thyroid gland. Okay then. Now let's switch gears and look at the larynx, which is responsible for voice production and maintaining a patent airway. The larynx contains the vocal cords and the rhizoglottis, which are responsible for voice production. In fact, the pitch of the voice is changed by variations in the tension and length of the vocal folds, the width of the rhizoglottis, and the intensity of the expiratory effort. However, one of the greatest changes to the larynx occurs during puberty. During puberty in biological males, the increased production of testosterone strengthens the walls of the larynx and enlarges the laryngeal cavity, where in biological females the size of the larynx only slightly increases. Furthermore, in biological males, the laryngeal cartilages enlarge and the laryngeal prominence becomes more apparent. The anteroposterior diameter of the rhizoglottis almost doubles its size and the vocal folds become longer and thicker. This is the reason why the voice in biological males typically becomes lower pitch after puberty, and why there's that awkward transition stage while the anatomy of the larynx matures during puberty. So, can you recall a few causes of a neck mass? How about the structures damaged during a thyroidectomy? Let's talk a bit more about the larynx. Now, everyone loves to hear someone who is good at singing, but have you ever wanted to take a look at their vocal cords to see what makes them an amazing singer? Or maybe take a look at what makes your friend who never stops singing a bad singer? Okay, looking at the vocal cords might not tell us what makes a good singer, but visualizing the larynx can help us identify a variety of clinical conditions. To look at the larynx, a laryngoscopy can be performed, which is a procedure that helps visualize the interior of the larynx. This can be done under direct laryngoscopy. Laryngoscopy is indicated in many clinical scenarios. It may be needed in acute scenarios during respiratory compromise in order to facilitate tracheal intubation, or intubation during general anesthesia. It can also be used to visualize the larynx if cancer is suspected, or visualize the vocal cords to investigate vocal cord pathology, such as polyps or paralysis. Taking a look at this laryngoscopy image of the larynx, we can identify the piriform fossa, the cricoid cartilage, which is covered in a layer of mucosa, the aryepiglottic fold, the vocal folds, the rhizoglottis, the quadrangular membrane, which is also covered in a layer of mucosa, the vestibular folds, the epiglottis, the median glossoepiglottic ligament, the valleculae, and the dorsum of the tongue. Now, I am sure you have seen a movie where someone accidentally inhales their food down the wrong tube and frantically needs the Heimlich maneuver. This is an example of a foreign object being accidentally inhaled into the airways, in which case it goes through the laryngeal inlet into the vestibule of the larynx and can become trapped superior to the vestibular folds. This causes the laryngeal muscles to spasm, tensing the vocal folds. The vocal folds can then close off the rhizoglottis so air cannot enter into the trachea, causing laryngeal obstruction, choking, and eventual asphyxiation if the obstruction is not removed. Now, the vestibular folds are part of the protective mechanism of the larynx. So when foreign objects such as food come in contact with the vestibular mucosa, violent coughing occurs in an attempt to eject the object from the larynx. If coughing doesn't eject the foreign object, urgent help must be given to remove the object and open the airway. One important measure is to give the Heimlich maneuver, which consists of a sudden compression of the abdomen that causes the diaphragm to elevate and compress the lungs. The lungs will still contain air, so compressing the diaphragm upwards will expel air from the lungs through the trachea and larynx, creating a backflow of pressure that usually dislodges the foreign object. In extreme cases, when the Heimlich maneuver fails, other procedures must be considered to get air into the lungs, such as cricothyrotomy or tracheostomy. A cricothyrotomy is a procedure that can be performed in both emergency and controlled surgical situations. Emergency cricothyrotomy involves the insertion of a large bore needle through the cricothyroid ligament to permit fast entry of air into the trachea, and is typically indicated in situations such as laryngeal edema due to anaphylactic reasons, massive hemorrhage, trauma, and any other upper airway obstruction, which can quickly progress to airway obstruction and compromise. The reason a cricothyrotomy is preferred in emergency situations is because the cricothyroid ligament is easily palpated, as it attaches the thyroid cartilage above to the cricoid cartilage below, and can be felt by palpating a soft spot inferior to the laryngeal prominence of the thyroid cartilage and above the cricoid cartilage. However, emergency cricothyrotomy is only a temporary measure until a definite airway can be established, which can be done with a surgical cricothyrotomy done under controlled conditions. where a tracheostomy tube is placed into the trachea through the incision. Another type of airway that can be established is a procedure called a tracheostomy, which is indicated in individuals with an upper airway obstruction or respiratory failure, and are preferred in situations that may require prolonged tube placement. A tracheostomy involves an incision through the skin of the neck and the interior wall of the trachea. From here, an opening is made into the interior wall of the trachea between the first and second tracheal rings, or anywhere through the second to fourth tracheal rings. This procedure establishes a patent airway, allowing the person to breathe without using the nose or the mouth. Finally, let's quickly discuss what a Zenker diverticulum is. A Zenker diverticulum describes a posterior outpouching of herniated esophageal mucosa through an area of muscle weakness on the posterior esophageal wall. A Zenker diverticulum is typically found in an area called the Killian triangle, which is a focal weakness in the hypopharynx, between the thyropharyngeus and cricopharyngeus parts of the inferior pharyngeal constrictor muscle, leading to a pseudo or false diverticulum where food and liquids can become trapped. The best way to visualize this condition is through an upper gastrointestinal contrast study as seen here. In most cases, a Zenker diverticulum is asymptomatic, but it should be suspected in individuals who present with progressive dysphagia, regurgitation, cough, aspiration, and foul-smelling breath, called halitosis, due to food getting trapped in this outpouching of esophageal mucosa. Alright, as a quick recap, a goiter refers to the swelling of the thyroid gland, which can be caused by iodine deficiency and autoimmune diseases like Hashimoto's thyroiditis and Graves' disease. A thyroglossal duct cyst is another cause of neck swelling, and is typically found in the anterior midline portion of the neck near the hyoid bone. Surgical removal of the thyroid gland is called a thyroidectomy, and during this procedure, the removal of the parathyroid glands can be done by mistake, causing tetany. A laryngoscopy can be performed to identify the cause of several issues involving the larynx, such as voice problems, throat pain, hoarseness, difficulty swallowing, or obstructive masses in the airway. Laryngeal obstruction can be caused by a foreign object that is accidentally inhaled into the airways, which can lead to asphyxiation if the object is not removed. In order to open the airway, emergency measures must be taken, such as the Heimlich maneuver. If the Heimlich maneuver fails, other procedures must be considered, such as cricothyrotomy or tracheostomy. Cricothyrotomy can be done in emergency situations for airway access, as the cricothyroid ligament is easily palpated, where tracheostomy can also be done to maintain a patent airway and is preferred in situations that require prolonged tube placement. A Zenker diverticulum is a posterior outpouching of the esophageal mucosa through a weakened area of the inferior pharyngeal constrictor muscle, and is an area where food and liquids can become trapped, leading to difficulty swallowing.
The neck is a compact tube containing many vital structures such as muscles, blood vessels, nerves, and lymphatics, as well as organs of the digestive and the respiratory tract. Now, the neck is like a sheath around these structures. However, it's still an area prone to various injuries and conditions. First of all, let's discuss central venous access, which is when a catheter is placed in a large vein, usually the internal jugular or the subclavian vein. A central access is usually obtained when peripheral access isn't available, like when an individual is severely hypovolemic, for example. If a patient will need intravenous access for a long period of time for medication delivery, such as chemotherapy, then central venous access is a great option to prevent repeated peripheral IV procedures or for those certain intravenous drugs that can cause damage to peripheral veins. It can be used for fluid resuscitation, blood transfusions, central venous pressure monitoring, giving medications, hemodynamic monitoring, or plasmapheresis. It can also be used when emergency dialysis is needed. So first, let's see how we go about accessing the internal jugular vein for central access. In order to better see the anatomy and maximize the internal jugular vein's diameter, the individual should be in Trendelenburg position, which means that their head is down at about 15 degrees compared to the rest of the body. If the catheter is placed in the right internal jugular, then the head must be turned towards the left and vice versa. Usually, for a catheter, the right internal jugular vein is preferred because it has a more direct path towards the superior vena cava. Now, there are some important landmarks that we can use to help us identify the internal jugular vein. First, there's the anterior cervical triangle, which is bordered inferiorly by the clavicle, medially by the sternal head of the sternocleidomastoid muscle, and laterally by the clavicular head of the sternocleidomastoid muscle. So far, so good. Now, near the lateral side of the sternal head, you can palpate the carotid artery, with the internal jugular vein lying superficial and lateral to the carotid artery. Then the introducer needle is inserted at a 40-degree angle to the skin at the apex of the anterior cervical triangle, aiming towards the ipsilateral nipple. Now let's switch gears and look at how you can access the subclavian vein for central access. You guessed it, it's landmark time. So, overlying the first rib, from anterior to posterior, there's the clavicle, the subclavian vein, the anterior scalene muscle, and then the subclavian artery. Medial to the junction of the medial and middle thirds of the clavicle is where you'll find good exposure of the subclavian vein, where it is usually targeted for catheterization using an infraclavicular approach. There are two insertion sites, either 1 to 2 centimeters inferior to the clavicle at the junction of the medial and middle thirds, or just inferior to the clavicle at its midpoint. The needle is advanced beneath the clavicle toward the sternal notch. Bear in mind that central venous access does come with associated risks, such as pneumothorax, hematomas, damage to the veins, infection, or thrombosis. In the same vein, pun intended, let's see how the jugular venous pressure and its flow dynamics can help us in clinical practice. Generally, the pulsations of the internal jugular vein can provide information about heart activity, specifically the right atrium. The vein's pulsations can be seen on the surface of the skin as it arises from beneath the sternocleidomastoid muscle superior to the medial end of the clavicle. There are no valves in the brachiocephalic vein or the superior vena cava, so when the right atrium contracts, there is blood flow that directly passes up these vessels to the inferior bulb of the internal jugular vein. These pulsations can be better visualized when the individual is in Trendelenburg position, and we usually observe the right internal jugular vein because it has a more direct course to the right atrium and is therefore a better reflection of its pressure and activity. With very low jugular venous pressure, the patient will need to be near supine to appreciate it, while for an individual with very high jugular venous pressure, we might actually see the pulsations going up to the earlobe even when the patient is upright. After you've determined the location of pulsation of the internal jugular vein, the individual can lie flat on the bed and you can measure the jugular venous pressure, which can then give us an estimation of pressure in the right atrium. You'll need 2 rulers. Extend the first one horizontally from the highest pulsation point of the jugular vein and cross it perpendicularly with the other ruler that you'll place vertically at the point of the sternal angle. Just for example, let's say we obtain 9 centimeters. To use this measurement to estimate right atrial pressure, we add 5 centimeters, which is the distance in order to get to the center of the atrium from the sternal angle. So, in this case, our estimated right atrial pressure is 14 centimeters. The internal jugular pressure increases in conditions such as mitral valve disease, which increases pressure in the pulmonary circulation and the right side of the heart. Okay, time for our first quiz. What are the anatomical landmarks used to identify the internal right jugular vein? Great. Let's switch gears and talk about the thyroid ima artery. Approximately 10% of people have a small, unpaired thyroid ima artery which originates from the brachiocephalic trunk. It can also arise from the aorta, the right common carotid, the subclavian artery, or from the internal thoracic arteries. It then ascends on the anterior surface of the trachea to the isthmus of the thyroid gland, where it supplies branches to both of these structures. The location of this artery is important when performing a tracheostomy. That's when a transverse incision through the skin of the neck and anterior wall of the trachea is made in order to establish a patent airway in individuals with upper airway obstruction. Usually the opening is made in the trachea just between the first and second tracheal rings, the second and third, or third and fourth rings. Care must be taken in these procedures to avoid damaging the thyroid ima artery if it's present, as significant bleeding can result. A similar sounding, but vastly different procedure is a thyroidectomy, which refers to the surgical removal of the thyroid gland. A hemithyroidectomy, on the other hand, is the removal of only one half or lobe of the thyroid gland. During a thyroidectomy or a hemithyroidectomy, the inferior laryngeal nerve, which is the continuation of the recurrent laryngeal nerve, can be damaged, which damages the muscles that move the vocal fold. This leads to paralysis or weakness of the one or both of the vocal folds. With unilateral paralysis, the voice is poor because the paralyzed vocal fold can't adduct to meet the normal vocal fold. Within weeks, the other vocal fold will adduct across the midline to compensate. However, with bilateral vocal cord paralysis, the voice is almost absent. This also results in high-pitched, noisy respiration known as stridor, as the laryngeal inlet is narrowed and cannot move to widen itself. Okay. Now, to switch things up a little bit, remember that the neck is divided into an anterior and a posterior triangle, mainly based on the borders of the sternocleidomastoid and trapezius muscles, as well as other muscular and bony structures found in the neck. These regions provide a clear anatomic map for localizing the structures, injuries, or pathologies involving the neck. The posterior triangle contains the spinal accessory nerve, or cranial nerve 11, which contributes to the innervation of the sternocleidomastoid and the trapezius muscles, so nerve injury results in diminished or absent function of these muscles. This can present as an asymmetric neckline, drooping shoulder, laterally displaced scapula, and weakness with overhead abduction of the shoulder. Now, the spinal accessory nerve is very long and has a superficial course, which makes it particularly susceptible to injury. The most common cause of spinal accessory nerve injury is iatrogenic, meaning due to medical procedures, in particular radical neck dissections and cervical lymph node biopsies. Other less common causes include blunt or penetrating trauma to the region, and in some cases, spinal accessory nerve injury may happen spontaneously. The posterior triangle also contains the brachial plexus and serves as an access point for this set of nerves, which can really come in handy. One very important technique is the interscalene nerve block, which refers to the placement of local anesthetic around the roots or trunks of the brachial plexus at the level of the C6 vertebral body, between the anterior and middle scalene muscles. The anatomical landmarks to identify the interscalene space are the clavicle, the external jugular vein, and the posterior border of the sternocleidomastoid muscle. This type of block provides anesthesia to the upper limb and is indicated for surgical procedures on the distal clavicle, shoulder, and proximal humerus. It allows for surgery to take place on the upper limb without using a general anesthetic. Now, bear in mind that the interscalene nerve block covers most of the upper roots of the brachial plexus, but can sometimes spare the inferior proximal brachial plexus, which eventually makes up the ulnar nerve. This can limit its usefulness for more distal surgical procedures involving the forearm or hand. And there are also some important potential side effects to keep in mind. The most common is temporary blockade of the recurrent laryngeal nerve, as this nerve may be bathed by the anesthetic, causing hoarseness. Another side effect can be spread of the local anesthetic around the anterior scalene muscle toward the sympathetic chain and sympathetic cervical ganglia. Blockade of these nerves leads to Horner syndrome, characterized by ptosis, meiosis, and anhidrosis. Finally, interscalene nerve block can be associated with phrenic nerve block and diaphragmatic paresis, impairing our ability to breathe effectively. So caution should be taken in patients with underlying respiratory conditions before undergoing an interscalene nerve block. Okay, great. Now, when food passes through the laryngopharynx during swallowing, some of it can enter the piriform fossa or recess. Foreign bodies, such as a chicken bone or a fish bone, which enter the pharynx with swallowing, can become stuck in this recess. A medical image, such as a radiograph or a CT scan, can often reveal the presence of a radiopaque foreign body. If the object is sharp, it can pierce the mucous membrane and injure the underlying internal laryngeal nerve. The internal laryngeal branches off the superior laryngeal nerve in this area, so both of these nerves are vulnerable to injury during removal of the object if the instrument used to remove the foreign body accidentally pierces the mucous membrane. Injury to these nerves can result in lack of sensation of the laryngeal mucous membrane as far inferiorly as the vocal folds, which can lead to impairment of the cough reflex that protects us from aspiration. Bear in mind that young children tend to swallow a variety of objects, most of which reach the stomach and pass through the alimentary tract without difficulty. In some cases, however, the foreign body stops at the inferior end of the laryngopharynx, which is its narrowest part. Foreign bodies in the pharynx are often removed under direct vision using a pharyngoscope. Okay, time for another quick break. Can you recall the anatomical landmarks for the interscalene space? And finally, let's look at something all of us have probably experienced at some point in our lives, adenoiditis, which is inflammation of the pharyngeal tonsils. The adenoids are located high up in the upper part of the throat, above the soft palate within the roof and back wall of the pharynx. Their enlargement can obstruct the passage of air from the nasal cavities through both the choana into the nasopharynx. Furthermore, the infection from the pharyngeal tonsils can spread to the tubal tonsils, which further leads to swelling and closure of the pharyngotympanic tubes. Infection from here can then spread to the middle ear, causing otitis media. This means that nasal obstruction from adenoiditis can actually lead to either temporary or permanent hearing impairment. Common symptoms and signs from adenoiditis include fever, purulent rhinorrhea, throat pain, and nasal obstruction. So, when the pharyngeal tonsils are enlarged, we call them adenoids, and an adenoidectomy can be performed to remove them. By comparison, the palatine tonsils, commonly just referred to as the tonsils, can be surgically removed through a procedure called a tonsillectomy. Through this procedure, the two tonsils at the back of the throat in the oropharynx are removed. Finally, an adenotonsillectomy removes both these palatine tonsils and the adenoids in the same operation. This is done by dissecting the palatine tonsil from the tonsillar bed or by a snare operation. It involves the removal of both the tonsil and some surrounding connective tissue. Remember that the tonsils have a rich blood supply, which means that bleeding can happen from the large external palatine vein or from the tonsillar artery. The glossopharyngeal nerve accompanies the tonsillar artery on the lateral wall of the pharynx, and it can also be damaged during surgery. If the internal carotid artery has a tortuous course and lies directly lateral to the tonsil, it can become vulnerable to injury as well, potentially leading to serious bleeding. Indications for adenotonsillectomy include obstructive sleep apnea, particularly in children, recurrent infections, and peritonsillar abscesses. Alright, as a quick recap, central venous access typically uses the right jugular vein or the subclavian vein. The jugular venous pressure is measured with the individual laying flat at the highest pulsation point of the jugular vein. From there, you need to extend a ruler horizontally to cross with another ruler placed on the sternal angle, and then add 5 centimeters. Approximately 10% of people have a thyroid ima artery, which usually originates from the brachiocephalic trunk, and it's important to know about it, especially during tracheostomy. During a thyroidectomy or a hemithyroidectomy, the inferior laryngeal nerve can be damaged, leading to paralysis of the vocal folds. The posterior triangle contains the spinal accessory nerve, which, when damaged, can affect the functions of the sternocleidomastoid and the trapezius muscles. An interscalene nerve block refers to the placement of local anesthetic around the roots or trunks of the brachial plexus at the level of C6 vertebral body. This provides anesthesia to the upper limb and is indicated for surgical procedures on the distal clavicle, shoulder, and proximal humerus. When food passes through the laryngopharynx during swallowing, some of it enters the piriform fossa or recess. If the object is sharp, it can pierce the mucous membrane and injure the internal laryngeal nerve. The superior laryngeal nerve and its internal laryngeal branch are also vulnerable to injury during removal of the object. Adenoiditis is the inflammation of the pharyngeal tonsils. This can obstruct the passage of air from the nasal cavities through both the choana into the nasopharynx and may also result in middle ear infection. A tonsillectomy is the surgical removal of the tonsils. An adenoidectomy removes the adenoids, while an adenotonsillectomy removes both the tonsils and the adenoids. The neck contains many vital structures, including blood vessels, nerves, and lymphatics, as well as organs like the thyroid and parathyroid glands, parts of the airway like the larynx and trachea, and parts of the digestive tract like the pharynx and esophagus. All these structures are protected by the bones, fascia, and muscles of the neck. The skeleton of the neck is formed by the cervical spine, the hyoid bone, the manubrium of the sternum, and the clavicles. All of these structures are prone to injuries, so hopefully learning about them in this video won't be too much of a pain in the neck. Boo. Let's get started. First, let's look at cervical spine fractures. The cervical spine is the most flexible and mobile part of the vertebral column. But that flexibility comes with a price, making the cervical spine vulnerable to injury. Now, cervical spine fractures can be stable, meaning the spinal cord is at minimal to no risk of injury due to the fracture pattern, or unstable, meaning the spinal cord is at a much greater risk of injury due to the fracture pattern. Let's take a look at some important types of cervical fractures. Let's start from the C1 or atlas vertebra. These fractures are also called Jefferson or burst fractures. As you might remember, C1 is a ring-shaped bone that has paired wedge-shaped lateral masses connected by thin anterior and posterior arches and a transverse ligament. The C1 vertebra sustains the weight of the cranium, kind of like how the god Atlas of Greek mythology bore the weight of the world on his shoulders. Now, because the taller side of the lateral mass is directed laterally, when there are vertical forces that compress the lateral masses between the occipital condyles above and the C2 or axis below, this compressive force drives the two lateral masses of the C1 vertebrae apart, which can lead to fractures in either the anterior arch, the posterior arch, or both. A classic example of this is striking the bottom of the pool with the top of your head when diving. If the force is really strong, it could even rupture the transverse ligament. These fractures don't necessarily cause a spinal cord injury because the diameter of the vertebral ring actually increases. However, spinal cord injuries could happen if the transverse ligament ruptures, potentially resulting in compression of the spinal cord by the dens of the C2 vertebra, also called the odontoid process. On a CT scan, a C1 fracture looks something like this. You can see where the bone has been broken and how the lateral mass shifts laterally. Now, the C2 vertebra, or the axis, can also be fractured. C2 is called the axis because it has a bony protrusion called the dens of the axis that fits within the atlas ring, so this articulation allows rotation of the neck from side to side. One of the most common injuries to the cervical vertebrae is a fracture of the vertebral arch of the axis. The fracture usually occurs in the bony part formed by the superior articular process and inferior articular processes of the axis, also known as a traumatic spondylolysis of C2. This happens as a result of hyperextension of the head on the neck. So, in the past, this fracture pattern was often seen in people who were executed by hanging. Therefore, it has also been referred to as a hangman's fracture. In more severe injuries, the body of C2 is displaced anteriorly. Regardless of whether there is anterior displacement of the body, injury of the spinal cord can occur, which can cause paralysis in all four limbs and even death. You can recognize a C2 fracture on X-ray in the area of the lamina and pedicles. The dens of the axis can also be fractured, usually because of forced flexion or extension in the anterior-posterior plane. There are three types of dens fractures. Type 1 is the most uncommon type, and it's when the fracture occurs above the transverse ligament, resulting in a relatively stable fracture. Type 2 is the most common fracture pattern, and it's usually located at the base of the dens where it attaches to C2. These fractures tend to be unstable and can be complicated by non-union, which is when a fracture won't heal properly because of poor blood supply, excessive movement at the fracture site, or infection. Finally, type 3 fractures occur below type 2 fractures at the vertebral body inferior to the base of the dens. These fractures heal faster because the fragments retain their blood supply. However, they are mechanically unstable as this fracture moves with the occiput as one unit. Dens fractures are best seen on an open-mouth radiograph. You can see the bone discontinuation at the base of the dens. It is easier to distinguish on a coronal CT scan and a sagittal CT scan. Okay, now if the force causing a C1 or C2 fracture is really strong, for example during a car crash that causes extreme flexion or extension, it can rupture the transverse ligament. This can result in anterior dislocation of the atlas on the axis or atlantoaxial subluxation. Additionally, if there's an associated fracture of the dens and preservation of the transverse ligament, the dens dislocates, moving together with the atlas. Other than trauma, some other conditions can also cause atlantoaxial subluxation. First, there can be pathological softening or loosening of the transverse ligament, leading to an incompetent transverse ligament that's unable to maintain the position of the atlantoaxial joint. This typically results from connective tissue disorders like rheumatoid arthritis, systemic lupus erythematosus, and ankylosing spondylitis. Second, there is laxity of the transverse ligament, which is often associated with congenital disorders like Marfan syndrome, Ehlers-Danlos syndrome, or Down syndrome. Finally, there can be transverse ligament agenesis, which is when an individual is born without the transverse ligament, and this can also be associated with Down syndrome. Pathology to the transverse ligament is significant because the spinal cord can become impinged between the posterior arch of the atlas and the dens. Even though most individuals with atlantoaxial subluxation are asymptomatic or just experience mild neck pain, a sudden or large movement may lead to compression and injury of the spinal cord. This can result in sensory loss and paralysis in all four limbs or even injury to the brainstem, leading to death. Initial management is to place the individual in spinal precautions and immobilize the cervical spine, and depending on the stability of the injury, the patient may need a halo, which is a rigid structure that is secured to the frontal and parietal skull bones with metal pins, or a cervical spine collar. Stable fractures can be managed conservatively, however, more severe injury may require surgery. Alright, that was a lot of info. Feel free to pause the video and see if you can recognize these three images and recall the three types of odontoid process fracture. Okay, now remember, the vertebrae are not the only bones of the neck. There's also the U-shaped hyoid bone. The hyoid bone is a mobile bone located in the anterior part of the neck at the level of C3 vertebra, which serves as an attachment for anterior neck muscles and functions to help keep the airway open. Hyoid bone fractures usually result from strangulation, where the throat is compressed and the body of the hyoid bone is pushed backwards against the thyroid cartilage. Individuals with a hyoid bone fracture can experience anterior neck pain, as well as dyspnea or shortness of breath, dysphonia or hoarseness, dysphagia or difficulty swallowing, and odynophagia or painful swallowing. In addition, because the hyoid bone keeps the airway open and separates it from the esophagus, dysfunction can lead to food or liquid mistakenly going into the airway, which can cause aspiration pneumonia. Finally, a fractured bone fragment might pierce into nearby structures such as the lingual artery, causing profuse bleeding. Alright, now let's switch gears and look at the cervical fascia of the neck, which is composed of the superficial fascia, sitting right underneath the skin, enclosing the head and neck, and the deep fascia, which can be thought of as segmented compartments separating the different muscles and structures of the neck extending from the base of the skull to the mediastinum. The deep cervical fascia has 3 layers. There's the superficial or investing layer, which surrounds the entire neck deep to the skin and subcutaneous layer and helps prevent the spread of abscesses, or purulent infections, into the compartments of the neck. Then there is the pretracheal fascia, which has 2 parts, a thin muscular part that encloses the infrahyoid muscles, and a visceral part that encloses the thyroid gland, trachea, and esophagus. And finally, the deepest layer is the prevertebral fascia, which contains muscles of the spine and vertebral column. Between these 3 different layers of the deep cervical fascia, there are a number of important spaces which become clinically significant when it comes to neck infections. First, posterior to the pharynx, there's a potential space called the retropharyngeal space. This space is bounded anteriorly by the buccopharyngeal fascia, which is the superior continuation of the pretracheal layer, and posteriorly by the alar fascia, and communicates with the superior mediastinum distally, meaning there is potential for spread of infection of this space into the thorax. Infection in the retropharyngeal space can also lead to a retropharyngeal abscess, resulting in difficulty swallowing and speaking. Another important space to know about is the danger space, which is posterior to the retropharyngeal space and bounded anteriorly by the alar fascia and posteriorly by the prevertebral layer. This space extends from the base of the skull to the posterior mediastinum to the level of the diaphragm and is the most important route for spread of infection between the neck and thorax. Infection can also arise between the superficial investing layer and the visceral part of the pretracheal layer, or between the muscular and visceral parts of the pretracheal layer, in the pretracheal space surrounding the esophagus and trachea, where it can spread to the carotid sheaths laterally and the superior mediastinum inferiorly. Finally, another space susceptible to deep neck infection is the peritonsillar space, which lies between the palatine tonsils medially and the superior constrictor muscle laterally. In this area, a peritonsillar abscess, also known as quinsy, can form, which can obstruct the airway. Symptoms of deep neck space infections include sore throat, difficulty swallowing or breathing, and systemic signs of infection. Importantly, remember that any infection involving these spaces can potentially spread to the mediastinum, which can cause a life-threatening complication called descending necrotizing mediastinitis, which can be fatal. And finally, let's discuss torticollis, which literally means twisted neck. Now, torticollis results from a contraction or shortening of the muscles of the neck, such as the sternocleidomastoid and trapezius muscle. This condition typically presents with the head tilted towards the affected side and the chin rotated away from the affected side, limiting the range of motion of the neck. This is because this condition mimics the action of the sternocleidomastoid, which functions to laterally flex the head to the side of contraction and laterally rotate the head or chin away from the side of the contraction. Now, torticollis can be congenital or acquired. The most common one is congenital torticollis, which is a postural deformity of the neck that develops prenatally. This is most often caused by the development of a fibrous tissue tumor in the sternocleidomastoid muscle, and less often by neurological or bony abnormalities. There is also congenital muscular torticollis, which is a postural deformity that is typically evident 2 to 4 weeks after delivery, and often occurs during delivery when there is tearing of the muscle fibers of the baby's neck, resulting in subsequent fibrosis and shortening of the neck muscles. On the other hand, acquired torticollis typically appears after delivery and can be caused by a variety of conditions that cause injury or inflammation to the muscles of the neck. These can range anywhere from trauma, infection, or neurological disorders. It typically occurs in children, but can also occur in adults as well. Adults typically get a type of torticollis referred to as spasmodic torticollis or cervical dystonia, resulting from strenuous movement or awkward positioning for too long. This is a chronic and painful condition characterized by involuntary contraction of the neck muscles, leading to involuntary tilting, turning, flexing, or extending of the neck. In most cases, the cause of spasmodic torticollis is unknown, but more serious causes include cervical spine injuries, such as fractures and subluxations. Alright, as a quick recap, a Jefferson or burst fracture occurs due to a downward force on the C1 vertebrae, leading to fracture of the anterior and posterior arches, whereas traumatic spondylolysis of the C2 vertebrae is a fracture of the vertebral arch often caused by hyperextension. Fractures of the odontoid process or dens usually occur due to forced flexion or extension in the anterior-posterior plane, and there are 3 types. Type 1 is a stable fracture above the transverse ligament, Type 2 is an unstable fracture located at the base of the dens, and Type 3 are unstable fractures at the vertebral body inferior to the base of the dens. Atlantoaxial subluxation is a misalignment of the atlas and axis that can result from transverse ligament rupture, pathological softening, laxity, or agenesis. Hyoid bone fractures usually result from strangulation, where the body of the hyoid bone is pushed backwards onto the thyroid cartilage. There are numerous spaces created by the deep cervical fascia where infection can spread. These include the retropharyngeal space, which communicates with the superior mediastinum, the danger space, which communicates with the posterior mediastinum, the pretracheal space, which communicates with the superior mediastinum, and local spread of infection of the peritonsillar space. Infection spreading through these spaces can lead to descending necrotizing mediastinitis, which can be life-threatening. Finally, torticollis is caused by contraction or shortening of the muscles of the neck and presents with the head tilted towards the affected side and the chin rotated away from the affected side, limiting the range of motion of the neck. Torticollis can either be congenital or be acquired after birth in both infants and adults. The knee is one of the most complex joints in the human body, and along with the rest of the lower limb, there are numerous ligamentous, muscular, and bony structures that are prone to injury. Oftentimes, we can injure many of these structures at the same time, but injury to even one of these structures can affect how we walk, dance, or exercise. This video will go over all the relevant anatomy you need to know in order to understand the clinical conditions affecting the knee. First up, let's discuss the Q angle, where Q stands for quadriceps. The Q angle is the angle measured between the femur and the tibia. This angle is created by the femur's diagonal placement within the thigh and by the tibia's vertical placement in the leg. This angle is typically below 20 degrees and on average is higher in biologic females, and a normal Q angle allows the weight supported by the knee joint to be centered through the middle of the knee, in the knee's intercondylar region. When the Q angle increases over the normal range, it can lead to genu valgum, or knock knees. With genu valgum, the increase in Q angle shifts the weight-bearing center to the lateral compartment of the knee, which increases the quadriceps lateral pull and causes the medial collateral ligament to overstretch. This can cause joint misalignment and a predisposition for articular degeneration in the lateral compartment of the knee and subsequent gait abnormalities. To remember the knock-knee appearance of genu valgum, think of the G as standing for gum, sticking the knees together. Alternatively, when the Q angle is below normal range, a genu varum alignment can occur where the legs angulate away from the midline and create a bow-legged appearance. This results in the weight-bearing center being shifted through the medial compartment of the knee, stretching the lateral capsule and lateral collateral ligament. So this time, there's joint misalignment and a predisposition to articular degeneration in the medial compartment of the knee and subsequent gait abnormalities. To remember this, think that in genu varum, the knees are far, apart from each other. Risk factors for both genu valgum and genu varum is prior trauma, abnormal physiological development, and vitamin D deficiency, also known as rickets. However, both of these alignments can be physiological in infants and resolve in adulthood. Genu valgum and genu varum can be recognized on an X-ray. Next up, there are knee dislocations, or tibiofemoral dislocations, which are considered a limb-threatening injury. That's because they can lead to injury and compression of the neurovascular structures found in the popliteal fossa, specifically the popliteal artery. Knee dislocations are usually caused by high-energy traumas such as a car crash, where excessive force is directed to the proximal tibia, resulting in the tibia being forced posterior in respect to the femur. This results in a posterior dislocation, causing disruption of multiple knee ligaments, such as the anterior and posterior cruciate ligaments and the medial and lateral collateral ligaments. In a posterior dislocation, the tibia can cause damage to the popliteal artery, resulting in ischemia and the potential for irreversible lower limb injury, which may necessitate amputation. Patients will present with severe knee pain and likely the inability to weight bear or even move the knee joint properly. Management should be to immediately reduce the dislocated knee, followed by a thorough neurovascular exam, such as palpating the popliteal artery, posterior tibial artery, and dorsalis pedis artery. ABI and CT angiography may also be considered. If closed reduction is not possible, surgery is required. Now, if you need a break, let's see if you can remember what the Q angle is. And can you identify genu valgum and genu varum on these images? Moving on, let's discuss iliotibial band syndrome, which refers to lateral knee pain during flexion and extension of the knee, as well as tenderness over the lateral femoral epicondyle. This is thought to be due to an overuse injury of the iliotibial band, which is a fibrous fascial structure of the lateral leg that inserts onto the lateral tibia. During flexion and extension, the distal insertion of the iliotibial band irritates the lateral femoral epicondyle, which it covers. Let's look at the risk factors of iliotibial band syndrome. Runners and cyclists are at an increased risk of this syndrome, as well as those who have genu varum alignment. Clinically, individuals present with pain over the iliotibial band course, particularly over the lateral femoral epicondyle, where activity modification and stretching can relieve the pain. Okay, now let's move on to some of the more famous injuries of the knee, the ones which seem to plague sports stars all over the world. To start, we have the medial and lateral collateral ligaments, also called the tibial and fibular collateral ligaments. The medial collateral ligament, or MCL, is a flat band that extends from the medial epicondyle of the femur to the medial condyle of the tibia. This ligament is commonly injured during sports that undergo twisting motions, like basketball. Additionally, injury can occur after a direct blow to the lateral knee while the foot is planted, as this results in a valgus stress, causing stretching of the medial surface of the knee. Individuals typically present with swelling, bruising, and joint line tenderness of the medial knee. Of note, the medial collateral ligament does have attachment points to the medial meniscus. Therefore, injury to this structure can also cause injury to the medial meniscus, which we will talk about soon. To test for MCL injury, a valgus stress test is done. Here, the individual lies on their back with the knee slightly flexed. One hand is positioned on the lateral surface of the knee, placing gentle inward pressure, and the other hand is placed around the medial ankle, applying lateral force in order to create a valgus stress on the knee, opening up the medial compartment. If the medial compartment widens and has increased laxity, this is indicative of medial collateral ligament damage, as the ligament provides medial knee stability. Going forward, or rather laterally, is the lateral collateral ligament, or LCL. The ligament extends distally from the lateral epicondyle of the femur to the lateral surface of the fibular head. Isolated injury to the lateral collateral ligament, or LCL, is rare, and it is more commonly injured along with other structures of the posterolateral knee, such as the lateral meniscus. Individuals usually present after trauma to the anteromedial or medial aspect of the knee, which results in varus stress. This frequently occurs during sports such as football, rugby, or wrestling. Individuals clinically develop lateral knee pain, swelling, bruising, and instability. LCL injuries can be diagnosed clinically using the varus stress test, which is when the individual lies on their back with the knee slightly flexed. One hand is positioned on the medial surface of the knee, placing gentle outward pressure, and the other hand is placed on the lateral ankle, applying medial force in order to create a varus stress on the knee, opening up the lateral compartment. If the lateral compartment widens and has increased laxity, this is indicative of lateral collateral ligament damage, as the ligament provides lateral knee stability. Imaging is often not done for MCL and LCL injuries. However, MRI can be done to classify the severity of the injury, as surgical management is considered for a severe injury. The anterior cruciate ligament, or ACL, is also frequently injured in athletes. ACL tears can occur due to both high-energy mechanisms, such as a motor vehicle collision, and non-contact or low-energy mechanisms, which often occurs as a sudden internal rotation when the foot is planted, as well as a rapid deceleration or direction changes often seen in sports. The ACL functions mainly to prevent anterior displacement of the tibia in relation to the femur, and also functions to resist rotational forces of the knee and resist varus and valgus forces. Therefore, a direct blow to the anterior femur can result in ACL injury, as this causes posterior translation of the femur relative to the tibia, which is the same as anterior translation of the tibia relative to the femur. Clinically, ACL injuries present with pain, instability, and the potential for severe swelling due to rupture of the ACL vascular supply, which can present as rapid onset hemarthrosis of the knee. Non-contact injuries may also present with an audible pop. Injury can be diagnosed clinically with a positive Lachman test and anterior drawer tests. The Lachman test is done by flexing the knee to 30 degrees and stabilizing the distal femur with one hand while pulling the proximal tibia anteriorly with the other hand, all to produce anterior translation of the tibia. An intact ACL should limit anterior translation and have a distinct endpoint. With an ACL injury, there's increased translation compared with the uninjured knee and a vague endpoint. Next, in the anterior drawer test, the individual is supine and the knee is flexed at 90 degrees with the foot flat on the bed. With the foot flat and secured to the table, the examiner grasps the leg around the calf with the thumbs placed on the tibial tuberosity and attempts to translate the tibia anteriorly. The test is positive if there is laxity or excess anterior translation of the tibia compared to the contralateral side. To confirm the diagnosis of a ruptured ACL, an MRI is usually done. A sagittal view of the knee with an intact ACL will show continuous fibers from their attachment points, where a ruptured ACL will show fiber discontinuity between the attachment points. Finally, we have the posterior cruciate ligament, or PCL, which normally prevents posterior translation of the tibia relative to the femur, and is usually injured after a direct blow to the anterior tibia. This can happen during a car crash, or as with most other ligaments, it can also be damaged during sports, usually when an athlete, like a gymnast, falls on their flexed knee while the foot is plantar flexed. Symptoms of a PCL injury include pain, instability, potential swelling of the knee, and may also present with a popping sensation. Diagnosis is based on symptoms and clinical findings. The main clinical test for an injured PCL is the posterior drawer test, which is similar to the anterior drawer test. With the foot flat and secured to the table, the examiner grasps the leg around the calf with the thumbs placed on the tibial tuberosity and attempts to translate the tibia posteriorly. The test is positive if there is laxity or excess posterior translation of the tibia compared to the contralateral side. Additionally, if you place the leg at 90 degrees and look at the knee from a lateral view, you may also see the posterior sag sign, which is when the tibia sags below the level of the uninjured side. Yet again, to confirm the diagnosis of a ruptured PCL, an MRI is used. A sagittal view of the knee with an intact PCL will show continuous fibers from their attachment points, where a ruptured PCL will show fibered discontinuity between the attachment points. If you need a quick break, you're in luck. Can you recall the 4 ligaments commonly injured in the knee? How about the clinical tests used to diagnose an ACL injury? Now let's switch gears and talk about medial and lateral meniscus injury. Acute meniscal injuries more commonly involve the medial meniscus, and they're often the result of twisting injuries with the foot in a fixed position. This frequently occurs in sports that involve deceleration and change in direction, like soccer, basketball, or American football. Meniscus injuries can also be secondary to chronic degenerative conditions, such as arthritis, which contribute to breakdown of the menisci so they are more easily damaged. With a meniscus injury, individuals can describe a tearing or popping sensation at the time of injury, followed by pain and local tenderness over the medial or lateral joint line. Furthermore, patients may describe a locking or catching of the knee where they feel like their knee is locked and can't mechanically move past a certain range, or they might describe knee instability where it gives out, for instance when going up and down stairs. Clinically, the Thessaly test and McMurray tests can be used to assess for a meniscus injury. Both tests recreate the discomfort or catching sensation by rotating and extending the knee under a mechanical load. The McMurray test involves repeated passive flexion and extension of the knee, while simultaneously putting the lower leg and foot into internal or external rotation and pushing upwards on the lower leg to stimulate a loading force. The test is positive if they have palpable locking or clicking, which may be accompanied by pain and crepitus. When testing the medial meniscus, the lower leg and foot are placed into external rotation during flexion, which causes force to go through the medial compartment of the knee in order to put more force on the medial meniscus. To test the lateral meniscus, the lower leg and foot are placed in internal rotation, so force is placed through the lateral compartment. To remember this, think of the word LIME, which stands for lateral internal rotation and medial external rotation. The Thessaly test is done with the individual and examiner facing each other, holding hands for support. The individual then stands on the affected leg with the knee flexed to 20 degrees, while trying to internally and externally rotate the body. The test is positive if it causes pain or a locking sensation. Diagnosis of meniscal tears is confirmed using MRI. Before we move on, we should also briefly mention a commonly tested injury pattern on the knee called the unhappy triad, which is often taught as a multi-structure injury comprising the anterior cruciate ligament, medial collateral ligament, and the medial meniscus. The unhappy triad is caused by lateral blow or valgus force to the knee while the foot is fixed on the ground like in football or rugby. Subsequently, the resulting valgus or rotary force to the knee tears the components of the unhappy triad together. Classically, the unhappy triad has been taught to include the medial meniscus. However, more recent understanding shows that a more common injury pattern is actually a combined injury of the anterior cruciate ligament, medial collateral ligament, and lateral meniscus instead of the medial meniscus. However, both injury patterns can be seen. Okay, now let's switch gears and look at bursitis, which refers to inflammation of the different bursa around the knee. A bursa is a fluid-filled sac that helps reduce friction and cushion the knee structures. Acute bursitis can often be caused by microorganisms like Staphylococcus aureus, crystalline substances like those that accumulate in gout, or autoimmune conditions. Acute bursitis clinically presents with pain, swelling, and redness, which are exacerbated by movement. Chronic bursitis is often due to repetitive overuse, microtrauma, or inflammatory conditions like rheumatoid arthritis. Now, let's look at each bursa one by one. First, there's prepatellar bursitis, sometimes referred to with the antiquated term of housemaid's knee, which results from friction between the skin and the patella and presents with pain, erythema, or bogginess over the patella. It is usually seen in individuals who frequently kneel, like during gardening or plumbing. Then there's superficial infrapatellar bursitis, which affects the subcutaneous infrapatellar bursa, referred to as the clergyman's knee, which results from friction between the skin and patellar ligament, and presents with pain and tenderness over the distal patellar ligament. Deep infrapatellar bursitis, on the other hand, affects the deep infrapatellar bursa and can result from friction between the patellar ligament and the tibial tuberosity. Both superficial and deep infrapatellar bursitis can occur when kneeling with a more erect back, such as roofers who don't wear knee pads or priests praying. Next, suprapatellar bursitis refers to inflammation of the suprapatellar bursa, which extends from deep beneath the quadriceps muscle to beneath the patella. Its positioning makes it vulnerable to superficial bacterial infections if there is injury or abrasions to the overlying skin. Clinical features include suprapatellar pain and swelling, redness, warmth, and a reduced range of motion of the knee. Then there's pes anserine bursitis. The pes anserine bursa lies just below the medial joint line and reduces friction for the tendons of the sartorius, gracilis, and semitendinosus muscles. The condition is usually caused by repetitive use and presents with localized medial knee pain over the pes anserinus and is common in those with osteoarthritis or diabetes. And finally, let's discuss Baker cysts or popliteal cysts. These are caused by extrusions of synovial fluid from the knee joint into the gastrocnemius tendon bursa and semimembranosus tendon bursa through open communication between these structures. Baker cysts can be found in both adults and children and are associated with either trauma or degenerative conditions of the knee such as meniscal tears, rheumatoid arthritis, and osteoarthritis. Baker cysts are typically asymptomatic and present as a chronic, painless bulge behind the knee. Individuals develop acute symptoms if the cyst ruptures or compresses on nearby structures. A ruptured Baker cyst can present with calf pain, warmth, erythema, and swelling, and may be confused for a deep vein thrombosis. An ultrasound may be used to distinguish the two. Congrats, we have reached the end. Before we move on to a final recap, can you remember what the unhappy triad refers to? What type of injury pattern is more common? All right. As a quick recap, with genu valgum, the Q angle is greater than normal and the knees are close to one another. With genu verum, the Q angle is lower than normal, so the knees are far from one another. Dislocations of the knee can cause vascular compromise to the popliteal artery, resulting in an ischemic limb, so they are considered medical emergencies. Iliotibial band syndrome refers to pain over the lateral knee, typically as a result of overuse and irritation of the iliotibial band over the lateral femoral epicondyle. Medial collateral ligament injuries typically occur with a valgus force, and a valgus stress test is positive for clinical diagnosis. The lateral collateral ligament can occur with a varus stress force, and a varus stress test is positive for clinical diagnosis. The anterior cruciate ligament is susceptible to injury after a direct anterior blow to the femur or from a non-contact twisting injury when the foot is planted. The Lachman test and anterior drawer tests can be used to test clinically. The posterior cruciate ligament is susceptible to injury after a direct anterior blow to the tibia, where the posterior drawer test can be used to test clinically. Medial and lateral meniscus injury often result from twisting injuries and present with pain, locking, catching, and giving out at the knee. Both the McMurray and Thessaly tests are used to test this clinically. The unhappy triad is when there's a combined tear of the anterior cruciate ligament, the medial collateral ligament, and medial meniscus. However, a more common injury pattern involves the anterior cruciate ligament, medial collateral ligament, and lateral meniscus. Bursitis refers to inflammation of the different bursa found around the knee. The 5 common types of knee bursitis include prepatellar bursitis, superficial infrapatellar bursitis, deep infrapatellar bursitis, suprapatellar bursitis, and pes anserine bursitis. Finally, Baker cysts, or popliteal cysts, are caused by extrusions of synovial fluid from the knee joint into either the gastrocnemius or semimembranosus tendon bursa. When it comes to the clinical correlates of the leg and ankle, there is so much more than just rolling our ankle or banging our shin bone. There are a variety of clinical conditions that affect these structures, and it's not until these conditions occur that we remember the importance of our lower limbs. So we hope you get a kick out of this video, learning the clinical conditions affecting the leg and ankle. First up, let's discuss tibial nerve injury. The tibial nerve is the medial and larger branch of the sciatic nerve, and it often splits from the common fibular nerve at the apex of the popliteal fossa, eventually dividing into the medial plantar nerve and lateral plantar nerve, which provide motor and sensory information to the foot. Tibial nerve injuries can occur either proximally at the popliteal fossa or distally at the tarsal tunnel, which is more common. Injury at the popliteal fossa is rare as the nerve is protected deep within soft tissue at this level. Mechanisms that may cause injury at the popliteal fossa are deep penetrating trauma, knee surgery, compression from a tumor or a Baker's cyst, and posterior knee dislocation. An injury at the popliteal fossa affects the innervation of both the lower leg and the foot. Individuals can present with weakness in plantar flexion, inversion, and toe flexion of the foot due to decreased innervation to the muscles in the deep compartments of the lower leg. Additionally, those affected can present with their foot in a calcaneo-valgus position, or more simply in dorsiflexion and eversion. Injury at this level also impairs innervation to the intrinsic muscles of the foot and can also cause paresthesia to the sole of the foot. On the other hand, there are distal tibial nerve injuries, most commonly at the tarsal tunnel. Distally, the tibial nerve passes through the tarsal tunnel between the medial malleolus and calcaneus deep to the flexor retinaculum. Injury at the tarsal tunnel can be caused by fractures or dislocations involving the talus, calcaneus, or medial malleolus. The tibial nerve can also become entrapped or compressed within the tarsal tunnel, and this can be due to enlargement or swelling of other structures passing through the tarsal tunnel, such as the tibialis posterior, flexor digitorum longus, and flexor hallucis longus tendons, or external pressure from things such as tight shoes or a cast. Any compression of the tibial nerve at the tarsal tunnel can lead to what is called tarsal tunnel syndrome. Injury of the tibial nerve at the tarsal tunnel impairs innervation to the intrinsic muscles of the foot and causes pain and paresthesia over the sole of the foot. In contrast to injury at the popliteal fossa, if the tibial nerve is injured at the tarsal tunnel, plantar flexion and foot inversion remain intact as the innervation to the muscles of the lower leg are not affected. Next up, let's look at injury to the common fibular nerve. This nerve typically branches as the lateral division of the sciatic nerve, at the apex of the popliteal fossa. It then courses posterior to the head of the fibula and wraps laterally around the neck of the fibula to eventually divide into the superficial fibular nerve, which supplies the lateral compartment of the leg mainly responsible for reversion of the foot, and the deep fibular nerve, which supplies the anterior compartment of the leg mainly responsible for dorsiflexion of the foot and supplies the region between the first and second toes. Injury to the common fibular nerve typically occurs due to compressive forces at or near the fibular head. Compression of the common fibular nerve can be due to prolonged bed rest or positioning during surgical procedures, cast immobilization, which is too tight at the fibular head, or positionally, such as leg crossing or squatting. Symptoms of nerve compression are typically transient. However, more severe mechanisms such as fibular neck fractures and knee dislocation can cause severe or permanent damage. A classic sign of common fibular nerve compression is unilateral foot drop, which means difficulty dorsiflexing the foot, particularly when walking. Affected individuals describe a steppage gait, which is a tendency to trip over the affected leg unless they compensate by flexing the hip higher when walking. Other symptoms include paresthesia and sensory loss over the dorsum of the foot and lateral shin. However, if there is only injury to the superficial division of the fibular nerve, then sensation between the first two toes in the first web space is preserved, as this area is supplied by the deep fibular nerve. Individuals may have weakness in foot eversion due to impairment of the lateral compartment muscles. If the fibular nerve is fully damaged, then flaccid paralysis of all muscles in the anterior and lateral compartments of the leg can occur. With common fibular nerve injury, plantar flexion and ankle reflexes remain intact as they are controlled by the tibial nerve. Okay, time for a quick break. Can you remember where proximal and distal tibial nerve injury can happen? Let's switch gears and look at tibial fractures next. Tibial fractures tend to occur during high-energy trauma, such as motor vehicle crashes and sports injuries, and with low-energy trauma, such as falls or twisting injuries. Repetitive, low-energy actions, for example long-distance running, can also lead to what is called stress fractures, which progressively weaken the bone, leaving it susceptible to future fracture. Tibial fractures typically occur at the middle or distal third, where the bone is thinnest and has the poorest blood supply. Okay, so low-energy fractures tend to cause spiral fractures of the tibia, whereas high-energy fractures can lead to severe soft tissue injury and compound or open fractures, which is when the fracture breaks the surface of the skin and bony fragments can maybe be seen protruding through. Other complications of tibial fractures include comminution, meaning there are multiple bony fragments resulting from the fracture, which can ultimately lead to poor healing and non-union if the tibial blood supply is compromised. This often occurs at the middle or distal third of the tibia, particularly at the medial malleolus. If fracture occurs in the proximal tibia, there can be extension into the tibial plateau and intercondylar notch, which can affect the articular cartilage. Finally, tibial fractures can lead to a complication called compartment syndrome, which is increased pressure in the muscular compartments of the lower leg. To understand compartment syndrome, remember that the lower leg is made up of 4 closed-off compartments divided by the tibia, fibula, interosseous membrane, and intermuscular septa. They are the anterior compartment, lateral compartment, and the superficial posterior and deep posterior compartment, which extend from the knee joint above to the ankle joint below. Because these compartments are closed off, any increase in compartmental pressure can compress the structures found within these compartments. This can lead to vascular compression, compromising blood flow, which may result in ischemic and eventual irreversible muscle and nerve damage. Fractures, such as tibial fracture, are the most common reason for compartment syndrome, but it can also be a consequence of crush injuries, such as a car crash, bleeding disorders, vascular disease, or from constrictive bandages or casting. Symptoms can progress rapidly, so it is important to recognize compartment syndrome clinically, as diagnosis is considered a surgical emergency. Compartment syndrome, resulting in vascular compromise, typically presents with the 6 Ps. The first is pain, typically out of proportion to the clinical situation. For example, if passive stretching of the toes causes excruciating pain. Then there's pallor, or loss of color in the leg, paresthesia, or loss of nerve sensation related to the affected compartment, paralysis of the muscles of the affected compartment, palpable swelling, and finally pulselessness, which is a late finding, and at this stage amputation may be needed. The anterior compartment of the leg is the most commonly affected site. Remember that it contains the anterior tibial artery and the deep fibular nerve. Symptoms include loss of sensation between the first and second toes, weakness of foot dorsiflexion and inversion, potential foot drop, and loss of the dorsalis pedis artery pulse on palpation. The lateral compartment contains the superficial fibular nerve and the proximal segment of the deep fibular nerve, resulting in paresthesia of the lower leg and the dorsum of the foot, loss of foot eversion, and potential foot drop and first web space sensory loss if the compartment syndrome extends proximally enough to affect the deep fibular nerve. The deep posterior compartment contains the posterior tibial artery, fibular artery, and the tibial nerve. Increased pressure in this compartment can cause symptoms like loss of plantar flexion, ankle inversion, and toe flexion, as well as loss of sensation to the sole of the foot and loss of the posterior tibial artery pulse on palpation. The superficial posterior compartment contains the major muscles of plantar flexion, but no major arteries or nerves. Therefore, the superficial posterior compartment is less likely to develop compartment syndrome. Symptoms include local pain and tenderness on palpation. Diagnosis can be confirmed by measuring compartment pressures using needle pressure measurements, but only if this doesn't delay treatment. Blood work such as serum creatinine kinase and inflammatory markers such as CRP can help determine the extent of muscle damage. A urinalysis showing tea-colored urine, indicating myoglobinuria, may also indicate compartment syndrome. Treatment starts with removing anything that might cause external pressure on the compartment. This includes any dressing, splint, cast, or even tight-fitting clothing. Next, symptomatic management and monitoring is done in case this is not a true compartment syndrome. If compartment syndrome is diagnosed, emergent fasciotomy of all 4 compartments is done. This is when incisions are made in the fascial septa surrounding the compartments to release the pressure, either at the bedside or in the operating room. Amputation might be a last resort in some cases. Now, let's quickly look at medial tibial stress syndrome, also known as shin splints, which describes pain felt at the mid to distal tibial shaft due to inflammation. Shin splints result from repetitive microtrauma of the tibialis anterior muscle and its periosteal attachment point on the anterior tibia, resulting in edema and swelling, and is similar to the microtrauma mechanism suffered in tennis and golfer's elbow. Frequent runners or walkers experience shin splints, or sedentary individuals who suddenly take up running or walking. Clinically, those with shin splints get diffuse pain around the medial surface of the distal 2/3 of the tibial shaft during exercise or overuse. Now, for a quick break, can you remember the 6 Ps that help you recognize compartment syndrome clinically? Okay, now let's switch gears and look at ankle sprains, which is one of the most common lower limb injuries. They occur when the ligaments that support the ankle stretch beyond their limits, resulting in injury. Ankle sprains can affect any of the ligaments supporting the ankle joint, but they typically affect ligaments on the lateral side. So, starting with lateral ankle sprains. Lateral ankle sprains typically occur when the ankle is forced into extreme inversion and plantar flexion. The most common lateral ankle sprain is an isolated injury to the anterior talofibular ligament. This injury commonly affects athletes. Think about jumping up in basketball and landing on someone else's foot. Ouch! In severe ankle sprains, there can be an associated fracture of the lateral malleolus. Medial ankle sprains, on the other hand, occur when the ankle is forced into eversion. Medial ankle sprains typically affect the deltoid ligament complex, however, this complex is strong and not commonly injured. Due to the strength of the deltoid ligament complex, medial ankle sprains are often associated with avulsion fractures of the medial malleolus. Finally, a syndesmotic sprain, or high ankle sprain, can be caused by excessive dorsiflexion with or without excessive eversion. This is because the anterior talus is wider, and dorsiflexion causes this area to wedge upwards into the ankle mortise, between the tibia and fibula. This causes injury to the syndesmotic structures, which include the anterior, posterior, and transverse tibiofibular ligaments, and the interosseous membrane. Now, severe sprains can lead to ankle fractures. One example of this is a common fracture pattern called a pot fracture, which typically occurs when the ankle is forced into eversion. When this occurs, the strong medial deltoid ligament complex causes avulsion fracture of the medial malleolus, and the lateral movement of the talus either fractures the fibula, typically above the tibiofibular syndesmosis, or fractures the lateral malleolus. Additionally, the posterior margin of the distal tibia may also become fractured, resulting in what is called a trimalleolar fracture. Diagnosis of a pot fracture can be confirmed with anterior and lateral X-rays, which can show if there is unimalleolar, bimalleolar, or trimalleolar fracture. Let's continue with calcaneal tendon rupture, more famously known as Achilles tendon rupture. Now, the calcaneal, or Achilles tendon, is formed when the soleus, plantaris, and gastrocnemius muscles merge as a common tendon before inserting on the posterior surface of the calcaneus. Now, the tendon tends to rupture where its blood supply is poorest, 2 to 3 inches above its insertion point. Rupture usually occurs with sudden muscle contraction, for example, where there is rapid acceleration, deceleration, and sudden pivoting of the foot in activities such as tennis, running, or sprinting, which place a large stress on the tendon. Individuals with prior Achilles tendonitis or calcifications are at an increased risk of rupture as well. Other risk factors that predispose someone to tendon rupture are those with a sedentary lifestyle who markedly and suddenly increase their activity, vascular diseases, neuropathy, and rheumatologic diseases. Achilles tendon rupture often presents after an individual pushes off their foot, and all of a sudden their leg gives out and they may describe hearing an auditory pop similar to a gunshot. Then, individuals often experience severe acute pain and are often unable to plant or flex their ankle. On inspecting the region of the Achilles tendon, there might be bruising, swelling, crepitus, and palpable defect in the Achilles tendon if a complete rupture has occurred. The calf squeeze, or Thompson test, can be used to assess for Achilles tendon rupture. To perform the test, the individual lies on their belly with their feet hanging off the examination table. Then the clinician squeezes the gastrocnemius muscle. If the ankle plantar flexes, the tendon is intact. If the ankle does not plantar flex, the tendon has been compromised. Okay, so just for a quick break before the recap, can you recall what's the most commonly affected ligament in ankle sprains? Alright, as a quick recap, tibial nerve injury can occur at the popliteal fossa of the knee, resulting in deficits in plantar flexion and inversion of the foot, as well as intrinsic foot muscle weakness and paresthesia at the sole of the foot. Tibial nerve injury can occur at the tarsal tunnel, where plantar flexion and inversion is maintained, but there are deficits to the intrinsic muscles of the foot and paresthesia at the sole of the foot. Common fibular nerve injury typically results from compression or injury at the fibular head and neck. Signs and symptoms include transient foot drop, steppage gait, and sensory loss over the dorsum of the foot and lateral shin, along with weakness in foot eversion. Tibial fractures commonly affect the mid to distal third of the tibia, but less frequently affect the proximal third. Common complications of tibial fractures are compound fractures, comminution, tibial plateau injury, and compartment syndrome. Compartment syndrome typically affects the anterior compartment of the leg and compresses the surrounding muscle, nerve, and vasculature, which may lead to ischemia and irreversible muscle and nerve damage. Classical findings of ischemia are the 6 Ps: pain, pallor, paresthesia, paralysis, palpable swelling, and pulselessness. Medial tibial stress syndrome, or shin splints, is inflammation and edema resulting from overuse and microtrauma of the tibialis anterior attachment on the anterior tibia. Ankle sprains most frequently present as injury to the lateral ankle ligaments caused by excessive inversion of the plantar flexed foot. Ankle sprains can be complicated by fracture, such as a pot fracture. Calcaneal tendon rupture occurs with sudden muscle contraction, especially in sports requiring rapid acceleration, deceleration, and sudden pivoting. Individuals present with sharp, excruciating pain in the posterior ankle with the inability to plantar flex the ankle and may hear a loud, audible pop.
At Osmosis, we are not too sure where the phrase break a leg comes from, but we're pretty sure it's not meant to be taken literally. In this video, we're going to discuss the anatomy behind the clinical conditions affecting the hip, gluteal region, and thigh. And we hope you won't even break a sweat learning these conditions, let alone a leg. Let's start with femoral neck fractures, often simply called hip fractures. They can be classified as intercapsular or extracapsular fractures, based on their anatomic location. Intercapsular fractures occur in the region of the femoral head and neck within the joint capsule of the hip, while extracapsular fractures occur outside the fibrous joint capsule, anywhere in the intertrochanteric or subtrochanteric area of the femur. Hip fractures are typically caused by mechanical falls or a trauma, such as a car crash. And while they can affect anyone, they're more likely to occur in the elderly because of associated conditions such as osteoporosis or vitamin D and calcium deficiency. The classic presentation of a hip fracture is an individual who presents after a fall and has an acutely shortened, externally rotated leg on physical examination, compared to the contralateral side. This is due to the attachment points and pull of the iliopsoas and gluteus muscles. Other clinical features of a hip fracture include hip or back pain, joint deformity, and inability to bear weight. Intercapsular fractures are at risk of avascular necrosis and displacement of the femoral head, whereas extracapsular fractures are less likely to undergo avascular necrosis. See, with an intracapsular hip fracture, the retinacular arteries, branching mainly from the medial circumflex femoral arteries, are disrupted, resulting in potential avascular necrosis to the femoral head, as the artery within the ligament to the head of the femur isn't able to ensure adequate blood supply on its own. Conversely, with extracapsular femoral neck fractures, these arteries are not disrupted and maintain their function. Confirming the diagnosis of a hip fracture usually relies on anterior, posterior, and lateral hip x-rays. But if x-rays are inconclusive in the context of strong clinical suspicion, a CT scan can be done. On imaging, intracapsular fractures can be identified by a loss of Shenton's line, a line drawn from the inferior border of the superior pubic rami along the inferomedial border of the neck of the femur. Other features of an intracapsular fracture include a prominent lesser trochanter due to external rotation of the femur compared to the contralateral side, and shortening or angulation of the femoral neck. Extracapsular fractures, on the other hand, are typically intertrochanteric fractures extending between the greater and lesser trochanter, or subtrochanteric fractures found distal to the trochanters in the subtrochanteric region. Management of intracapsular and extracapsular hip fractures is typically surgical, and the choice depends on the surgeon. It can be done using open reduction and internal fixation, or ORIF for short, which is a type of open surgery where the fractured bone is put back together using screws, plates, intramedullary rods, or a combination of these. Arthroplasty can also be done, and that's when the femoral and acetabular components of the hip joint are either totally or partially replaced. Finally, a rare complication of hip fractures is sciatic nerve damage. See, the sciatic nerve runs close to the posterior aspect of the hip joint, and fracture at this site can injure the sciatic nerve and result in paresthesia of the sciatic nerve dermatomal distribution, as well as weakness in knee flexion, ankle dorsiflexion, and ankle plantar flexion. Other complications of hip fracture include chronic pain, non-union, future arthritic changes of the associated hip joint, and dislocation. Speaking of which, let's talk about hip dislocation, which occurs when the femoral head is forced out of the acetabular socket, either anteriorly or posteriorly. Hip dislocations are typically caused by a traumatic injury, such as a head-on motor vehicle collision. Posterior dislocations are the most common, amounting to 90% of dislocations. An example of this is a dashboard injury due to a high-velocity car accident, where the hip is forced into flexion, adduction, and internal rotation due to the dashboard of the car as it pushes back on the flexed hips during a head-on collision. On the other hand, hyperabduction with extension will produce anterior dislocation, especially in motorcycle crashes, where the legs are hyperabducted while riding. Individuals with hip replacements are at an increased risk of hip dislocations, as well as with a higher chance of posterior dislocation. Individuals suffering a hip dislocation may also hear an audible pop or clunk as the femur comes out of its socket, in addition to pain and inability to bear weight. On examination of a posterior dislocation, there can be shortening and internal rotation of the affected limb, whereas an anterior dislocation presents with shortening and external rotation. Diagnosis is confirmed by X-ray. Hip dislocations, especially posteriorly, can also damage the sciatic nerve, and other complications include labral tears, which is when the ring of fibrocartilage surrounding the hip joint gets torn, and associated hip fracture. Hip hip hooray! Let's take a quick break and remember the most common complications of hip fractures. Now, another issue in the hip area can be trochanteric bursitis, or greater trochanteric pain syndrome, which is when the small bursa that covers the greater trochanter becomes inflamed. Trochanteric bursitis is usually the result of repetitive actions, such as climbing stairs, because repetitive movements cause the tendons from the gluteus medius and minimus to compress the trochanteric bursa against the greater trochanter, resulting in inflammation. Diagnosis is based on clinical symptoms, such as chronic pain in the lateral thigh and point tenderness over the greater trochanter. Pain can also be elicited by manually resisting abduction of the thigh while the person is lying on the unaffected side. Now, let's switch gears and talk about the femoral artery pulse. You can locate the femoral artery as it enters the femoral triangle by palpating distal to the inguinal ligament at the mid-inguinal point, which is halfway between the pubic symphysis and anterior superior iliac spine. It's a good idea to remember this, because feeling the femoral pulse can give us a good idea of blood flow to the limb in case of peripheral artery disease, and also because it's a significant place for catheterization during therapeutic and diagnostic procedures. For example, the femoral artery can be used for cardiac catheterization for both diagnostic angiography and for therapies like stent placement. Speaking of cardiac catheterization, one complication to be aware of is retroperitoneal hemorrhage. This can occur if the posterior wall of the common femoral artery is punctured, allowing blood to track into the retroperitoneal space. Additionally, before crossing distal to the inguinal ligament, the common femoral artery is a continuation of the external iliac artery. If arterial puncture is done above the inguinal ligament, there is a higher risk of retroperitoneal hemorrhage, as this area is directly inferior to the peritoneum. Retroperitoneal hemorrhage is a potentially deadly condition because external compression can't be applied on the retroperitoneal space. So without surgery, the affected individuals can bleed to death. Clinical signs to recognize include hemodynamic instability, such as hypotension and pallor, pain on the affected flank, and a significant drop in hemoglobin. The femoral artery is also prone to injury due to its anatomical location close to the femur, as proximal femur fractures or hip surgery can result in femoral artery injury. Additionally, due to its superficial position within the femoral triangle, the artery can also be easily lacerated during traumatic events. Now let's move on to varicose veins, which can develop because of venous insufficiency. With venous insufficiency, blood begins to pool in the veins of the leg rather than return to the heart, and in time, the veins become varicose or dilated. This can cause complications such as painful thrombosis, edema, as well as cosmetic issues. One test that helps diagnose and characterize venous insufficiency is the Trendelenburg test, or the tourniquet test. When performing this, the individual lies on their back, and the affected leg is then raised above their head, where the veins of the leg are massaged or milked down towards the groin. After the veins of the leg have been drained manually, with the leg still elevated, a tourniquet is placed around the thigh at the saphenous opening, and the individual is asked to stand up as the examiner is observing the limb for any signs of the varicose veins reappearing. If the varicose veins do not reappear when the tourniquet is at the saphenous opening, this indicates the incompetence resulting in the venous insufficiency is at the saphenofemoral valve, and the tourniquet is acting as a valve. If the varicose veins pop up again, this indicates the problem is distal to the level of the tourniquet, as the veins are filling again. Therefore, the incompetent valve is lower down. One common condition associated with varicose veins is saphenovarix, which is a dilation of the saphenous vein at its junction with the femoral vein in the groin. Clinically, individuals can present with a groin swelling the size of a golf ball, which enlarges with increased intra-abdominal pressure, like when coughing. However, bear in mind that a femoral hernia also becomes apparent when asking a patient to cough, so a saphenovarix is commonly mistaken for an inguinal hernia. Characteristic features for a saphenovarix include a bluish tinge and typically disappears when lying down. Speaking of the saphenous veins, it's also worth mentioning that they're also the main venous graft sites for things such as coronary bypass surgery in coronary artery disease. Both the great and the small saphenous vein can be used, with the great saphenous vein being the more popular choice, because it's superficial and easy to access. It's long enough to take a piece from it without affecting the blood flow to the area, and it has a wall rich in muscular and elastic fibers. One complication during great saphenous vein harvesting is saphenous nerve injury, as the saphenous nerve accompanies the great saphenous vein as they travel distally, so it can be accidentally cut during the procedure. Injury of the saphenous nerve can cause pain or numbness along the medial border of the lower leg and foot. Now let's take a quick break and see if you can recall the clinical findings with a saphenous-varix. Okay, now let's discuss intramuscular injections. See, the lower limb is one of the preferred sites for intramuscular administration of medication because of large muscles that have numerous blood vessels, making absorption faster than subcutaneous injections. One of the most popular intramuscular injection sites is the gluteal region, specifically the superolateral quadrant of the buttock. The superolateral quadrant of the buttock is used for large volume and more viscous injections. The superolateral area is located above the line extending from the posterior superior iliac spine to the superior border of the greater trochanter. To mark this area, the index finger is placed on the anterior superior iliac spine, with the fingers spreading posteriorly along the iliac crest, until the tubercle of the crest is felt by the middle finger. The injection can then be given safely in the triangle between the fingers, just anterior to the proximal joint of the middle finger, to avoid injuring the sciatic nerve. Also note that the supromedial quadrant of the buttock should always be avoided, as you are at risk of injuring the sciatic nerve and the major blood vessels that pass through the area. Another nerve that can be damaged in the supromedial quadrant is the superior gluteal nerve, which is important as the superior gluteal nerve innervates the gluteus medius, gluteus minimus, and tensor fascia lata, which all function to stabilize the pelvis and abduct the thigh. Injury to the superior gluteal nerve results in the presentation of a Trendelenburg gait, not to be confused with the Trendelenburg venous insufficiency test. Trendelenburg gait is characterized by tilting of the pelvis towards the unaffected side when the patient stands on the affected leg, as the abductors of the affected hip cannot keep the contralateral hip up, indicating a positive Trendelenburg sign. With Trendelenburg gait, the patient leans towards the side of the affected superior gluteal nerve in order to compensate and maintain balance. Other causes of a Trendelenburg gait include gluteus medius and gluteus minimus weakness, resulting from things such as osteonecrosis of the hip, Legg-Calvé-Perthes disease, developmental dysplasia of the hip, non-union of femoral neck fractures, and hip surgery. Other nerve injuries of the lower limb include meralgia paresthetica, which is a condition caused by entrapment of the lateral femoral cutaneous nerve, as it passes distal to the inguinal ligament. This nerve supplies sensory innervation to the skin of the anterolateral and lateral aspects of the thigh, and can become impinged in those who are pregnant, obese, or wear tight clothing. It can also be affected in conditions like diabetes mellitus or hip replacement surgery. Symptoms include pain, burning, numbness, and coldness over the anterolateral aspect of the thigh, especially when using the affected limb or sitting. Next, piriformis syndrome refers to piriformis muscle injury, or hypertrophy, resulting in sciatica-like symptoms. This occurs because the sciatic nerve runs inferior to the piriformis muscle and can become compressed. Piriformis syndrome is characterized by pain, tingling, and numbness in the buttocks and sciatic nerve distribution. Piriformis syndrome can develop following trauma to the buttocks or piriformis muscle strain, leading to scarring and fibrosis around the nerve. The wallet sign is often associated with piriformis syndrome, and it's when an individual can no longer sit on their wallet without it causing symptoms. Now that we have talked about vessels and nerves, let's move on to muscles. One of the more common injuries we encounter are muscular strains and tears. First, hamstring strains typically occur because of overuse, so they're common in active individuals, such as professional athletes. They can also occur because of inadequate warm-up before activity, muscle fatigue, and trauma. These types of injuries can occur when there is forced flexion of the hip when the hip and knee are extended, for example, when kicking a football. Hamstring strains can be mild, causing only minimal clinical consequences, like pain and swelling, with little functional loss. However, complete tears of the muscle can cause severe pain, significant loss of knee flexion, and associated large muscle hematomas. Very severe hamstring injuries can even tear or cause an avulsion fracture of the ischial tuberosity, where the proximal tendons attach. And lastly, let's go over quadriceps tendon tears, which can occur during sudden, forceful contraction of the quadriceps muscle during a deceleration from a fall or athletic activities. Quadriceps tendon injuries can be classified in relation to the patella as either proximal or distal to the patella. Injury can occur proximally at the quadriceps tendon, causing a palpable defect proximal to the patella, which may potentially cause the patella to be pulled down. Or injury can occur distal to the patella, within the patellar ligament, where the palpable defect is below the patella, and the patella may be pulled upwards. Clinical findings include pain, inability to bear weight, and loss of knee extension, rapid knee effusion, and a loud pop as the injury occurs. Risk factors for tendon tears include anabolic steroid abuse, hypoparathyroidism, and chronic kidney disease. We made it to the end! Before the recap, can you recall the main site in the lower limb where intramuscular injections can be administered? All right, as a quick recap, hip fractures can be intracapsular or extracapsular. And the latter can be either intertrochanteric or subtrochanteric. Diagnosis should always be confirmed by hip X-rays or CT. Hip dislocation is when the ball of the hip joint is pushed out of the socket, either anteriorly or posteriorly, which is more common, and may be complicated by fracture or sciatic nerve injury. Trochanteric bursitis presents with deep diffuse pain in the lateral thigh region and point tenderness over the greater trochanter. The femoral pulse is best palpated distal to the inguinal ligament at the mid-inguinal point. The femoral artery can also be injured during catheterization, proximal femur fractures, hip surgery, or lacerated during traumatic events. Complications of femoral artery catheterization include retroperitoneal hemorrhage, with a greater risk if the artery is punctured proximal to the inguinal ligament. Varicose veins can be diagnosed using the Trendelenburg test. A saphenous is a dilation of the great saphenous vein at its junction with the femoral vein in the groin. With saphenous vein grafting, the great saphenous vein is usually used because it's easy to access, long, and because its wall is rich in muscular and elastic fibers. Intragluteal injections can be administered in the supralateral quadrant of the buttock. Trendelenburg gait refers to aberrant hip abduction and a drooping of the pelvis on the contralateral side while weight-bearing on the affected side. This can be due to weakness of the gluteus medius and minimus muscles after damage to the superior gluteal nerve. Meralgia paresthetica, or impingement of the lateral femoral cutaneous nerve, causes symptoms such as pain, burning, numbness, and coldness over the anterolateral aspect of the thigh. Piriformis syndrome causes gradual pain located around the buttocks that increases with sitting and can present with sciatica-like symptoms. Hamstring strains as well as quadriceps tendon tears can frequently occur in highly active individuals, usually due to overuse, inadequate warm-up, fatigue, trauma, or poor biomechanics. The foot is the most distal part of our lower limbs, and while it represents only a small part of the body, its unique structure allows for walking, running, and dancing, but is also an unfortunate vulnerable point for being tickled. Laughing aside, let's kick off this video, which will focus on the clinical conditions affecting the foot. First, let's talk about plantar fasciitis. Plantar fasciitis describes inflammation of the deep plantar fascia, also called the plantar aponeurosis. The deep plantar fascia is a thick, pearly white band of tissue that attaches to the medial process of the calcaneal tuberosity and extends to the toes and supports the medial longitudinal arch of the foot. Excessive training, particularly those who frequently run, jog, or walk, can cause repetitive microtrauma. This leads to inflammation of the plantar fascia, particularly at its attachment point to the calcaneus. Additionally, individuals who undergo high-impact exercise, like jumping and volleyball, or frequently train in bare feet, may also experience plantar fasciitis. Risk factors for plantar fasciitis include obesity, prolonged standing or working on hard surfaces, and pes planus, which is flat feet, defined by the loss of the medial longitudinal arch of the foot where it contacts the ground. Diagnosis of plantar fasciitis is often clinical, and it commonly presents in middle-aged adults. Individuals typically present with unilateral or bilateral heel pain that is worse in the morning and after prolonged rest, and gradually lessens with activity. The pain is typically palpated over the medial process of the calcaneal tuberosity, but can be felt along the length of the sole of the foot, while pain can also be felt on passive dorsiflexion of the toes. Heel spurs often coexist with plantar fasciitis, but it is also unclear whether they can cause plantar fasciitis or represent a secondary response to an inflammatory reaction. Let's talk a bit more about pes planus, also known as flat feet, and is a term used to describe loss of the foot's medial longitudinal arch. Flat feet can be classified as either flexible, meaning they have normal appearance at rest, but flatten with weight bearing, or rigid, which appear flat even when not weight bearing, and has a reduced range of motion at the tarsal and subtalar joints. After birth, the appearance of flat feet is normal due to ligamentous laxity and a thick subcutaneous fat pad of the sole of the foot, and the most common type is flexible pes planus. Furthermore, conditions that may lead to congenital ligament laxity and exacerbate pes planus include Down syndrome, Marfan syndrome, or Ehlers-Danlos syndrome. Typically, flexible pes planus resolves. As kids age, their fat pad is lost. The lax ligaments grow and mature. The medial longitudinal arch of the foot becomes visible, and a normal arch develops. However, there are many kids whose pes planus doesn't resolve. This leads to acquired pes planus, which persists into adulthood. though pes planus can also develop in adulthood without pre-existing pes planus as a child. Acquired pes planus is thought to be due to the breakdown of the foot-supporting structures, such as the tibialis posterior tendon, which provides dynamic support of the medial longitudinal arch, and the plantar calcaneonavicular ligament, also known as the spring ligament. The breakdown of these structures may be due to obesity, trauma, degenerative or inflammatory arthropathies such as rheumatoid arthritis, or denervation such as a neuropathy caused by conditions like diabetes, all leading to a loss of the foot's medial longitudinal arch. Now, pes planus is mostly asymptomatic, especially in children, but when it is problematic, it typically presents with arch pain. However, in time, it can alter the biomechanics of the lower limbs and lumbar spine, causing pain or discomfort in the midfoot, heel, lower leg, knee, hip, and back. On examination, there's evidence of flat feet during rest, or excessive pronation of the feet during standing. One test that can be done is looking at the individual from the back and looking for the too many toes sign. From this view, only the fourth and fifth toe should normally be seen. But with flat feet and excessive pronation, more toes will be seen. Let's switch gears and discuss hallux valgus, which is characterized by a valgus deformity of the big or great toe, and famously referred to as a bunion. Hallux valgus occurs when the proximal phalanx of the great toe deviates laterally on the first metatarsal, which deviates medially. Think of the L in valgus to remind you of lateral deviation. Furthermore, there may be internal rotation of the toe, so the toenail on the big toe faces medially. And as the big toe rotates medially, the sesamoid bones shift laterally, limiting their function. Now, its exact etiology is unclear, and the case of hallux valgus is likely multifactorial. It is most common in biological females, and its incidence increases with age. And risk factors include genetic predisposition, ligamentous laxity, inflammatory joint disease such as rheumatoid arthritis, pes planus, abnormal gait, and wearing poor footwear such as high heels. Hallux valgus has a chronic and progressive onset, and even though it may be asymptomatic, individuals often present with difficulty wearing their shoes due to the pronounced medial protrusion of their toe. The pain associated with hallux valgus is chronic, sharp, and often exacerbated by walking. The deformity is often obvious on examination, and the skin overlying the medial metatarsophalangeal joint can become red and painful due to inflammation of the subcutaneous bursa protecting the joint, and it is this area that is considered the bunion. The individual may also complain of a burning sensation on the dorsal side of the deformity due to compression on the medial dorsal cutaneous nerve. As the hallux valgus deformity progresses, so does the pain and the size of the deformity. Blisters, ulcerations, and irritated skin adjacent to the deformity can also be present on examination, as can limited toe mobility. Finally, inflamed, thickened areas of skin can develop over the proximal interphalangeal joints of the other toes due to the altered mechanics of the foot, often over the little toe, and these are called corns. Okay, quiz time! Can you recognize these three conditions? Now, let's discuss the lymphatic drainage of the lower limb, as damage to the lymphatic drainage can lead to something called Lymphadenopathy. Lymphadenopathy is a common condition, and it represents an abnormality in size, number, or consistency of lymphatic nodes within the body, and can be caused by things such as infection or malignancy. The lower limb has both superficial and deep lymphatic vessels. The superficial lymphatic vessels follow the venous system, and they receive lymph from the skin and the subcutaneous tissue of the lower limb. Now, the superficial system is further divided into a medial and lateral tract. The medial tract accompanies the great saphenous vein until it reaches the superficial inguinal lymph nodes and bypasses the popliteal lymph nodes. As a consequence, medial foot infections can cause inguinal lymphadenopathy. Alternatively, the lateral tract, which drains lymph from the lateral leg and foot, drains into both the popliteal and the inguinal nodes. So infections of the lateral foot cause popliteal lymphadenopathy and eventually inguinal lymphadenopathy. The deep lymphatic vessels of the lower limb follow arteries and enter popliteal lymph nodes as well, and they receive lymph from the muscles and deep vessels of the lower limb. And finally, let's touch on the posterior tibial and dorsalis pedis pulses. Let's start with the posterior tibial pulse. Okay, so the posterior tibial artery arises from the popliteal artery at the lower margin of the popliteus muscle. It then descends medially through the posterior compartment of the leg and enters the foot by passing posterior to the medial malleolus. Now, the posterior tibial pulse can be palpated by pressing your fingers posterior to the medial malleolus, in the space between the medial malleolus and the Achilles tendon, just above the calcaneus. Furthermore, passively have the individual invert their foot, which will relax the flexor retinaculum in order to better palpate the artery. Next is the dorsalis pedis pulse. The dorsalis pedis artery is a continuation of the anterior tibial artery, which passes anterior to the ankle joint midway between the two malleoli and runs anteromedially. It lies deep to the inferior extensor retinaculum, lateral to the extensor hallucis longus tendon, and passes to the first interosseous space. The dorsalis pedis artery is fairly superficial and more easily palpated than the posterior tibial pulse. It can be palpated by starting at the midpoint between the two malleoli and pressing your fingers roughly a third to halfway from this point to the web space between the first and second toe, just lateral to the tendon of the extensor hallucis longus. If needed, you can ask the patient to extend their big toe to show this tendon, and you can then palpate lateral to it. Palpating these pulses is important, as a weak or absent pulse typically indicates vascular insufficiency due to arterial disease, which will cause arterial occlusions proximal to these pulses. Furthermore, obesity, edema, trauma, or other compressive lesions can result in a weak or absent pulse. Some individuals will have a congenital non-palpable pulse. However, always remember non-palpable pulses are a late sign of acute arterial occlusion and may require urgent intervention. All right, as a quick recap, plantar fasciitis is inflammation of the deep plantar fascia caused by repetitive microtrauma of the fascia. It presents with unilateral or bilateral heel pain, with pain worse in the morning and after prolonged rest. Next, pes planus represents loss of the medial longitudinal arch of the foot and can either be flexible or rigid, It typically resolves in childhood. However, it may progress to adulthood or develop in adulthood due to breakdown of the supporting structures of the medial longitudinal arch, such as the tibialis posterior muscle and spring ligament. Hallux valgus is a valgus deformity of the big toe, where it deviates laterally on the first metatarsal. It can present with an obvious medial deformity of the first metatarsophalangeal joint that gets worse with time, and is associated with pain, redness, and paresthesia. Lower limb lymphadenopathy is common in infection or malignancy. Medial foot lesions cause inguinal lymphadenopathy, while lateral lesions can cause both popliteal and inguinal lymphadenopathy. And finally, the posterior tibial pulse can be palpated by pressing your fingers posterior to the medial malleolus, in the space between the medial malleolus and the Achilles tendon, just above the calcaneus. The dorsalis pedis pulse can be palpated by starting at the midpoint between the two malleoli and pressing your fingers roughly a third to halfway from this point to the web space between the first and second toe, just lateral to the tendon of the extensor hallucis longus.
The head is one of the most complex parts of our body. Besides having an abundance of muscles, nerves, and blood vessels, it protects our brain and houses various facial structures. In this video, we'll go through a variety of conditions that can affect the skull, face, and scalp. This might not be the easiest subject to learn about, but you'll see that it's nothing to get a headache over. First, let's discuss the bones of the skull that make up the cranial vault, which as a group are also called the calvaria. We'll start from the very beginning of their development. See, the flat bones that make up the skulls of neonates have gaps between them, and these gaps are covered by fibrous membranes. These membrane-covered gaps between the bones are called fontanelles. The anterior fontanelle is a large diamond-shaped area found at the junction of the sagittal suture, coronal sutures, and frontal suture. In adults, this point where the sutures eventually come together is called the bregma. The anterior fontanelle is bordered by the frontal bone anteriorly and two parietal bones posteriorly. By 18 months of age, the bones fuse together and the anterior fontanelle closes. The posterior fontanelle is a triangular-shaped membrane found at the junction of the lambdoid sutures and sagittal suture. In adults, this point is called the lambda. The posterior fontanelle is bordered by the two parietal bones anteriorly and the occipital bone posteriorly. The posterior fontanelle usually closes during the first few months of life and is no longer palpable by the end of the first year. By palpating fontanelles before they close, bone growth and development of the skull can be assessed. How fontanelles look is also important from a clinical standpoint. For example, a depressed fontanelle can indicate dehydration, while a bulging fontanelle can signal increased intracranial pressure. Now, let's move on to bone fractures, and to start, let's remember an intersection of the skull called the pterion. This is where the frontal, parietal, temporal, and sphenoid bones meet. Now, immediately deep to the pterion is a branch of the maxillary artery called the middle meningeal artery and its branches. So, if an individual receives a hard blow to the area of the pterion, this can then fracture these bones right at that weak spot where they all meet. The fracture can then damage the middle meningeal artery, causing significant intracranial bleeding. Specifically, the bleeding occurs between the outer endosteal or periosteal layer of the dura mater and the bone. Bleeding in this layer leads to the formation of an epidural hematoma. The typical presentation of an epidural hematoma is the individual may initially lose consciousness, which can be followed by a lucid period where they may act completely normal even though the bleed is getting worse. Eventually, the individual will show signs of elevated intracranial pressure such as headache, vomiting, and decreasing mental status. Diagnosis requires a CT scan, which shows a biconvex or lentiform hyperdense mass between the endosteal or periosteal layer of the dura mater and the bone of the calvarium, which does not cross suture lines. Now, when it comes to injuries to the facial bones, some of the more common fractures are orbital blowout fractures. These can occur with motor vehicle crashes, a direct blow to the eye region, or with certain sports injuries, where in each case an external force is applied to the orbit and its contents. Since the orbit is a closed space, this external force increases the pressure within the orbit, which then leads to a fracture of its thinnest part, usually the orbital floor, which is made up mainly by the maxilla and the zygomatic bone. Since the maxillary sinus is right below the orbit, the contents of the orbit may be forced through the fractured floor and into the sinus. Usually, the inferior rectus and the inferior oblique muscles are the structures that are forced into the maxillary sinus. This can cause limited movement of the affected eye, which presents as double vision when the individual looks upwards. A branch of the maxillary nerve, called the infraorbital nerve, which travels through the orbit along its floor and emerges beneath it through the infraorbital foramen, can also be damaged. This can cause numbness in the lower eyelid, cheek, nose, upper lip, and upper gingiva. The best way to diagnose an orbital floor fracture is with a CT scan, which can show the fractured bone as well as the herniation of orbital contents into the maxillary sinus. Okay, time for a quick break. Can you identify the anterior and posterior fontanelle on this image? Also, what can a depressed fontanelle signal? Now let's switch gears and discuss the danger triangle of the face, which refers to the area from the upper lip to the bridge of the nose. Blood from this area drains through the facial vein. Usually, blood from the facial vein drains down into the internal jugular vein. However, the reason it's called the danger triangle is that the facial vein has no valves, so blood can flow through other draining branches upwards and can communicate with the cavernous sinus. One way that happens is by draining through the superior ophthalmic vein and ultimately into the cavernous sinus. Alternatively, it can drain through the inferior ophthalmic veins and then into the pterygoid venous plexus, which then ends up connecting into the cavernous sinus. This means that any infection from the danger triangle, like an abscess or cellulitis, can cause thrombophlebitis of the facial vein, which can then spread and cause intracranial infection to places such as the cavernous sinus. Finally, let's discuss some clinical correlates related to the scalp, starting with injuries that occur during birth and delivery. Injuries to the scalp are usually caused by passing through the birth canal or iatrogenically through the use of vacuum extraction. The most superficial injury is called caput succedaneum, which is a fancy way to say scalp swelling caused by venous congestion that leads to fluid collecting right beneath the skin. The swelling is superficial to the pericranium, which is the periosteum that covers the skull, so it is not limited by the suture lines that the pericranium is anchored to and can thus spread freely along the scalp. This condition is not harmful to the newborn, and the swelling is often mild, resolving on its own within a few days. Another type of injury that can occur to the scalp at birth is a subgaleal hemorrhage, which is a serious condition caused by strong traction that pulls the scalp away from the bone. This leads to a rupture of emissary veins, which connect the veins of the scalp to the dural venous sinuses within the skull. Bleeding occurs in the loose connective tissue that lies superficial to the pericranium and deep to the galea aponeurotica, also known as the epicranial aponeurosis. Since there is no strong connective tissue or sutures to limit the bleeding, it can spread through the entire scalp and even into the neck. A subgaleal hemorrhage can progress over 2 to 3 days and cause substantial blood loss. The deepest type of scalp injury at birth is a cephalohematoma, which is caused by rupture of emissary veins right below the pericranium or periosteum layer of the bone. Now, the pericranium is attached to the underlying bones, and therefore this bleeding can only spread over one bone up to the suture lines that surround it. It presents as a firm swelling on one side of the head, limited by suture lines, and so it does not spread all over the calvaria. A cephalohematoma usually resolves on its own within 2 to 3 weeks. Finally, in adults, the most common type of scalp injury is a scalp laceration, which can cause profuse, potentially fatal bleeding if left untreated due to the numerous anastomoses between the arteries of the scalp. Now, when there is a deep laceration to the scalp in the coronal direction involving the tense connective tissue of the galea aponeurotica, this laceration can be gaping and is held open by the occipital and frontal muscle bellies of the occipitofrontalis muscle. In contrast to deep scalp lacerations, which will gape, superficial scalp wounds will not gape because it won't be under tension from the muscle bellies. Keep in mind, all scalp wounds will need careful examination to see if they need sutures or staples for closure. Okay, time for a quick break. Can you label these 3 different types of scalp bleeds? Alright, as a quick recap, fontanelles are gaps between cranial bones spanned by fibrous membranes. The anterior fontanelle is bordered by the frontal bone and 2 parietal bones, and it closes by 18 months of age. The posterior fontanelle is bordered by the 2 parietal bones and the occipital bone, and it closes by the end of the first year of life. A depressed fontanelle can indicate dehydration, while a bulging one can signal increased intracranial pressure. Fractures of the pterion can damage the middle meningeal artery or its branches, causing an epidural hematoma. Clinically, an epidural hematoma presents with initial loss of consciousness, followed by a lucid period, after which mental status decreases. Diagnosis requires a head CT. Orbital floor fractures can cause herniation of the inferior rectus and the inferior oblique muscles into the maxillary sinus, as well as damage to the infraorbital nerve. The danger triangle of the face includes the area from the upper lip to the bridge of the nose, which is drained by the facial vein. The facial vein is valveless and is connected to the cavernous sinus, so any infection from the danger triangle can spread to the cavernous sinus. Types of scalp injuries at birth include caput succedaneum, subgaleal hemorrhages, and cephalohematomas. Scalp lacerations can be deep, which will gape, or superficial, which do not gape.
The face is made up of a large network of nerves, vessels, muscles, and other structures which are susceptible to disease. In particular, there are many clinical conditions that can affect the temporal region, oral cavity, and nose. Understanding the anatomy of these areas can help us better understand the clinical presentation, complications, and management of these conditions. So, let's get face to face with our face. First up, the parotid gland. Remember that the facial nerve enters the parotid gland to form the parotid plexus and give rise to the temporal, zygomatic, buccal, marginal mandibular, and cervical branches. However, these branches don't actually innervate the gland, but they just pass through it to exit at its borders. The auriculotemporal nerve, which is a branch of the mandibular nerve, courses superficially to the gland and is responsible for general sensation of the gland. Additionally, parasympathetic innervation from the glossopharyngeal nerve travels with the auriculotemporal nerve to innervate the parotid gland. Now, understanding these anatomical relationships is also important when it comes to surgery to the parotid gland, as the majority of salivary gland tumors occur within the parotid gland, which are often surgically removed. During parotid gland surgery, the surgeon needs to identify, dissect, and isolate the facial nerve and its branches with great care, so that there's no damage to them. See, if the nerve or one of its branches is damaged, that causes paralysis of some or all of the facial muscles on that side. The auriculotemporal nerve also requires special care to avoid damaging it during surgery, because during healing, the nerve can go on to re-innervate into the sweat glands of the overlying skin. So, instead of salivating when eating or thinking about food, this re-innervation causes excessive sweating and redness of the cheek during the normal parasympathetic response. This condition is called Frey syndrome. Now, let's move a bit up and talk about the temporomandibular joint, starting with dislocations. The temporomandibular joint can be dislocated in multiple directions, with the most common being anterior dislocation. This is when the condyle of the mandible is displaced anteriorly from its articulation within the mandibular fossa of the squamous portion of the temporal bone. It most commonly occurs when there is extreme jaw opening, causing excessive translational movement, and can occur when yawning, having a seizure or dental procedure, or undergoing intubation. A traumatic force to the jaw, especially when the mouth is open, can result in dislocation to the side of the blow. Posterior dislocations, on the other hand, are very rare because the postglenoid tubercle, with help from the strong intrinsic lateral ligament which holds the joint together, limit posterior movement. Any dislocation of the TMJ can also be accompanied by fractures of the mandible, and it can result in stretching of the surrounding ligaments causing pain, as well as spasm of the mastication muscles, particularly the lateral pterygoids, which can actually prevent the joint from popping back into place on its own. In this case, a manual reduction is required. If surgery is needed, damage to the overlying facial nerve and auriculotemporal nerve and its TMJ articular branches may occur. Damage to the articular branches of the TMJ can lead to joint laxity and instability. Common clinical features of temporomandibular joint dislocation include the inability to close the mouth, difficulty speaking, drooling, and pain in front of the ear. On the other hand, temporomandibular joint disorder is an umbrella term that refers to many conditions affecting the joint itself and the muscles of mastication, where the etiology is multifactorial. Typical symptoms include jaw tenderness, jaw pain that worsens with opening the mouth, difficulty opening and closing the mouth with clicking, headaches, and neck stiffness. Repetitive jaw motions, such as gum chewing, as well as clenching and grinding of the jaw, is considered a leading cause of temporomandibular joint disorder. Other causes involve trauma and jaw misalignment. TMJ disorder may be associated with hypersensitivity of the mandibular nerve, which can cause pathologic contraction of the pterygoids and masseter muscles, exacerbating pain and jaw dysfunction. Furthermore, in addition to supplying the TMJ, the mandibular nerve also provides cutaneous innervation to the ear and external auditory canal. Therefore, TMJ disorders can result in otalgia due to referred pain to the ear. Time for a quick break. What structures can be damaged during parotid gland surgery? And what is the most common type of TMJ joint dislocation? Great. Now, let's switch gears and look at the oral cavity. Surgery of the oral cavity is not uncommon. Whether it's a third molar extraction, dental implant surgery, or tumor removal, care must be taken to preserve the inferior alveolar nerve. As a little reminder, this nerve passes through the mandibular canal and provides innervation to the mandibular molar and premolar teeth, and the surrounding gingiva. It continues as the mental nerve, which innervates the anterior teeth and the surrounding gingiva, the skin of the chin, and the lower lip. Because of its close relation to the teeth, the inferior alveolar nerve is the most commonly injured nerve during oral surgery. Symptoms usually include paresthesia, complete numbness, or pain in the teeth, gingiva, chin, and lower lip. However, numbness in this area isn't always a bad thing. For example, an inferior alveolar nerve block is a common anesthetic method to reduce pain during dental procedures, where a local anesthetic agent is injected near the mandibular foramen to numb the inferior alveolar nerve. Specifically, the needle is inserted between the two important landmarks, the coronoid notch and the pterygomandibular raphe. This way, the mandibular teeth, gingiva, lower lip, and chin are anesthetized. Part of the tongue can be anesthetized as well, because the anesthetic may also bath the lingual nerve. Another commonly used nerve block is the greater palatine nerve block. In this case, the anesthetic is inserted at the greater palatine foramen. This way, all of the palatal mucosa and lingual gingiva posterior to the maxillary canines and underlying bone of the palate of one side are anesthetized. The third type of block is the nasopalatine nerve block. The anesthesia is inserted into the nasopalatine foramen. This block anesthetizes the palatal mucosa, gingiva, and the 6 anterior maxillary teeth. Okay, let's take another quick break. Can you recall the most commonly injured nerve during oral surgery? Also, which 2 landmarks help identify it for a nerve block procedure? Finally, let's discuss some clinical correlates related to the nose. First up, there are nosebleeds, or epistaxis, which are very common due to the highly vascular nasal mucosa. Anterior nosebleeds are much more common and originate from an area called the Kieselbach plexus, which is a watershed area formed by the anastomosis of the superior labial artery branches, the anterior and the posterior ethmoidal arteries, the greater palatine artery, and the sphenopalatine artery. A good memory trick for this is to remember that Kieselbach drives his plexus with his legs, where legs stands for labial artery, ethmoidal arteries, anterior and posterior, greater palatine artery, and sphenopalatine artery. Posterior nosebleeds are not as common, but they're more dangerous than anterior nosebleeds, as they are much more difficult to control and can cause substantial blood loss. Arteries involved are often the sphenopalatine artery and the posterior ethmoidal arteries. Switching gears a little bit, remember that the nasal cavity has numerous connections to nearby surrounding spaces. This is important, as nasal congestion can cause inflammation and swelling of the mucosa close to these openings, meaning these structures cannot drain properly, resulting in potential infection or spread of infection. So why don't we take a look at the different connections of the nasal cavity? First off, the roof of the nasal cavity has a direct connection to the anterior cranial fossa through the cribriform foramina. Then, there are the sphenoid sinuses, which open into the sphenoethmoidal recess, which is superior posterior to the superior concha. As a side note, this anatomic relationship is important because the sphenoid sinuses are in close proximity to the hypophyseal fossa, which contains the pituitary gland. Because sphenoidal sinuses are made of thin bone, pituitary tumors can be assessed and resected through the nose through this connection during a procedure called transsphenoidal resection. Now, back to what drains into the nasal cavity. The frontal sinuses and anterior ethmoidal cells drain into the nasal cavity through the ethmoidal infundibulum, which opens into the semilunar hiatus of the middle nasal meatus. Middle ethmoid cells open directly into the middle meatus, and posterior ethmoidal cells open directly into the superior meatus. Next, the maxillary sinuses open into the middle meatus through the semilunar hiatus through one or more maxillary ostia. We also have the lacrimal apparatus, which drains into the anterior part of the inferior nasal meatus. Posteriorly, the nasal cavity is continuous with the nasopharynx through large openings called choanae. The pharyngotympanic tube also opens up into the nasopharynx posterior to the inferior nasal meatus. Because of these connections, infections from the nasal cavity can spread to any of these regions. Most commonly, infections spread to the maxillary sinuses because their openings are small and can be easily obstructed when the surrounding nasal mucosa is congested. Also, because of their high draining location, it's difficult for the maxillary sinuses to drain properly when the head is upright or when lying on your side, as the ostia are directed towards one another. So, when lying on the side, only the top sinus can drain. Alright, as a quick recap. During parotid gland surgery, injury can occur to the facial nerve as it passes through the gland and the auriculotemporal nerve as it passes superficial to the gland. If the facial nerve or one of its branches is damaged, this can cause facial muscle paralysis on that side. If the auriculotemporal nerve is damaged, that can cause Frey syndrome. Anterior dislocation is the most common type of temporomandibular joint dislocations. Temporomandibular joint disorder refers to any of the conditions causing dysfunction of the temporomandibular joint and surrounding muscles, and are often caused by repetitive jaw motions or clenching of the teeth. Surgery of the oral cavity can damage the inferior alveolar nerve, resulting in paresthesia, numbness, and pain in the teeth, gingiva, chin, and lower lip. During dental procedures, local nerve blocks can be done through an inferior alveolar nerve block, greater palatine nerve block, or nasopalatine nerve block for pain control. Anterior nosebleeds are the most common type of nosebleed and originate from the Kieselbach plexus, which is an anastomosis between the superior labial artery branches, the anterior and the posterior ethmoidal arteries, the greater palatine artery, and the sphenopalatine artery. Posterior nosebleeds are less common but more dangerous, as they're more difficult to control. Infection from the nasal cavity can spread through its connections with surrounding structures. The maxillary sinuses are a common site of infection because their openings are small and high up, so they're easily blocked and do not drain well. Pituitary tumors can be accessed and removed through the nose, specifically through the sphenoid sinuses in a procedure called a transsphenoidal resection.
The eyes enable us to see trees of green, red roses too, and basically everything in the wonderful world around us. From an anatomical perspective, the eyes are sensory organs, and they're protected by a hard bony casing called the orbit and shielded from the outside environment by softer tissues like the eyelids. Unfortunately, all of these structures are prone to various diseases, but luckily, understanding eye anatomy can help us recognize and treat these conditions. Let's start with the eyelids. Remember that they're controlled by a muscle called the orbicularis oculi, which is a ring of muscles with two different parts that are arranged in circumferential bands around the orbit. The outer and thicker ring is the orbital part, while the thinner part that lies nearer to the eyelids is known as the palpebral part. The orbicularis oculi muscles are innervated by the facial nerve, and when they contract, they bring the eyelids together to close the eye for protection. So with a facial nerve lesion, the function of the orbicularis oculi muscle is affected, which impairs the muscle's ability to close the eyelids. First, this means that blinking and moisturizing the front of the eye with lacrimal secretions is impaired, so the cornea can dry out. Then, there is also the added risk of foreign bodies entering the eye due to impaired blinking, for example, sand blowing into our face during a windstorm. Abrasions and infections can then result, which can ultimately lead to corneal ulceration. Now, the eye can also be subject to infection even if the eyelids are working properly. One of the most common ones is hordeolum, usually referred to as a stye. This is an abscess of the eyelid, typically presenting as localized erythematous and painful swelling on the eyelid. A hordeolum can be external, which is when it arises from either the gland of Zeiss or the gland of Moll, which both secrete sebum in the eyelash follicle on the margin of the eyelid. A stye can also be internal, in which case it arises from the meibomian gland, causing a swelling under the conjunctival side of the eyelid. The meibomian glands are the tiny oil glands at the roots of our eyelashes. Another type of eyelid lesion, known as a chalazion, has an origin similar to that of a stye, a blocked duct of a gland, and it can also even develop from an old stye. Chalazions, however, differ from the hordeolums as they generally present as a painless swelling on the inner part of the eyelid, and more often than not, they involve the meibomian gland. Another common eye condition is conjunctivitis, also known as pink eye. Conjunctivitis means inflammation of the conjunctiva, which is a mucous membrane on both the inner surface of the eyelids covering the eyeball, as well as globe of the eye except for the cornea, which is the transparent part of the globe located just over the iris and the pupil. On the other hand, when the cornea is inflamed, that's called keratitis. And just to put two and two together, when it's both the conjunctiva and the cornea that are inflamed, that's called keratoconjunctivitis. Now let's take a quick look at uveitis, which is an inflammatory condition of the eye that's commonly associated with systemic inflammatory disorders. Remember that the uvea is the middle layer of the eye which lies between the outer sclera layer and the inner retinal layer. This vascular and pigmented layer of the uvea is made up of the choroid, the ciliary body, and the iris. So, based on anatomic positions of these structures, anterior uveitis will involve the iris and can sometimes be referred to as iritis, and posterior uveitis will involve the choroid and can sometimes be referred to as choroiditis. Because of the choroid's intimate relationship with the retina, posterior uveitis can also involve the retina, leading to additional retinitis or chorioretinitis when both layers become inflamed together. Okay, now time for a quick quiz. Can you recall the parts of the eye that are inflamed with conjunctivitis, keratitis, and uveitis? Okay, now let's switch gears and look at glaucoma. This term refers to a group of eye diseases in which there is damage caused to the optic nerve. Usually, but not always, glaucoma results from an abnormally high intraocular pressure. Remember that normally, the aqueous humor produced by the ciliary body is drained by the trabecular meshwork found in the angle of the anterior chamber. So basically, anything disrupting the flow of aqueous humor through this meshwork can cause an accumulation of aqueous humor, which will ultimately result in increased intraocular pressure. In time, this buildup of pressure against the optic nerve can cause damage to it and lead to vision loss. Now, two of the main types of glaucoma are closed angle and open angle. Closed angle glaucoma occurs when the iris bulges forward, for example due to an enlarged lens, and narrows or closes the angle of the anterior chamber, which is the angle formed laterally by the cornea and iris where drainage occurs. The closure or tightening of this angle impairs the drainage of the aqueous humor, resulting in an increased IOP and subsequent damage to the optic nerve. On the other hand, with open-angle glaucoma, the anterior chamber angle is not decreased. Instead, open-angle glaucoma occurs as a result of the clogging of the trabecular meshwork, which still leads to reduced drainage of the humor, causing a gradual increase in IOP that once again damages the optic nerve. Both open and closed glaucoma, if left untreated, result in progressive and irreversible visual loss. Finally, bear in mind that glaucoma can also be classified as acute or chronic. Traditionally, open-angle glaucoma is the slowly progressing, chronic type that steadily causes damage to the optic nerve over time. Acute glaucoma, on the other hand, typically refers to closed-angle glaucoma that has an acute onset, and symptoms may include severe eye pain, blurry vision, redness of the eye, sudden loss of vision, or photophobia. This is called acute angle closure glaucoma and should be treated urgently. Okay, now another important condition that involves the eye is Horner syndrome. So let's take a closer look at the sympathetic innervation of the eye first. Normally, the sympathetic innervation to the eye consists of a 3-neuron arc, which is a pathway consisting of 3 orders of neurons. The first-order neuron consists of central sympathetic fibers, which arise from the posterolateral hypothalamus, descending through the midbrain and pons until the first synapse, which is located in the cervical spinal cord at the C8 to T2 level. The second-order neuron consists of preganglionic pupillomotor fibers contained within the sympathetic trunk. On its way up to the head, the second-order neuron passes over the lung apex and past the brachial plexus roots. Ultimately, these second-order fibers ascend to the superior cervical ganglion, which is located alongside the internal carotid artery near the angle of the mandible, just above the level of the common carotid artery bifurcation. Finally, the third-order neuron takes over, and it continues as a set of branches that cover the internal carotid artery and pass through the cavernous sinus with it. From here, the fibers enter the orbit and the eye to provide sympathetic innervation to the dilator pupillae muscle and the superior tarsal muscle, also known as Mueller muscle. This last muscle is a small muscle responsible for elevating and retracting the upper eyelid, along with its bigger cousin, the levator palpebrae superioris. Recall that the levator palpebrae superioris is innervated by the oculomotor nerve, so some upper eyelid lifting is still possible even when Horner syndrome is present. Now, Horner syndrome can be caused by a lesion anywhere along the sympathetic pathway that supplies the eye. When the lesion causing Horner syndrome is along the first-order neuron, it's referred to as first-order Horner syndrome. These lesions include central infarctions, strokes, tumors that can occur in the hypothalamus, brainstem, or cervicothoracic spinal cord above T1, and other conditions such as syringomyelia and cervical spinal cord trauma. Second-order Horner syndrome, on the other hand, occurs as a result of a lesion involving the sympathetic trunk, commonly at the thoracic outlet or at the lung apex. Damage can also be in the neck, where the cervical sympathetic ganglia are located, which can occur iatrogenically from surgery in the neck. Second-order lesions at the lung apex are typically associated with Pancoast tumors, a type of lung cancer affecting the apex of the lungs. Finally, third-order Horner syndrome can be seen in lesions affecting the internal carotid artery, like a dissection, and other vascular lesions such as cavernous sinus aneurysm or iatrogenically from carotid artery stenting. Basically, anything that can compress or injure the third-order neuron can cause third-order Horner syndrome. Now, Horner syndrome causes a typical triad of symptoms. First, there is ptosis, which is the drooping of the upper eyelid due to loss of the sympathetic innervation to Mueller's muscle. Second, there is anhidrosis, which is the absence of sweating caused by impaired sympathetic innervation to facial sweat glands. Third, there's meiosis, which is constriction of the pupil caused by disruption of the sympathetic innervation of the dilator pupillae muscle, resulting in unopposed parasympathetic innervation. You can remember these features using the mnemonic Pam plays the French horn. Okay, now let's switch gears and take a quick look at central retinal artery occlusion. That's when the central retinal artery is blocked, often by an embolus. The central retinal artery arises from the ophthalmic artery, which is a branch of the internal carotid artery. Central retinal artery occlusion is commonly seen in people with atherosclerosis of the ipsilateral internal carotid artery. Much of the retina and part of the optic nerve is supplied by the direct terminal branches of the central retinal artery, so obstruction in the central retinal artery will cut off blood supply to these structures, resulting in a sudden, painless, total loss of vision of the affected eye. Alright, as a quick recap, orbicularis oculi paralysis can occur because of a facial nerve lesion, and it impairs the ability of the eye to close. This can cause the cornea to dry out and leave it exposed to injuries. An external hordeolum, classically known as a stye, is a painful swelling caused by an inflammation of the glands of Zeiss and glands of Moll in the eyelid. Internal hordeolums are caused by inflammation of the meibomian gland. A chalazion is also caused by the obstruction of Zeiss or meibomian glands, but it presents without pain. There's also conjunctivitis and keratitis, which are inflammatory conditions affecting the conjunctiva and the cornea, respectively. We also have uveitis, which is an inflammation of any anatomical part of the uvea. With glaucoma, there's usually, but not always, increased intraocular pressure. Glaucoma can be classified as open-angle glaucoma and closed-angle glaucoma. Typically, open-angle glaucoma is a chronic condition that progresses over time, whereas closed-angle glaucoma can have an acute onset. Horner syndrome presents as ipsilateral partial ptosis caused by the sympathetic denervation of Mueller's muscle, meiosis caused by the interruption of sympathetic fibers to the dilator pupillae muscle, and anhidrosis, which occurs as a result of denervation of facial sweat glands. Finally, central retinal artery occlusion presents as an acute, painless, monocular loss of vision. It commonly occurs as a complication of emboli and/or atherosclerosis of the internal carotid artery.
The ear has many roles, from hearing and maintaining balance to showing off jewelry and piercings. But just like the rest of our body, there are a variety of conditions that can affect them. So understanding the anatomy of the ear can help us better understand the clinical conditions that affect it. Let's start with the auricular hematoma, also known as a cauliflower or boxer's ear. You may have guessed from its name, This condition is most common in professional boxers and wrestlers. Boxer's ear is a deformity caused by blunt trauma to the auricle, in which blood accumulates between the perichondrium and auricular cartilage, resulting in a hematoma. If left undrained, fibrosis can develop in the overlying skin, which causes deformity of the auricle. This results in the auricular deformity known as the cauliflower or boxer's ear. Next up, let's look at ear pain. The ear receives cutaneous innervation from multiple nerves of the head and neck, which makes it prone to referred pain. This is called secondary otalgia, which means that the ear perceives pain when the primary issue is in another anatomical site. Now, the majority of the external auditory canal innervation comes from the auriculotemporal nerve, which is a branch of the trigeminal nerve. It provides sensory innervation to the anterior portion of the preauricular skin, anterior auricle, and the anterior portions of the external auditory canal. Conditions such as dental infections, maxillary sinusitis, as well as temporomandibular joint disease can cause referred pain in these parts of the ear. Along with the auriculotemporal nerve innervating the ear, a small auricular branch of the vagus nerve and parts of the glossopharyngeal nerve go on to innervate a small portion of the posterior external auditory canal and tympanic membrane. As these two nerves also innervate portions of the pharynx and larynx, pathologies irritating these areas can be referred to the ear. Examples include hypopharyngeal and laryngeal cancer, as well as oropharyngeal infections, which can all cause otalgia. The ear also receives a large portion of cutaneous innervation from the lesser occipital and the greater auricular nerves, which come from the C2 and C3 nerve roots of the cervical plexus and innervate the posterior auricle, the skin overlying the parotids, and the mastoid. Referred pain from these nerves is rare, and causes include cervical spine tumors and neck trauma. Finally, there's also the posterior auricular nerve, which is a branch of the facial nerve. This nerve supplies a small part of the posterior wall and auricle. Referred pain in these areas can result from facial nerve pathology. Now, this intricate innervation is also the reason for why stimulating the ear region can stimulate the vagus nerve, since the posterior aspects of the external auditory canal are innervated by the vagus nerve via its small auricular branch. When these parts of the ear are stimulated, this can produce a vagal reflex, which can include symptoms such as vomiting, bradycardia, coughing, and syncope. This can occur when getting your ears checked at the doctor's office, as the otoscope can irritate these areas. Now let's switch gears and look at middle ear effusions caused by obstruction of the pharyngotympanic tube, also known as the auditory or eustachian tube. Remember that the pharyngotympanic tube is a canal that opens up posterior to the inferior nasal meatus and connects the nasopharynx to the middle ear, and mainly functions to equalize the pressure in the middle ear with the atmospheric pressure. This is why you swallow on an airplane so your ears don't feel like they want to pop. When this tube is not working properly, it causes pressure to build up in the middle ear, leading to transudative middle ear effusions. Symptoms of middle ear effusion include a feeling of fullness and pressure in the ear, hearing loss, and tinnitus. Pathologies associated with pharyngotympanic tube obstruction include rhinosinusitis, allergic rhinitis, or infections like the common cold. The tube can also be anatomically obstructed by tumor or by enlarged adenoid tonsils that cause a mass effect. Next up, there's otitis media, which is a painful infection of the middle ear, generally caused by bacterial upper respiratory infections. Common bacteria involved in the pathologies of otitis media include Streptococcus pneumoniae or Haemophilus influenzae. Now, the middle ear is in close proximity to the mastoid process of the temporal bone, and the mastoid bone contains air spaces called mastoid air cells, which communicate with the middle ear through the mastoid antrum. So any infection of the middle ear can spread to the mastoid bone, causing mastoiditis. Left untreated, mastoiditis can cause osteomyelitis of surrounding bone, or even progress and invade into the adjacent cerebellum or temporal lobe of the brain, causing a brain abscess. This outlines the importance of early recognition and treatment of mastoiditis, where the mainstay of treatment is antibiotics. Okay, now let's take a look at hyperacusis, which is an increased sensitivity to sound, where normal noises can seem painfully loud. Normally, the stapedius muscle, which is innervated by the facial nerve, helps dampen the excessive vibrations caused by loud noises on the stapes by pulling on it. This prevents excess movement of the stapes, which helps control the amplitude of sound waves. With damage to the facial nerve, the stapedius muscle is unable to contract and properly dampen the oscillations of the ossicles. This results in the individual perceiving sound as abnormally loud on the affected side. So far, so good. Before we move on, feel free to take a quick break and see if you can remember the major complications of otitis media. Great. Finally, let's have a look at hearing loss, which can be categorized as conductive, sensory neural, or mixed hearing loss. First, let's start with conductive hearing loss, which refers to anything that interferes or limits the amount of sound that gets into the external and middle ear. Anatomical structures that can be affected in conductive hearing loss include the external auditory canal, tympanic membrane, and the middle ear ossicles. In this type of hearing loss, the cochlear nerve is unaffected, so individuals actually perceive their voices to be louder in their own heads and tend to speak quieter. Some causes include cerumen impaction, which is when earwax builds up and obstructs the external auditory canal, tympanic membrane perforation, which is literally what it sounds like, infections such as otitis media and externa, and cholesteatomas, which is an abnormal growth of skin and debris buildup in the middle ear, which can erode the ossicles or mastoid air cells. On the other hand, sensory neural hearing loss usually occurs as a result of any lesion disrupting the transmission of a neural impulse from the cochlea to the brain. This can result from damage to the inner ear, cochlea, cochlear nerve, or the brainstem. This means that the outside world, as well as the individual's voice, are both perceived as quieter. Common causes include inner ear tumors like a vestibular schwannoma, noise-induced hearing loss, where excessive chronic noise exposure can damage the stereocilia cells of the organ of Corti, presbycusis, which is age-related hearing loss, ototoxic medications such as aminoglycosides or chemotherapeutics, congenital viral infections, as well as other diseases of the inner ear like Meniere's disease, which is related to excess endolymph and Alport syndrome, an X-linked disorder of collagen. Diagnostic workup of hearing loss involves the Weber and Rinne tests, among others. These tests help determine whether a patient is suffering from conductive or sensory neural hearing loss. During the Weber test, a tuning fork is struck and placed on the bridge of the forehead, and the individual is asked if the sound is louder in one ear or the other, as this test is determining the ear's ability to sense bone-conducted sound. In individuals with normal hearing or bilateral symmetric hearing loss, there would be no lateralization of sound, meaning the sound will be perceived as equally loud on both sides. Now, in individuals with unilateral conductive hearing loss, the sound is lateralized towards the affected ear. This means that the sound is perceived as louder on the affected side, because that ear now has a relative improvement in the ability to sense bone-conducted sound. This is in contrast to an individual with unilateral sensory neural hearing loss, where the sound is lateralized to the unaffected ear as the damaged side has a reduced ability to sense bone-conducted sound. This means that in a positive Weber test, where the sound lateralizes to one side, there is either unilateral conductive hearing loss on the side that perceives the sound as louder, or unilateral sensory hearing loss on the side that perceives the sound as quieter. The Rinne test, on the other hand, compares the ear's ability to sense bone conduction versus air conduction. Bone conduction is tested by striking the tuning fork and placing it on the mastoid bone, and air conduction is tested by striking the tuning fork and placing it next to the person's ear. After each of these are done, the individual is asked what they think is louder. Normally, air conduction is perceived as louder than bone conduction. So with a normal Rinne test, the individual perceives the tuning fork next to the ear as louder than when placed on their mastoid. During conductive hearing loss, the sound from the tuning fork beside the ear is blocked from getting into the inner ear, so bone conduction will be perceived as louder than air conduction. However, in sensory neural hearing loss, both are affected equally, so air conduction is still louder than bone conduction. Using these two tests together can help localize the side and type of hearing loss. For example, let's look at right side conductive hearing loss. Using the Weber test, we know that the right side perceives the sound as louder. Then, using the Rinne test, bone conduction will be louder than air conduction, confirming this is a conductive hearing loss and not a sensory neural hearing loss. If the Rinne test had air conduction as louder, then we know the results of the Weber test was due to sensory neural hearing loss of the other side. Alright, as a quick recap, Cauliflower ear or boxer's ear occurs as a result of accumulation of blood in the space between the perichondrium and auricular cartilage, resulting in deformity. Referred ear pain, or secondary otalgia, is caused by a lesion somewhere outside the ear which affects a nerve providing cutaneous innervation to the ear, which are cranial nerves 5, 7, 9, and 10, and the cervical plexus. Pharyngotympanic tube obstruction can cause middle ear effusions because of inflammatory or infectious processes, or compression from masses such as a tumor. Otitis media is typically caused by a middle ear bacterial infection, which can lead to mastoiditis. Left untreated, it can progress and result in surrounding osteomyelitis or local brain abscess. With hyperacusis, there's increased sensitivity to sound due to stapedius muscle dysfunction, which is usually due to facial nerve lesions. Finally, hearing loss can be conductive, sensorineural, or mixed. Conductive hearing loss occurs because of disruption in the transmission of sound from the outside world to the inner ear, while sensorineural hearing loss occurs as a result of any lesion disrupting the transmission of neuronal input to the central nervous system. Diagnostic workup of hearing loss involves the Weber and Rinna tests.
The glossopharyngeal, vagus, spinal accessory, and hypoglossal nerves, also known as cranial nerves 9, 10, 11, and 12 respectively, all combine to carry sensory, motor, and parasympathetic innervation to the pharynx, larynx, tongue, and many other regions. Injury of these nerves can affect important functions like swallowing, the gag reflex, breathing, and even cardiac output. Now, we know that cranial nerves can be a hard pill to swallow, but soon you'll see that by knowing the anatomy and the important functions of these nerves, the clinical presentations and the management of these injuries isn't so difficult to understand. First, let's discuss bulbar palsy, which refers to a unilateral lower motor neuron lesion of cranial nerves 9, 10, 11, and 12, and it's caused by a lesion in the medulla that affects the nucleus ambiguus and the hypoglossal nucleus. Symptoms are associated with impaired function of the affected nerves. For example, if the glossopharyngeal nerve is damaged, this causes difficulty with swallowing. Other common symptoms include nasal regurgitation, slurred speech, and difficulty speaking. Also, reflexes like the gag reflex and jaw jerk are usually absent. Pseudobulbar palsy, on the other hand, refers to a bilateral upper motor neuron lesion of cranial nerves 9, 10, 11, and 12 caused by more supranuclear proximal damage to motor fibers somewhere between the cortex and the medulla, leading to an upper motor neuron injury. The symptoms are similar to bulbar palsy, however, the gag reflex and jaw jerk are usually overactive, which, if you remember, is indicative of an upper motor neuron lesion. Next, let's discuss jugular foramen syndrome, which refers to a collection of symptoms that arise when cranial nerves 9, 10, and 11, which all pass through the jugular foramen, are damaged in that area. Any obstructions or lesions, most commonly tumors in the area, but also trauma or an abscess, can damage these cranial nerves and cause jugular foramen syndrome. Let's talk a bit about an important function of the glossopharyngeal and vagus nerve, which is blood pressure control. The glossopharyngeal nerve innervates baroreceptors in the carotid sinus, while the vagus nerve innervates baroreceptors in the aortic arch. Baroreceptors detect changes in blood pressure and send that information through their corresponding nerve to the solitary nucleus. The solitary nucleus indirectly modulates autonomic control of the heart and blood vessels by decreasing sympathetic impulses and increasing parasympathetic impulses. Simply put, baroreceptors detect changes in the blood pressure and send that information to the solitary nucleus, which then adjusts the blood pressure accordingly to either raise or lower it. Now, a hypersensitive carotid sinus reacts too strongly to a rise in blood pressure, which leads to overactivation of the parasympathetic innervation and a drop in blood pressure that can cause dizziness or syncope. Carotid sinus massage is a maneuver that can tell us if there is carotid sinus hypersensitivity and can help to diagnose or treat paroxysmal supraventricular tachycardia. The way this works is that by applying external pressure to the carotid sinuses, the baroreceptors become activated as if there is a high blood pressure. This causes them to send their impulses through the glossopharyngeal nerve up to the solitary nucleus. The solitary nucleus then sends impulses down through the parasympathetic nerve fibers of the vagus nerve, which tell the sinoatrial and atrioventricular nodes to slow down, leading to a reduction of the heart rate. Since there is a parasympathetic effect mediated through the vagus nerve, a carotid sinus massage is sometimes referred to as a vagal maneuver. The glossopharyngeal and vagus nerves also play a role in the gag reflex. The gag reflex is an important mechanism that prevents objects in the oral cavity from entering the throat and also helps prevent choking. This reflex has an afferent limb supplied by the glossopharyngeal nerve and an efferent limb supplied by the vagus nerve. Damage to either of these nerves will result in a diminished or lost gag reflex. If the glossopharyngeal nerve is damaged on one side, there will be no gag reflex when that side of the soft palate or posterior tongue is stimulated. The taste and general somatic sensation on the posterior third of the tongue on that side will also be lost. An example of when the glossopharyngeal nerve is vulnerable to injury is during tonsillectomies. Now, if the vagus nerve on one side is damaged, the sensation and taste will be normal, but pharyngeal muscles will only contract on the healthy side. The main complication of diminished or lost gag reflex is difficulty swallowing, as well as a risk of aspiration and choking. Okay, it's time for a quiz. Can you recall the differences between the bulbar and the pseudobulbar palsy? Great. Now let's talk about each nerve separately. The word vagus comes from the Latin word vagare, which means wandering. This reflects the vagus nerve's wide distribution throughout the body. In fact, it's the most extensively distributed cranial nerve. The vagus nerve has plenty of branches, but let's focus on just 3 for now. The group of pharyngeal branches, the superior laryngeal nerve, and the recurrent laryngeal nerve. Now, to assess for injury to the pharyngeal branches, it's often enough to just look at the uvula. Seriously. That's because these branches also innervate the levator veli palatini muscles on either side, which keeps the palatal arches elevated and the uvula in the center. Now, if the vagus is damaged on one side, the palatal arches of that side will drop, while the arches on the contralateral side keep pulling the uvula, so it deviates to the contralateral, healthy side. The superior laryngeal nerve, on the other hand, can be injured during skull base surgery, which results in loss of sensation to the superior laryngeal mucosa. Now remember that the superior branches into an internal and an external branch, and injury to the external branch is more common. The external branch lies deep to the superior thyroid artery, and it innervates the cricothyroid muscle, which tenses the vocal folds. If the external branch is damaged, which can happen during a thyroidectomy, the vocal folds won't be able to stretch tightly, which is required for raising our voice or changing its pitch. So with injury to the external branch, the affected individual can sound more monotone and have poor vocal quality. Finally, the recurrent laryngeal nerve in the neck passes adjacent to the inferior thyroid artery and its branches. An enlarged thyroid can put pressure on the nerve, and procedures like neck surgeries and thyroidectomies can injure the nerve. Remember that in the thorax, where these nerves start, the right recurrent laryngeal nerve loops just below the right subclavian artery, while the left one loops below the aortic arch. So it makes sense that mediastinal masses and Pancoast tumors can injure these nerves earlier on in their path. Because the left one loops close to the left atrium, an enlarged left atrium can put pressure on the nerve. Aneurysms of the aortic arch can also impair the function of the left recurrent laryngeal nerve. Since these nerves innervate the muscles that move the vocal folds, any injury to the recurrent laryngeal nerves will result in voice changes. If only one nerve is damaged, the vocal fold on that side won't be able to adduct and meet the healthy fold. At the time of injury, the voice is weak and raspy, which is referred to as hoarseness. After a few weeks, the muscles on the other side compensate and the voice can return to normal, or close to normal. If both nerves are damaged, vocal folds on either side will become paralyzed. In this case, the voice is almost absent. And now, there's another much more important issue here. Paralyzed vocal folds can't move outwards to allow for adequate respiration and widening of the upper airway. So let's say an individual goes for a run. If their vocal folds are paralyzed, they won't be able to move as they normally do to widen the diameter of the airway through the larynx, so their breathing becomes high-pitched as it passes through this narrow tube. This high-pitched, noisy breathing on inspiration is referred to as stridor. These individuals might also have difficulty with protecting their airway and closing it off from foreign bodies, and they are at an increased risk of aspiration. One more quick break. Can you remember how to assess for damage to the pharyngeal branches of the vagus nerve? What happens when they are injured? Great. Now let's move on to the spinal accessory nerve. The spinal accessory nerve is at its most superficial point when it's crossing the roof of the posterior triangle of the neck. So this is where it can get injured following trauma or medical procedures that involve the posterior triangle of the neck, like tumor removals, cosmetic surgery, or lymph node biopsy. These kinds of nerve injuries lead to lower motor neuron injury, which causes paralysis of the trapezius muscle. This manifests as shoulder drop on the side of the lesion, weakness when individuals shrug against resistance, lateral displacement of the scapula, and limited shoulder abduction to 90 degrees. Affected individuals usually complain of not being able to lift their arm and perform overhead tasks like brushing and washing their hair. A more proximal injury to this nerve might also result in weakness of the ipsilateral sternocleidomastoid muscle, leading to impaired rotation of the head to the opposite side of the injury when resistance is applied. And finally, just a few words on the hypoglossal nerve. This nerve travels down the neck and loops around a branch of the external carotid artery called the occipital artery. So the hypoglossal nerve is most prone to injury during carotid surgery and surgery in the cervical region of the neck. Injuries at this point result in lower motor neuron injury of the nerve, which causes weakness of the tongue muscles on the same side. If you ask an affected individual to stick their tongue out, you'll notice that it deviates towards the side of the injury. Alright, as a quick recap, bulbar and pseudobulbar palsies are associated with lesions of cranial nerves 9, 10, 11, and 12. Bulbar palsy refers to the unilateral lower motor neuron lesion, while pseudobulbar palsy refers to a bilateral upper motor neuron lesion. Symptoms include difficulty chewing and swallowing, nasal regurgitation, slurred speech, and difficulty speaking. Reflexes are absent in bulbar palsy, while they can be increased in pseudobulbar palsy. Jugular foramen syndrome is often caused by tumors that obstruct the jugular foramen, paralyzing cranial nerves 9, 10, and 11. Carotid massage works by activating baroreceptors in the carotid sinus. Impulses are sent from here through the glossopharyngeal nerve to the nucleus ambiguus, which sends signals through parasympathetic fibers of the vagus nerve to sinoatrial and atrioventricular nodes of the heart to ultimately lower the heart rate. The gag reflex is an important mechanism that prevents objects in the oral cavity from entering the throat and also helps prevent choking. This afferent limb is supplied by the glossopharyngeal nerve, and the efferent limb is supplied by the vagus nerve. A diminished or absent gag reflex can cause difficulty swallowing, aspiration, and choking. Injured pharyngeal branches of the vagus nerve will cause the uvula to deviate to the healthy side. The external branch of the superior laryngeal nerve lies deep to the superior thyroid artery, which makes it vulnerable to damage during thyroidectomy. The affected individual can't produce pitched sounds, so their voice will become more monotone. The right recurrent laryngeal nerve in the neck can also be injured during thyroidectomy. In the thorax, the right nerve loops just below the right subclavian artery, while the left one loops below the aortic arch. Mediastinal masses and pancoast tumors can injure these nerves. An enlarged left atrium can also put pressure on the left nerve. If only one nerve is damaged, the vocal fold on that side won't be able to adduct and meet the other healthy fold. If both nerves are damaged, vocal folds on either side will become paralyzed. Voice is almost absent. Paralyzed vocal folds won't be able to move to allow increased respiration, which results in stridor. The spinal accessory nerve can be injured by trauma or surgery in the posterior triangle of the neck. Injury causes paralysis of the trapezius muscle, which manifests as shoulder drop on the side of the lesion and limited shoulder abduction to 90 degrees, and proximal lesion can cause dysfunction of the sternocleidomastoid muscle. Lastly, the hypoglossal nerve is most vulnerable to injury during carotid surgery and cervical surgery as it loops around the occipital artery. Injuries cause ipsilateral weakness of the tongue muscles and deviation of the protruded tongue to the side of the injury.
The facial nerve is all about supplying those facial muscles and allowing for the whole range of facial expressions that they create. But don't just judge a nerve by its face, because that's not all it can do. The facial nerve is also involved in salivating, secreting tears, and it even plays a role in taste. On the other hand, the vestibulocochlear nerve is the cranial nerve that helps you hear your favorite song. So then you can use your facial nerve to smile when you hear it. And it also plays a role in balance, so you can dance along without tipping over. Understanding the anatomy of the facial and vestibulocochlear nerves is important, as damage to these nerves can cause significant impairments when it comes to facial expression, hearing and balance, among several other functions. Let's start with the general anatomy of the facial nerve. Remember that there are two facial nerves, one on each side, and each of them is primarily responsible for providing motor innervation to the muscles of facial expression. The facial nerve also innervates the stapedius muscle in the middle ear, gives parasympathetic innervation to the lacrimal glands, nasal glands, palatal mucosal, submandibular, and sublingual salivary glands, and also carries the special sensory information of taste from the anterior 2/3 of the tongue and the palate. It is also involved in the corneal reflex, also known as the blink reflex, which causes involuntary blinking when the cornea is stimulated to protect the eye from foreign bodies like sand. In this reflex, the trigeminal nerve is the sensory or afferent pathway, while the facial nerve serves as the motor or efferent pathway. Now, the clinical presentation of facial nerve damage is called facial nerve palsy. If the entire facial nerve is damaged, all of its functions are affected. Without motor innervation, facial muscles become weak or impaired. This means the affected individual will have trouble when trying to smile, frown, raise their eyebrows, puff their cheeks, or whistle. Paralysis of these muscles can also cause the face to look different on the affected side. For example, there can be loss of the characteristic nasolabial fold or less wrinkling in the forehead when compared to the unaffected side. Because the orbicularis oculi muscle is affected, the lower eyelid can become everted, and they can't close the affected eye. Because the sphincter and dilator muscles of the mouth are affected, the corner of the mouth droops. There is also decreased tear secretion, decreased salivation, and loss of taste due to loss of innervation to the lacrimal glands and submandibular glands. Since the stapedius muscle normally acts on the stapes to dampen down excessive vibrations, when it loses its innervation and becomes paralyzed, increased sensitivity to certain sound frequencies can result, which is called hyperacusis. Finally, if you stimulate the cornea by lightly touching it with a piece of cotton, you will notice that the corneal reflex is absent, meaning that there is no involuntary blinking. The facial nerve can be injured in many ways. If the fibers above the facial nucleus are damaged, it is referred to as an upper motor neuron lesion or central facial palsy. Common causes include stroke, trauma, multiple sclerosis, and brain tumors. Remember that the facial nucleus has a dorsal and a ventral part. The dorsal region controls the muscles of the upper face. It receives innervation from the upper motor neurons from both the right and left hemispheres of the brain, meaning it is under bilateral control. So, if upper motor neuron fibers from one side of the brain are damaged, they still receive innervation from the upper motor neuron in the other hemisphere. So the muscles of the upper face won't be affected with a unilateral upper motor neuron lesion of either facial nerve. On the other hand, the ventral part of the facial nucleus, which controls the muscles of the lower part of the face, only receives innervation from the upper motor neurons of the contralateral hemisphere. Therefore, an upper motor neuron lesion will result in contralateral dysfunction of the muscles of the lower face. This is because the upper motor neuron fibers decussate right before synapsing with the lower motor neuron, so symptoms of upper motor neuron lesions will appear on the contralateral side. A good way to remember this is to think of the phrase upper spares upper, meaning an upper motor neuron lesion will spare the muscles of the upper face and will only affect the muscles of the lower face on the contralateral side. A lower motor neuron lesion, or peripheral facial palsy, refers to any injury that affects the facial nerve from the facial nucleus up until it gives off its terminal branches. Things are a bit different now. There is no dual innervation here, and fibers travel through the lower motor neuron to the ipsilateral side. Also, information from both the dorsal and ventral parts of the nucleus are together at this point in the nerve. So, these lesions will affect all muscles of facial expression, both of the upper face and the lower face, on the same side as the lesion. Okay, that was a lot of information. Can you tell the difference between central and peripheral facial nerve palsy? Great. Now let's look into Bell palsy, which is the most common cause of peripheral facial palsy. The cause of this condition hasn't been established yet, but it is thought to be caused by the reactivation of the herpes simplex virus. In addition to unilateral facial paralysis, those with Bell palsy may also have hyperacusis, decreased tear production, and loss of taste to the anterior two-thirds of the tongue. Another cause of peripheral facial nerve palsy is Ramsay-Hunt syndrome, which is a lower motor neuron palsy of the facial nerve, which is caused by the varicella-zoster virus, the same virus that causes chickenpox. Now, after someone has had chickenpox, the virus can remain dormant in the geniculate ganglion of the facial nerve. Later in life, the virus can reactivate and cause symptoms in the distribution of the facial nerve. Symptoms include painful blisters around the external ear canal and pinna, along with signs of facial nerve palsy. Sometimes, blisters can appear on the tongue as well. Parotid gland disorders like tumors or inflammation can also cause facial nerve palsy. Once again, let's go back to basic anatomy and figure out how this works. The motor component of the facial nerve enters the parotid gland, where it completes its journey by splitting into 5 terminal branches: the temporal nerve, the zygomatic nerve, the buccal nerve, the marginal mandibular nerve, and the cervical nerve. These branches are responsible for innervating the muscles of facial expression. Now, if the parotid gland becomes enlarged, it puts pressure on the facial nerve and causes facial nerve palsy. In this case, there's no hyperacusis or loss of taste, as the nerve testopedius and chorda tympani have already branched off from the facial nerve before it reaches the parotid gland. Other causes of peripheral facial palsy include trauma, especially to the temporal bone, otitis media, birth injuries, tumors, infections like mumps, mononucleosis, Lyme disease, and systemic conditions like sarcoidosis and diabetes mellitus. Medical procedures like mastoid surgery or parotid surgery can also result in injury to the nerve as well. Now, the facial nerve is most vulnerable in babies, and that's because the mastoid process is not yet fully developed. So in this case, the nerve can be damaged due to birth trauma, especially if forceps are used. Just like in adults, this type of injury to the nerve leads to an ipsilateral facial palsy. However, unlike injuries in adults, this one is more serious because one of the affected muscles, called the buccinator, is vital for suckling and therefore feeding. Okay, now let's switch gears and discuss some clinical conditions affecting the vestibulocochlear nerve. You know the drill, basic anatomy first. The facial nerve and the vestibulocochlear nerve both emerge between the pons and medulla near the cerebellopontine angle and travel through the internal acoustic meatus. Because of this close relation, some tumors can affect both nerves. Cerebellopontine angle tumors can damage both nerves right as they emerge from the brainstem. Symptoms include facial palsy, sensory neural hearing loss, vertigo, and cerebellar symptoms like poor coordination, unsteady gait, and slurred speech. One of the most common types of tumors found at the cerebellopontine angle are acoustic neuromas, also known as vestibular schwannomas. This is a growth that arises from Schwann cells of the vestibular portion of the vestibulocochlear nerve within the internal acoustic meatus, and often expands proximally to enter into the cerebellopontine angle where the nerves originate. Remember that both the facial nerve and the vestibulocochlear nerve travel through the internal acoustic meatus together. Patients with this tumor primarily present with hearing loss and tinnitus because of cochlear nerve involvement, but facial palsy as well as vestibular symptoms are also common. Alright, as a quick recap, symptoms of facial nerve palsy usually affect one side of the face. They include facial muscle weakness, inability to frown, smile, or whistle, lower eyelid eversion, mouth corner droop, decreased tear secretion and salivation, loss of taste, and hyperacusis. Upper motor neuron lesions, also known as central facial palsy, are caused by lesions above the facial nucleus, like stroke, trauma, multiple sclerosis, and brain tumors. Muscles of the lower face on the contralateral side are affected, but upper face muscles like those in the forehead are spared. Lower motor neuron lesions, also known as peripheral facial palsy, can happen at the facial nucleus or along the nerve itself. It can be caused by Bell palsy, trauma, infections like Ramsay-Hunt syndrome, certain surgical procedures, sarcoidosis, and diabetes. In lower motor neuron lesions, all facial muscles on the ipsilateral side are affected. Parotid disorders can also cause facial nerve palsy, but without ear or taste symptoms, as the nerve testopedius and chorda tympani are not affected at this point. The facial nerve is more vulnerable in babies because the mastoid process that protects it is not completely developed. Some conditions can injure both the facial nerve and the vestibulocochlear nerve. Cerebellopontine angle tumors cause facial palsy, hearing loss, vertigo, and cerebellar symptoms. Acoustic neuromas cause sensory neural hearing loss and tinnitus with facial paralysis.
In order to move our eyes and see the world around us, like watching this osmosis video, we rely on the control of our extraocular muscles, which are primarily innervated by three cranial nerves: cranial nerve 3, or the oculomotor nerve, cranial nerve 4, or the trochlear nerve, and cranial nerve 6, or the abducens nerve. These cranial nerves allow us to move our eyes in various directions, and also help to govern certain reflexes of the eyes. Injury to these cranial nerves can lead to a number of problems involving the eye, so understanding their anatomy can help us better understand the clinical consequences of these conditions. First up, let's discuss damage to the oculomotor nerve, also called oculomotor nerve palsy. The oculomotor nerve carries both motor and parasympathetic fibers, which can be injured either individually or together. When looking at the anatomy of the oculomotor nerve, the parasympathetic fibers are found in the peripheral or superficial portion of the nerve, and the motor fibers are found in the central or deep portion of the nerve. This is significant, as more external compression may only affect the parasympathetic fibers, where lesions of central nerve fibers might only affect the motor fibers. Remember, motor is middle, and parasympathetic is peripheral. Now, if the motor fibers on the oculomotor nerve are damaged, that results in ophthalmoplegia, meaning impaired function of the four extraocular muscles innervated by the oculomotor, which are the superior, medial, and inferior rectus, and the inferior oblique muscles. When these four muscles are impaired, that leaves the two other extrinsic eye muscles unaffected, so their actions are now left unopposed. This means the lateral rectus pulls the eye laterally, and the superior oblique pulls it inferiorly and laterally. Individuals with this type of injury present with the ipsilateral eye in a characteristic down and out position. When the individual tries to look in any other direction, they will complain of double vision, or diplopia. Furthermore, there is also paralysis of the levator palpebrae superioris muscle that leads to ptosis, or drooping of the upper eyelid. On the other hand, damage can occur to the parasympathetic fibers of the oculomotor nerve, which affects the function of the smooth muscle of the sphincter pupillae that normally constricts the pupil, and to the ciliary body, where parasympathetic stimulation causes a sphincter-like contraction of the ciliary body to relax and thicken the lens for near-vision accommodation. Impaired parasympathetic innervation of the sphincter pupillae results in mydriasis, a dilated and fixed pupil, due to unopposed action of the dilator pupillae, and this is often referred to as a blown pupil. An impaired ciliary muscle results in cyclopegia, which is the inability to accommodate the lens. Let's look into the causes of oculomotor nerve injury and their symptom patterns. First up, there's vascular compromise, such as a midbrain stroke, which can injure the oculomotor nerve before it even leaves the midbrain. This results in damage to the motor fibers of the oculomotor nerve and the typical down and out appearance. Additionally, the individual can also develop contralateral hemiparesis if the descending motor tracts, which travel through the midbrain, are also damaged. This combination of symptoms should raise suspicion for a midbrain stroke. Remember that the oculomotor nerve leaves the midbrain between the cerebral peduncles and crosses the tentorial notch. So, if there's a tumor or an intracranial hemorrhage, those can increase the intracranial pressure and cause a transtentorial herniation. One type is an uncal herniation, during which the medial part of the temporal lobe, called the uncus, is forced through the tentorial notch, which can compress or stretch the oculomotor nerve due to its close proximity. Since the parasympathetic fibers are more superficial, early compression can initially present with a blown pupil. As compression continues, the motor fibers will be affected as well, leading to extraocular muscle dysfunction and a down and out position of the ipsilateral eye. If pressure continues to increase, the uncus can also compress the contralateral oculomotor nerve, as well as the midbrain, leading to coma. The oculomotor nerve also courses alongside the posterior communicating artery as it exits the brain. So if a posterior communicating artery aneurysm occurs, that can compress the oculomotor nerve. Similar to uncal herniations, posterior communicating artery aneurysms can initially present with a blown pupil, with progressive compression leading to motor fiber compression and extraocular muscle dysfunction. Aneurysms are typically asymptomatic, but with rapidly developing oculomotor palsy together with a sudden onset of severe headache, rupture of a posterior communicating artery aneurysm should be suspected. Finally, microvascular injury can also cause damage to the oculomotor nerve. One major cause of microvascular injury is diabetes mellitus, as chronically elevated blood glucose levels damage the endothelial cells of blood vessels, resulting in ischemia. This process typically affects smaller blood vessels, for example, the vasa vasorum, which are small arterial vessels that supply the deep central portion of the oculomotor nerve and can be damaged in diabetic vascular disease. Because the vasa vasorum supplies the central portion of the oculomotor nerve, the motor fibers will become damaged first, leading to motor deficits of the oculomotor nerve. However, the parasympathetic nerves may be spared, as their blood supply comes from the blood vessels that supply the overlying pia mater of the nerve. So with diabetes mellitus, oculomotor palsy typically spares the pupil, and the light and accommodation reflexes are preserved. Remember our memory trick before where the M in motor stands for medial? You can also use the M in diabetes mellitus to remember medial as well. Speaking of the light and accommodation reflexes, let's discuss a characteristic pupil finding called an Argyll-Robertson pupil. This refers to a pupil that does not constrict when exposed to light, but still has a functioning accommodation reflex. The Argyll-Robertson pupil is most commonly associated with late-stage neurosyphilis. Now, parts of the light and accommodation reflex share the same pathway. By following and comparing their pathways, we can see the possible sites where a lesion may occur to result in an Argyll-Robertson pupil, where one pathway is damaged and the other is preserved. So, both reflex pathways travel together from the retina to the optic tract. From here, the accommodation pathway travels to the lateral geniculate body of the thalamus, to the visual cortex, and eventually back to the superior colliculus of the midbrain, and then the Edinger-Westphal nuclei. The light reflex pathway, on the other hand, differs from the optic tract and goes straight to the pretectal nuclei of the midbrain, and then to the Edinger-Westphal nuclei. Once both of these pathways travel through the Edinger-Westphal nuclei, they both travel with the oculomotor nerve to the eye. Based on these two different pathways, we can see three possible sites of a lesion, which may result in preservation of the accommodation reflex and loss of the pupillary light reflex. First, there may be a lesion of the fibers along their pathway from the optic tract to the midbrain, only affecting the pupillary light pathway. Second, there may be a lesion of the pretectal nuclei, where only the pupillary light reflex synapses. And third, the part of the Edinger-Westphal nuclei that only receives input from the pretectal nuclei, not the superior colliculus fibers of the accommodation reflex, may be damaged. It is thought that neurosyphilis affects one of these areas, resulting in an Argyll-Robertson pupil. Let's take a short break and see if you can recall the clinical features of oculomotor nerve palsy. Great! Let's switch gears and look at the trochlear nerve, or cranial nerve 4, that innervates the superior oblique muscle. The main role of this muscle is to internally rotate the eye, but remember that it can also depress the eye when it's adducted. During trochlear nerve palsy, the individual is unable to turn the eye inferomedially, so the eye deviates superiorly and laterally, resulting in impaired downward gaze and the eye being forced into external rotation. Individuals typically present with vertical diplopia, especially when trying to look down and inwards, like when reading a book or walking downstairs. This is because the superior oblique assists the inferior rectus in depressing the eye. And when the eye is adducted, the superior oblique is the main muscle that depresses the eye. In order to compensate for the superolateral position of the eye, the individual has to tuck their chin and tilt their head towards the healthy side in order to compensate for the deficit. Because the eye is deviated superiorly and laterally to the upper corner of the eye, the individual can only really see out of the top corner of their eye, which is why they try to keep this head position, because it relieves their diplopia. In order to easily recall that these individuals have a problem looking downwards, just remember that you can't see the floor with damage to cranial nerve 4. Injury to the trochlear nerve can be idiopathic, but because the trochlear nerve is very small, fragile, and has a long intracranial course, this makes it susceptible to injury, such as severe head traumas. When injured during head trauma, there are often signs and symptoms of other cranial nerve injury as well. Microvascular damage and ischemia during diabetes mellitus is also thought to result in trochlear nerve lesions. Last but not least, there's cranial nerve 6, or the abducens nerve, which innervates the lateral rectus muscle. Normally, this muscle abducts the eye, hence the name of the nerve. When abducens nerve palsy develops, the eye deviates medially due to unopposed contraction of the medial rectus, and individuals present with diplopia exacerbated by moving the eye towards the side of the lesion, with resolution of the diplopia when moving the eye towards the contralateral side of the lesion. The abducens nerve emerges from the brainstem at the pontomedullary junction and has the longest intradural course within the cranial cavity of all the cranial nerves, making it prone to injury. The most common cause of injury is increased intracranial pressure, such as a space-occupying lesion, which can push the brainstem downwards and backwards. This stretches and injures the abducens nerve, especially as it sharply bends over the apex of the petrous part of the temporal bone. Other possible causes of abducens nerve palsy include severe head trauma, fractures or infections of the petrous portion of the temporal bone, and clinical conditions affecting the cavernous sinus. Let's wrap this up by talking about cavernous sinus syndrome, which is a condition that can affect the oculomotor, trochlear, and abducens nerve individually or together. The cavernous sinus is a large venous sinus containing many important structures and is found on each side adjacent to the sella turcica. So within the cavernous sinus is the internal carotid artery, along with the postganglionic sympathetic fibers that travel with it, and, as we said, cranial nerve 3, 4, and 6, as well as the V1 or ophthalmic division of the trigeminal nerve, and V2 or maxillary division of the trigeminal nerve. So, injury to the cavernous sinus can compress and cause deficits to any of these structures found within it. So, cavernous sinus syndrome can occur because of a carotid artery aneurysm occurring within the cavernous sinus, a pituitary tumor that compresses the sinus, or a carotid cavernous fistula. Alternatively, cavernous sinus syndrome can develop secondary to cavernous sinus thrombosis, which often occurs when infection spreads to the sinus from other areas of the head, as the cavernous sinus openly communicates with the valveless facial venous system, as well as the ethmoid and sphenoid sinuses. Infection can also spread to the cavernous sinus from the teeth, the eyes, and even the ears. Clinical features associated with cavernous sinus syndrome include various combinations of ipsilateral nerve palsies, depending on the affected nerves. The abducens nerve is commonly affected first because it runs through the cavernous sinus. The oculomotor nerve and trochlear nerve course along the lateral wall of the sinus, so they get affected later on, producing mixed ocular muscle palsies. Also coursing along the lateral wall are the ophthalmic and maxillary branches of the trigeminal nerve. So when they're affected, it leads to decreased sensation in the upper face and loss of the afferent limb of the corneal reflex, which makes us blink when a foreign object touches the cornea. Finally, the postganglionic sympathetic fibers that surround the internal carotid artery can also be compressed, which can lead to Horner syndrome, a classical triad consisting of a constricted pupil, or miosis, drooping of the upper eyelid, or ptosis, and decreased sweating on the affected side of the face. Cavernous sinus syndrome can also cause other symptoms, such as headache, fever, swelling of the eye, proptosis, chemosis, and diplopia. All right, as a quick recap, oculomotor nerve palsy results from damage to either the central motor fibers or peripheral parasympathetic fibers, Damage to the motor fibers is characterized by a down-and-out gaze, diplopia, and ptosis, where damage to the parasympathetic fibers is characterized by a loss of light and accommodation reflexes, also seen as a characteristic blown pupil. Motor fibers are positioned centrally, while parasympathetic fibers are positioned peripherally. Causes of oculomotor nerve palsy include midbrain stroke, uncal herniation, compression by tumors and aneurysm of the posterior communicating artery, and diabetes mellitus. Argyll-Robertson pupil doesn't react to light, but constricts with accommodation, and is a classic finding of late-stage neurosyphilis. Trochlear nerve palsy causes superior and lateral deviation of the eye with external rotation, diplopia, and inability to look downwards and inwards. Abducen's nerve palsy causes medial deviation of the eye and diplopia, and is usually caused by increased intracranial pressure that stretches the nerve. Cavernous sinus syndrome can result in injury to the oculomotor nerve, abducen's nerve, trochlear nerve, and the V1 and V2 branches of the trigeminal nerve, along with sympathetic fibers coursing with the internal carotid artery, resulting in various combinations of nerve palsies, loss of sensation in the face and cornea, and Horner syndrome.
The trigeminal nerve is the fifth cranial nerve. It provides both sensory and motor functions while also serving as a highway for parasympathetic innervation. This is the nerve that allows you to feel wonderful things like the kiss of your partner or a summer breeze on your face, but also less pleasant things like a dentist drilling into your teeth. Luckily, understanding the anatomy and distribution of the trigeminal nerve can help us better diagnose and manage several conditions, and it even makes going to the dentist less painful. First off, let's remember some important anatomical features of the trigeminal nerve. The trigeminal nerve has three divisions: the ophthalmic, or V1, the maxillary, or V2, and the mandibular division, or V3. Through its branches, the trigeminal nerve supplies sensory innervation to the skin of the entire face, the mucosa of sinuses, as well as the nasal and oral cavities. It also carries the sensory fibers for taste, which go on to travel with the chorda tympani branch of cranial nerve 7, or the facial nerve. The trigeminal nerve also carries parasympathetic innervation to the ciliary body and sphincter pupillae, the lacrimal gland, the nasal glands, palatal salivary glands, and the parotid, submandibular, and sublingual glands, though these parasympathetic fibers originally arise from other cranial nerves. Finally, the trigeminal nerve supplies motor innervation to the muscles of mastication. And if all that wasn't enough, the trigeminal nerve is also involved in the corneal reflex, also known as the blink reflex, and which causes involuntary blinking when the cornea is stimulated to protect the eye from foreign bodies, like a pesky grain of sand getting in your eye. In this reflex, the trigeminal nerve is the sensory, or afferent pathway, while the facial nerve serves as the motor, or efferent pathway. Talk about a jack of all trades. So with that in mind, you can see why trigeminal nerve injuries can cause a lot of problems. For starters, if the entire nerve is affected, individuals might have decreased sensation, called hypoesthesia, or even complete loss of sensation, called anesthesia, of all areas supplied by the nerve. Keep in mind that sometimes only one or two of the divisions might be injured. In the case of a V1 injury, for example, the corneal reflex would be absent. You could test for this by stimulating the cornea by lightly touching it with a wisp of cotton. Normally, this would cause involuntary blinking, but if the reflex is absent, there will be no blinking. Without motor innervation from V3, the muscles of mastication become paralyzed. Usually, only the trigeminal nerve on one side is affected, so muscles of that side become paralyzed. In this case, when the jaw is open, the healthy and properly innervated pterygoid muscles of the contralateral side function to move the jaw towards the affected side. Without the normal opposition from the muscles of the affected side, the jaw deviates towards the paralyzed side when it is open. Now let's dive a bit deeper into the sensory function of the trigeminal nerve. Remember that the ophthalmic nerve transmits sensory fibers from the eyeball, the skin of the forehead and anterior scalp, the lining of the upper part of the nasal cavity and the air cells, the skin of the dorsal nose and its tip, and it even carries sensation from the meninges of the anterior cranial fossa. The maxillary nerve transmits sensory fibers from the skin of the face between the palpebral fissure and the mouth, the lateral external nose, the nasal cavity and the sinuses, and from the maxillary teeth. The mandibular nerve transmits sensory fibers for the skin over the mandible, the side of the cheek and temple, the oral cavity, including gross sensation from the anterior 2/3 of the tongue, parts of the external ear and tympanic membrane, and the temporomandibular joint. With all of that in mind, let's discuss trigeminal neuralgia, which is a common cause of facial pain. Trigeminal neuralgia produces excruciating unilateral shooting pain in the area supplied by one or more divisions of the trigeminal nerve, most often the mandibular nerve. The pain can last from a couple of seconds to a couple of minutes and can occur multiple times a day. It can be set off by chewing, talking, shaving, washing the face or teeth, hot or cold air, or just by touching an area of the face. Okay, it's time for a break and a quiz. What is the corneal reflex? How does an absent corneal reflex manifest? Great! Now let's look at trigeminal herpes zoster, better known as shingles. This condition is caused by the varicella zoster virus, the same virus that causes chickenpox. See, if someone has had chickenpox at some point in their life, the virus can remain dormant in the trigeminal ganglion. Later in life, the virus can reactivate and cause shingles in the distribution of any division of the trigeminal nerve on one side. Clinically, trigeminal shingles presents with pain in the affected area. Later, a rash with tiny blisters, called a vesicular rash, will appear. This condition is most dangerous if it affects the ophthalmic nerve, or V1, because the virus can spread to the eye and cause a major complication called herpes zoster ophthalmicus. Symptoms of this complication include redness of the conjunctiva and sclera and an inflamed, swollen cornea. Corneal inflammation is called acute keratitis, and it's the most common presentation of herpes zoster ophthalmicus. Unfortunately, acute keratitis can ultimately cause vision loss. Sometimes this condition can also spread to other parts of the eye and cause uveitis, retinal necrosis, and optic neuritis, which can all cause vision loss too. Now, another cause of trigeminal nerve injury is trauma, which usually affects one of the trigeminal nerve branches. So let's start by discussing trauma to the forehead. Remember that the ophthalmic nerve gives rise to the frontal nerve, which travels along the roof of the orbit and gives off two branches, the supraorbital nerve and the supratrochlear nerve. These nerves pass from the orbit to the forehead through their corresponding supraorbital and the supratrochlear notches and supply sensation to the skin of the forehead. Now, the supraorbital and the supratrochlear nerves can be injured as a result of injury to the supraorbital rim, which can occur when someone gets hit in the face by a ball. This kind of injury to these nerves can cause paresthesia of the forehead, and in some cases, can progress to supraorbital neuralgia, meaning chronic forehead pain. Additionally, any blunt trauma to the face can cause a maxillary sinus fracture. The weakest point of the maxillary sinus is its roof, which separates it from the orbit. So with a maxillary sinus fracture, a branch of the maxillary nerve called the infraorbital nerve that travels along the floor of the orbit can be damaged. This causes numbness in the cheek, upper lip, and upper gingiva. Some branches of the infraorbital nerve, called the superior alveolar nerves, travel through the maxillary sinus and provide sensory innervation to both the maxillary sinus and the upper teeth. So when the maxillary sinus is inflamed, either from trauma or another condition like maxillary sinusitis from an infection, this can put pressure on these nerves and cause referred pain to the maxillary teeth. Let's take another break here and see if you can remember. What is the major complication of trigeminal herpes zoster called? Okay, now let's move on to the mandibular nerve and see how its branches can be injured. An important branch here is the inferior alveolar nerve, which passes through the mandibular canal and provides innervation to the mandibular molars and premolar teeth and the surrounding gingiva. The inferior alveolar nerve then continues as the mental nerve, which innervates the lower anterior teeth and their surrounding gingiva, the skin over the chin, and the lower lip. Because of its close relation to the teeth, the main trunk of the inferior alveolar nerve is most commonly injured during oral surgery. So, whether it's a third molar extraction, dental implant surgery, an osteotomy to remove defects, submandibular gland removal, or tumor removal, care must be taken to preserve this nerve. Symptoms of inferior alveolar nerve injury usually include paresthesia, complete numbness, or pain in the teeth, gingiva, chin, and lower lip. Another clinically important branch of the mandibular nerve is the auriculotemporal nerve. This nerve passes just above the parotid gland and gives branches that provide parasympathetic secretomotor innervation, originally from cranial nerve 9, to this gland. Secretomotor nerve activity at our salivary glands is what causes salivation to increase when we see food, think about eating, or eat something very sour like a lemon. The auriculotemporal nerve also provides sensory innervation to the external acoustic meatus and to the skin of the temporal region. So, when the parotid gland becomes inflamed, this can cause referred pain to these areas. During surgery on or around the parotid gland, the auriculotemporal nerve requires special care. If it gets damaged, then during its healing process, the parasympathetic fibers from the auriculotemporal nerve can mistakenly reattach to other damaged nerve endings in the area, including the nerves connected to sweat glands and blood vessels in the skin. Now, instead of causing salivation like it should, the nerve will cause redness and sweating of the cheek whenever an individual is eating or just thinking about food. This is clinically referred to as gustatory sweating and flushing, and the syndrome is called auriculotemporal or Frey syndrome. Alright, as a quick recap, signs of trigeminal nerve injury include hypoesthesia or anesthesia of all areas supplied by the nerve, absent corneal reflex, paralysis of muscles of mastication, and jaw deviation towards the affected side. Trigeminal neuralgia causes severe unilateral shooting pain in the area supplied by one or more divisions of the trigeminal nerve that lasts up to a couple of minutes and repeats throughout the day. It can be triggered by chewing, talking, shaving, washing the face or teeth, hot or cold air on the skin, or just by touching an area of the face. Herpes zoster, or shingles, is caused by reactivated varicella zoster virus that was dormant in the trigeminal ganglion. It is most dangerous in the distribution of the ophthalmic nerve, as it can cause herpes zoster ophthalmicus, which can potentially cause vision loss. Trauma can also damage branches of the trigeminal nerve. Supraorbital injury can damage the supraorbital and the supratrochlear nerves and cause paresthesia of the forehead. Maxillary sinus fractures can damage the infraorbital nerve and cause numbness in the cheek, upper lip, and upper gingiva. Inflamed maxillary sinus mucosa can press on the superior alveolar nerves and cause referred pain in the maxillary teeth. The inferior alveolar nerve can be injured during oral surgery. Symptoms include paresthesia, complete numbness, or pain in the teeth, gingiva, chin, and lower lip. Finally, the auriculotemporal nerve can be injured during surgery of the parotid gland or surgery nearby to it. If this injury happens, the nerve might not heal properly and can attach to other nerves such as the ones going to the sweat glands in the skin. Instead of salivation, the nerve now causes a condition called Frey syndrome, whose main symptoms are sweating and redness of the cheek whenever an individual is eating or just thinking about food.
It's time to stop and smell the roses. Or perhaps stop and see the clinical correlates of cranial nerve 1 and cranial nerve 2? Common sayings aside, this video will focus on the olfactory nerve, or cranial nerve 1, which allows us to experience smells, and your optic nerve, or cranial nerve 2, which allows us to see the world around us. Both of these nerves are prone to injury along their pathways, so knowing their anatomy can help us locate the different types of lesions that affect these nerves and understand why they are prone to injury. Let's start with the olfactory nerve. The olfactory nerve consists of chemoreceptors found in the nasal mucosa, and their axons make up rootlets that project through the cribriform plate of the ethmoid bone. These rootlets then synapse in the olfactory bulb, which rests on top of the cribriform plate, and this thin bony plate makes up the roof of the nasal cavity. Fast acceleration and deceleration movements, such as a high-impact car crash, can cause shearing and tearing of these rootlets as they travel through the cribriform plate. Head trauma, such as a direct blow to the nose, can also fracture the thin cribriform plate, putting the olfactory nerve at risk of injury. The fracture can injure both the rootlets passing through it or the bulb resting on top of it. Fracture of the cribriform plate can sometimes present with cerebrospinal fluid rhinorrhea, which is cerebrospinal fluid leaking from the nose. Not to be confused with an ordinary runny nose from a cold. Damage to the olfactory nerve can cause anosmia, which means loss of smell. As smell is extremely important in the perception of taste, most individuals with anosmia actually complain of loss of taste. Clinical testing of anosmia is usually not performed, and diagnosis is made by asking the individual if they've lost their sense of taste or smell. One clinical condition that is associated with dysfunction of the olfactory nerve is called Kallmann syndrome. This syndrome occurs when there is a failure of development and migration of neurons from the olfactory placode during fetal development. This structure normally gives rise to both the olfactory nerves responsible for smell, as well as the neurons that secrete gonadotropin-releasing hormone, or GnRH. The GnRH neurons migrate from the olfactory placode and settle in the hypothalamus, from where they control secretion of sex hormones, sexual development, and reproduction. Therefore, individuals with Kallmann syndrome present with issues related to low GnRH production, such as failure to start or complete puberty, delayed growth, low sperm count, and amenorrhea, as well as a decreased sense of smell, known as hyposmia, or complete anosmia. Okay, now let's switch gears and talk about the optic nerve, starting with papilledema, which describes swelling of the optic disc, usually in both eyes, due to increased intracranial pressure. Increased intracranial pressure has many causes, such as expanding intracranial masses like tumors and hematomas, or hydrocephalus, which is an increase in cerebrospinal fluid volume and pressure within the cranium. Anatomically, as the optic nerve is an extension of the central nervous system, it is covered by pia mater and surrounded by the subarachnoid space within the optic sheath. This increased pressure within the subarachnoid space compresses on the nerve, where it occludes the central retinal vein first because the venous pressure is lower than the arterial pressure in the central retinal artery. By occluding the central retinal vein, This slows venous return from the retina, resulting in swelling and edema of the optic disc, which is where the optic nerve sensory fibers and vessels of the optic nerve enter the eyeball. So, when using an ophthalmoscope or fundoscope to view the retina, the examiner will see an elevated optic disc with blurred edges. Furthermore, as the optic disc is not sensitive to light, this results in a physiological blind spot, and swelling of the optic disc will enlarge the individual's blind spot. Another disorder that can affect the optic nerve is multiple sclerosis, which is an autoimmune inflammatory disease which can result in demyelination of the myelin sheaths in the central nervous system. Remember that CNS neurons are myelinated by oligodendrocytes, compared to the peripheral nervous system, which are myelinated by Schwann cells. The reason multiple sclerosis affects the optic nerve is because the optic nerve, as we said, is considered an extension of the central nervous system and not a peripheral nerve. So it is myelinated by oligodendrocytes and susceptible to multiple sclerosis. Damage to the optic nerve due to multiple sclerosis causes optic neuritis. Clinical features associated with optic neuritis include unilateral eye pain, which can worsen with eye movements, and visual problems, ranging from small disturbances to complete loss of vision. Additionally, optic neuritis can also lead to dysfunction of the pupillary light reflex, and this is referred to as a relative afferent pupillary defect, or Marcus-Gunn pupil. A normal pupillary light reflex controls the diameter of the pupil in response to light, where the optic nerve is responsible for the afferent portion of the reflex. When light enters either retina, it is sensed by the optic nerve, which sends this signal to the pretectal nucleus and then to the Edinger-Westphal nucleus. The signal then passes through the oculomotor nerves back to both eyes to cause direct constriction of the ipsilateral pupil and consensual constriction of the contralateral pupil to reduce the amount of light entering the eye. During the swinging light test in a patient with optic neuritis, shining a light in the normal eye causes bilateral pupillary constriction. But when swinging the light to the affected eye, there is a sluggish or absent bilateral pupillary constriction. Sometimes the pupils can actually dilate in response to light. This is because the injured optic nerve can't properly send afferent signals for the pupillary reflex, resulting in the relative afferent pupillary defect. Now let's discuss lesions of the optic nerve pathway. Optic nerve pathway lesions can occur anywhere from the beginning of the pathway, where the optic nerve first senses light on the retina, to the end of the pathway, where the signal is interpreted and processed in the visual cortex of the occipital lobe. Depending on the individual's visual deficits, we can then determine where along the visual pathway the lesion is. Remember that the image that forms on the retina is actually flipped upside down in the vertical plane and reversed on the horizontal plane. For example, the nasal retina of each eye receives input from the temporal visual field, and the temporal retina receives input from the nasal visual field, while the lower half of the retina receives input from the upper half of the visual field, and the upper half of the retina receives input from the lower half of the visual field. With this in mind, let's start by describing the visual field defects we would see with different lesions along the optic nerve pathway. First up, there are complete lesions through the optic nerve. This damages both the nasal and temporal portion of the retina, resulting in complete loss of the visual field, Overall, this causes total vision loss, called anopia, in the affected eye. Next, there are lesions that affect the middle of the optic chiasm, where fibers from the nasal portion of both retinas cross over to the contralateral side to join the fibers from the temporal portion of the retina of the same eye. Lesions of the central optic chiasm damage the crossing fibers carrying information from both nasal portions of the retina, resulting in bitemporal hemianopia, which is loss of the temporal visual field in both eyes. Alternatively, lesions affecting only the lateral portion of the optic chiasm can occur, which is where the uncrossed fibers from the temporal portion of the retina travel. This causes ipsilateral nasal hemianopia, depending on the affected eye, or loss of the nasal half of the visual field of the affected eye. Furthermore, lesions can also affect the optic tract, which is the portion of the visual pathway past the optic chiasm, which holds the fibers from the temporal portion of the retina from the ipsilateral eye, and the nasal portion of the retina from the contralateral eye. Injury here causes homonymous hemianopia, which is a loss of nasal visual field in one eye and temporal visual field in the other eye, or a complete loss of the left or right visual field, where in this example, a right optic tract lesion causes complete loss of the left visual field. Lastly, lesions can affect the signal as it travels from the lateral geniculate nucleus of the thalamus to the visual cortex, known as the optic radiation, which has two pathways, the Meyer loop and the dorsal optic radiation. The Meyer loop carries fibers relaying information from the lower portion of the retina and loops around the inferior horn of the lateral ventricle in the temporal lobe. Lesions of the Meyer loop occur during temporal lobe lesions and results in contralateral upper quadrantinopia, damaging the lower lateral quadrant of the retina on the ipsilateral eye and the lower medial quadrant of the retina of the contralateral eye, resulting in a contralateral upper quadrantinopia, sometimes referred to as a pie-in-the-sky visual defect. On the other hand, the dorsal optic radiation carries fibers relaying information from the superior portion of the retina and passes through the parietal lobe. A lesion here can occur with parietal lobe lesions and results in contralateral lower quadrantinopia, sometimes called a pie-on-the-floor visual defect. Okay, now let's just quickly go back to the optic chiasm and the possible causes of injury to this area. The optic chiasm sits just anterior to the pituitary stalk, where the middle part of the chiasm, which holds the crossing nasal fibers, is in close relation to the pituitary gland and the anterior communicating artery. Therefore, an aneurysm of the anterior communicating artery can compress the midline of the optic chiasm, injuring the crossing fibers, or a pituitary tumor known as a craniopharyngioma. This causes loss of temporal visual field in both eyes, or bitemporal hemianopia. Lateral aspects of the optic chiasm is where uncrossed ipsilateral temporal fibers travel, and these can become compressed by calcification or aneurysm of the internal carotid artery, which is in close proximity but is very rare. In this case, individuals lose the nasal half of the visual field of the ipsilateral eye, or ipsilateral nasal hemianopia. All right, as a quick recap, fast movements or a fracture of the cribriform plate can injure the olfactory nerve, causing anosmia and cerebrospinal fluid rhinorrhea. Kalman syndrome is a condition which also affects the olfactory nerve, causing hyposmia or anosmia together with problems with sexual development. Papilledema is swelling of the optic disc caused by increased intracranial pressure, resulting in a swollen optic disc and enlarged blind spot. Multiple sclerosis can affect the optic nerve, causing optic neuritis, which presents with pain and visual problems. Optic neuritis is also associated with a relative afferent pupillary defect, where the pupils do not reflexively constrict appropriately to light. A lesion of the optic nerve causes anopia of the corresponding eye. A lesion of the middle aspect of the optic chiasm causes bitemporal hemianopia, while a lesion of its lateral aspect causes ipsilateral nasal hemianopia. Lesions of the optic tract cause homonymous hemianopia. Lesions of the Meyer loop cause contralateral upper quadrantinopia, while lesions of the dorsal optic radiation cause contralateral lower quadrantinopia. Central optic chiasm lesions can result from craniopharyngiomas and anterior communicating artery aneurysms, where lateral optic chiasm lesions can result from calcification or aneurysm from the internal carotid artery. The cerebellum, which is Latin for little brain, is a part of the brain that plays a major role in posture, balance, maintenance of muscle tone, and coordination of skilled voluntary motor activities. The brainstem, on the other hand, is a trunk-like structure that connects the higher parts of the central nervous system with the spinal cord and serves as a center for life-sustaining reflexes, such as breathing and our heartbeat. Injury and disease to these parts of our brain can result in a variety of complex neurological problems, which can even have life-threatening consequences. First off, let's look at lesions of the cerebellum, which can be caused by a variety of things, such as stroke, space-occupying lesions, infections, or drug toxicities. Remember that the cerebellar cortex can be divided into 3 functional regions that are positioned longitudinally: the lateral zone, the intermediate or paravermal zone, and the median or vermal zone. One type of lesion is a lateral lesion of the cerebellum, which affects the lateral and intermediate zone of the cerebellum and their associated cerebellar nuclei, which impairs voluntary movements of the extremities. Think lateral lesions affect lateral structures. The lateral zone assists in motor planning, and the intermediate zone has been shown to control muscles of the distal parts of the limbs, particularly the hands and feet. Clinically, lateral cerebellar lesions can cause ipsilateral limb ataxia, meaning loss of coordination of the limb on the same side as the lesion. This can manifest as intention tremor, which are involuntary trembling movements that occur with voluntary targeted movements. Dysmetria, which is when individuals overshoot or undershoot an intended position of the extremities, for example, during the finger-to-nose test. Dysdiadochokinesia, which is the inability to perform fast alternating movements. A loss of balance with a tendency to fall to the same side as the lesion. and finally, reduced muscle tone on the ipsilateral side. Next, there are medial lesions to the cerebellum, which affects the vermis, or median zone, the flocculonodular lobe, or the fastigial nucleus. These areas modulate posture and coordination of the trunk and proximal limbs, which are medial structures. So now, remember, a medial lesion affects the medial structures. Clinically, medial lesions cause truncal ataxia, which is when individuals have an unsteady and wide-based gait, sometimes referred to as drunken sailor gait. Lesions of the flocculonodular lobe tend to cause vestibular symptoms, such as nystagmus, vertigo, and vomiting. One of the most common causes of medial cerebellar degeneration in adults is chronic alcohol abuse, while in children, damage is often caused by brain tumors, such as medulloblastomas or ependymomas. Let's take a short break and see if you can compare clinical symptoms of the lateral versus medial lesions to the cerebellum. Now, the cerebellum sits in the posterior cranial fossa, covered by a fold of dura mater, called the tentorium cerebelli. This fold separates the cranial cavity into the infratentorial space, containing the cerebellum and parts of the brainstem, and the supratentorial space, containing the cerebrum. On the anterior part of the tentorium, there is an opening called the tentorial incisure, or notch, through which the brainstem passes. Since the cranium is a hard structure that can't expand, if supratentorial intracranial pressure rises, it can force parts of the brain to protrude through the tentorial incisure, causing a transtentorial herniation. In a central or downward transtentorial herniation, the whole brainstem is pushed downward, or caudally, through the tentorial notch. This can occur because of severe cerebral edema, like after a traumatic head injury. Other possible causes are space-occupying lesions of the brain, particularly in the supratentorial space, such as tumors or hemorrhages. When herniation develops rapidly, it can tear off small paramedian basilar artery branches that supply the medulla and pons. These small parenchymal bleedings are called Duret hemorrhages. Unfortunately, these are usually fatal, seeing as the brainstem plays a vital role in breathing and regulating heartbeat. Another type of transtentorial herniation is called an uncal herniation, where the medial part of the temporal lobe, called the uncus, is pushed through the tentorial notch, where it compresses on the midbrain of the brainstem. It's usually caused by an expanding mass such as hematomas, tumors, or abscesses in the temporal lobe. One of the first structures that can become compressed is the oculomotor nerve, or cranial nerve 3, on the ipsilateral side. This nerve arises from the midbrain between the cerebral peduncles, providing motor control to the eye muscles, as well as relaying parasympathetic innervation for the constriction of the iris and accommodation of the lens. Since the parasympathetic fibers are positioned superficially to the motor fibers, they're the first to become compressed, resulting in a dilated and fixed pupil, often referred to as a blown pupil, and paralysis of accommodation of the ipsilateral eye. As compression progresses, the motor fibers get affected as well, causing oculomotor nerve palsy, resulting in the eye being pulled downwards and outwards due to unopposed action of the superior oblique and lateral rectus muscles, which are innervated by cranial nerve 4 and cranial nerve 6, respectively. This can cause symptoms like double vision, diplopia, as well as potential ptosis, as the oculomotor nerve supplies the upper eyelid muscle. The uncus can also compress on the cerebral peduncle, where descending corticospinal fibers decussate, which may lead to contralateral hemiparesis. In severe cases of midline shift due to uncal herniation, the brainstem can become compressed on the contralateral edge of the tentorium cerebelli, called the Kernahan notch. This can result in the Kernahan phenomenon, resulting in damage to the contralateral oculomotor nerve and cerebral peduncle, which causes a fixed and dilated contralateral pupil with oculomotor palsy and ipsilateral hemiparesis. Last but not least, there's cerebellar tonsillar herniation, which can be caused by tumors or bleeds, leading to elevated intracranial pressure in the posterior cranial fossa. This increased intracranial pressure causes the cerebellar tonsils to herniate down through the foramen magnum. The tonsils can then compress the brainstem and its respiratory and cardiac centers, leading to coma and potential death. Let's take another short break and see if you can recall the 3 most common types of herniations involving the brainstem and cerebellum. Let's switch gears and talk about the lesions of the brainstem, starting with the midbrain. Lesions or compression of the tectum or dorsal part of the midbrain at the level of the superior colliculi can lead to dorsal midbrain syndrome, also known as the Perronneau syndrome. They involve the vertical gaze center, causing vertical gaze palsy, where individuals are unable to perform upward or downward conjugate gaze. Lesions also involve the Edinger-Westphal nuclei, causing light near dissociation, where pupils do not react to light, but react to accommodation. Damage to the dorsal midbrain in Perronneau syndrome can also cause bilateral eyelid retraction, revealing the sclera above the superior corneal limbus, which is known as the Collier sign. This mechanism is not fully understood, but is thought to be due to overstimulation of the upper eyelid muscles. Finally, when an individual tries to look upwards, there may be irregular, jerky nystagmus that is associated with convergence and retraction of both eyes, particularly with upward gaze, and this is called convergence retraction nystagmus. This can happen because of sustained contraction of the medial rectus and other extraocular muscles. Perronneau syndrome can be caused by a stroke to the dorsal midbrain, a tumor of the pineal gland called a pinealoma, and hydrocephalus. Now, the midbrain is home to many structures, one of which is the medial longitudinal fasciculus, or MLF for short. Damage to the MLF can cause what's called internuclear ophthalmoplegia, which is an impairment of horizontal conjugate gaze. Remember that for horizontal gaze, the frontal eye field sends a signal to the contralateral paramedian pontine reticular formation, which then communicates with the abducens nucleus on that side to act on the contralateral lateral rectus muscle of the frontal eye field, where the signal was sent. Simultaneously, fibers from that abducens nucleus also send fibers through the MLF tract to communicate with the oculomotor nucleus on the ipsilateral side of the original signal from the frontal eye field to act on the medial rectus muscle of the ipsilateral eye, allowing both eyes to coordinate horizontal gaze together in the same direction. Unilateral damage to the MLF causes the inability to adduct the ipsilateral eye, while the contralateral eye can still perform abduction. So, for example, if the right MLF gets damaged and the individual tries to look to the left, the right eye stays fixed while the left eye abducts, causing diplopia. The abducted eye may also undergo nystagmus. Unilateral damage of the MLF is usually due to lacunar infarcts of pontine arteries from the basilar artery in the area of the midbrain and dorsal pons. Bilateral MLF damage can also occur, and it's usually associated with multiple sclerosis. Bear in mind that convergence and pupillary light reflex are not affected by MLF damage because they use different pathways. Lower in the pons, we can also have a lesion to the paramedian pontine reticular formation, or PPRF, which is the subcortical lateral gaze center. As we said, the PPRF receives input from the contralateral frontal eye field and sends signals to the abducens nucleus on the same side to stimulate the lateral rectus muscle of that ipsilateral eye. The signal is simultaneously sent through the medial longitudinal fasciculus to the contralateral oculomotor nuclei to stimulate the medial rectus muscle of the contralateral eye. When there is a lesion to the PPRF, both eyes deviate to the contralateral side, away from the brainstem lesion. This is in contrast to frontal eye field lesions, where both eyes will deviate to the ipsilateral side of the lesion, or towards the side of the lesion. So, for example, when eyes are deviated to the right, the lesion can either involve the left PPRF or the right frontal eye field. Some possible causes for lesions to the PPRF include ischemic or hemorrhagic stroke involving the paramedian branches of the basilar artery that supply it. Now let's take a look at the ventricular system, which is a network of cavities housing cerebrospinal fluid, or CSF for short, within the brain. When there is an increase of CSF volume, this can lead to a dilation of the ventricles, resulting in a condition called hydrocephalus. Normally, CSF is produced by the choroid plexuses of the ventricles and flows from the two lateral ventricles through the third and fourth ventricles, and ultimately to the subarachnoid space to be reabsorbed. The narrowest aspect of the ventricular system is the cerebral aqueduct, also called the aqueduct of Sylvius, which can be found within the midbrain and connects the third to the fourth ventricle. This is the most common site of obstruction that can lead to a buildup of CSF and subsequent hydrocephalus. The cerebral aqueduct can be blocked due to intraventricular hemorrhages, bacterial and fungal infections, or due to congenital aqueductal stenosis. Other possible causes are tumors or masses, like a glioma or a colloid cyst, that compress and further narrow the cerebral aqueduct. Clinically, this can result in non-communicating or obstructive hydrocephalus, which causes headaches, nausea, vomiting, papilledema, coma, and even death. Let's take another break and see if you can recall two conditions and their clinical features that can develop from the compression of the dorsal midbrain by pinealoma. All right, Now let's move on to the reticular activating system, or RAS for short, which is a complex processing center found in the midbrain in an ill-defined area called the reticular formation. The reticular formation is responsible for controlling consciousness and arousal, receiving afferent information from multiple sensory pathways, such as auditory, visual, and somatosensory centers, and relaying this information to the cerebral cortex, which processes this information. It is thought our degree of wakefulness and awareness of oneself in the environment is related to the degree of activity coming from the reticular formation, where things such as pain sensation may stimulate the reticular formation and subsequent increase in arousal. Therefore, lesions of the midbrain, such as bilateral pontine hemorrhage, can damage the RAS, reducing levels of arousal and consciousness. This can cause lethargy, stupor, and coma. Okay, let's look at another midbrain structure called the red nucleus, which helps coordinate muscle tone and body posture. The red nucleus is located in the tegmentum, or ventral part of the midbrain, and gives rise to the rubrospinal tract that descends and acts on the flexor muscles of the upper limb. Severe lesions of the proximal midbrain above the red nucleus damages the descending inhibitory signals from the cortex to the spinal cord and red nucleus. As a result, the red nucleus is overstimulated, sending signals to the flexor muscles of the upper extremities through the rubrospinal tract, increasing their tone. Furthermore, other descending motor tracts, such as the vestibulospinal and reticulospinal tracts, lose inhibitory control, and they also overstimulate the extensor muscles of the body. This leads to a characteristic pathological posturing called decorticate or flexor posturing, where upper extremities are flexed with the wrists and hands flexed into fists near the chest, while the lower extremities are extended and internally rotated with foot plantar flexion. On the other hand, lesions at or below the red nucleus damage the rubrospinal tract, so the flexors of the upper limbs are no longer stimulated. In turn, the vestibulospinal and reticulospinal tracts overstimulate the extensor muscles of the entire body, causing the characteristic decerebrate or extensor posturing, where the upper extremities are adducted, extended, and in hyperpronation, while the lower extremities are also extended with foot plantar flexion. Decerebrate posturing is associated with a worse prognosis. Pro tip: to easily differentiate between these two postures, just remember that in decorticate posturing, the arms are close to the heart, or core in Latin. Let's take a final break and see if you can differentiate between lesions to the frontal eye field, paramedian pontine reticular formation, and medial longitudinal fasciculus. Lastly, let's look at the vomiting center of the brain, which is responsible for our vomiting reflex. The vomiting center is coordinated by the nucleus tractus solitarius, or solitary nucleus, found in the medulla oblongata, and it receives input from multiple sources to initiate the vomiting reflex. First, it receives information from the chemoreceptor trigger zone, or CTZ, which is located on the dorsal surface of the medulla on the floor of the fourth ventricle in an area called the area postrema, or area pukestrema. The CTZ doesn't have a well-developed blood-brain barrier, which means that it can be exposed to chemical substances found in the blood and CSF, which can directly activate it and initiate the vomiting reflex. These substances include toxins, hormones, and drugs, such as chemotherapy drugs, as well as alcohol. It also receives input from visceral afferent fibers coming from the GI tract via the vagus nerve. For example, chemotherapy drugs can stimulate vagal afferent nerve fiber receptors in the bowel wall of the gastrointestinal tract, which ascend and trigger the vomiting reflex in the CTZ. Additionally, it also receives input from the vestibular system, which can explain car and boat sickness. All right, as a quick recap, lateral lesions to the cerebellum cause limb ataxia and loss of balance, while the medial lesions cause truncal ataxia and nystagmus. Increased intracranial pressure can cause central or downwards transtentorial herniation of the brainstem, tearing basilar artery branches supplying the medulla and pons, and may be life-threatening. In uncal transtentorial herniation, the uncus compresses the ipsilateral oculomotor nerve and the descending motor pathways to the contralateral body in the midbrain. In cerebellar tonsillar herniations, the respiratory and cardiac centers of the brainstem are compressed, which can lead to coma and death. Perronneau syndrome refers to a lesion of the dorsal midbrain that causes vertical gaze palsy, light near dissociation, Collier sign, and convergence retraction nystagmus. Lesions of the medial longitudinal fasciculus cause internuclear ophthalmoplegia and impaired horizontal gaze characterized by inability to adduct the ipsilateral eye, diplopia, and nystagmus of the contralateral eye. A lesion of the paramedian pontine reticular formation leads to the deviation of the eyes to the contralateral side. Blockage of the cerebral aqueduct in the midbrain can lead to non-communicating hydrocephalus that presents with headaches, nausea, vomiting, papilledema, coma, and even death. Lesions of the reticular activating system of the midbrain reduce levels of consciousness and may lead to coma. Lesions above the red nucleus present with decorticate posturing, while lesions below it present with decerebrate posturing. The vomiting center of the brain activates our vomiting reflex and receives input from the chemoreceptor trigger zone in the area postrema, which senses emetogenic substances from the blood and CSF, visceral afferents from the GI tract, and the vestibular system. Blood supply to the brain can be divided into an anterior and a posterior circulation. The posterior circulation supplies the cerebellum, brainstem, occipital lobes, and inferomedial temporal lobes, and comes from the vertebral arteries. The vertebral arteries combine to form the basilar artery, which eventually divides into the posterior cerebral arteries. The posterior circulation then connects to the anterior circulation through the posterior communicating arteries. Remember that the anterior circulation comes from the internal carotid artery, which divides into the anterior and middle cerebral arteries. Together, the connection between the posterior and the anterior circulation form the circle of Willis, which is an anastomotic network of arteries at the base of the brain that ensure adequate blood flow, even in cases where part of this circulation becomes occluded. However, there are still instances where obstruction of these arteries and their branches can disrupt blood flow to the brain. So understanding their anatomy and what parts of the brain they nourish can help us better understand the clinical manifestations and management. When blood flow to the brain is obstructed, that causes a stroke, which can either be ischemic or hemorrhagic. Ischemic strokes can be caused by thrombi, emboli, and hypoperfusion injuries, with the latter most commonly affecting the watershed areas of the brain. Hemorrhagic strokes, on the other hand, occur when there is a bleed within the brain tissue, called an intracerebral or intraparenchymal hemorrhage, or a bleed in the subarachnoid space, called a subarachnoid hemorrhage. The posterior circulation of the brain is susceptible to all of these, and the clinical signs and symptoms depend on which artery is occluded. Let's look at the vertebral arteries first, starting with the subclavian steal phenomenon. This is when the vertebral artery on the same side as an occluded or blocked subclavian artery steals blood from the contralateral subclavian artery circulation. This happens when the occlusion is proximal to the vertebral artery. So blood from the contralateral vertebral artery flows to the basilar artery and then continues as retrograde flow through the ipsilateral vertebral artery to the blockage. This allows blood flow to the area supplied by the occluded subclavian vessel and is often asymptomatic. The most common cause of subclavian stenosis is an atherosclerotic plaque, but other less common causes include Takayasu arteritis and complications from cardiovascular surgery, like an aortic coarctation repair surgery. When subclavian steal phenomenon becomes symptomatic, it is considered subclavian steal syndrome. Clinical features usually occur during an exercise, when blood flow to the occluded arm is not enough to meet demand, causing muscle weakness and claudication, meaning pain or cramping of the muscles. Individuals can also have neurological symptoms, such as lightheadedness, dizziness, and vertigo. Next up, let's look at the anterior spinal artery, which arises from the vertebral arteries. The anterior spinal artery, together with the vertebral arteries, give paramedian branches for the anteromedial parts of the medulla. This region of the medulla includes many important structures, such as the lateral corticospinal tract within the pyramids, medial lemnisci, and the hypoglossal nucleus and fibers coming from it. So when the paramedian branches of the anterior spinal arteries don't provide adequate blood flow, the structures within the anteromedial parts of the medulla are damaged, leading to medial medullary syndrome. Clinically, damage to the lateral corticospinal tracts at this level causes contralateral hemiparesis of the upper and lower extremities. Damage to the medial lemniscus pathway at this level leads to contralateral hemisensory loss of proprioception, fine touch, and vibratory sensations from the trunk and extremities. And finally, damage to the hypoglossal nucleus or nerve fibers leads to ipsilateral flaccid paralysis of the tongue that can be seen as deviation to the paralyzed side when protruded. A good way to remember the symptoms of medial medullary syndrome is to think of 3 midline structures. The M in midline stands for medial, and all 3 structures start with an M. 1. Motor pathway, cortical spinal tract. 2. Medial lemniscus. And 3. Motor fibers of hypoglossal nerve. Okay, now let's look at the posterior inferior cerebellar artery, or PICA for short, which is a branch of the vertebral artery that supplies the lateral part of the medulla and regions of the cerebellum. This region of the medulla it supplies contains many important structures, such as the vestibular nuclei, spinal trigeminal nucleus, spinothalamic tract, nucleus ambiguus, the inferior cerebellar peduncle, and sympathetic fibers. Now, infarction to the PICA can lead to lateral medullary syndrome, also known as pica or Wallenberg syndrome. Clinically, damage to the vestibular nuclei leads to nystagmus, vertigo, nausea, and vomiting. Damage to the spinal trigeminal nucleus leads to loss of pain and temperature sensation from the ipsilateral side of the face, where damage to the spinothalamic tract that is already crossed over at the spinal cord leads to loss of pain and temperature sensation from the contralateral side of the trunk and extremities. Damage to the nucleus ambiguus, which houses the motor nuclei for the cranial nerves 9, 10, and 11, leads to dysphagia, dysphonia or hoarseness, dysarthria, and loss of gag reflex. Damage to the nucleus ambiguus is actually specific to pica syndrome, distinguishing this condition from similar ones. Next up, damage to the inferior cerebellar peduncle leads to ipsilateral ataxia, or lack of muscle control and coordination when performing voluntary movements. Dysmetria, or inappropriate voluntary action execution, such as overreaching for a glass of water, and dysdiadochokinesia, or an inability to perform rapid alternating muscle movements. Finally, damage to descending sympathetic fibers can result in Horner syndrome, which includes ptosis, anhidrosis, and meiosis. In order to remember the structures damaged in this syndrome, we can remember that the lateral side of the medulla has 6 S's. 1. The vestibular nuclei. 2. The spinal trigeminal nucleus. 3. The spinothalamic tract. 4. Speech and swallowing, representing the nucleus ambiguus. 5. Inferior cerebellar peduncle. Okay, we know that starts with a C, but it sounds like an S. And 6. Sympathetics. Another mnemonic that you can use to recall the most common clinical features of the lateral medullary syndrome is don't pica, horse, hoarseness, nut can't eat, dysphagia. Okay, now after the vertebral arteries combine to form the basilar artery, there is a branch called the anterior inferior cerebellar artery, or ICA for short, which supplies the lower lateral part of the pons and the inferior and middle cerebellar peduncles. Infarction of the ICA can lead to something called lateral pontine syndrome, also known as the ICA syndrome. Now, in this region, there are structures like the facial motor nucleus, the vestibular nuclei, the spinothalamic tract, spinal trigeminal nucleus, sympathetic fibers, the middle and inferior cerebellar peduncles, and the labyrinthine artery. Damage to the facial motor nucleus results in ipsilateral facial paralysis due to lower motor neuron damage, along with decreased tear and saliva production, loss of taste from the anterior 2/3 of the tongue, and loss of corneal and stapedial reflexes. Vestibular nuclei lesions result in nystagmus, vertigo, and vomiting. Spinothalamic tract and spinal trigeminal nucleus damage lead to loss of temperature and pain sensations in the ipsilateral side of the face and contralateral side of the trunk and extremities. Damage to the inferior and middle cerebellar peduncles result in ipsilateral ataxia, dysmetria, and dysdiadochokinesia. Finally, damage to the sympathetic fibers can cause ipsilateral Horner syndrome. Bear in mind that the ICA typically gives rise to the labyrinthine artery that supplies the inner ear. So infarction of the ICA also causes ipsilateral sensorineural deafness, accompanied with tinnitus and vertigo. Now, when trying to differentiate between all of these syndromes, in particular from lateral medullary syndrome, which shares similar features, facial paralysis is specific to ICA territory infarcts. Let's take a short break and see if you can remember the difference between pica and ICA infarction. Great! Now let's move on to the basilar artery, which supplies the lower midbrain, the anterior medial part of the pons, and the anterior parts of the medulla. Infarction of the basilar artery causes locked-in syndrome, which is a scary condition where the individual may have full consciousness but is paralyzed. More specifically, there is bilateral damage to the descending corticospinal tracts, leading to quadriplegia. There is also bilateral damage to the descending corticobulbar tracts, leading to paralysis of the facial, mouth, and tongue muscles. There is damage to the paramedian pontine reticular formation, also known as the lateral gaze center, resulting in loss of horizontal gaze, in addition to damage of the nuclei to cranial nerve 4 and 6, leading to deficits in ocular movement. Now, with locked-in syndrome, the reticular activating system, or RAS for short, which spans across the brainstem, can be spared, making the individual conscious and aware of their surroundings. However, they are unable to move and interact with the outside world due to damage of the previously mentioned structures. The only way of communication is through blinking and vertical eye movements, as the oculomotor nucleus in the midbrain is spared, and the vertical gaze center is located more superiorly in the midbrain. Respiratory muscles are also paralyzed, so individuals need to be ventilated. To easily recall that the locked-in syndrome is caused by the basilar artery infarction, just remember the mnemonic, locked in the basement. Okay, and last but not least, there's the posterior cerebral artery, or PCA for short, which is the terminal branch of the basilar artery, and supplies areas such as the occipital lobe, inferomedial temporal lobe, splenium of the corpus callosum, thalamus, as well as the hippocampal formation and amygdala, located within the temporal lobe. During a PCA infarct, one commonly affected area is the primary visual cortex, found in the occipital lobe. And lesions here cause contralateral hemianopia, where individuals lose vision in the contralateral halves of the visual fields of both eyes. However, the central part of the visual field is usually preserved, a phenomenon known as macular sparing. This is thanks to the collateral branches of the middle cerebral artery, supplying the part of the visual cortex that receives input from the macula of the eye. Bilateral damage to the occipital lobes results in cortical blindness. However, the pupils are still reactive to light, since the light reflex does not involve the visual cortex. Furthermore, a PCA territory infarct can also affect the splenium of the corpus callosum, which connects the occipital lobes and also allows visual input to reach the parietal language centers of the dominant hemisphere. Damage to the dominant hemisphere can result in dyslexia, as well as alexia without agraphia, meaning that they lose the ability to read but can still write. Non-dominant hemisphere lesions include visual agnosia, which is the inability to recognize objects, and prosopagnosia, which is the inability to recognize faces. If the thalamus is affected during a PCA territory infarct, the individual may experience numbness and paresthesia of the contralateral face, trunk, and limbs. Finally, lesions of the dominant or bilateral temporal lobes, hippocampal formations, and amygdalas lead to the development of amnesia, where individuals can't form new long-term memories. Okay, final quiz. Can you name all the arteries of the posterior circulation? All right, as a quick recap, the brain is supplied by the posterior and anterior circulation, where the posterior circulation comes from the vertebral arteries, which combine to form the basilar artery, and eventually branch as the posterior cerebral arteries, all which are susceptible to stroke or infarct. Stenosis of the subclavian artery can cause subclavian steal phenomenon, where we get retrograde flow through the vertebral artery on the affected side, in order to maintain perfusion of the affected subclavian. Anterior spinal artery infarction leads to medial medullary syndrome, damaging the lateral corticospinal tract, the medial lemnisci, and the hypoglossal nucleus, or fibers coming from it. Infarction of the posterior inferior cerebellar artery, or PICA, leads to lateral medullary syndrome, or Wallenberg syndrome, causing damage to the vestibular nuclei, spinal trigeminal nucleus, spinothalamic tract, nucleus ambiguus, the inferior cerebellar peduncle, and sympathetics. Damage to the nucleus ambiguus is specific for this syndrome, and symptoms include dysphagia, hoarseness, dysarthria, and loss of gag reflex. Infarction of the anterior inferior cerebellar artery, or ICA, causes lateral pontine syndrome, which is when there's damage to the facial motor nucleus, which is specific to this syndrome, the vestibular nuclei, the spinothalamic tract, spinal trigeminal nucleus, sympathetic fibers, the middle and inferior cerebellar peduncles, and the labyrinthine artery. Infarction of the basilar artery leads to locked-in syndrome that includes quadriplegia, paralysis of the facial, mouth, and tongue muscles, and loss of horizontal gaze. But the individual may still retain consciousness and can only communicate through blinking and limited eye movements. The PCA supplies the occipital lobe, medial temporal lobe, splenium of the corpus callosum, and hippocampal formation. A PCA stroke can lead to the contralateral hemianopia with macular sparing. PCA territory infarct can also lead to dyslexia, alexia without agraphia, visual agnosia, prosopagnosia, and numbness of the contralateral face, trunk, and limbs. The cerebral hemispheres are two symmetrical halves of the brain that contain billions of neurons and their connections, forming an amazing network of cells which help govern our everyday actions. These cerebral hemispheres consist of the cerebral cortex, subcortical white matter, and gray matter masses called the basal ganglia, found throughout the subcortical white matter. Due to the complexity of our brains, the clinical conditions affecting our cerebral hemispheres lead to a variety of abnormal and strange symptoms. So understanding the anatomy of the cerebral hemisphere is crucial in understanding these conditions. Let's start with lesions of the cerebral cortex, which is the superficial gray matter of our brains, containing billions of neurons responsible for processing information. Depending on which part of the cortex these lesions occur in, it can cause different clinical manifestations. First, there are lesions of the prefrontal cortex, which is an area responsible for the makeup of a person's personality and governs social behavior. So prefrontal cortex lesions cause frontal lobe syndrome, which generally result in personality changes and can specifically cause problems with planning, initiative, judgment, and social behavior. Individuals have difficulty making decisions and may become impulsive and aggressive. Individuals can also exhibit socially unacceptable behavior, where they no longer restrain from saying or doing inappropriate things, and may also no longer care about their clothing and appearance. Injury to the prefrontal cortex may also contribute to the reemergence of primitive reflexes, such as the grasp reflex, suckling reflex, and groping reflex. Bilateral damage of the prefrontal cortex may lead to incontinence, gait apraxia, and can even lead to akinetic mutism, where awake individuals lack the will or motivation to move or speak, but will follow you with their eyes in response to noise. Next up, there are injuries to the frontal eye fields, which can be found on the middle frontal gyrus, specifically in Brodmann's area 8. Possible causes of lesions to the frontal eye fields include stroke involving the middle cerebral artery, brain tumors, or injury during neurosurgery. This area allows voluntary control of eye movement and conjugate gaze to the contralateral side, as fibers cross over to the contralateral lateral gaze center, which is located in the paramedian pontine reticular formation in order to govern contralateral gaze. Damage to the frontal eye field of one of the cerebral hemispheres will cause both eyes to deviate towards the same side as the lesion, and the inability to voluntarily move the eyes toward the contralateral side. This is in contrast to a lesion of the paramedian pontine reticular formation, which will cause the eyes to deviate to the contralateral side of the lesion, away from the injury. So, for example, when eyes are deviated to the right, the lesion can either involve the left paramedian pontine reticular formation or the right frontal eye field. Let's take a short break and see if you can remember clinical features associated with the prefrontal cortex lesions. What about the frontal eye field lesion? Continuing with lesions of the cerebral cortex, let's cover those that can lead to aphasia, which is the inability to understand and produce speech. These lesions usually affect the dominant hemisphere, which is the left hemisphere for right-handed individuals, and the right hemisphere for left-handed individuals. First, let's look at lesions to Broca's area, or Brodmann's area 44 and 45, which is the motor area responsible for controlling the muscles that allow us to produce words and speak. Located at the inferior frontal gyrus, a lesion to this area results in Broca's aphasia, also known as motor, non-fluent, or expressive aphasia. In Broca's aphasia, individuals have difficulties planning and executing movements necessary for the production of speech. Therefore, they would talk slowly with poor fluency, and there will be increased effort and pauses between words. The individual's comprehension of speech is intact, since Wernicke's area is preserved, but repetition is usually impaired. Individuals can have difficulty naming objects, and are usually aware of their problem, which can be very frustrating for them. You can use Broca to remind yourself of the broken boca, where boca means mouth in Spanish. When Broca's area is damaged, the nearby primary motor cortex may also be affected, so patients may also have accompanying symptoms of weakness or paralysis to the contralateral face and upper limb. Then we can have a lesion to Wernicke's area, or Brodmann's area 22, 39, and 40, which is responsible for processing and understanding both written and spoken language, allowing us to understand a sentence and say it back comprehensively. Wernicke's area is located in the superior temporal gyrus, so a lesion here results in Wernicke's aphasia, also known as sensory or receptive aphasia. In Wernicke's aphasia, individuals are fluent, well-articulated, and may even speak faster than usual, but their comprehension and repetition of spoken and written language is impaired. Because of this, they don't find the right words to use, and their speech appears meaningless, which has been described as word salad. Quick tip: you can use Wernicke to remember word salad. Unlike Broca's aphasia, individuals with Wernicke's aphasia are unaware of their deficits, so they will speak as if nothing is wrong. On a quick note, the optic radiation is in close proximity to Wernicke's area, so individuals can also have accompanying symptoms of contralateral superior quadrant visual field defects. Both Broca's and Wernicke's areas are connected by a bundle of white matter tracts called the arcuate fasciculus, which is located beneath the supramarginal gyrus and the frontoparietal operculum. Lesions of the arcuate fasciculus cause conduction aphasia. In conduction aphasia, individuals have preserved fluency and comprehension of speech, but the repetition of spoken language is severely impaired. They can also have difficulty naming objects, and they are aware of their deficits. And finally, when lesions are so extensive that they affect both Broca's and Wernicke's areas, that causes global aphasia. With global aphasia, there's a loss of speech production and a loss of understanding of both written and spoken words. Individuals are not able to formulate, comprehend, or repeat both spoken and written language. Let's take another break and see if you can remember the common symptoms of Broca's aphasia. What about Wernicke's aphasia? Okay, now let's switch gears and look at lesions of the medial aspect of the precentral gyrus, also known as the anterior paracentral lobule. This area is responsible for motor control of the lower limbs. Damage to the paracentral lobule causes contralateral lower limb weakness and upper motor neuron lesion signs, such as hyperreflexia and positive Babinski sign. Because the falx cerebri extends between the hemispheres to the corpus callosum, a common and usually benign type of tumor called a parasagittal meningioma can compress and affect the paracentral lobules of both hemispheres. Motor control to the urinary sphincters is also located in the anterior paracentral lobule, so bilateral lesions can result in urinary incontinence. Now let's switch gears and cover Gerstmann syndrome, which is caused by a lesion of the angular gyrus, located in the inferior parietal lobe of the dominant hemisphere. The angular gyrus is an area that integrates visual, acoustic, and somatosensory information in order to understand and solve problems, particularly in regards to speech and number processing. The angular gyrus is supplied by the angular and posterior parietal arteries, which are branches of the middle cerebral artery. And occlusion of these arteries can result in Gerstmann syndrome. Gerstmann syndrome typically has 4 key features, which are left-right disorientation, which is confusion differentiating the left and right side of the body, finger agnosia, which is the inability to recognize individual fingers on your hand, acalculia, which is the inability to perform mathematical calculations, and agraphia, which is the inability to write. Furthermore, some lesions may also result in aphasia, as well as alexia, which is the inability to read. Now, a similar lesion in the inferior parietal lobe of the non-dominant hemisphere typically results in hemispatial neglect syndrome. This area also receives its blood supply from angular and posterior parietal arteries of the middle cerebral artery. Clinical features associated with this syndrome is spatial neglect of the contralateral side of the body. Simply put, if the non-dominant hemisphere is the right one, as is the case for right-handed individuals, a lesion in the inferior parietal lobe results in a lack of awareness of the left half of the body and the space around it. An example of this is construction apraxia, where when asked to draw a clock, the individual only draws the right half of the clock, but is unaware that they have not drawn the whole thing. Or dressing apraxia, where they only dress half of their body. The individual also suffers from anosognosia, which is an indifference or lack of ability to recognize their condition. And just briefly, let's cover the hippocampus, which is part of the limbic system and is involved in memory formation. Individuals with bilateral hippocampal damage develop anterograde amnesia, which means they are unable to make new memories, but they can still recall old ones. Neurons of the hippocampal cortex are extremely vulnerable to ischemic damage, and injury begins just 5 minutes after the onset of hypoxia. The hippocampus is so vulnerable to ischemia because it constitutes a watershed area, which means it receives its blood supply from the terminal branches of 2 different arteries, the anterior choroidal artery and the posterior cerebral artery, with limited collateral blood supply. Therefore, there is a high risk for hippocampus injury in clinical situations which are more likely to damage these vessels, such as hypertension, smoking, dyslipidemia, and diabetes, and situations with excessive metabolic demand, like during an epileptic seizure. Let's take another short break and see if you can remember what are the syndromes and clinical features of a dominant parietal cortex lesion. And what about non-dominant? Okay, let's take a look at a lesion that affects the function of the basal ganglia, particularly a lesion of the subthalamic nucleus. Normally, the subthalamic nucleus assists the basal ganglia in the regulation of movements by exciting the globus pallidus internus, which inhibits the thalamus. Once the subthalamic nucleus gets damaged, the globus pallidus internus stops inhibiting the thalamus, which overstimulates the motor cortex, causing a condition called hemibalismus. Hemibalismus usually presents as the sudden, involuntary, and large amplitude flailing of one or both extremities on the side of the body that is contralateral to the side of the lesion. To remember this, you can use the word hemibalismus to recall that half of the body goes ballistic. The subthalamic nuclei mainly receives blood from the small penetrating arteries of the middle cerebral arteries, called the lenticulostriate arteries, and small branches from the posterior circulation. Due to the small size of these arteries, they are prone to blockage, especially in the setting of hypertension or diabetes. Strokes occurring from these small arteries are called lacunar strokes. Okay, now let's discuss another condition called Kluver-Bucy syndrome, which can be caused by bilateral lesions of each amygdala and surrounding cortex of the temporal lobe. These lesions usually develop as a complication of viral encephalitis, typically caused by herpes simplex virus type 1, which usually affects the temporal lobe. Some other possible causes include temporal lobe surgery that aims to treat epilepsy, head trauma that leads to temporal lobe contusions, or hypoperfusion of the bilateral anterior choroidal arteries supplying the amygdala. Kluver-Bucy syndrome usually presents with 3 types of disinhibited behavior: hypersexuality, or increased sexual drive, hyperphagia, or uncontrollable desire to eat, and hyperorality, which is an urge for exploring objects by mouth. Other symptoms that can develop are visual agnosia, or psychic blindness, where individuals cannot recognize objects that they see, in addition to personality changes, like passivity or docility. Speaking about hunger, the hypothalamus contains 2 more nuclei that regulate hunger, which are the lateral hypothalamic nucleus and the ventromedial nucleus. The lateral nucleus stimulates hunger and represents the hunger or feeding center. Lesions of the lateral nucleus, therefore, cause loss of appetite and anorexia and starvation. The ventromedial nucleus, on the other hand, monitors blood glucose and mediates satiety, and stimulation of this area reduces hunger. Injury or a lesion to this area can lead to hyperphagia and obesity. In order to easily differentiate between these lesions, just remember that lateral lesion makes you lean, while ventromedial injury makes you very massive. Injuries which can affect these nuclei include tumors, like a craniopharyngioma, infection, trauma, and vascular disorders. Finally, let's finish off by taking a look at the thalamus and its role in relaying somatosensory information. The ventral posterolateral nucleus of the thalamus receives input from the spinothalamic tract and dorsal columns of the contralateral side of the trunk and extremities, while the ventral posteromedial nucleus receives input from the trigeminal pathway of the contralateral side of the face, and projects this information to the cortex via the thalamocortical fibers in order to be processed. Therefore, damage to these 2 nuclei may result in complete contralateral sensory loss. This means that the individual loses the sense of touch, tactile discrimination, vibration, proprioception, pain, and temperature from the contralateral side of the body, and may even lead to unsteady gait. Damage to these thalamic nuclei can be due to vascular compromise or local compression from things such as tumors. Quiz time! What happens when there is an injury to the subthalamic nucleus? Also, can you recall, injury to which hypothalamic nuclei can cause anorexia and hyperphagia? All right, as a quick recap, lesions of the prefrontal cortex can lead to personality changes, often causing issues in decision-making, socially unacceptable behavior, and apathy towards appearance. A lesion of the frontal eye field leads to deviation of the eyes to the ipsilateral side, while a lesion of the paramedian pontine reticular formation leads to deviation of the eyes to the contralateral side. Lesions to Broca's area can cause motor or expressive aphasia, resulting in difficulty producing words and word repetition. Wernicke's area lesions can cause sensory or receptive aphasia, where individuals have fluent speech but have difficulty with language comprehension. Damage to the arcuate fasciculus leads to conduction aphasia, leading to difficulties in repetition of spoken language, while damage to all these areas leads to global aphasia. Damage to the paracentral lobule causes contralateral lower limb upper motor neuron signs, with bilateral damage also causing incontinence. Lesions of the dominant parietal cortex cause Gerstmann syndrome, which presents with left-right disorientation, finger agnosia, acalculia, and agraphia, while lesions of the non-dominant parietal cortex cause hemispatial neglect. Bilateral damage to the hippocampus causes anterograde amnesia. Injury to the subthalamic nucleus results in hemiballismus. Kluver-Bucy syndrome is caused by bilateral damage to both of the amygdala. Lesions of the lateral hypothalamic nucleus lead to anorexia, while lesions of the ventromedial nucleus lead to obesity. Damage to the ventral posterolateral and posteromedial nuclei of the thalamus leads to the total contralateral sensory deficit. Your brain is awake and working hard all day, every day, even when you're sleeping. So it makes sense that it needs a lot of oxygen and energy, which is why it is well supplied from several major arteries. The circulation of the brain can ultimately be divided into the anterior and posterior circulation, and the understanding of their anatomy can help us understand the clinical consequences and management of various issues that can arise. So let's delve into the anterior circulation of the brain. Remember that the anterior circulation supplies the anterior portion of the brain and comes from the internal carotid arteries, which divide into the anterior and middle cerebral arteries. The anterior circulation then connects to the posterior circulation through the posterior communicating arteries. The posterior circulation comes from the vertebral arteries, which combine to form the basilar artery. Together, the connection between the anterior and posterior circulation form the circle of Willis, which is an anastomotic network of arteries at the base of the brain, which ensure adequate blood flow to the brain, even in cases where part of this circulation becomes occluded. However, there are still instances where obstruction of these arteries and their branches disrupts blood flow to the brain, causing a stroke, which can lead to irreversible neuronal damage. Now, a stroke can be classified as either ischemic or hemorrhagic. Ischemic strokes are much more common, and they happen because of an acute blockage of one of the blood vessels supplying the brain. Ischemic strokes can be thrombotic, embolic, or hypoxic. A thrombotic stroke occurs when there's a blood clot in the artery, formed directly at the site of infarction, which typically occurs because of a ruptured atherosclerotic plaque. An embolic stroke, on the other hand, is where an embolus from another part of the body travels to the site of infarction to cause obstruction. For example, with atrial fibrillation, a blood clot can form in the heart, where it then travels through the circulation to eventually obstruct brain vessels. Then there are hypoxic strokes, where there is not a direct blockage of a vessel, but systemic hypoperfusion, or hypoxemia of the brain. This can cause inadequate oxygenation of the brain, especially in watershed areas, which are supplied by the terminal branches of two large vessels, and are therefore more prone to hypoperfusion injuries. Hemorrhagic strokes, on the other hand, occur when there is a bleed within the brain tissue, called an intracerebral or intraparenchymal bleed, or a bleed in the subarachnoid space called a subarachnoid hemorrhage. This happens most often as the result of chronic untreated hypertension and associated hypertensive vasculopathy. Other causes include amyloid angiopathy, a ruptured vascular aneurysm, and vascular malformations. Now, we can typically identify which artery of the anterior circulation is affected during a stroke based on clinical symptoms. Let's start with the middle cerebral artery, or MCA for short, which supplies most of the lateral cerebral cortex of the frontal, parietal, and temporal lobes, the insular cortex, as well as a large portion of the basal ganglia and internal capsule. Depending on which portion of the MCA is occluded, clinical presentation can vary. Now, the MCA supplies a large portion of the primary motor and sensory cortex, which can be found along the precentral and postcentral gyrus, respectively. Looking at the motor homunculus, we can see that the MCA supplies the area for the face, trunk, and upper extremity. Therefore, lesions of the motor cortex cause weakness or paralysis of the contralateral side of the face and arm, and eventual upper motor neuron signs such as hyperreflexia. Looking at the sensory homunculus, we can see that the MCA also supplies the face and upper extremity area. Because of this, lesions of the sensory cortex produce loss of sensations in the contralateral side of the face and arm. The MCA also supplies the posterior part of the inferior frontal gyrus. This area is in the dominant cerebral hemisphere, which is the left hemisphere for right-handed people and right hemisphere for left-handed people, and is where Broca's area is located. Lesions of this area cause Broca's aphasia, where individuals have difficulties planning and executing movements necessary for the production of speech, while their comprehension of speech is not affected. Furthermore, the MCA also supplies the posterior part of the superior temporal gyrus. In the dominant hemisphere, this is where Wernicke's area is located. When injured, it causes Wernicke's aphasia, where individuals are fluent and may even speak faster than usual, but their comprehension and repetition of spoken and written language is impaired, and their speech appears meaningless. So in a right-handed individual presenting with Broca's or Wernicke's aphasia, we would suspect a lesion to the left MCA. An MCA artery stroke can also affect other regions of the brain, such as the frontal lobe, which contains the frontal eye field in the middle frontal gyrus. This is the center for voluntary control of eye movements and conjugate gaze to the contralateral side. So when injured, it causes both eyes to deviate towards the ipsilateral side, as if they are looking at the lesion. The frontal lobe also contains the prefrontal cortex, and its injuries lead to frontal lobe syndrome, where individuals experience personality changes, such as problems with planning, initiative, and judgment, while the individual also exhibits socially unacceptable behavior. Next, lesions of the angular gyrus of the parietal lobe on the dominant cerebral hemisphere lead to Gerstmann syndrome, which presents with 4 key features: left-right disorientation, finger agnosia, acalculia, and agraphia. Involvement of the parietal cortex on the non-dominant cerebral hemisphere, on the other hand, would cause hemispatial neglect syndrome. This means that individuals have agnosia, or inability to process sensory information of the contralateral side of the body and space around it. Finally, the MCA supplies the subcortical area of the temporoparietal lobe, which contains the optic radiation, where, depending on which hemisphere is affected, a lesion here would result in contralateral homonymous quadrantinopia. Let's take a short break and see if you can remember the most common clinical syndromes associated with a middle cerebral artery stroke. Okay, now let's switch gears and discuss the anterior cerebral artery, or ACA for short, which supplies the medial aspect of the frontal and parietal lobes, as well as anterior portions of the basal ganglia and internal capsule. The ACA supplies specific portions of the primary motor and somatosensory cortex, in particular the anterior and posterior paracentral lobule. When we look at the motor and sensory homunculi, We can see that the ACA mainly supplies the areas for the lower extremities and genitalia. Therefore, occlusion of the ACA leads to paresis, or motor loss of the contralateral leg, with eventual upper motor neuron signs such as lower limb hyperreflexia and positive Babinski sign, while lesions of the sensory cortex lead to sensory loss of the contralateral leg. To make matters worse, the left and right ACA can sometimes get occluded at the same time, causing bilateral damage to both hemispheres. Motor control to the urinary sphincters is also located in the anterior paracentral lobule, so bilateral lesions can result in urinary incontinence. Now, as we recall, the brain is contained within the rigid bony cranium, which provides great protection, but doesn't allow the intracranial space to expand. Because of this, any mass-occupying lesion, such as a hemorrhagic stroke or a tumor, increases the intracranial pressure and pushes the brain tissue of the frontal, parietal, or temporal lobe away from the lesion. In a setting like this, the cingulate gyrus of the affected cerebral hemisphere is forced under the falx cerebri, which separates the hemispheres, leading to a subfalcine or cingulate herniation. As herniation progresses, the cingulate gyrus pulls the ipsilateral anterior cerebral artery together with it under the falx, where it can be compressed or occluded. This leads to infarction in the regions of the cerebral cortex supplied by the ACA and its characteristic clinical features, which are hemiplegia and hemisensory loss of the contralateral leg. Subfalcine herniation can also obstruct the foramen of Monro, which allows passage of cerebrospinal fluid from the lateral ventricles to the third ventricle, causing obstructive hydrocephalus, or a buildup of cerebrospinal fluid in the brain. Now, let's discuss a particular type of stroke known as a lacunar stroke, which involves small blood vessels arising from the MCA and ACA, called the lenticulostriate arteries. The lenticulostriate arteries arising from the MCA are sometimes referred to as the lateral lenticulostriate arteries, and the ones arising from the ACA are sometimes referred to as the medial lenticulostriate arteries. They penetrate the brain and supply deep subcortical structures, like the striatum, composed of the caudate and lentiform nucleus, and the internal capsule. These arteries are susceptible to injury secondary to uncontrolled hypertension. The high blood pressure damages their endothelial cells and leads to the development of hyaline atherosclerosis, thickening the arterial wall, which reduces their lumen size and blood flow, setting the stage for a lacunar stroke. Lesions that develop from a lacunar stroke commonly affect the posterior limb of the internal capsule and damage the descending corticospinal and corticobulbar tracts. This causes hemiplegia of the contralateral side of the body, with eventual signs of upper motor neuron lesion, such as hyperreflexia, hyperspasticity, and positive Babinski sign. The thing that differentiates lacunar stroke from other types of strokes is the absence of cortical signs, such as aphasia, visual field defects, hemi-neglect syndrome, and others. This is why lacunar strokes are sometimes referred to as pure motor strokes. Let's take one more break and see if you can recall the areas of the brain supplied by the anterior cerebral artery. Now let's move on to the concept of watershed zones of the brain. A watershed zone is a cortical or subcortical area supplied by two major arteries. For example, between the MCA and ACA, or between the MCA and PCA. Watershed zones get their blood supply from the terminal branches of both adjacent arteries. So if there's systemic hypoperfusion or hypoxemia, these terminal branches cannot provide enough blood supply to this area. This is why watershed zones are especially prone to infarction. Some of the most common causes of hypoperfusion include cardiovascular surgery and cardiac arrest, which cause bilateral lesions, or major arterial stenosis, such as the internal carotid artery stenosis, which often causes unilateral lesions. Going back to the motor homunculus, we can see that the cortical area for the proximal part of the upper and lower extremities is a watershed zone between the ACA and MCA. Because of this, infarction of the watershed zones between the ACA and MCA causes proximal muscle weakness of both upper and lower extremities, which is sometimes referred to as the man-in-a-barrel syndrome. On the other hand, infarction of the watershed zones between the MCA and PCA damages areas around the visual cortex that are in charge of processing visual information. This presents as a higher-order visual dysfunction, such as prosopagnosia, or the inability to recognize people's faces. Visual agnosia, or loss of the ability to recognize objects, alexia, or the loss of the ability to comprehend written language, and achromatopsia, which is a form of colorblindness. Finally, let's look at the different types of brain bleeds that can occur. Depending on where the bleed occurs in relation to the dura, arachnoid, and pia mater, brain bleeds can be divided into epidural, subdural, and subarachnoid hemorrhages. So let's start with the epidural hematomas, which typically develop after injury of the middle meningeal artery, following a traumatic event and possible skull fracture. The most common site of fracture is the pterion, which is the thinnest area of the skull. It can be found in the lateral region of the skull, where the frontal, parietal, temporal, and sphenoid bones come together. Sharp bone fragments can lacerate distal branches of the middle meningeal artery, coursing in the area of the pterion, after it enters the foramen spinosum to act as the major blood supply for the cranial dura mater. Once ruptured, the artery then bleeds, causing a fast-growing hematoma to accumulate in the space between the outer or periosteal dura layer and the inner skull. On a head CT, the hematoma presents as a hyperdense, biconvex, or classical lens shape blood collection that does not cross the suture lines of the skull. To remember that epidural hematomas are outside of the dura, think that when you go outside, you need to wear sunglasses with lenses in them to protect yourself from the sun. Individuals can sometimes present with a lucid interval, where they experience an interval of no symptoms. But these hematomas can progress quickly in a matter of hours and be fatal. Next up, there are subdural hematomas, which can either be acute or chronic. Acute injuries can develop following a traumatic event or blow to any part of the skull. This blow displaces the brain, damaging the bridging veins found in the subdural space that drain the superior cerebral veins into the superior sagittal sinus. Individuals that are at higher risk of developing subdural hematomas are elderly individuals and alcoholics. These people are prone to brain atrophy, which shrinks the brain down, creating more space and putting more stress on longer bridging veins within the subdural space. So even minor traumas can cause subdural hematomas. In children, subdural hematomas are also a sign of shaken baby syndrome, which is an indicator of child abuse. Once damaged, these veins bleed below the dura in the subdural space between the dura and arachnoid. On a head CT, there's a crescent-shaped hematoma that crosses the suture lines, making it distinguishable from an epidural hematoma. Finally, there are subarachnoid hemorrhages. These can occur after trauma, aneurysmal rupture, or arteriovenous malformation of the major arteries at the base of the brain. With a ruptured aneurysm, individuals may experience what's called a thunderclap headache, typically described as the worst headache of their life. The bleeding occurs between the arachnoid and pia mater, in the subarachnoid space that is normally filled with the cerebrospinal fluid. On a head CT, a subarachnoid hemorrhage can be seen as hyperdense areas of blood collected in the subarachnoid space, which can be found in the major brain fissures and sulci, along the falx cerebri, tentorium cerebelli, and falx cerebelli, or the cisterns of the brain. Okay, final quiz. Can you name all the arteries of the anterior circulation? All right, as a quick recap, the anterior circulation supplies the anterior part of the brain. The MCA supplies the lateral side of the brain. A stroke in this area usually leads to the contralateral hemiparesis and sensory loss of the face and arm. A stroke in the dominant hemisphere can also lead to Broca's or Wernicke's aphasia, or Gerstmann syndrome, while in the non-dominant side, it leads to hemi-neglect syndrome. The ACA supplies the medial side of the brain, and when occluded, that causes contralateral hemiparesis and hemisensory loss of the leg. When occlusion is bilateral, it also leads to urinary incontinence. Subfalcine herniation is when the cingulate gyrus is forced under the falx cerebri to the contralateral side of the brain, and if severe enough, the ACA can become compressed and occluded. A lacunar stroke involves the lenticulostriate arteries and leads to the hemiparesis of the contralateral side of the body and can manifest as pure motor stroke. Lesions of the watershed zones between ACA and MCA lead to the proximal muscle weakness of the arms and legs, while lesions of those between MCA and PCA produce higher-order visual dysfunctions. Intracranial bleeds can also be categorized as epidural, subdural, and subarachnoid hemorrhages, depending on their location. Our spinal cord is protected by a strong vertebral canal. However, it's still vulnerable to a variety of clinical conditions. Being able to recognize and identify these clinical conditions can help us understand the functional deficits that coincide with those conditions, and ultimately allow us to treat them. The spinal cord transmits information from both motor neuron branches and sensory neuron branches between the brain and the rest of the body. One way we can test whether there is injury to the spinal cord and disruption of these neuronal pathways is eliciting the autonomic tendon reflexes. You know, when the doctor hits your knee with a tendon hammer and you automatically kick him? This occurs because when you hit the tendon with a tendon hammer, stretch receptors in the muscle tendon send afferent impulses to the spinal cord through their cell bodies in the dorsal root ganglion, which synapse with alpha motor neurons in the anterior horn. These alpha motor neurons then transmit an automatic efferent signal back to the muscle, leading to a contraction in the muscle. All you have to do is locate the muscle tendon, get the individual to fully relax the muscle, and strike the tendon with a tendon hammer. Testing tendon reflexes can give important information about a patient's condition. Eliciting testing tendon reflexes can tell us if there is damage to a particular nerve root, to an area of the spinal cord or brain, or the general state of a patient's entire peripheral nervous system, which can be affected in things such as diabetes and motor neuron disease. Testing tendon reflexes can also help us to determine different myotome levels that may be affected during nerve dysfunction. Now remember, a myotome is a group of muscles innervated by a single spinal level. However, it is difficult to test a single myotome as each muscle is innervated by multiple spinal levels. Therefore, clinically, when we test tendon reflexes, we are gaining information on multiple myotomes. The commonly affected tendon reflexes and their associated myotomes tested in clinical practice, as well as a little memory trick, are the brachioradialis and biceps tendon, which test myotome C5 and C6 to pick up sticks, the triceps tendon, which tests C6, C7, and C8 to make your arms straight, the patellar tendon, which tests L2, L3, and L4 to kick the door, and the Achilles tendon, which tests S1 and S2 to buckle your shoe. One of the most commonly talked about injuries to the spinal cord is disc herniation, which often results in nerve compression and spinal cord radiculopathy, which affects the motor and sensory function of that nerve. Before we get into this, let's start with some basic anatomy. The intervertebral disc has a rounded region in its center, called the nucleus pulposus. And the nucleus pulposus is surrounded by a fibrous ring called the annulus fibrosus. Disc herniation typically occurs during forward flexion of the vertebral column. This compresses the disc anteriorly and stretches it posteriorly, pushing the nucleus pulposus posteriorly. And it's more likely if there's violent hyperflexion of the vertebral column. Herniation of the nucleus pulposus usually extends posterolaterally. This is because posteriorly, the annulus fibrosus is thinner and doesn't receive support from either the posterior longitudinal ligament or anterior longitudinal ligament. This type of herniation is more likely to cause symptoms because it's close to the spinal nerve roots. If there is degeneration of the annulus fibrosus, then the nucleus pulposus can actually herniate to the vertebral canal itself, causing impingement of the spinal cord, or cauda equina. Posterolateral herniations of the nucleus pulposus are most common in the lumbar and lumbosacral region. More specifically, they usually occur at the L4, L5, or L5S1 levels. When intervertebral discs herniate, that affects the nerve root corresponding to the inferior level of the herniated disc. This is because spinal nerves in the lumbar region exit the intervertebral foramen superior to the level of the herniated disc. So, for example, a herniated disc at the L4-L5 level will not impinge spinal nerve L4 because it exits the intervertebral foramen above the intervertebral disc located between L4 and L5. However, it will impinge on the L5 nerve root because it will cross this disc on its way to exiting the intervertebral foramen between L5 and S1. Nerve impingement causes clinical symptoms such as lower back pain, paresthesia, and weakness in the territory innervated by that nerve. Pain can also be referred down the back of the legs due to this nerve impingement. Now, a particular type of pain often caused by a herniated lumbar intervertebral disc is sciatica. And this results in lower back pain, as well as radiating pain to the hips, the back of the thigh, and lower legs. Individuals may also have weakness in hip extension, knee flexion, and ankle plantar flexion, as well as an absent ankle tendon reflex. It occurs when a herniated lumbar intervertebral disc compresses any portion of the sciatic nerve from L4 to S3. However, it most commonly occurs at the level of L5 or S1. Now, any maneuver that stretches the sciatic nerve can elicit symptoms clinically. Classically, the straight leg test is used to elicit symptoms. During this test, an individual lies on their back, and their leg is lifted while straight to flex the thigh and stretch the sciatic nerve. Normally, no pain is present until about 80 to 90 degrees, where if sciatica is present, pain occurs at less than 60 degrees. However, this test may be variable. Now, intervertebral disc herniation can also occur in the cervical region, almost as often as in the lumbar region. This can be caused by chronic or sudden forced hyperflexion of the cervical region, like with a head-on collision, or during sports such as football if someone makes a hit with the top of their head. In the cervical region, when the spinal nerves exit the intervertebral foramen, they cross the intervertebral disc of the same level and exit inferior to it, unlike in the lumbar region. Therefore, a herniated disc in the cervical region compresses the nerve that exits at that level and not the inferior level, as it would in the case of the lumbar region. With this in mind, you might expect a cervical disc herniation to therefore affect the spinal nerve above. However, we must remember that there are 8 cervical spine nerves and only 7 cervical vertebrae. So each cervical spinal nerve will exit superior to the vertebrae of the same number. For example, nerve root C6 exits the intervertebral foramen above the C6 vertebrae. And because the cervical spinal nerves cross the intervertebral disc at the same level it exits, intervertebral disc herniation in the cervical area will affect the nerve root corresponding to the inferior level of the herniated disc, just like in the lumbar region. Using the 2 most frequent areas of cervical disc herniation as an example, herniations that occur at the C5-C6 level would impinge the C6 nerve root, and herniation of the C6-C7 level would affect the nerve root of C7. To make things easy, just remember no matter where you have a disc herniation, the nerve root affected typically corresponds with the same vertebral level as the vertebral body below. So like we said, an L4-L5 herniation will impinge on the L5 nerve root, and a C6-C7 herniation will impinge on the C7 nerve root. Disc protrusions resulting in cervical radiculopathy can cause pain in the neck, shoulder, arm, and hand, as well as cutaneous deficits of the nerve roots affected. All right, let's review. Where do lumbar disc protrusions mostly occur? And where do cervical disc protrusions mostly occur? We also have 2 more syndromes that can affect the spinal cord, either of which can be the result of intervertebral disc herniation, fractures or other trauma, and tumor invasion. The first involves the conus medullaris, which is the point where the spinal cord tapers and terminates in adults at the L1-L2 vertebrae, and the branching nerves of L3 to S4 below this point, which are collectively known as the cauda equina. A lesion at the level of L1-L2 can result in conus medullaris syndrome, where a lesion below this can result in cauda equina syndrome. Any lesion from T12 to S4 can cause damage to both the conus medullaris or cauda equina, and can result in numerous symptoms such as radicular low back pain radiating down the legs and lower extremity weakness. Conus medullaris syndrome, however, typically causes symmetric bilateral lower extremity weakness, in addition to a potential mixed picture of both upper and lower motor neuron signs, with a preference for upper motor neuron signs, including things such as spasticity and hyperreflexia. This is in contrast to cauda equina syndrome, which typically affects both legs, but is more likely to present with asymmetric lower extremity weakness, as well as the potential for loss of the knee and ankle reflex indicative of a lower motor neuron deficit. Furthermore, lesions in the T12 to S4 region resulting in either conus medullaris and cauda equina syndrome can cause more severe symptoms, such as loss of bladder and anal sphincter control, due to compression of parasympathetic innervation traveling through the pelvic splanchnic nerves in S2 to S4, as well as the classic finding of saddle anesthesia, meaning that there's a loss of sensation in the area of the buttocks, perineum, and inner surface of the thighs. As these syndromes have the potential for severe neurological dysfunction, they require urgent evaluation and may ultimately need surgical decompression. Typically, when we think of damage to the nerves of the spinal cord, we think of some sort of trauma or compression. Another type of condition that can affect the nerves, though, is infection, one being a herpes zoster infection, better known as shingles. This type of infection affects the dermatomal distribution of a particular nerve, resulting in an agonizing and painful skin condition of the dermatomal distribution of that nerve. This is typically caused by a reactivation of the varicella zoster virus after initial infection, which also causes the chickenpox virus, as it remains dormant in the dorsal root ganglia of sensory nerves. For example, if the T10 sensory nerve is affected, the reactivated virus will invade the sensory nerve dorsal root ganglion and affect its dermatomal distribution of T10, which courses along the mid-back towards the abdomen at the level of the belly button. The skin will become red with vesicular eruptions, and the pain may either come before the skin is affected or after. Typically, this affects a single nerve, but can migrate to multiple ganglia and affect multiple dermatomal areas. Let's move on and talk about lumbar punctures, or LP for short. An LP is the withdrawal of cerebrospinal fluid, or CSF, from the lumbar cistern, and it's useful for evaluating central nervous system disorders, like meningitis. Typically, before an LP is performed, the intracranial pressure is determined. This is done by either CT scan or by examination of the fundus of the interior of the eye with the help of an ophthalmoscope. This is because increased intracranial pressure is a relative contraindication to lumbar puncture, as it increases the risk of brainstem herniation. Therefore, additional precautions should be taken in these particular individuals who require a lumbar puncture. During a lumbar puncture, CSF can be analyzed, giving us information about the contents of the CSF. Typically, CSF analysis will see if there are any microorganisms present, whether there is an abnormal amount of red or white blood cells, and whether there are any changes in the normal concentration of CSF elements, such as glucose or protein. Long story short, this can help diagnose both bacterial and viral infections, as well as potential brain bleeds, such as a subarachnoid hemorrhage, and are often done in individuals presenting with things such as fever, headache, petechial rash, and neck stiffness. Now, an LP is performed with the individual lying on their side with the back and hips flexed, also called the recumbent or knee-chest position, or sitting position leaning over their knees. This flexion of the vertebral column makes room for easier insertion of the needle by spreading apart the vertebral laminae and spinous processes, and by stretching the ligamentum flavum. Now, keep in mind that in adults, the spinal cord terminates at the level of the L1, L2 vertebrae, and the subarachnoid space extends to the S2 vertebrae. However, at birth, the tip of the spinal cord is at the level of L3, L4, as the vertebral column grows more rapidly than the spinal cord. So there should be special consideration to make sure the lumbar puncture is performed below the level of L3, L4 in infants. To begin the procedure, anesthetize the skin and sterilize over the area of the lumbar puncture. A lumbar puncture requires using a lumbar puncture needle, which is a hollow needle fitted with a stylet. Next, insert the needle in the midline just between the spinous processes of L3 and L4 or L4 and L5 vertebrae in adults, and between L4 and L5 vertebrae in children. To find this location, there is a plane transecting the highest points of the iliac crests, which usually passes through the L4 vertebral body. Therefore, by palpating the iliac crests, you can locate the L4 vertebral level. Insertion of the needle at these levels means you are safe from damaging the spinal cord. The needle initially enters the skin and fascia before it pierces the interspinous and supraspinous ligament. The needle then continues and pops through the ligamentum flavum, a ligament which attaches to the lamina of adjacent vertebral segments. Going forward, the needle enters the epidural space. To get to the subarachnoid space, it then punctures the dura and arachnoid matter. When the stylet is removed, cerebrospinal fluid drips out, indicating you are in the right space, which can then be collected for analysis. Speaking of sticking needles in the back, let's talk about spinal and epidural anesthesia, which is often done during childbirth. Which type of person will receive will depend on timing of delivery, as well as institutional preference. With spinal anesthesia, the anesthetic agent is introduced with a needle into the subarachnoid space at the L3, L4 vertebral level in the same way a lumbar puncture is done, and anesthesia usually occurs within 1 minute. The spinal anesthesia produces a temporary anesthesia below the waist, so individuals can't feel pain in the perineum, pelvic floor, and birth canal, or the sensation of uterine contractions, and the motor and sensory functions of the entire lower limbs. This means that the mother is conscious, but they depend on electronic monitoring of uterine contractions. If the labor is extended or the level of anesthesia is inadequate, then it's almost impossible to re-administer the anesthesia. Spinal anesthesia may be preferred when there is a quick onset of delivery. The anesthetic agent circulates into the cerebral subarachnoid space in the cranial cavity when the individual lies flat. So the most common side effect of this type of anesthesia is a severe headache. With epidural anesthesia, on the other hand, the patient is in the same position as a lumbar puncture. However, the needle does not pierce the dura and arachnoid matter to enter the subarachnoid space, and the anesthetic agent is administered in the epidural space instead. Furthermore, this technique uses an indwelling catheter, which stays in the epidural space, which allows the administration of more anesthesia if needed, and is often chosen as it provides analgesia throughout longer labors and can be constantly re-administered. During an epidural anesthesia, the goal is to anesthetize the spinal nerves in that area and below, such as the S2 to S4 spinal nerve roots, which contribute pain fibers from the uterine cervix, superior vagina, and also the afferent fibers from the pudendal nerve. The goal is for anesthesia of the birth canal, pelvic floor, and majority of the perineum. Because the amount of epidural administered is controlled through an indwelling catheter, the mother may be able to feel her uterine contractions in order to help guide pushing during delivery, depending on how much anesthesia is given. With epidural anesthesia, there's no spinal headache because the vertebral epidural space is not continuous with the cranial epidural space. However, the anesthetic must be administered in advance of delivery and cannot be done when childbirth occurs suddenly. Can you remember where we should insert the needle during a lumbar puncture in adults and in children? What layers are pierced in a lumbar puncture? How about in an epidural? All right, as a quick recap, automatic tendon reflexes of the brachioradialis and biceps tendon, triceps tendon, patellar tendon, and Achilles tendon allow us to test myotome nerve roots for dysfunction. Disc herniation is when the nucleus pulposus slips into or through the annulus fibrosus. Posterolateral herniations of the nucleus pulposus are most common in the lumbar and lumbosacral region at the level of L4, L5, affecting the L5 nerve root, or L5, S1, affecting the S1 nerve root. A herniated lumbar intervertebral disc can cause sciatica, which is pain in the lower back and hip that radiates down the back of the thigh into the leg. Disc herniation can also occur in the cervical region, usually between C5-C6, affecting nerve root C6, or between C6-C7, affecting nerve root C7. Conus medullaris syndrome and cauda equina syndrome occurs when there is compression of the spinal roots below L1-L2, and this usually happens due to intervertebral disc herniation or a tumor. They can share similar features such as low back pain, saddle paresthesia, bladder and bowel dysfunction, and lower leg weakness. Specifically, conus medullaris syndrome may present with symmetric bilateral lower extremity weakness, with potential upper motor neurons signs. In contrast, cauda equina syndrome can present as more asymmetric unilateral weakness, with potential lower motor signs. Shingles is a dermatological condition where reactivation of the herpes zoster virus causes redness and vesicular eruptions along a sensory nerve's dermatomal distribution, where pain can precede or follow skin findings. Finally, a lumbar puncture can be done to evaluate central nervous system disorders by evaluating cerebrospinal fluid. With spinal anesthesia, the anesthetic agent is introduced into the spinal subarachnoid space, whereas with epidural anesthesia, the anesthetic agent is administered using an indwelling catheter in the epidural space. The vertebral column is a very complex bony structure, with numerous articulating joints and multiple muscles that support it, and the vertebral canal. As with any part of our body, all of these structures are prone to injury. If you aren't familiar yet with what type of injuries, don't worry, we got your back. Let's start with fractures involving the C1 vertebra, or atlas. These fractures are also called Jefferson or burst fractures. As you might remember, C1 is a ring-shaped bone that has paired wedge-shaped lateral masses, connected by thin anterior and posterior arches, and a transverse ligament. The C1 vertebra sustains the weight of the cranium, kind of like how the god Atlas of Greek mythology bore the weight of the world on his shoulders. Now, because the taller side of the lateral mass is directed laterally, when there are vertical forces that compress the lateral masses between the occipital condyles above and the C2 or axis below, this compressive force drives the two lateral masses of the C1 vertebrae apart, which can lead to fractures in one or both of the anterior or posterior arches. A classic example of this is striking the bottom of the pool with the top of your head when diving. If the force is really strong, it could even rupture the transverse ligament. The Jefferson fracture doesn't necessarily lead to spinal cord injury. This is because the diameter of the vertebral ring actually increases. However, spinal cord injury could happen if the transverse ligament ruptures as well, potentially resulting in the dens of the C2 vertebra, or the odontoid process, compressing on the spinal cord, which we will get to shortly. On a CT scan, a C1 fracture looks something like this. You can see where the bone has been broken, and how the lateral mass shifts laterally. Moving on, the C2 vertebra, or the axis, can also be fractured. C2 is called the axis because it has a bony protrusion called the dens of the axis that fits within the atlas ring. So this articulation allows rotation of the neck from side to side, like shaking your head no. Now, one of the most common injuries to the cervical vertebrae are fractures of the vertebral arch of the axis. The fracture usually occurs in the bony part formed by the superior articular process and inferior articular processes of the axis, also known as a traumatic spondylolysis of C2. This happens as a result of hyperextension of the head on the neck. So in the past, this fracture pattern was often seen in criminals who were executed by hanging. Therefore, it has also been referred to as a hangman's fracture. In more severe injuries, the body of C2 is displaced anteriorly. Regardless of whether there is anterior displacement of the body, injury of the spinal cord may occur, which can lead to paralysis in all 4 limbs and even death. You can recognize a C2 fracture on X-ray in the area of the lamina and pedicles. Now, the dens of the axis, or odontoid process, as we said, can also be fractured, usually because of force, flexion, or extension in the anterior-posterior plane. There are 3 types of dens fractures. Type 1 is the most uncommon type, and it's when the fracture occurs above the transverse ligament, resulting in a relatively stable fracture. Type 2 is the most common fracture pattern, and it's usually located at the base of the dens where it attaches to C2. These fractures tend to be unstable and may be complicated by non-union, which is when a fracture won't heal properly because of poor blood supply, excessive movement at the fracture site, or infection. Finally, type 3 fractures occur below type 2 fractures at the vertebral body inferior to the base of the dens. This fracture heals faster because the fragments retain their blood supply. However, they are mechanically unstable, as this fracture moves with the occiput as one unit. Dens fractures are best seen on an open mouth radiograph. You can see the bone discontinuation at the base of the dens. It is easier to distinguish on a coronal CT scan and a sagittal CT scan. Before going any further, let's see if you can remember what a Jefferson fracture is, and what's the most common mechanism that causes it. Oh, and why is the C1 vertebra called the atlas? That last one's just for fun. Let's move on to a pretty common pathology called osteoporosis, which often affects postmenopausal females and elderly individuals regardless of sex. Risk factors for osteoporosis include a decrease in estrogen levels, old age, and drug use such as steroids, alcohol, and other medications. With osteoporosis, there is an imbalance between bone formation and resorption in favor of the latter, resulting in gradual loss of bone mass, so bones fracture more easily. The most affected bones are the neck of the femur, the bodies of the vertebrae, the metacarpals, and the radius. Now, osteoporosis typically affects the horizontal trabeculae of the trabecular bone of the vertebral body. The remaining vertical trabeculae are less able to resist compression, and so compression fractures can occur, which lead to short and wedge-shaped vertebrae. A vertebral compression fracture can present with low back pain, immobility, and tenderness at the level of the fracture. However, these fractures can also be chronic and painless, leading to height loss and kyphosis. On a vertebral column X-ray, you can see vertebral collapse or compression fractures, which can be seen in later stages of osteoporosis due to the decrease in bone density. Moving on, let's talk about spondylolysis, which usually affects the lower lumbar vertebrae. This is when there's a unilateral or bilateral defect of the vertebral arch in the vertebral pars interarticularis, which causes the posterior part of the arch to separate from the rest of the vertebrae. If the defect is bilateral, the vertebrae can slip anteriorly relative to the vertebrae below, and this is called spondylolisthesis. For example, spondylolysis of L5 can cause the L5 vertebral body to move anterior relative to the S1 vertebra and overlap the sacral promontory. Spondylolisthesis can compress spinal nerves and typically leads to lower back pain and lower limb pain. On this X-ray, you can observe how the L5 vertebra has slipped anteriorly relative to the S1 vertebra. Another ailment of the vertebral column is spinal stenosis. This occurs because as the intervertebral discs degenerate, this results in corresponding loss of disc height, leaving a disproportionate load on the posterior aspect of the spinal column, resulting in osteophyte formation. This narrowing, or stenosis, can lead to compression of one or more spinal nerve roots that occupy the vertebral canal, which may or may not cause symptoms such as back pain, difficulty walking, and tingling and numbness in one or both legs. More severe symptoms of nerve compression include poor control of bowel movements and urination. This compression of the spinal nerves due to the spinal stenosis is called neurogenic claudication, which is different from another type of claudication called vascular or intermittent claudication, which is caused by decreased arterial blood flow. Symptoms of both neurogenic and vascular claudication may be similar, such as pain, cramping, and tightness in the legs. However, the symptoms of neurogenic claudication are more posture-dependent. With neurogenic claudication, walking and standing in an erect position causes increased narrowing of the spinal canal, further worsening symptoms. And those affected find symptom relief when leaning forward, such as when leaning over a shopping cart at the grocery store or walking uphill. With vascular claudication, on the other hand, patients find relief when standing upright. Okay, it's quiz o'clock. Let's see if you can remember what spondylolysis and spondylolisthesis are. Okay, that's very good. Now, let's have a look at the normal and abnormal curvatures of the vertebral column. The vertebral column has 4 normal curvatures, which can be seen on a lateral view. First, there's the thoracic and sacral kyphosis, which are normal spinal curvatures, which have a concave shape in the anterior direction. Then there's cervical and lumbar lordosis, which are normal curvatures which have a concave shape in the posterior direction. Abnormal curvatures can be identified by asking the individual to stand in an anatomical position, then inspecting the profile of the vertebral column from the person's side and then from the posterior aspect. Abnormal curvatures can result from developmental anomalies, or they can be a result of pathological processes, such as osteoporosis. Excessive thoracic kyphosis is an abnormal increase in the curvature of the thoracic spine. For example, osteoporosis can cause excessive erosion of the anterior part of one or more vertebrae, resulting in kyphosis. The excessive kyphosis leads to a decrease in the anteroposterior diameter of the thorax, and it can reduce pulmonary capacity. Next up is excessive lumbar lordosis, which is when the pelvis tilts anteriorly and leads to increased extension of the lumbar vertebrae, which produces an abnormal increase in lumbar lordosis. This can be caused by weakened trunk musculature or physiologically, for example, during late pregnancy. After childbirth, the lower back pain and discomfort usually disappears. Another cause of excessive lordosis for any individual is obesity, which can lead to lower back pain due to the increased weight of the abdominal contents anterior to the normal line of gravity. In this case, weight loss and exercise can correct this type of excessive lordosis. Another type of pathological curvature is scoliosis, and it's when there's an abnormal lateral curvature of the vertebral column that's also accompanied by rotation of the vertebrae. Scoliosis most commonly occurs in adolescence during periods of growth, and in most cases, scoliosis is idiopathic, meaning without an identifiable cause. Adolescent idiopathic scoliosis refers to a Cobb angle over 10 degrees of the spine, and typically presents in children over 10 years of age. It is usually asymptomatic and discovered during annual physicals where asymmetry is noticed. A forward bend test may show asymmetry of the thoracic or lumbar region. The management of scoliosis depends on the skeletal maturity of the individual, which is reflected by puberty status, as well as the degree of curvature, or Cobb angle. A Cobb angle between 10 and 30 degrees is considered mild scoliosis and should be monitored every 6 months. In children with a Cobb angle of over 30 degrees and remaining growth potential, a thoracolumboSacral spinal brace is indicated. In children with a Cobb angle over 40 degrees, surgery may be indicated. Before moving forward, let's see if you can recognize which abnormal curvatures of the vertebral column are pictured here. Okay, moving on to a very common problem, back strains, sprains, and spasms, the 3 S's of the back. Back strains are common in individuals who participate in sports or undergo heavy lifting, and can affect any of the muscles involved in stabilizing or producing movements of the spine. For example, the erector spinae muscles. Have you ever lifted something awkwardly and felt it in your back for days? This was likely due to an imbalance of weight distribution on the vertebral column when lifting, putting a strain on certain portions of your back muscles, resulting in a back strain. Strains are more likely when we use the back as a lever to lift things, and we can minimize this risk by using the gluteal muscles and lower limb muscles to assist with the lifting. The moral of the story is, it's better to lift with your legs than your back. Next up is a back sprain, which is an injury to the ligamentous tissue or its attachment to bone. It can be a result of excessive strong contractions in relation to movements of the vertebral column, for example during excessive extension or rotation. Last but not least, a muscle spasm of the back is a protective mechanism where back muscles go into spasm after an injury or in response to inflammation. A spasm is basically a sudden involuntary contraction of one or more muscle groups. Spasms are accompanied by cramps and pain. To try and avoid the 3 S's of the back, remember to always warm up and stretch before working out, and also exercise and strengthen your core muscles, or the muscles of the anterolateral abdominal wall, especially the transverse abdominis muscle, which plays a role in lumbar stabilization. All right, as a quick recap, fractures of the C1 vertebra often involve a downward force leading to fracture of the anterior arch and posterior arch, whereas C2 fractures commonly affect the vertebral arch. With osteoporosis, bones become weakened, brittle, and are more prone to fractures. Spondylolysis usually affects the lumbar column, and spondylolysis of L5 can lead to spondylolisthesis, which is anterior movement of the L5 vertebral body relative to the S1 vertebra. With spinal stenosis, there's a narrow vertebral foramen in one or more vertebrae that also typically affects the lumbar column. The abnormal curvatures of the spine include excessive thoracic kyphosis, excessive lumbar lordosis, and scoliosis. Adolescent idiopathic scoliosis is when the Cobb angle measuring the lateral curvature of the spine is over 10 degrees, and management depends on the severity of the Cobb angle and skeletal maturity. A back strain is an overly strong muscular contraction, while a back sprain is an injury where only ligamentous tissue or the attachment of ligament to bone is involved, without any dislocation or fracture. A back muscle spasm is a protective mechanism where back muscles go into spasm after an injury or in response to inflammation.
The spinal cord is made up of millions of neurons whose axons and cell bodies are constantly transmitting information between our brain and the rest of our body. In doing so, the spinal cord acts as an amazing information highway, allowing our brain and body to work together to interact with the world around us. But what happens when this information highway is disrupted or damaged? Well, injury to the spinal cord leads to a variety of classic clinical conditions with predictable deficits, which we will explore in this video. So let's get to it. Okay, before we move on to spinal cord injuries, let's freshen up our knowledge of the spinal cord itself. Zooming in on a cross-section of the spinal cord, you'll see it's made up of both gray and white matter. Gray matter is found in the center of the spinal cord and has two dorsal or posterior horns that contain sensory neuron cell bodies, and two ventral or anterior horns that contain motor neuron cell bodies. Surrounding the gray matter is white matter, which consists of the axons of various neurons. They are organized into tracts that carry information to and from the brain. There are four main sensory pathways ascending the spinal column. First, there's the spinothalamic tract, which is divided into two parts. The lateral tract carries sensory information for pain and temperature, while the anterior tract carries information for crude touch and pressure. Next, there are two dorsal column tracts, the fasciculus gracilis, which carries sensory information from the lower trunk and legs, and the fasciculus cuneatus, which carries sensory information from the upper trunk and arms. These tracts both carry sensations such as two-point discrimination, vibration, fine touch, and proprioception. Then there's the spinocerebellar tract, which has an anterior and posterior part. These are ascending pathways from the spinal cord to the cerebellum and carry proprioceptive information from the body. Finally, the major motor pathways descending down the spinal column are the anterior and lateral corticospinal tracts, which are descending tracts that allow us voluntary movement of the limbs. Spinal cord injuries can happen because of a number of different causes. First, the spinal cord can undergo compression or increased pressure, such as from a protruding intervertebral disc or osteophytes, and this can produce sensory and motor symptoms in the area innervated by that particular spinal segment. In more severe cases, the spinal cord may undergo transection, leading to the loss of all sensation and voluntary movement inferior to the site of the lesion. Let's take a closer look at the effects of spinal cord transection. The higher the level the transection occurs at, the more function is lost. If transection happens between C1 and C3, then there's no function below the level of the head, and a ventilator is needed to maintain respiration. If transection happens between C4 and C5, then the individual will suffer quadriplegia, meaning they have no function of their upper and lower limbs or trunk. However, they can still breathe on their own since the phrenic nerve is spared. If transection happens between C6 and C8, then there's still a complete loss of trunk and lower limb function. However, some movements of the upper limb will still be intact, allowing for functions such as feeding or using a wheelchair. If transection happens between T1 and T9, the individual becomes paraplegic, so there's paralysis of both lower limbs, while upper limb function remains intact. In this case, the amount of trunk control varies with the height of the lesion, meaning the higher the lesion, the more severe the deficits are. If transection happens anywhere between T10 and L3, then there will be some level of dysfunction of the lower limbs, resulting in difficulties with walking and ambulation. Now, unlike a complete lesion of the spinal cord, which causes bilateral loss of function of the structures below the lesion, a hemilesion, which is a lesion to only one side of the spinal cord, also known as Brown-Séquard syndrome, will spare certain functions on each side of the body, depending on the side of the lesion. The most common cause is a penetrating trauma, like a gunshot injury or stab wound in the back. But a large spinal cord tumor can also lead to this syndrome. A complete hemisection would result in damage to multiple neural tracts while sparing others. When we consider each tract, we have to think about what happens to that motor or sensory modality at the level of the lesion and below the level of the lesion. We also need to think about which side of the body will be affected, since the tracts cross over at different locations. For example, a complete hemisection on the right-hand side would result in the following. First, there'd be damage to the dorsal column on the right side, which will lead to the loss of fine touch, two-point discrimination, vibration, and proprioception in the right side of the body, which is ipsilateral to the side of the lesion. The loss of these sensory modalities would occur at the level of the injury and below it. Second, the anterior horn will be damaged, resulting in a lower motor neuron lesion at that particular level. Remember, the lower motor neurons synapse with the upper motor neurons of the descending tracts, such as the corticospinal tract. Damage to the anterior horn cells will lead to lower motor neuron signs, such as ipsilateral flaccid paralysis and hypoactive deep tendon reflexes at the specific spinal level of the lesion. Third, damage to the lateral corticospinal tract passing through that spinal level results in upper motor neuron signs on the ipsilateral side of the lesion, below the level of the lesion. These signs include things such as spastic paralysis, hyperactive deep tendon reflexes, and a positive Babinski reflex. Finally, there's damage to the spinothalamic tract. The spinothalamic tract is a bit different, though, because fibers of the anterior tract, which carries crude touch and pressure, will actually ascend one or two spinal segments above the level where the first-order neurons enter, and then cross over to the opposite side of the spinal cord. In contrast, the fibers of the lateral tract, which carry pain and temperature, cross over right away. So, since these fibers all cross over within the spinal cord, a hemilesion on the right side of the spinal cord will cause loss of these sensory modalities on the left side. The level that's affected, though, will change a bit. This means on the contralateral side, 1 to 2 levels starting below the lesion, there is a loss of crude touch and pressure due to anterior tract damage. And at the level of the lesion and below, there's loss of pain and temperature due to lateral tract damage. Furthermore, on the ipsilateral side of the lesion, the lateral spinothalamic tract, which synapses at that level, and the anterior spinothalamic tract fibers that have not crossed yet will both be damaged. So at the level of the lesion on the ipsilateral side, there will be complete loss of all sensory sensation. But starting 1 to 2 levels below the lesion, there is a complete sparing of crude touch, pressure, pain, and temperature. To sum up, during a hemisection, on the ipsilateral side of the lesion, there will be 1, at the level of the lesion, loss of all sensory sensation; 2, below the lesion, complete loss of fine touch, 2-point discrimination, vibration, and proprioception, where 1 to 2 levels starting below the lesion, there is complete sparing of crude touch, pressure, pain, and temperature. 3, there will be lower motor neuron signs, such as flaccid paralysis at the level of the lesion. 4, upper motor neuron signs below the level of the lesion. And 5, on the contralateral side, at the level of the lesion and below, there's loss of pain and temperature, where 1 to 2 levels starting below the lesion, there's loss of crude touch and pressure. Of note, hemisection at T1 may result in ipsilateral Horner syndrome. Alternatively, damage to the spinal cord can also be a result of ischemia. Now remember that the spinal cord gets its blood supply from branches of the vertebral, ascending cervical, deep cervical, intercostal, lumbar, and lateral sacral arteries. One of the major arteries supplying the spinal cord is the anterior spinal artery, which is formed by branches of the vertebral arteries, running longitudinally down and supplying the anterior 2/3 of the spinal cord, with the posterior 1/3 of the spinal cord being supplied by the posterior spinal arteries. Occlusion of the anterior spinal artery can be iatrogenic, such as during surgery for aortic aneurysm repair, or it may also occur as a complication of trauma, aortic dissection, thrombosis, embolism, vasculitis, and severe hypotension. Normally, above the level of T8, the anterior spinal artery arises from branches of the vertebral arteries, while below the level of T8, it's mainly supplied by the artery of Adamkiewicz, which is a branch of the aorta. This means the area below the level of T8 is particularly vulnerable during aneurysm repair. As a result, anterior spinal artery occlusion can result in anterior cord syndrome. This is characterized by 3 aspects. First, there's damage to the anterior horn, causing lower motor neuron injury at the level of the lesion, which results in muscle paralysis and atrophy. Second, there's damage to the lateral corticospinal tracts, which result in paralysis below the lesion and subsequent upper motor neuron signs, such as spasticity and hyperreflexia over a few days to weeks. And third, there's damage to the spinothalamic tract on both sides of the cord, which results in bilateral loss of pain, temperature, crude touch, and pressure below the level lesion. Bear in mind, though, that this does not affect the dorsal columns as they are supplied by the posterior spinal arteries, so fine touch, two-point discrimination, vibration, and proprioception will be spared. If you need a breather after all that, you're in luck. So, can you identify the ascending and descending spinal tracts on this image? Up next, let's talk about some other conditions that can affect the ascending and descending tracts of the spinal cord. First, there's syringomyelia, a lesion of the central spinal cord. This is a cystic cavity or syrinx within the central canal of the spinal cord, which contains cerebrospinal fluid that gradually expands. The cause of syringomyelia isn't well understood, but is most commonly associated with a congenital condition called Chiari malformation type 1. Some acquired conditions that can cause syringomyelia are things like spinal cord tumors or trauma. Normally, cerebrospinal fluid would flow through the four ventricles of the brain, and after the fourth ventricle, the fluid either flows into the subarachnoid space or moves down into the central canal. In Chiari malformations, cerebellar displacements of structures, such as the cerebellar tonsils, occurs and blocks these openings. The expanding cyst in syringomyelia usually causes compression of the anterior white commissure first. This is where the fibers of the spinothalamic tract cross over on their way to bringing sensory information to the brain. Symptoms of this compression would result in bilateral symmetrical loss of pain and temperature sensation. Depending on the spinal cord level the compression is at, certain dermatomes will be affected. It's more likely to affect the upper extremities, but can occur anywhere. If the cyst expands further, it can compress the ventral horns. This can result in flaccid paralysis of muscles innervated by that spinal cord level, as the synapses of the lower motor neurons are affected. Next up, there's tabes dorsalis, which is caused by tertiary syphilis. With tabes dorsalis, there's demyelination and degeneration of the dorsal columns and dorsal roots of the spinal cord. Typically, tabes dorsalis results in a loss of the sensations of two-point discrimination, vibrations, fine touch, and proprioception. Without the sensations of vibration and proprioception, the individual will often stumble in the dark and have difficulty in coordination while walking, also known as sensory ataxia. Another telltale sign is a positive Romberg sign, which is a test of proprioception where the person stands with their feet close together, arms to the sides, and the eyes closed, which results in unsteadiness. The dorsal columns can also be affected by vitamin B12 or cobalamin deficiency, which can result from autoimmune gastritis, tapeworms, or prolonged vegan diets with no B12 supplementation, and results in neurological dysfunction called subacute combined degeneration, or SCD. The main sites of involvement are the spinocerebellar tract, resulting in ataxia and recurrent falls, the lateral corticospinal tracts, causing spastic paralysis, increased deep tendon reflexes, and the Babinski reflex, and the dorsal columns, causing loss of position and vibration sensation, and sensory ataxia, which can lead to a positive Romberg sign. Patients may also develop a smooth, erythematous, shiny tongue, referred to as atrophic glossitis. A good way to remember that is by thinking of SCD as spinocerebellar, corticospinal, and dorsal columns. Then there's amyotrophic lateral sclerosis, or ALS, which is a motor neuron disorder that affects both the upper and lower motor neurons of the corticospinal and corticobulbar pathways throughout the body. This can result in upper motor neuron signs, such as spastic paralysis with hyperactive deep tendon reflexes and positive Babinski sign. The medulla and spinal cord also undergo degeneration, causing lower motor neuron signs, such as muscle atrophy, hypoactive deep tendon reflexes, and fasciculations. Okay, now for a quick recap. Spinal cord injuries can be caused by compression or pressure of spinal nerve root, ischemia, or transection. There can be complete transection of the spinal cord, as well as a hemisection of the spinal cord, which results in Brown-Séquard syndrome. Anterior cord syndrome occurs with a loss of blood supply from the anterior spinal artery, affecting the anterior 2/3 of the spinal cord. With central cord lesion, specifically syringomyelia, fluid builds up within the central canal, causing compression of the anterior white commissure of the spinothalamic tract. With tabes dorsalis, caused by tertiary syphilis, there's demyelination and degeneration of the dorsal columns and dorsal roots of the spinal cord, resulting in a loss of the sensations of two-point discrimination, vibrations, fine touch, and proprioception. With vitamin B12 deficiency, there can be subacute combined degeneration involving the spinocerebellar tract, the corticospinal tracts, and the dorsal columns. With ALS, both the upper and lower motor neurons of the corticospinal and corticobulbar pathways are affected.
The gastrointestinal tract runs from the mouth all the way to the anus and contains the esophagus, the stomach, the small and large intestine, and the anus. All of these structures, like any other part of our body, are prone to injury or disease. This video will give you a better understanding of the anatomy of the GI tract and how it relates to the clinical conditions that affect them. Let's start by looking at gastric and duodenal ulcers, which are open lesions in the lining of the stomach or duodenum that lead to inflammation in the gastric or duodenal wall. These are often associated with a specific stomach bacteria called H. pylori, Helicobacter pylori. Duodenal ulcers are more frequent than gastric ulcers and can be located anywhere along the duodenal wall, classically affecting either the anterior or posterior duodenal wall. If severe enough, ulcers can erode through the duodenal wall, which can cause perforation or gastrointestinal bleeding. Anterior wall duodenal ulcers are more prone to perforation into the anterior abdominal cavity, and this can result in a pneumoperitoneum because air from the gastrointestinal tract enters the abdominal cavity. A classic finding on X-ray is free air under the diaphragm indicating a pneumoperitoneum. This can also result in peritonitis, because as duodenal contents leak into the abdominal cavity, they irritate the peritoneum. Posterior wall duodenal ulcers can also cause perforation, but more frequently they cause upper gastrointestinal bleeding. That's because the first part of the duodenum, called the duodenal bulb, is positioned directly anterior to the gastroduodenal artery, so an erosion of the posterior wall can also cause erosion into the gastroduodenal artery, resulting in an upper gastrointestinal bleed. Most gastric ulcers are located at the lesser curvature of the stomach, an area where both the left and right gastric artery can be found perfusing the stomach. So, if a gastric ulcer erodes the lesser curvature, this can result in an upper gastrointestinal bleed. Gastric ulcers can also be located posteriorly, in which case they can erode through the stomach wall and into the pancreas. In doing so, these ulcers can also erode the splenic artery, which lies along the upper border of the pancreas, resulting in severe bleeding into the peritoneal cavity. Now, speaking of gastric blood supply, most of the stomach is well perfused with a rich anastomotic network, for example, the lesser curvature receiving blood from both the right and left gastric artery. The fundus of the stomach, however, is mainly perfused by the short gastric arteries, which are branches of the splenic artery. Unfortunately, these short gastric arteries have a poor anastomotic network, leaving the area they supply susceptible to ischemia following any blockage to the splenic artery. Therefore, any potential blockage to the splenic artery, such as atherosclerosis, emboli, or compression, can result in ischemia to the fundus of the stomach. To wrap up our discussion on stomach clinical correlates, let's talk about gastric cancer. The most common type of gastric cancer is gastric adenocarcinoma, which is capable of aggressive local spread and metastasis. The most common physical exam finding of metastasis in gastric cancer is an enlarged, palpable, sometimes even visible left supraclavicular node, also known as Virchow node. Metastasis may also spread to the periumbilical nodules, known as a sister Mary Joseph nodule. Time for a quick quiz. Where are GI ulcers often located? What happens if a duodenal ulcer perforates posteriorly? Let's switch gears and talk about some clinical correlates regarding the small and large intestine. First, there's superior mesenteric artery syndrome, which is a rare cause of proximal intestinal obstruction, which is when the duodenum is compressed between the superior mesenteric artery and the aorta. Anatomically, the third portion of the duodenum passes between the aorta and the superior mesenteric artery as it courses from right to left across the abdomen. Typically, the duodenum crosses anteriorly to the aorta at the L3 vertebral level. The superior mesenteric artery arises from the anterior part of the aorta at the level of L1 and extends downwards into the mesentery as it goes on to supply the small and large intestines. In most individuals, the angle between the superior mesenteric artery and the aorta is at about 45 degrees, allowing space for the duodenum to pass between them. If this angle diminishes to less than 20 degrees, then the duodenum has the potential to become trapped between the superior mesenteric artery and the aorta, which causes compression of the duodenum, leading to superior mesenteric artery syndrome. Clinical presentation of superior mesenteric artery syndrome may present insidiously and are consistent with proximal small bowel obstruction. This narrowing of the aorto-mesenteric angle can occur with any condition that reduces mesenteric fat. This is often associated with things that cause large weight loss, such as malignancy, eating disorders, malabsorption syndromes, burns, or bariatric surgery. Furthermore, significant anatomic changes can lead to this syndrome, such as corrective scoliosis surgery. Symptoms of superior mesenteric artery syndrome can mimic those of bowel obstruction and include postprandial epigastric pain, early satiety, and in more severe cases, nausea, bilious emesis, and weight loss. Next, let's quickly go over some tips and tricks on how to identify the appendix during surgery. The appendix is normally located at the junction of the small and large intestine, roughly 2 centimeters below the ileocecal valve. To remove the appendix, the 3 Taenia coli are used as a landmark. The Taenia coli begin distally as a continuous layer of longitudinal muscle that surrounds the rectum below the serosa. At the rectosigmoid junction, this muscular layer forms 3 distinct longitudinal bands that can be seen on the external surface of the colon. These 3 bands continue proximally along the colon where they converge at the root of the vermiform appendix, so by following these Taenia coli to the cecal base, the appendix can be identified. When in doubt, search for the Taenia coli. Sticking with the appendix, recall that there is anatomical variation to the position of the appendix. The attachment of the appendix is constant to the base of the cecum, however, the tip of the appendix can migrate. The most common position is a retrocecal appendix, where the tip extends posterior to the cecum and extends superiorly toward the right colic flexure. Other times, the appendix lies beneath the peritoneal covering of the cecum, and in this case it's often fused to the cecum or to the posterior abdominal wall. The appendix may also project inferiorly into the pelvis. These variations can affect the clinical manifestations of appendicitis. For example, with retrocecal appendicitis, individuals may present with an iliopsoas sign, which is when pain appears during extension of the hip. A more anterior placed appendix may cause localized sharp pain in the right lower quadrant. Finally, when the appendix lies in the pelvis, atypical pain below the McBurney point may occur. Individuals can also present with a positive obturator sign, which is when there's pain on flexion and internal rotation of the hip as the appendix is in contact with the obturator internus muscle fascia and is stretched and irritated during this maneuver. Moving down our tubular pathway, let's look at a clinical condition affecting the vasculature of the large intestine. Remember that the GI tract is supplied by 3 major arteries: the celiac trunk, the superior mesenteric artery, and the inferior mesenteric artery. Now, between these major arteries, there are anatomical areas called watershed regions, which are anatomical regions supplied by the terminal branches of 2 major arteries. In regards to the large intestine, its blood supply comes from the superior mesenteric artery and the inferior mesenteric artery. Therefore, any area that received blood supply from the terminal branches of both these vessels is considered a watershed region. One watershed region is the splenic flexure, or left colic flexure, which receives blood from narrow terminal branches of the superior mesenteric artery and the inferior mesenteric artery. Another watershed region is the rectosigmoid junction, which receives blood from narrow terminal branches of the inferior mesenteric artery and the superior rectal artery. Because they are supplied by narrow terminal branches, these two areas are more prone to ischemia due to hypoperfusion, which can be the result of blockage due to atherosclerosis, emboli, or thrombi. The main symptoms of colon ischemia includes mild to severe abdominal pain and cramping in the region where ischemia occurs, rectal bleeding, diarrhea, distension, and in severe cases, shock and dehydration. Next, let's tackle sigmoid volvulus, which is when the sigmoid colon twists around its mesentery, leading to obstruction of its lumen, compression of blood supply, and subsequent ischemia. The sigmoid colon has a higher likelihood of volvulus due to its freedom of movement, and the risk of volvulus increases with a particularly long sigmoid colon with a narrow mesenteric attachment. Symptoms of sigmoid volvulus have an insidious onset and include abdominal distension and progressive abdominal pain, and eventually signs of obstruction, such as nausea and vomiting. Now, on an X-ray, you can see a U-shaped distended sigmoid colon seen as a collection of gas, which can extend anywhere from the pelvis to the upper abdomen. If you look closely, this kind of looks like a coffee bean, which is why it's also called the coffee bean sign. Finally, let's wrap up this video by talking about hemorrhoids, which is a term used to describe the dilation of veins in the rectal venous plexus. These vessels may become swollen or inflamed, leading to what we refer to as internal hemorrhoids or external hemorrhoids. Okay, now hemorrhoids result from the breakdown of the muscularis mucosa of the rectal wall, which allows rectal veins to prolapse through. Hemorrhoids are classified into internal and external hemorrhoids based on their location to the pectinate or dentate line. Internal hemorrhoids are located above the pectinate line and affect the internal venous plexus, which drains into the superior rectal veins. External hemorrhoids, on the other hand, are below the pectinate line and affect the external venous plexus, which drains into the inferior rectal veins. Due to their position above the pectinate line, internal hemorrhoids receive visceral innervation from the inferior hypogastric plexus and are not sensitive to pain, touch, or temperature. External hemorrhoids, however, receive somatic innervation from the inferior rectal nerve, a branch of the pudendal nerve, and are therefore sensitive to touch, temperature, and pain. Both types of hemorrhoids are typically asymptomatic. Internal hemorrhoids can prolapse through the anal canal and become compressed, which may cause strangulation. Alternatively, internal hemorrhoids may bleed, resulting in painless, visible bleeding coming from the rectum. External hemorrhoids can become inflamed, causing itching and discomfort, and due to the somatic innervation of external hemorrhoids, they can be a literal pain in the behind if they thrombose. Hemorrhoids are often the result of increased intra-abdominal pressure and can result from chronic constipation, pregnancy, obesity, and increased straining on defecation. Alright, as a quick recap, when duodenal or gastric ulcers perforate the anterior wall, that can cause a pneumoperitoneum, which is associated with free air under the diaphragm on an X-ray. Posterior wall erosion of duodenal and gastric ulcers, as well as lesser curvature ulcers of the stomach, can cause gastrointestinal bleeding. The fundus of the stomach is supplied by the short gastric arteries, which are prone to ischemia if there is a blockage to the splenic artery. Next, signs of metastatic gastric cancer would be a left supraclavicular node enlargement, known as Virchow node, and periumbilical nodal enlargement, known as Sister Mary Joseph nodule. Superior mesenteric artery syndrome is a rare cause of proximal intestinal obstruction where the third portion of the duodenum is compressed between the aorta and superior mesenteric artery. During an appendectomy, the Taenia coli can be used as a landmark to find the appendix. The position of the appendix can vary. It can lie behind the cecum, beneath the peritoneal covering of the cecum, in which case it's often fused to the cecum or abdominal wall, or it can project inferiorly into the pelvis. The watershed regions of the colon include the splenic flexure and the rectosigmoid junction, and these regions are more prone to ischemia, due to the fact that their blood supply is provided by narrow terminal branches of the superior mesenteric artery and inferior mesenteric artery. Sigmoid volvulus happens when the sigmoid colon twists around its mesentery, causing obstruction in the descending colon, and it can cause the coffee bean sign on an X-ray. Finally, hemorrhoidal disease is when the internal and external venous plexuses of the anal canal become swollen. These include internal hemorrhoids, which are found above the pectinate line, and external hemorrhoids, which are found below the pectinate line. Both are often asymptomatic, however, external hemorrhoids may cause severe pain if thrombosed. The abdominal cavity is home to plenty of organs. Some of them, like the stomach and intestines, are part of the gastrointestinal tract. Other organs, like the liver, gallbladder, and pancreas, help with digestion, even though they're not part of the GI tract itself. And then there are also organs like the spleen, kidneys, and ureters, which are part of other important non-gastrointestinal systems. So let's take a look at the injuries and diseases that can affect these abdominal organs. First off, we have portal hypertension, which basically means increased pressure in the portal venous system. This is most commonly caused by liver cirrhosis, but can also be caused by vascular obstruction. Some causes of vascular obstruction include portal vein thrombosis, Budd-Chiari syndrome, which is thrombosis or compression of the hepatic veins, as well as the parasitic flatworm infection known as schistosomiasis. Okay, now when fibrosis in the liver from cirrhosis obstructs the portal vein, the pressure rises in the portal vein and into its tributaries. This large volume of congested blood flows out from the portal system into the systemic system at the sites of portosystemic anastomoses, also called portocaval anastomoses. The first site of portosystemic anastomosis is at the lower esophagus. At this point, the high pressure in the portal system can reach the anastomosis between the left gastric veins and the esophageal veins in the lower esophagus, causing engorged varicose veins, which may then go on to rupture and lead to upper gastrointestinal bleeding. In more severe cases of portal hypertension, the veins of the anterior abdominal wall, called the epigastric veins, which anastomose with the paraumbilical veins, become varicose and look like small snakes radiating from the umbilicus under the skin. This clinical sign is called caput medusae. There is another portosystemic anastomosis in the rectum, which in the case of portal hypertension can lead to anorectal varices. Some other signs and symptoms of liver cirrhosis include palmar erythema, petechiae, ascites, and jaundice. These might be present in addition to the signs of portal hypertension as we discussed: anorectal varices, caput medusae, and esophageal varices. Now let's talk about the gallbladder, which is often affected by gallstones. Gallstones are tiny stones that form in the gallbladder, and the technical term for these gallstones in the gallbladder is cholelithiasis. To understand the clinical repercussions of gallstones, let's review the anatomy of the hepatobiliary tree and the pancreatic ducts. So, the liver cells, called hepatocytes, secrete bile, and the bile drains from the hepatocytes through bile canaliculi to the interlobular biliary ducts, then the collecting bile ducts, and finally into the right and left hepatic ducts. The right and left hepatic ducts then join to form the common hepatic duct. Also, the gallbladder has its own duct called the cystic duct. The common hepatic duct meets the cystic duct and they join together to form the common bile duct. The common bile duct then descends and passes posterior to the first part of the duodenum and the head of the pancreas. At this point, it converges with the main pancreatic duct, and together they form the hepatopancreatic ampulla, or ampulla of Vater, which empties into the duodenum. Now, gallstones are mainly made of cholesterol crystals, and they arise more commonly in biological females. Even though they usually form and stay in the gallbladder, sometimes they can migrate and obstruct different parts of the hepatobiliary tree. When a gallstone blocks the cystic duct, it obstructs the passage of bile from exiting the gallbladder. In this case, contraction of the gallbladder, like after a fatty meal, can lead to biliary colic, which is an intense, spasmodic pain located in the right hypochondrium or right upper quadrant. When the gallbladder relaxes, the stone might move back into the gallbladder, relieving symptoms. Alternatively, it can remain lodged in the cystic duct, and this causes inflammation and enlargement of the gallbladder, known as cholecystitis. Symptoms of cholecystitis include right upper quadrant pain or epigastric pain, along with anorexia, nausea, vomiting, and fever. Since the stone is only obstructing the gallbladder from emptying via its cystic duct, while the common bile duct remains open, patients with cholecystitis do not often present with jaundice. On clinical examination, there's a positive Murphy sign. This is when the individual is asked to take a deep breath while the doctor palpates the area of the gallbladder just beneath the edge of the liver. Deep breaths cause the gallbladder to descend and press against the examining fingers, which in individuals with acute cholecystitis leads to pain and discomfort. A positive Murphy sign is when the patient catches their breath and ceases to inspire due to the pain of the inflamed gallbladder descending against the examiner's hand. Gallstones can also migrate and obstruct the common bile duct, which is known as choledocholitis. Obstruction at this level leads to inflammation of the common bile duct and bile stasis, which can then allow bacteria from the small intestine to multiply within the common bile duct. This situation is called ascending cholangitis, a fancy term for the common bile duct is obstructed, inflamed, and bacteria are wreaking havoc inside. Symptoms of ascending cholangitis include fever, abdominal pain, and jaundice, also known as Charcot triad. Jaundice occurs due to the obstruction of the common bile duct and subsequent buildup of bilirubin in the liver and then in the blood. Interestingly, gallstones can also migrate to where the common bile duct meets the pancreatic duct at the ampulla of Vater and obstruct both the common bile duct and the main pancreatic duct. This obstruction of the pancreatic ducts leads to pancreatitis, which is the inflammation of the pancreas. Symptoms of pancreatitis include anorexia, malaise, and epigastric pain, which often radiates to the back. With the gallstone obstructing the common bile duct at the same time, patients often appear jaundiced as well. Finally, an enlarged and inflamed gallbladder can attach itself to and form communications with adjacent viscera, and these are called fistulae. For example, a cholecystoenteric fistula is when a communication between the gallbladder and the intestine forms. The location of the gallbladder affects which organs are most likely to develop a fistula with it. These organs are the superior part of the duodenum and the transverse colon. A large enough gallstone won't be able to enter and pass through the cystic duct, but it could pass through a cholecystoenteric fistula and enter the gastrointestinal tract. Such a stone can then travel distally and become trapped at the ileocecal valve, causing small bowel obstruction. This particular type of bowel obstruction is called a gallstone ileus. Symptoms include recurring diffuse abdominal pain and vomiting. Air from the intestinal tract may also enter the biliary tree through this fistula, leading to pneumobilia, which can be detected on imaging. Luckily, a cholecystectomy, which is when the gallbladder is surgically removed, can be done to manage several gallbladder issues, some of which we've just discussed. Surgery ultimately depends on the patient's clinical symptoms and surgeon preference, but reasons for cholecystectomy include choledocholitis, gallstone pancreatitis, uncomplicated cholecystitis, acalculous cholecystitis, porcelain gallbladder, gallbladder polyps larger than 0.5 centimeters, as well as asymptomatic cholelithiasis in individuals at increased risk for developing gallbladder cancer. During surgery, it's important to identify callow triangle or the cystohepatic triangle in order to ensure safe ligation of the cystic duct and cystic artery. The triangle is bounded inferiorly by the cystic duct, medially by the common hepatic duct, and superiorly by the inferior surface of the liver. The cystic artery is located within the triangle and is identified during a laparoscopic procedure and then ligated or clipped off. The triangle also contains the right hepatic artery and might contain anomalous bile ducts. Because of this, ligation of the cystic artery should only happen once the boundaries of callow triangle have been identified and the structures passing through it have been dissected and identified. During cholecystectomy, the common bile duct can be damaged, which can lead to leakage of bile into the abdomen and consequent peritonitis. The surgical instruments used to remove the gallbladder can also injure other structures, like the intestine and surrounding blood vessels. Before moving on, a quick quiz. What can happen when a gallstone migrates to the common bile duct? Now let's have a quick chat about the spleen and the pancreas. The spleen is an intraperitoneal organ that lies in the left hypochondrium close to other intraperitoneal organs like the stomach, the transverse colon, and the descending colon. It's also close to the left kidney and the pancreas, both of which are retroperitoneal organs. In most individuals, the spleen doesn't extend inferiorly past the rib cage unless it's enlarged. The spleen is the most commonly injured organ during blunt trauma, for example by car crashes, sports injuries, and fistfights. Splenic injuries can occur due to fracture of the overlying ribs or impact to the spleen itself and can range from a simple contusion or subcapsular hematoma to splenic laceration and subsequent internal bleeding. Individuals with a ruptured spleen can present with nausea, abdominal pain, abdominal guarding, tenderness in the epigastrium, and pain in the left flank, as well as hypotension or shock due to profound intra-abdominal bleeding from this highly vascular organ. Moreover, a ruptured spleen can present with a positive Kerr sign, which is when there's referred pain, typically to the upper left shoulder, due to irritation of the phrenic nerve in the diaphragm. A ruptured spleen is considered a surgical emergency and must be addressed as soon as possible. In most cases, a ruptured spleen requires a splenectomy, which is the surgical removal of the spleen. And now for the pancreas, which is an elongated, digestive gland that lies in the retroperitoneum, crossing the bodies of the L1 and L2 vertebra on the posterior abdominal wall. It lies posterior to the stomach between the duodenum on the right and the spleen on the left. One of the most important diseases of the pancreas is pancreatic cancer, of which pancreatic adenocarcinoma is the most common type. Symptoms of pancreatic cancer include weight loss, abdominal pain, and jaundice. Unfortunately, however, it may be asymptomatic and may not be detected until much later in the progression of the disease. Abdominal pain is usually located in the epigastrium and can radiate to the back or sides. Jaundice may happen as a result of obstruction of the nearby biliary tree by the tumor or by metastasis. Pancreatic cancer can also invade major arteries, like the superior mesenteric artery, which is posterior to the neck of the pancreas. In patients with suspected biliary obstruction and jaundice, Courvoisier's law states that an enlarged and non-tender gallbladder accompanied by mild jaundice is unlikely to be caused by gallstones and is more likely caused by pancreatic or gallbladder cancer. Finally, it's worth mentioning that the tail of the pancreas passes anterior to the left kidney and is closely related to the splenic hilum and left colic flexure. The pancreatic tail is mobile and can pass between the layers of the splenorenal ligament along with the splenic vessels. This is important because during a splenectomy, one complication of the surgery occurs when the tail of the pancreas is damaged. Post-operatively, patients may show biochemical markers of pancreatic injury and pancreatitis, and may also lead to the patient developing diabetes. Let's take a quick quiz. What can cause a positive Kerr sign? Where does it occur for a ruptured spleen? Let's finish off this video by discussing the abdominal organs that belong to the urinary system. The left kidney is usually located between the transverse processes of T12 and L3 vertebrae and is a bit more superior than the right kidney. Adjacent to the left kidney, there's the left 12th rib. Now, remember that rib fractures are the most common injury during blunt thoracic trauma. I hope you know where I'm going with this. If the 12th rib is fractured, then its distal tip can displace into the retroperitoneal cavity and cause a laceration of the left kidney. Okay, let's giddy up and talk about what's called a horseshoe kidney. In some individuals, during embryological development, the kidneys are fused together at their inferior poles, forming a big kidney called a horseshoe kidney because, well, look at it. The central isthmus of the horseshoe kidney lies anterior to the aorta and posterior to the inferior mesenteric artery. The root of the inferior mesenteric artery catches onto this isthmus and prevents the kidneys from relocating to their normal position, so this type of anomalous kidney usually rests in the lower abdomen. A horseshoe kidney is usually asymptomatic and is discovered incidentally during abdominal imaging. However, these individuals have an increased risk of ureteropelvic junction obstruction, recurrent urinary tract infections, renal calculi, and renal tumors. On a CT scan, we can identify renal tissue on both sides of the aorta connecting at the isthmus distal to the origin of the inferior mesenteric artery. This is still normal renal tissue, but with an abnormal configuration. Another important clinical concept is nutcracker syndrome, which is when the left renal vein is squeezed between the superior mesenteric artery and the abdominal aorta. Normally, the angle between the superior mesenteric artery and the abdominal aorta is around 45 degrees, and the renal vein is cushioned by a layer of fat in the mesentery. If this angle gets smaller, then the two arteries can compress the left renal vein. Precipitating factors include tumors like pancreatic and retroperitoneal tumors, as well as abdominal aortic aneurysms. This syndrome leads to renal hypertension because blood has a hard time leaving the left kidney through the left renal vein, so the pressure rises in the left kidney, compromising kidney function. Since the left gonadal vein drains directly into the left renal vein, it will also become backed up. This can then lead to left testicular pain or left lower quadrant pain, especially during intercourse and menstruation. In rare cases, this backflow through the left gonadal vein can cause a varicocele in biological males, which is the enlargement of the venous plexus of the testicle. In biological females, venous congestion in the ovarian vein can lead to symptoms such as pelvic pain. Symptoms of nutcracker syndrome can include gross hematuria and left flank pain that might improve or get worse when changing positions. Finally, remember that urine leaves the kidneys through the ureters. Unfortunately, these organs can be affected by ureteric calculi, which are solid stones that get lodged inside the ureter. Anatomically, there are 3 locations where the ureters are the narrowest and where a stone is more likely to get stuck: the ureteropelvic junction, the pelvic brim, and at the point where the ureter enters the bladder, called the ureterovesical junction. When a stone is stuck in the ureter, this can lead to renal colic, which is described as an acute episode of severe flank and groin pain, often referred to as loin-to-groin pain. Now, nervous supply to the ureters comes from the renal, testicular, or ovarian, and hypogastric plexuses. So the sensory fibers from the ureters enter the spinal cord at T11 through L2, therefore ureteric pain is referred to those dermatomal areas, which explains the sensation of loin-to-groin pain. Upper ureteric stones cause pain that radiates to the flank and lumbar areas. Mid-ureteric calculi cause pain that radiates anteriorly and inferiorly from the flank and lumbar areas. Distal ureteric stones cause pain that radiates to the groin and/or the testicles or labia majora. That's because the pain is referred through the ilioinguinal nerve, which originates at L1, and through the genitofemoral nerves, which originates at L1 and L2. Alright, as a quick recap, Portal hypertension is increased pressure in the portal venous system, which can cause increased pressure in the portosystemic anastomoses. This can lead to esophageal varices, anorectal varices, and caput medusae. Gallstones are usually located in the gallbladder and are asymptomatic, but they can migrate and obstruct the cystic duct, the common bile duct, and even the pancreatic ducts, with each case causing specific symptoms and clinical outcomes. An enlarged and inflamed gallbladder can develop communications with adjacent viscera, like the intestine, and this is called a cholecystoenteric fistula, which can result in gallstone ileus, a type of small bowel obstruction. Cholecystectomy is the surgical removal of the gallbladder. The spleen is the most commonly injured internal organ during blunt trauma. Splenic injury ranges from a simple contusion or subcapsular hematoma to laceration and internal bleeding. A ruptured spleen may commonly present with a positive Kerr sign. Courvoisier's law states that an enlarged and non-tender gallbladder accompanied by mild jaundice is unlikely caused by gallstones and rather caused by pancreatic or gallbladder cancer. During a splenectomy, the tail of the pancreas can be damaged, causing issues such as pancreatitis and diabetes. A 12th rib fracture can displace anteriorly into the retroperitoneum and cause a laceration of the left kidney. When the kidneys fuse together at their lower poles, they form a big kidney called a horseshoe kidney because of its appearance. Nutcracker syndrome happens when the left renal vein is squeezed between the superior mesenteric artery and the abdominal aorta. Backflow of blood through the left gonadal vein, which drains into the left renal vein, may also occur, leading to pelvic symptoms in biological females and varicocele in biological males. Ureteric calculi are the presence of a solid stone, typically causing symptoms when they travel along the ureters. Anatomically, there are 3 locations where the ureters are the narrowest and where a stone is more likely to get stuck: the ureteropelvic junction, the pelvic brim, and at the ureterovesical junction.
The peritoneum is a transparent serous membrane that lines the abdominal cavity and covers the abdominal organs, whereas the diaphragm is a skeletal muscle that separates the thoracic cavity from the abdominal cavity and plays an important role in respiration. Understanding the anatomy of these structures allows us to better understand the unique clinical conditions that affect them. Let's start off by reviewing the innervation of visceral and somatic pain in the abdomen. The peritoneum is made up of 2 continuous layers, the visceral peritoneum and the parietal peritoneum. The inner visceral layer mainly covers the abdominal organs and has a visceral nerve supply, where the outer parietal layer mainly covers the internal surface of the abdominopelvic walls and has a somatic nerve supply. Furthermore, both the visceral and somatic nerve supply of the peritoneum sense pain during different clinical conditions. However, the way in which they sense pain is different. The visceral peritoneum is innervated by the autonomic nervous system. When the visceral peritoneum is irritated, pain sensation is detected by visceral afferent fibers, which travel with the autonomic nerves, mainly sympathetic nerve fibers, back to the spinal cord. Visceral pain is typically sensed as a diffuse, dull pain, which is not very well localized, and the pain is often referred to the midline region of the dermatomal areas of the same spinal level as the autonomic nerve supply. Typically, pain sensed by the foregut visceral peritoneum is referred to the epigastric region. Midgut visceral pain is referred to the umbilical region, and hindgut visceral pain is referred to the hypogastric region. Patients who experience visceral pain may also present with nausea, vomiting, or sweating due to activation of the autonomic nervous system. On the other hand, the parietal peritoneum has a somatic nerve supply, which is the same as the adjacent abdominopelvic wall in which it lines. When the parietal peritoneum is irritated, pain sensation travels back with these somatic nerves to the spinal cord. Somatic pain is typically sensed as a sharp, localized pain specific to the spinal level innervating that irritated area. To illustrate these types of pain, let's use appendicitis as an example, where appendicitis refers to inflammation of the appendix and can cause both visceral and somatic pain. Visceral pain occurs due to irritation of the visceral peritoneum of the appendix and surrounding areas, which travel with sympathetic fibers back to the level of T10. As a result, there may be vague pain in the right lower quadrant where the appendix is, as well as anywhere along the T10 dermatome level, frequently being felt around the umbilicus. As the appendix becomes more and more inflamed, it can also irritate the parietal peritoneum, causing somatic pain, specifically a sharp localized pain to the right lower quadrant over the appendix to an area classically known as McBurney point. Traveling from the umbilicus, the McBurney point is situated at 2/3 of the distance between the umbilicus to the anterior superior iliac spine, and tenderness due to palpation over this area is a classic sign of appendicitis. In addition to appendicitis, there are many situations that can cause irritation and inflammation of the peritoneum, and this is called peritonitis. Often, peritonitis is the result of bacterial contamination, such as during open surgery, when the gut is penetrated during trauma, or as the result of a ruptured internal organ, such as the appendix. This exposes the peritoneum to gas and fecal matter, which is usually contained within the gastrointestinal tract, and allows bacteria to enter the otherwise sterile peritoneal cavity, leading to infection and subsequent inflammation of the peritoneum. Peritonitis causes intense pain in the abdomen and results in increased tone of the anterolateral abdominal muscles, which is a mechanism that aims to protect the contents of the abdominal cavity. Therefore, on examination, the abdomen is extremely tender to palpation, resulting in patient discomfort and voluntary guarding. Other signs include abdominal wall rigidity, which is due to involuntary increased muscle tone, as we just mentioned, as well as another clinical sign called rebound tenderness. Rebound tenderness is when you slowly perform deep palpation on the abdomen and then quickly remove your hand, which elicits a stabbing pain over the area of palpation, resulting in a rebound tenderness indicating peritonitis. Symptoms of peritonitis include severe abdominal pain, nausea, vomiting, fever, and constipation. Now, if the peritoneum is damaged or infected because of trauma, surgery, or peritonitis, fibrin starts to deposit on the inflamed peritoneal surface, which results in fibrous tissue formation during healing. This fibrous tissue, often referred to as scar tissue, can lead to the formation of adhesions, which are abnormal fibrous attachments between the visceral peritoneum of nearby organs or between the visceral peritoneum of an organ and the parietal peritoneum of the nearby abdominal wall. Abdominal adhesions are often the result of an abdominal operation, such as an appendectomy, and adhesion formation can limit the normal movements of abdominal viscera. Adhesions can cause chronic pain or complications, such as an intestinal obstruction, as the intestine can become tethered or twisted around an adhesion and can also result in a potential volvulus. This is one reason why less invasive surgical techniques, such as laparoscopy, are preferred to open surgery when possible. Before we move on, we can't discuss the peritoneum without mentioning how one of its really cool features is that it can be used for peritoneal dialysis. The peritoneum is a semi-permeable membrane with a large surface area rich in blood and lymphatic capillary beds. The fact that the peritoneum is semi-permeable means that it allows certain substances or molecules to be rapidly absorbed, just like how the information in this osmosis video is absorbed into your brain. Okay, maybe it's not exactly the same, but you get the point. Now, in individuals with end-stage renal disease, waste products like urea accumulate in the individual's blood and tissues because they cannot be excreted, causing signs and symptoms like nausea, vomiting, pruritus, mental status changes, or even pulmonary edema. If the individual is unable to overcome the renal dysfunction, dialysis may be needed. There are two main types of dialysis: peritoneal dialysis, which takes advantage of the semi-permeable peritoneal membrane, and hemodialysis, where waste products are removed from the blood. Peritoneal dialysis involves inserting a large indwelling catheter in the peritoneal space, where a dilute sterile solution is introduced in the peritoneum through the catheter, which creates a concentration gradient between the blood and the fluid in the peritoneal cavity. This concentration gradient pulls waste and excess fluid from the blood and into the peritoneal cavity, where the fluid is then removed through the indwelling catheter. This procedure relies on the peritoneum's large surface area and semi-permeable membrane to eliminate waste. Quick quiz before we move on to the next section. What is the difference between visceral and somatic abdominal pain? Now let's talk about one of the unknown heroes of the peritoneal cavity, the greater omentum. The greater omentum is a large, four-layered peritoneal fold containing a large amount of fat that hangs from the greater curvature of the stomach. It is a very mobile structure which covers a large portion of the abdominal organs and, in doing so, prevents the visceral peritoneum from sticking to the parietal peritoneum. Furthermore, it has a protective mechanism where it can form adhesions and surround inflamed organs, such as the appendix, in order to wall them off and keep inflammation from spreading to other abdominal organs and viscera. The greater omentum is also a cushion for the abdominal organs against injury and also forms insulation against loss of body heat. Next up, there's the hepatoduodenal ligament, which is the thickened free edge of the lesser omentum that extends between the liver and the superior part of the duodenum. The hepatoduodenal ligament contains three very important structures: the hepatic artery, the portal vein, and the common bile duct. Due to the risk of hemorrhage during liver injury or hepatic surgery, the best way to prevent and control bleeding is to compress the hepatoduodenal ligament. This can be done using the Pringle maneuver, which is clamping the hepatoduodenal ligament manually or with the use of a clamp. During uncontrolled bleeding of the liver, the Pringle maneuver can be used to help localize the source of bleeding. If the bleeding stops, then the source is likely from the hepatic artery or portal vein, and if it does not stop, then bleeding is likely due to the inferior vena cava or hepatic veins. Alright, now let's switch gears and discuss the clinical conditions affecting the diaphragm. The diaphragm receives most of its sensory supply from the phrenic nerves, which carry signals to C3 through C5 spinal nerves, where the periphery of the diaphragm receives sensory innervation from the T5 through T11 intercostal nerves and the subcostal nerves. So, when there is irritation to the diaphragmatic peritoneum innervated by the phrenic nerve, this can result in referred pain to the dermatome area supplied by C3 through C5. This is because as the phrenic nerve is irritated, it sends this signal back to spinal level C3 through C5, and our body confuses this for sensation at the C3 through C5 dermatome levels. This would manifest as shoulder tip pain and is referred to as a Kier's sign. Can you recall another clinical condition that results in shoulder tip pain? That's right, a myocardial infarction can, because the phrenic nerve also innervates the pericardium. Going back to the diaphragm, irritation of the peripheral portions of the diaphragm will lead to more localized pain over the costal margin and anterolateral abdominal wall, as these areas receive sensation from the T5 through T12 spinal levels. Irritation of the diaphragm can be the result of numerous clinical conditions such as peritonitis, which we already talked about, or other things such as splenic rupture or a hemoperitoneum. Next up, let's talk about something called a pneumoperitoneum, which is when there is free air located in the peritoneal cavity. Free air is often recognized on clinical imaging, such as during X-ray or CT scan. One of the classic signs is on X-ray, where free air is seen underneath the diaphragm on an upright abdominal or chest radiograph, as seen here. A pneumoperitoneum is caused by any condition where air can leak into the peritoneal cavity. For example, any perforation along the gastrointestinal tract, such as a perforated ulcer or perforated diverticulum. Other causes include trauma, tumors, or even iatrogenic causes such as injury during endoscopy. Remember our earlier talk about diaphragmatic irritation and shoulder tip pain? Well, free air under the diaphragm can also result in shoulder tip pain. Pneumoperitoneum is a sign of a life-threatening intra-abdominal condition and needs urgent surgical management. If you need a quick break, feel free to pause this video and see if you can recall what Kier's sign is. Moving on to something more annoying than dangerous, let's talk about hiccups. Hiccups are involuntary and spasmodic contractions of the diaphragm that cause sudden inhalations of air being pushed against the closed larynx, creating a variety of funny-sounding noises from person to person. Hiccups are often the result of phrenic nerve irritation and can be caused by things such as gastroesophageal reflux disease, diaphragmatic irritation as we mentioned before, or any thoracic or abdominal lesion disturbing the phrenic nerve. Finally, let's talk about hernias. First, there are diaphragmatic hernias, which is when the abdominal viscera, for example the stomach or small intestine, can be forced into the thoracic cavity through any opening throughout the diaphragmatic surface. This can be due to congenital defects of the pleuroperitoneal membrane, or be the result of a blunt trauma to the abdomen, which causes a sudden increase in intra-abdominal or intrathoracic pressure, resulting in a defect of the diaphragm throughout its surface or at its attachment points. This increase in pressure leads to diaphragmatic rupture and herniation of contents through it. Now, diaphragmatic rupture occurs most often on the left hemidiaphragm, as the right hemidiaphragm is protected by the large mass of the liver. Second, there are hiatal hernias, which are a type of diaphragmatic hernia but occur when the upper part of the stomach pushes through the esophageal hiatus and extends up into the thoracic cavity. There are two types of hiatal hernias, a sliding hernia and a paraesophageal hernia. A sliding hernia is more common and is when the proximal stomach pushes into the thoracic cavity or slides into the thoracic cavity. This is due to laxity of the phrenoesophageal membrane, which is a membrane that circumferentially attaches the distal esophagus to the diaphragm at the gastroesophageal junction. Sliding hernias predispose individuals to reflux symptoms as gastric contents and acid can reflux proximally into the esophagus, leading to symptoms such as heartburn, indigestion, and epigastric or chest pain. The second type of hiatal hernia is a paraesophageal hernia, which is when the fundus of the stomach bulges into the thoracic cavity adjacent to the esophagus due to a hole or defect in the phrenoesophageal membrane. Large enough defects can even result in the additional herniation of the gastroesophageal junction, as well as other structures such as the spleen and bowel. Paraesophageal hernias are less common than hiatal hernias, but have a higher risk of complications such as gastric obstruction, ulcerations, and even respiratory symptoms. Alright, as a quick recap, the visceral peritoneum senses visceral pain, which is diffuse and non-localized and often results in referred pain, while the parietal peritoneum senses somatic pain, which is more sharp and well localized. During acute appendicitis, dull pain around the umbilicus is an example of visceral referred pain, where pain over the McBurney point is an example of somatic pain. Peritonitis is inflammation of the peritoneum, where individuals can present with intense pain in the abdomen, nausea, and vomiting, and clinical signs include a tender, rigid abdomen with potential rebound tenderness. When the peritoneum is damaged, the peritoneal surfaces can develop fibrous or scar tissue, leading to adhesions which can limit the movements of the abdominal viscera. A Pringle maneuver is when the hepatoduodenal ligament, which contains the hepatic artery, the portal vein, and the common bile duct, is compressed during hepatic surgery. The peritoneum can be used to remove toxic waste products in individuals with end-stage renal disease. This is called peritoneal dialysis and is a temporary solution for individuals needing dialysis. Any intra-abdominal or intrathoracic process which causes irritation of the phrenic nerve of the diaphragm can result in referred shoulder tip pain, referred to as Keir sign. Diaphragmatic irritation can also result in irritating hiccups. A pneumoperitoneum occurs when free air accumulates in the abdominal cavity and can be caused by things such as gastrointestinal tract perforation, trauma, or tumors, and is classically seen as free air under the diaphragm on X-ray. Diaphragmatic hernias can result from congenital defects or are acquired when an individual suffers blunt trauma to the abdomen, typically affecting the left side of the diaphragm. Finally, hiatal hernias are when the abdominal cavity contents herniate into the thoracic cavity through the esophageal hiatus. Sliding hiatal hernias are more common and occur when the proximal stomach pushes into the thoracic cavity due to a weakened phrenoesophageal membrane, where paraesophageal hernias are typically when the fundus of the stomach bulges into the thoracic cavity due to a hole or defect in the phrenoesophageal membrane.
The inguinal region, located near the groin, is found in the lower part of the anterior abdominal wall, and it contains several important structures that enter and leave the abdomen. Understanding the anatomy of the inguinal region is important for understanding common clinical conditions such as hernias, and many others. Speaking of which, hernias occur when an organ or tissue protrudes through the wall of the muscle or tissue that normally contains it. The majority of hernias occur in the abdominal cavity, or the inguinal region, through which subcutaneous fat, abdominal omental fat, or even abdominal viscera can protrude. In order for a hernia to happen, there is typically a weak point along the abdominal wall, such as a weak linea alba, previous surgical interventions that weaken the abdominal wall muscles, or pregnancy. First, let's look at anterior abdominal wall hernias. They can be divided into 4 categories: epigastric, umbilical or periumbilical, Spigelian, and incisional hernias. Epigastric hernias are caused by a weakened linea alba and are basically defects in the abdominal midline between the umbilicus and the xiphoid process. Then there are umbilical or paraumbilical hernias, which are hernias through the umbilical ring or around the umbilicus. These are often found in children because the umbilical ring is weak at birth, but can also be acquired in adults and frequently affect pregnant or obese individuals. Spigelian hernias are found along the semilunar lines, which are skin folds from the inferior costal margin of the 9th costal cartilage to the pubic tubercles, and overlie the tendinous insertions of the rectus abdominis muscle, as abdominal tissue can protrude through these areas of tendinous insertions. Finally, an incisional hernia can develop at the site of a prior surgical incision, as the muscle and fascia is typically weakened, for example, over the surgical site of an appendectomy. Hernias can be classified as reducible, which means that they can be easily pushed back in the abdomen with position changes or a manual pressure, or irreducible, which can't be pushed back. Irreducible hernias can become either incarcerated or strangulated. Incarcerated hernias are when the hernia contents are trapped and cannot be reduced, leading to swelling and edema of the herniated contents. With severe swelling, obstruction of blood flow to the herniated contents can occur, and this leads to ischemia and necrosis, resulting in strangulation. Incarceration and strangulation can affect any protruding structure with a blood supply, such as the omentum and bowel. Risk factors for developing a hernia include genetic defects, increased intra-abdominal pressure, aging, obesity, and pregnancy. Symptoms and signs of a hernia may include pain, discomfort, and a lump or bulge in the affected area, which may be exacerbated by increasing intra-abdominal pressure, such as coughing or laughing. Strangulated hernias can present with severe pain, nausea, vomiting, as well as tenderness and overlying erythematous skin changes. Now, a similar concept to abdominal hernias is rectus abdominis diastasis, or divarication of the recti. This is when there's a separation between the rectus muscles due to conditions that weaken and stretch the linea alba. This condition can also be congenital or acquired, and risk factors include obesity, pregnancy, connective tissue disorders, or prior abdominal surgery. This particular type of hernia is not what we call a true hernia, because technically the midline fascial layer of the abdominal wall is intact. This means that strangulation doesn't occur. Individuals affected by rectus abdominis diastasis present with a midline abdominal ridge that becomes more obvious when increasing the abdominal pressure, and can disappear when the abdominal muscles are relaxed. Diagnosis is based on physical examination, and an abdominal ultrasound can be done to completely rule out a hernia. Time for a quick quiz. What are the 4 main types of anterior abdominal wall hernias? Now let's look at femoral and inguinal hernias. Femoral hernias occur when the hernia sac slips through the femoral ring into the femoral canal, below the inguinal ligament, medial to the femoral vein, and lateral to the pubic tubercle and lacunar ligament, One important risk factor for femoral hernias is advanced age, as the femoral ring can widen with age. Femoral hernias also tend to be more common in biologically female individuals compared to biological males. But don't get confused, as inguinal hernias are a more common type of hernia in both biological males and biological females. Now, as the space in the femoral canal is limited, femoral hernias can often become irreducible and incarcerated, and subsequently can cause bowel obstruction if there is bowel located in the hernia sac. In time, this type of hernia can become strangulated and cause bowel ischemia and necrosis. On the other hand, there are two types of inguinal hernias, direct and indirect inguinal hernias, both occurring above the inguinal ligament when compared with femoral hernias. Direct inguinal hernias occur when there is weakness of the transversalis fascia. In this case, the hernia sac pushes through the weak portion of the transversalis fascia, above the inguinal ligament. Here, it protrudes into an area called Hesselbach triangle, which is bounded laterally by the inferior epigastric vessels, medially by the lateral wall of the rectus abdominis, and inferiorly by the inguinal ligament. You should note, direct hernias do not pass through the deep inguinal ring, and may only protrude through the superficial ring. Therefore, they have no direct route into the scrotum. Indirect hernias occur when the hernia sac emerges lateral to the inferior epigastric arteries, which is in contrast to direct inguinal hernias, and protrude through the deep inguinal ring into the inguinal canal, with the potential to extend distally into the scrotum. Indirect hernias are typically caused by a failure of the processus vaginalis to close in biologic males, or the deep inguinal ring to close in biologic females. Remember that the processus vaginalis is an embryonic structure that precedes the descent of the testes through the inguinal canal. Normally, after the testes have descended into the scrotum, this structure closes up, but in some cases it can remain open and allow for communication between the abdomen and the scrotum. Inguinal hernias are the most common type of hernia in both biologically male and female individuals, and they occur much more frequently in males. Direct inguinal hernias are more common in older individuals, where indirect ones are more common in infants. Compared to femoral hernias, indirect inguinal hernias are less likely to become strangulated, with direct inguinal hernias the least likely to become strangulated. Signs and symptoms of both femoral and inguinal hernias are a palpable bulge, often exacerbated by increased intra-abdominal pressure, pain, and discomfort. If an indirect hernia extends into the scrotum, then it can present as a larger palpable mass in the inguinal canal and scrotal sac. If a hernia becomes incarcerated and strangulated, for example during a femoral hernia, this can lead to overlying erythematous skin changes, as well as nausea, vomiting, clinical obstruction, and extreme pain. Okay, now let's take a more practical approach on how to distinguish these different types of hernias based on clinical exam and anatomical landmarks. On clinical examination, femoral hernias are typically palpated lateral and inferior to the pubic tubercle. Both direct and indirect inguinal hernias occur above the inguinal ligament. Direct inguinal hernias push through the Hesselbach triangle, medial to the inferior epigastric artery, and may protrude into the superficial inguinal ring. So clinically, they can be palpated superficial or medial to the pubic tubercle. Finally, indirect inguinal hernias protrude lateral to the inferior epigastric artery, into the deep inguinal canal, located at the midpoint of the inguinal ligament, and may extend through the inguinal canal and into the scrotum. Therefore, they may be clinically palpated with deep palpation using the tip of the finger anywhere along the inguinal canal, medial to the pubic tubercle, where they exit the superficial ring, or along the spermatic cord and into the scrotum. However, keep in mind you still may be unable to identify which type of hernia is occurring based on the clinical exam alone. Okay, hernias can be resolved surgically with a procedure called herniorrhaphy, but sometimes complications arise. During hernia surgery, sometimes an artery called the aberrant or accessory obturator artery can be injured. Typically, the obturator artery branches from the internal iliac artery. However, in up to 20% of people, there can be an additional branch coming from either the inferior epigastric artery or external iliac artery that either replaces the obturator artery or joins it. And this is called an aberrant or accessory obturator artery. This artery runs in close proximity to the femoral ring and courses along the superior pubic rami. So during hernia repair, it can become injured or stapled. When this occurs, the artery retracts, making it very difficult to locate and ligate, leading to uncontrolled bleeding. This artery has been referred to as corona mortis, which means crown of death, as injury to it can be fatal. On the other hand, during inguinal hernia repair, more common complications include damage to the ilioinguinal, iliohypogastric, or genitofemoral nerves, which can lead to chronic residual neuralgia and post-operative constrictive scar tissue in the surgical area. Hey, look! It's quiz o'clock! Where are direct and indirect hernias located in relation to the inferior epigastric artery? Okay, now let's switch gears and look at the testes, specifically at cryptorchidism, which is the most common birth defect in biological males. Cryptorchidism is the abnormal or partial descent of either one or both testes into the scrotum before birth. Now, the testes develop during the first trimester in the abdominal cavity, where in the third trimester of pregnancy, they start to descend into the scrotum via the inguinal canal. In some biologic males, descent of the testes doesn't occur properly, and they can be found anywhere along the inguinal canal, while some may even be atrophied or absent. Risk factors for cryptorchidism include prematurity, low birth weight, specifically under 2.5 kilograms, and small for gestational age. Cryptorchid testes palpated in the inguinal canal usually descend by the age of 6 months, so the child must be closely monitored during this time. If the testes don't descend by then, a surgical procedure called orchiopexy can be done to bring them into the scrotum, and this should be done before the age of 1. Complications of cryptorchidism include infertility, malignancy, and testicular torsion. Next up, let's discuss varicoceles and hydroceles. A varicocele is a dilatation of the pampiniform plexus in either testicle, which is a network of small veins within the spermatic cord. It occurs in up to 20% of men, typically between the ages of 15 and 25. It is typically more common in the left pampiniform plexus for 2 reasons. First, unlike the right gonadal vein, which drains directly into the IVC, the left gonadal vein is longer and drains into the left renal vein at a more perpendicular angle. Second, the left renal vein may potentially be under higher pressure than the right due to compression between the aorta and superior mesenteric artery, as it courses between these two structures, resulting in a nutcracker effect. This further increases the intravascular pressure in the left gonadal vein and dilation of the pampiniform plexus. So typically, a varicocele occurs either bilaterally or in the left pampiniform plexus. In rare cases, an isolated right-sided varicocele occurs, which would raise suspicion for thrombosis or nearby malignant compression affecting the right gonadal vein. For example, compression from a right renal cell carcinoma. Varicoceles can be asymptomatic, but can also present with scrotal pain and a soft scrotal mass which looks and feels like a bag of worms on palpation. Not a comforting visual, we know. On examination, a varicocele decreases in a supine position and increases with standing or Valsalva maneuvers, and doesn't transilluminate when shining a light into the scrotum. Diagnosis is confirmed by an ultrasound that shows pampiniform plexus dilation and retrograde venous flow. Complications of a varicocele include infertility due to increased temperature and testicular atrophy. On the other hand, a hydrocele is when there's peritoneal fluid that collects within the tunica vaginalis of the scrotum and is often congenital. Remember the processus vaginalis? Well, when it fails to close, that doesn't only increase the risk of inguinal hernias, but also allows for peritoneal fluid to flow into the tunica vaginalis. A hydrocele can also be acquired at any age, typically following infection, trauma, or a tumor. Individuals present with a soft, fluctuant, non-tender fullness in the hemiscrotum. Unlike varicoceles, hydroceles transilluminate when shining a light into the scrotum, which has a red glow indicating serous fluid in the scrotum. Hydroceles can be precipitated by inflammatory conditions, such as epididymitis and testicular torsion. And complications include transformation into a hematocele, which is a collection of blood in the hemiscrotum, as well as calcification and testicular atrophy. Finally, there's testicular torsion, which is just as painful as it sounds. It's one of the most common causes of acute scrotal pain in infants and post-pubertal boys, and is most common in adolescents. It often happens due to insufficient fixation of the testis to the tunica vaginalis. This leads to hypermobility and twisting of the testis and the spermatic cord, typically affecting the pampiniform plexus first, reducing venous outflow, where the arterial blood flow is initially preserved and decreased. However, with prolonged compression, the arterial supply eventually becomes completely occluded, leading to hemorrhagic infarction and necrosis. Testicular torsion can happen spontaneously or after trauma or vigorous physical activity. Individuals present with a swollen erythematous, tender scrotum, along with acute onset scrotal pain, lower abdominal pain, nausea, and vomiting. Furthermore, individuals may have an asymmetrical high-riding testicle on the affected side due to shortening of the spermatic cord. Also, elevation of the testicle doesn't relieve the scrotal pain, which is called a negative Pren sign. Additionally, there may be an absent cremasteric reflex, meaning that the cremaster muscle doesn't contract when lightly stroking the superior and inner part of the thigh. Normally, stimulation of the motor fibers of the genitofemoral nerve causes contraction of the cremasteric muscle, and as a consequence, contraction of the scrotal sac. The cremasteric reflex is important in trying to differentiate testicular torsion from other conditions that cause scrotal pain, such as epididymitis, or inflammation of the epididymis, orchitis, which can be caused by mumps, and Fournier's gangrene, which is a necrotizing fasciitis of the genital area and perineum. Diagnosis of testicular torsion is based on physical examination, but a Doppler ultrasound is required to detect reduced blood flow or twisting of the spermatic cord. Testicular torsion is a surgical emergency, and urgent urological consultation and surgical detorsion is required. in addition to fixing both testicles to the scrotal septum to prevent further torsion. If surgery is unavailable, manual detorsion of the testicle can be attempted. Delaying both manual and surgical maneuvers can cause testicular non-viability within 12 hours, in which case surgical removal of the affected testicle or an orchiectomy is needed. Last quiz! What is a varicocele, and on what side does it most commonly occur? What's a hydrocele? All right, as a quick recap, hernias in the anterior abdominal wall can be divided into epigastric, umbilical, spigelian, and incisional hernias. Reducible hernias can be easily pushed back into the abdomen, while irreducible hernias can't. Irreducible hernias can eventually become incarcerated or strangulated, where the hernia contents lose their blood supply and become ischemic and necrotic. Rectus abdominis diastasis is when there's a separation between the medial sides of the rectus muscles due to a weakened and stretched linea alba. Femoral hernias occur when the hernia sac protrudes through the femoral ring into the femoral canal. They occur more commonly in older biological females and have a higher likelihood of becoming strangulated due to the tight space of the femoral ring. Inguinal hernias are the most common type of hernia in both biological males and females, and they can be direct or indirect. Direct hernias are caused by weakness of the transversalis fascia, where the hernia sac protrudes into the Hesselbach triangle, medial to the inferior epigastric artery, and can push into the superficial inguinal ring, but not into the scrotum. Indirect hernias can be caused by a patent processus vaginalis and occur lateral to the inferior epigastric artery and protrude through the deep inguinal ring into the inguinal canal and may extend into the scrotum. Cryptorchidism is the abnormal or partial descent of the testes prior to birth. Complications include infertility, malignancy, and testicular torsion. A varicocele is a dilatation of the pampiniform plexus. More often, it occurs on the left side and doesn't transilluminate on examination. It has a characteristic bag of worms finding on visual inspection and palpation. A hydrocele is an accumulation of peritoneal fluid around the testes in the tunica vaginalis of the scrotum and does transilluminate on examination. Testicular torsion is the twisting of the testes and the spermatic cord, resulting in severe pain, nausea, vomiting, and may result in testicular ischemia and necrosis due to restricted blood supply. It is a surgical emergency and requires manual or surgical detorsion immediately.
When we think about the clinical conditions affecting the abdomen, we immediately think about injury to organs such as the liver, intestines, or stomach. However, there are also many conditions that affect the anterior and posterior abdominal wall, as well as the structures adjacent to them. So let's get started. When examining the gastrointestinal system, first it's important to do a general inspection of the abdomen, which includes looking for scars and incisions which can indicate what surgeries the patient has had in the past. Typically, the location of the abdominal incision indicates what type of surgery the patient has had. First, there's the Coker incision, also called the subcostal incision, which is made parallel and at least 2.5 centimeters below the costal margin in order to avoid the 7th and 8th thoracic spinal nerves. Injury to these nerves results in decreased sensation of the anterior abdominal wall supplied by those respective branches. This type of incision is usually found on the right side and provides access to the gallbladder and biliary ducts and can be extended towards the left side of the abdomen to access the spleen. Next up, there are longitudinal incisions, which include midline incisions and paramedian incisions. They can be used in almost all abdominal surgeries, especially exploratory surgeries, which are sometimes needed to diagnose uncertain abdominal pathologies. Now, longitudinal incisions provide great exposure of the abdominal viscera and can also be extended as needed. The midline or median incision is made along any part or length of the linea alba, so from the xiphoid process all the way towards the pubic symphysis. This type of incision is preferred because the linea alba only has small vessels and nerves, so there's a lower risk of bleeding and nerve damage. A paramedian incision, which is lateral to the median plane, is made in a sagittal plane and can extend anywhere from the costal margin to the pubic hairline. The paramedian incision would therefore go through the anterior rectus sheath, the rectus abdominis muscle, and the posterior rectus sheath. Other surgical procedures may require oblique incisions, depending on muscle fiber orientation and surrounding nerves. Oblique incisions include the McBurney or gridiron incision and the Rutherford-Morrison incision. So first, the McBurney incision is typically needed for appendectomies, and it's done inferomedially in an oblique orientation to follow the muscle fiber orientation of the anterior abdominal wall, specifically the external oblique. This is typically done over McBurney point, which is 1/3 of the way from the anterior superior iliac spine to the umbilicus. This incision can be extended or mirrored on the left side of the abdomen as a Rutherford-Morrison incision, which is an oblique incision used for right and left-sided colonic resection. Instead of an oblique incision, surgeons can also use transverse incisions, which are often made through the anterior layer of the rectus sheath and rectus abdominis muscle. They provide good access and are less likely to damage the nerve supply of the rectus abdominis as the incision is parallel to the nerves, and are used in pediatric or vascular repair cases. Another type of transverse incision is a Lanz incision, which may also be used for appendectomies and is located in the right iliac fossa and has a more transverse orientation. These types of incisions leave the anterior branch of the iliohypogastric nerve at risk of injury, which would cause decreased sensation over the suprapubic region. Next up are suprapubic or pfannenstiel incisions, also called bikini incisions. These are made at the pubic hairline. These types of incisions are horizontal with a slight convexity and are used for most gynecological and obstetrical operations, like a cesarean section. Once this incision is made, the linea alba and anterior rectus sheath is resected, and the rectus muscles are retracted laterally. Care must be taken not to damage the iliohypogastric or ilioinguinal nerves, as damage to these could result in sensory deficits of the suprapubic and genital region. Sometimes, during a cesarean section, there isn't enough space to properly finish the procedure and take the baby out safely. In this case, a horizontal transection of the rectus abdominis muscle might be done in addition to the vertical incision along the linea alba. In order to perform a horizontal incision, first you need to locate the arcuate line, which lies below the umbilicus posterior to the rectus abdominis and marks the inferior limit of the posterior rectus sheath. This is done in order to identify the inferior epigastric arteries, which supply the inferior portion of the rectus abdominis as they ascend on its posterior surface to enter the lateral aspect of the muscle at the arcuate line. Since there's no supporting posterior rectus sheath below the arcuate line, this is where the inferior epigastric arteries are most susceptible to injury, so they need to be located and ligated when performing a horizontal incision in order to prevent significant hemorrhage. Now, bear in mind that any abdominal surgery comes with a risk of nerve injury. The inferior thoracic spinal nerves, those from T7 to T12, and the iliohypogastric and ilioinguinal nerves provide innervation of the abdominal muscles. They are distributed across the anterolateral abdominal wall where they run oblique but mostly horizontal. They can be injured during any surgical incision or from trauma at any level, leading to muscle weakness of that area of innervation. Muscle wall weakness can lead to herniation of underlying abdominal viscera through the abdominal wall. In addition to a general inspection of the abdominal wall, another key step in clinical examination is abdominal palpation, which is when you palpate the abdominal wall and the abdominal viscera while the individual lies in a supine position with exposure from their nipples to their pubic symphysis. One clinically relevant sign to look out for when palpating the abdomen is guarding, which is when the muscles of the abdomen get tense and produce spasms. Guarding can be either voluntary or involuntary. Voluntary guarding is a voluntary contraction of the abdomen performed by the patient in order to avoid pain during examination and usually represents a diffuse abdominal pain, meaning the entire abdomen tenses up. Involuntary guarding, on the other hand, also referred to as rigidity, happens when there's involuntary contraction of the abdominal muscles in order to protect the underlying abdominal viscera from pressure as they are irritated. Involuntary guarding is a reflexive muscular rigidity caused by an inflamed organ, such as the appendix, which results in peritonitis, or an inflammation of the abdominal peritoneum. This is often an indication of an acute abdomen, which is the sudden onset of severe abdominal pain, and why abdominal palpation is so important during a clinical exam. Next up, we're going to look at the psoas major muscle, which originates along the anterior surface of the transverse processes and lateral surface of T12 to L5 vertebral bodies, and eventually combines with the iliacus muscle to form the iliopsoas muscle. The main clinical condition affecting the psoas major muscle is a psoas abscess, which is a walled-off collection, typically pus-filled, found along the psoas fascia. This can be caused by things such as spread of infection from the thoracic or lumbar vertebral bodies, such as vertebral tuberculosis, other nearby abdominal infections such as appendicitis, colitis, or hip joint infections, as well as hematogenous seeding from a distant site like a skin infection. Risk factors include diabetes, IV drug use, HIV infections, and other forms of immunosuppression. A psoas abscess can result in severe pain in the back or flank region, which can also be referred to the hip, thigh, or knee joint. Other symptoms of a psoas abscess include fever and difficulty walking. A psoas abscess may be visualized and palpated in the inguinal region and may be mistaken as an inguinal hernia, an enlarged lymph node, or a saphenous vein varix. Furthermore, it is important to note the femoral nerve emerges laterally between the psoas major muscle and iliacus muscle, so an abscess can result in femoral neuropathy and quadriceps weakness, decreased patellar reflex, as well as sensory loss over the anterior and medial thigh and leg. To test for a psoas abscess, you can perform the iliopsoas test, which is when the individual is asked to lie on the unaffected side and a contralateral hip is put into extension by the examiner. A positive sign is when pain appears during movement and can indicate a psoas abscess. Other things that can cause a positive psoas sign are an inflamed or infected appendix, sigmoid colon, and iliac lymph nodes. Another important structure located along the posterior abdominal wall is the inferior vena cava, or IVC for short. The IVC ascends in the abdomen along the right side of the vertebral bodies to the right of the abdominal aorta. On a coronal section of a CT scan, however, the IVC can be seen along the vertebral bodies, but on the left side of the image, which corresponds to the right side of the body. This is because when looking at a transverse slice of a CT or MRI scan, we are viewing the section from below, which is why the structures on the right-hand side of the body are shown on the left-hand side of a transverse radiology scan, and vice versa. Sometimes an IVC filter, which is a tiny device able to stop blood clots and prevents them from traveling towards the heart and lungs, needs to be placed within the IVC. To do this, a long catheter is placed by surgeons through the internal jugular vein or the femoral vein until it reaches the inferior vena cava. The main indication for placing an IVC filter in someone is to prevent embolization of deep venous clots from the legs to the lungs, which would cause a pulmonary embolism. An IVC filter is often used in patients who have contraindications to anticoagulation, typically those who are at an increased risk of bleeding. Now, before we wrap up, let's look at abdominal aortic aneurysms, which is defined as a pathological dilation of the aorta usually greater than 50% of the normal aortic diameter. Typically, the normal infrarenal aortic diameter is 2.0 centimeters, and an aneurysm is considered anything larger than 3.0 centimeters, where a large aneurysm is defined as over 5.5 centimeters in diameter. Risk factors include being a biological male, old age, cigarette smoking, hypertension, a family history of abdominal aortic aneurysms, and last but not least, atherosclerosis. Even though atherosclerotic buildup contributes to the formation of abdominal aortic aneurysms, the pathophysiology of an abdominal aortic aneurysm is complex and involves systemic inflammation, as well as smooth muscle cell apoptosis and extracellular matrix degradation, resulting in thinning and weakening of the aortic wall and enlargement in aortic diameter. The most common location of an abdominal aortic aneurysm is just below the renal arteries and is referred to as an infrarenal aneurysm. Now, the majority of abdominal aortic aneurysms are asymptomatic, but people can also present with abdominal pulsations, compression of surrounding structures, abdominal, back, or flank pain, and if the aneurysm ruptures, it leads to severe abdominal pain, along with a pulsatile mass in the abdomen and arterial hypotension. Okay, let's take a look at this coronal section of a computed tomography scan. Can you see the balloon-shaped structure in front of the vertebral body? That's the dilated abdominal aorta. In a CT or MRI cross-sectional scan, the aorta is found on the right-hand side of the vertebral bodies in the image, which actually corresponds to the aorta being on the left-hand side of the vertebral bodies in the individual being scanned. Alright, as a quick recap, different surgical incisions are used to access the abdomen for different surgical procedures. These include Coker or subcostal incision, median or paramedian incision, the McBurney or gridiron incision, as well as the Lanz, Pfannenstiel, and Rutherford-Morrison incisions. During abdominal surgery, the inferior thoracic spinal nerves, as well as the iliohypogastric and ilioinguinal nerves, can be injured. During a horizontal transection of the rectus abdominis muscles, the inferior epigastric arteries need to be ligated to avoid hemorrhage. Voluntary guarding is a voluntary contraction by the patient of the abdomen in order to avoid pain during examination and is usually diffused over the entire abdomen. Involuntary guarding, or rigidity, happens when there's involuntary contraction of the abdominal muscles, usually caused by peritoneal inflammation, and indicates an acute abdomen. The iliopsoas test can be used to indicate certain abdominal pathologies, such as psoas abscess, appendicitis, or irritation to nearby structures. A psoas abscess happens when there is a walled-off collection, typically pus-filled, found along the psoas fascia. IVC filters are placed to prevent emboli from reaching the heart and the lungs. Aortic abdominal aneurysms are dilations of the abdominal aorta that are usually infrarenal. Symptoms of a ruptured aneurysm can include severe abdominal pain, along with a pulsatile mass in the abdomen and arterial hypotension.